Hi guys, so I'm sure you've heard me talk about Unicaf scholarship a couple of times. If you have ever started your application for the Unicaf scholarship, and even if you have not, this is a reminder to please complete your application. It is highly flexible and it is 100% online learning, and you get to network with international students across over 150 countries. It's an amazing opportunity for you if you want to study or further your education in masters and PhD. It is not enough to desire it. You need to take the action of applying and completing your applications, okay? And you get about 75 to 80% scholarship from Unicaf. Don't say I did not do anything for you this year. Apply for the Unicaf scholarship. Using my link is a very good way to support me. Thank you. Bye.
Here's where I'm going to be challenging you. You've heard me talk about cardiology in so many different ways for so many days. Now you got to tell me what you have learned. All right? So here's how you understand pathology. These are keywords they use in the vignette somewhere. To describe the patient, folks, all you need to do is look at that one word and you should know everything else about your patient without guessing, if you truly know your notes. All right, first one. Let's say you just know that the patient has a dilated cardiomyopathy. Cammie, tell me anything about your patient. All right, they're going to have an S3. Chris, tell me anything about your patient. Reduced cardiac output. Then V, anything about your patient? Yep. Decompensation. Josh, anything about your patient? They have a volume problem. Arrows, keep it rolling, man. Dilated.
They can have hypertrophic.
Oh, you can't use that word. This is dilated heart. If I hear the word hypertrophy, no, I'm on dilated right here. You're only on this one. That's it. That means you can't ever use that word. If I say dilated, anybody hypertrophy drops right out of your head. Just tell me anything about a patient with a dilated heart.
They'll have edema.
Edema.
The diastolic will be increased.
And diastolic volume will be increased. Nicole. Weakness and shortness of breath. Come on, Kathy.
The QRS is going to be wide.
QRS is going to be wide. What about the height? Huh? How that ventricle smaller or bigger? A dilated heart is smaller? You understand what dilation is? It's dilating out this way. How can it be smaller? This is smaller. Dilating. I know, but the QRS represents that ventricle, right? So if the ventricle is bigger, so has the QRS got to be bigger. It'll just be taller and wider versus hypertrophy, which would be tall and still narrow. Yeah, that's the only difference. All right, Adelide, tell me something about a dilated heart. You're going to die of heart failure. Elvis.
They'll have a decreased stroke volume.
You're going to have decreased stroke volume. Maria.
Low blood pressure.
Not necessarily. Low cardiac output is low volume state. That equals hypertension. In fact, most of them are hypertensive. So tell me something else about your patient. She said, wait a minute, I know I've heard that somewhere before. All right, Rochelle, dilated heart, tell me something. Decreased conductivity. Come on, Kimberly, tell me something. They have high triglycerides. Come on. Tamir, tell me something. Increase in intracranial pressure. Why increase in intracranial pressure? Because they have hypertension. That man's been learning. If you hear right to one, just connect to it. You know your answer's got to be right too. All right, that's what I like now. Yeah, that's what I'm talking about. Look at that. We went through about 20 things from one word, folks. This is how you control the exam. Don't let the exam control you. You control it. The test writer can't help himself but to use these words. He's got to tell you it's got a dilated heart. And then you should never be guessing what else comes after that. You'll see the answer come right off the screen. That's if you're interacting with the words. If you're just reading a story, you won't know it. You're too much into the story, you don't even see these words anymore. All right, hypertrophic heart. Tara, tell me anything about your patient. They have what? What'd you say again? Reduced cardiac output. Is that the first phase or second phase of hypertrophy? That would be only in the second phase. That would be long term. Remember I said the first phase, you have hypertrophy within the walls of the ventricle. That way the volume in here is still the same. Everybody remember this discussion, right? All right, then when it becomes pathological, you hypertrophy and start to obliterate your own ventricle. Then you start to lose the volume. So only long term they have decreased volume. All right, Al, tell me something about a hypertrophic heart.
Diastolic dysfunction.
Diastolic dysfunction. You're going to have trouble filling. Remember, a dilated heart with systolic dysfunction, you have trouble contracting. All right, Linda, tell me something about your patient. It has an S4. What if S4 got louder when you breathe in? Which ventricle? And if S4 gets louder when you breathe out, what side are we on? So let's say if the S4 got softer when you breathe in, what side are we on? No. I'll let this flip it around on you. If I say softer when you breathe in, that means it's louder when you breathe out. That's all right. You were doing good there. You were doing good. All right. Now, be careful, folks. They don't always have to use the same words Dr. Francis uses now. You got to know it backwards, forward, upside down. Doesn't matter how they say it. It means the same thing. Now you know what answer to click. Softer when you breathe in is the same thing as left-sided. Softer when you breathe out is the same thing as right-sided. Because whichever side is louder on tells you what side it's on. So then if they flip and say softer on, you got to say it's the opposite now. Okay. All right. Hypertrophic heart. Tell me something. Atherosclerosis can do it. Come on, Malika. What? Now you got to say S4. I'm on hypertrophic. You got to come off of hypertrophic. Excuse me? No, not decreased heart rate. When you hypertrophy, doesn't necessarily mean your heart rate has to slow down. Oh, I see what you're saying. Okay, because if you increase the output, so in the first phase, all right, as long as you qualify yourself, that's fine. Yeah, that's what she meant, y'all. Don't be messing with her. All right, Beanish, hypertrophic heart. What? How do you know it's going to be narrow as 2 splitting? That doesn't necessarily narrow the S2 splitting, though. It could. All right, give me a disease that would cause it to have hypertrophy and narrow S2 splitting, too. Or a problem. Give me a problem that will qualify what you're saying. You said it could, though. Now you switch over to volume. This is pressure, and all of a sudden, that's how you know that answer cannot be the best one. No. You got to give me a reason that'll cause hypertrophy and decreased splitting of S2. And your answer was? It's coming. It'll come in a minute. Whatever you're thinking in your head right now, that's the one I want. Speak. Nothing she said. None of the things she says. No. You know what? You gave me the answer 5 minutes ago. As soon as I asked you the question, you blurted out the answer. I just didn't say anything when you said it. Now I ask you, what were you saying? All of a sudden, I don't know. I don't know. Anything that causes hypoxia, pulmonary hypertension will lead to RVH and narrow S2 splitting. That's what you said. I heard you. Oh, that's wrong. That's wrong. I told you attendings do that to you all the time to see if you actually know why you're saying what you're saying. You got to stand your ground. The minute you switch, you're letting them know you don't really know what you're saying. You just kind of came out of nowhere. Just say it again. He'll never know. Okay? All right, Matt. All right, so that's hypertrophic. Restrictive cardiomyopathy. Restrictive cardiomyopathy means somehow the heart is restricted in its motility. All right, that means actin-myosin are restricted. They're not able to slide around on each other. Number one cause, collagen vascular disease. Why? Jenny's asking herself. Because fibrosis, you're scarring actin-myosin so they can't slide freely anymore. Everybody understand that? So that's how to remember. Fibrosis. Every collagen vascular disease will end in fibrosis. That's why that's number one. We've gone through all the vascularities, so there's a ton of them. But number one is fibrosis. All right? So, what drug do you know, Tim, that'll cause a restricted cardiomyopathy? No, that one's pulmonary fibrosis. I could have sworn I'm on the heart. Tino, no. It's called adriamycin. And what drug could you give to stop the release of all those free radicals onto the heart, Tina? Desroxazine, she says with incredible confidence. I'm liking that. I'm liking that. All right, very good. So, cardiovascular disease, number 1. Number 2, amyloidosis. So let's talk about amyloidosis. What the heck is amyloid? Michelle is asking herself. Amyloid is nothing but protein. Amyloid is protein. That's all it is, Tanvi. That means it's not a sugar. That means it's not a fat. It's a protein. Well, Tanvi, anytime you have too much protein floating around in your plasma, isn't there a blood test that could detect that for me? What blood test is that? SED rate or C-reactive protein will be high. I mentioned that in estrogen connection. Anytime you have too many proteins floating around, your SED rate or C-reactive protein will be high. Now, we'll actually discuss what that is in biochemistry next week. Okay? All right. So just in case they want to allude to it by saying, oh, the SED rate is high. Good enough for me. Okay? All right. So anytime you have too many proteins, it could be because you were born with this problem. That's primary amyloidosis. Or because you have some inflammatory disease. That's secondary amyloidosis. Either you were born with this problem where you're making too many proteins, primary amyloidosis, or you have chronic inflammation. And obviously that's the most common. It's rare to have primary amyloidosis. Hey, but wait a minute, Tara. Primary amyloidosis, since you're talking about the structure of the body, how is that going to be inherited? Anything structural is autosomal dominant. That is correct answer. So that means, Frank, if it's autosomal dominant, what's the chance of getting it if one parent has it? 50% if both parents have it. 75%. What if you have that gene, Diana, but you don't even show me the disease? How do I explain that? How can you have an autosomal dominant gene, but you don't show the disease? No, there's an explanation for it. So beat. Reminder. Incomplete or decreased penetrance. You understand? Every time. That's the reason why we keep going through these routines for all the genetic patterns. Once you hear how it's being inherited, folks, you should know the numbers. I've taught you the numbers for every one of them. All right? Again, it's just rehearsal, 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 so that you don't have to change your mind and rethink it anymore. All right, so what if you got different family members with different types of the same disease, Kathia? How do I explain that? No, not for autosomal dominant. We don't use that term in autosomal dominant. No, we don't use that term either. All right, Nicole. If you've got an autosomal dominant disease and you got different family members with the gene, but they have different types of that same disease, we have an explanation for it. Now, she said mosaicism and what's the other one? Heteroplasmy, but that's not the right answer. All right, Kathy, what's the answer? What? Variable expression. Variable expression. And there you guys go, writing it down again. Didn't work the other 5 times we talked about it. What makes you think it's going to work this time now? Is that habit? You guys write everything down 7 times. And then the next time I ask for it, I don't get it. Say it to yourselves. Look at that. You guys crack it up. Because you know it doesn't work, but you still got that habit. You want to do it again. Say it to yourselves. Whenever we're drilling it, say it. Don't write it. Once you write it, the brain says, okay, fine, it's written. I'll look at it later. That's exactly what it says. That means you don't have it in the cortex yet. Say it to yourselves. Remember, auditory and visual memory lasts a lifetime. Start getting the habit of doing that. All right, so primary amyloidosis, how do I know it? I know it because you get the classic clue. Intracerebral hemorrhage in a young person with no history of hypertension or trauma. Why would their blood vessel just explode for no reason? Well, Mark, if you got intracerebral hemorrhage, blood vessel just exploded. What does that tell you about the compliance of the arteries? It's decreased. If you put protein in smooth muscle, it can't stretch anymore. So intracerebral hemorrhage in a young person with no history of hypertension or trauma, amyloid angiopathy is what they call it. That's autosomal dominant amyloidosis, but that's rare. That's rare. Secondary amyloidosis is far more common. That's what you see 9 out of 10 times. It's due to chronic inflammatory diseases. So I put here before you the different types of amyloidosis. the first A stands for amyloidosis. The second letter then tells you what type of protein we're talking about. All right? So AA is the most common. The second A stands for acute phase reactants. That means any chronic inflammatory disease. Any. Tara, name a chronic inflammatory disease for me. What's that? Scleroderma. Tim, name another one. Any chronic inflammatory disease that we've talked about. It's all right. January, name one. That's not chronic inflammatory disease. That's just a complication or a result. Melanie, give me a chronic inflammatory disease that we spoke of. You can say any one you want. You can say asthma, you can say lupus, rheumatoid, Wagner's, good patches. Come on, folks. You know a list, a ton. All right? Okay. So AA is the most, that's the 90% of amyloids, because any chronic inflammatory disease can do it. All right? Even if you got a chronic cold, if it sticks around long enough, you can get it. All right? That acute phase reactants are stimulated, come out of the liver, stimulated by interleukin-6, in case they ask you which cytokine is responsible for it. You have that now. IL-6. All right, so that's AA. AB is for beta or tau protein. Beta or tau protein is seen in what disease, Eros?
That is Parkinson's.
Not Parkinson's.
No.
That's Lewy bodies. I want beta or tau. All right, redeem yourself, son.
That's going to be Alzheimer's.
That's called Alzheimer's. What neurotransmitter is decreased in Alzheimer's patients? Eros.
Dopamine.
Always pick the most common. If you don't know, go back to 90%. It's called acetylcholine. Always remember, ask yourself, what's the 90%? Whenever you're not sure, just go with the 90%. You got nothing to lose. You understand, Fazil? All right, so Fazil remembers, I gave you some drugs that can improve the memory of Alzheimer patients if you give it to them. So you got Parkinson's in my brain now. So Fazil, what drugs do we give Alzheimer patients to improve their memory? Improve their memory. Basil got the oldest stall techniques in the world, man. Now, you know we've all used it. That's why I laugh every time I see it, because I used to use it too. You know, attending to ask you a question, you don't know, so you start repeating the question. So, you know, you say, what drug do we use to treat Alzheimer's patients? A drug, right? All right. And inside of your mind, there's a prayer. Lord, please, help me out. Help me out, help me out. You said a drug to treat Alzheimer's patients, right? All right, come on, Lord, please. I'll be good. I went to church last Sunday. Please help me. You're hoping. Please, Lord, just give me an answer so I get out of this moment. He just keeps repeating. Every time I ask him, he repeats it 3 times. Okay. All right, so beta or tau protein. So we talked about 3 drugs. Again, what were they, Tan B? This is for you to see again. Don't write this down again. It's already in your notes. Just listen to it now. Tan B. Tacrin. Donepezil. And a new one now. Momentin. Now, again, remember visual and auditory. That's why I want you to hear it and see it. I'm not writing it down so you can write it down again. Even though I see you guys sneaking, looking right at me doing this. Man, you guys figured I've been at this a long time now. Plus you use the same old stuff I used to use. Come on now, I'm already hip to all these tricks. Just don't want to get away from that old habit. All right, now one more time. Okay. So anyway, AB2. The B2 is for beta-2 microglobulin. That is supposed to be excreted, Joseph, by the kidney. And that's how I know you got chronic renal failure if you're not excreting it. AB2, beta-2 microglobulin. Supposed to be excreted by the kidney, Rebecca. So if it's deposited all over your body, it means your kidney has failed. You're not excreting it. So chronic renal failure is what it's associated with. Does everybody understand the connection? The kids got to see how things make sense. So that next time they ask you the question, boom, it pops out easier. Okay? AE and AF go with the same disease. MEN2. E is for endocrine because they're endocrine tumors. F is for familial because MEN2 is genetic. AE and AF go with MEN2. E is for endocrine because you got endocrine tumors. F is for familial. All right? AL. L is for light chains. That's multiple myeloma, Linda. AL. L is for light chains. Multiple myeloma. What's the most common light chain? Kappa, lambda, then V. Speak now. Thank you. Direct, I told you, all you got to do is watch the eyes. Once it sparks like that, that's the one I want. Any more hesitation, you're going to talk yourself out of it and give me the other one. Whatever, the one that pops in your head first. Remember, your subconscious is being reprogrammed. It'll zip to the answer so fast, it'll scare you. That's what's when you're first doing it. Now, I already know what's going in your brain because it went through mine. And it used to scare me, too. I'm thinking, wait a minute, let me just make sure. And then I end up picking the wrong answer. Now I don't hesitate to make sure. Whatever pops out, I click. All I know is every time I look back, I got most of them right. Okay? That's what I'm telling you. Stop the hesitation. Once you understand it, don't have to hesitate anymore. All right, that's AL. Thyretrin is the protein produced just by aging alone. So if they give you some 70-year-old and ask you what protein you're going to see all over his body, so there it is, thyretrin. What's the lipoprotein now characteristic of Alzheimer patients, Diana? There's a lipoprotein that I told you was real specific for Alzheimer patients now. Let's see if Manny remembers it. Sakchai remembers it. Sandeep. Mustafa. Shouldn't have moved, man. Shouldn't have moved. Look at me, lost height real fast. All right, what is it? Okay, he doesn't know. Monica. Oh, okay. She got a defense. Nita has no defense, so now you have to answer the question. Yeah, remember E4, apolipoprotein E4. All right, don't forget your clues, folks. You got to drill it. All right, next one, hemochromatosis. In hemochromatosis, you got iron deposition in the way. In hemochromatosis, you have iron deposition in the way. All right, some terms. Anytime you overwhelm the bone marrow with iron, we use the term hemosiderosis. If you just overwhelm the bone marrow, that means it hasn't spilled out to other organs, hemosiderosis. I.e., if you remember, sideroblasts are macrophages just pregnant with iron. Hemosiderosis. That's the term for when the bone marrow is overwhelmed with iron. Okay? When it spills out into other organs, then you use the term hemochromatosis. So I want you to know both levels. Okay? Because if they just describe the bone marrow, you can't use this term. All right? It has to spill out into other organs. So what are the buzzwords they use? Bronze pigmentation means it's all over your skin. Bronze pigmentation. When it gets into the liver, bronze cirrhosis. If it gets into your pancreas, bronze diabetes. Okay, so those are nice buzzwords that let me know. If the bone marrow is full of a lot of iron, you can stain it with something called Prussian blue. So they might just tell you you got Prussian blue deposits in the skin or whatever. Then you know, oh, that's iron. All right? So now, primary and secondary. Primary, you're born with. It is autosomal recessive. Elvis, if it's autosomal recessive, what's the chance of getting it once there's a family history? Basil, what's the chance of getting it once there's a family history? 25%, what's the chance of being a carrier once there's a family history? 2/3. Don't pick that 50. That's the most commonly picked wrong answer. Everybody remember this? The Punnett square for autosomal recessive? All right, got to rehearse these numbers, folks. Every time you see a disease with one of those patterns, the numbers should pop out of your head because the numbers don't change by disease. It's always going to be, for autosomal recessive, 25% chance of getting it, 67% chance of being a carrier. Remember, 3 people are normal and only 2 carry the gene, 2 out of 3. Okay? If you don't have a family history, I say use Hardy-Weinberg equation. That means they have to give you the incidence of the disease. That's Q squared. Then you start from there.
Can you do one of those just one more time, the Hardy-Weinberg?
All right.
Just make up a number.
All right, let me see. Let me get some room over here. All right, so Hardy-Weinberg says P squared plus 2PQ plus Q squared equals 1. These are all the combinations from autosomal recessive. P squared is big A, 2PQ is 2 people who are A, big A, small a, and this is small a, small a.
Okay, so let's say that...
No, I'm going to go through the whole thing for you. First of all, everybody understand this part? All right. They can always give me this one. That means you go out to the population, count how many people have the disease. That's it. So they will give you 1 in 2,500. They say, okay, there it is. That's the incidence of the disease in the general population. If 1 in 2,500 equals Q squared, then all you got to do is take the square root of it to figure out the frequency of the gene, Q. What would that be? 1 in 50. So that means Q equals 1 in 50. Well, carrier is 2 times that, 2Q. So you just put 2 over 50, which is 1 over 25. So that's the incidence of the carrier. That's how you use Hardy-Weinberg equation. P would be 49 over 50, so that's 1. Yeah, close enough to 1. That's why they just ignore it. Yep. All right, so again, that's how you use Hardy-Weinberg equation. All right, let's just finish this side. So hemochromatosis primary is autosomal recessive. HLA-A3 is a marker for it, so that's a nice clue. HLA-A3 is a marker for primary hemochromatosis. The problem in primary hemochromatosis, Monica, is that you're absorbing way too much iron. From what part of the GI tract? Where do you absorb 90% of your iron from? No, Nita. Where's that? Remember, duodenum. 90% of everything, Monica, you say jejunum. Don't even go to helium. Unless you're talking about fat soluble vitamins. ADEC, A, D, E, K, and then B12. Otherwise, leave the helium alone. Jejunum does 90% of everything. Except when you're talking about iron, then it's duodenum. Everybody remember this. You just did this yesterday in GI. Okay? Very important. That means if ever in doubt for GI, just say jejunum. I'll give you a point just for that, even if you're wrong. Because you're going to be right 9 out of 10 times. Always ask yourself, what's the 90% answer whenever you don't know? Don't just guess. A guess is just wild when it doesn't have anything to connect to. All right, so that's primary hemochromatosis. You and I absorb maximum about 9% of the iron that you eat. That's it. That's why you have to eat so much iron, folks. 9%. Well, in primary hemochromatosis, they absorb maybe 30 or 40%. That's too much. And that's why it becomes a problem. All right, secondary hemochromatosis comes from too many blood transfusions. So when we start doing transfusions next week, then we'll be talking about all of this stuff again. Okay? If you have too much iron and you want to bind up specifically iron, we have a drug called deferoxamine. If you look in the middle of the word, you'll see iron. So you don't forget it. Deferoxamine. Yes, ma'am.
Should you have those people not eating vitamin C since vitamin C helps iron absorb?
Yeah, you probably cut down the amount of vitamin C they're taking. Just this way, they should only take their recommended daily allowance, and that's it. Yes, that means if they drink too much juice, it'll just exacerbate hemochromatosis. Good connection, though. Constrictive cardiomyopathy comes from tamponade or pneumothorax. Tamponade, number 1, pneumothorax, number 2. Now, we talked about pneumothorax before, so that means I got to tell you about how to manage a tamponade. Well, Bhargav, when are you likely to get a tamponade? When you get stabbed on the right or the left? On the left. Everybody understand? Which ventricle usually gets punctured, Bhargav? The right ventricle. Remember, it's anterior. All right, so that means if they get somebody who got stabbed on the left and all of a sudden they got pulsus paradoxicus and Kussmaul sign, boom, I got to rule out tamponade first. Does everybody understand that? Okay. How do you rule out tamponade? Quickly, what we do is we listen to both sides of the chest. If both sides of the chest, breath sounds are equal, it has to be tamponade because it's either tamponade or pneumothorax, one or two. So a quick exam. Breast sounds equal. Breast sounds okay. Boom. I stab him with a needle. You get a large gauge needle, like a 20 gauge needle. That means it's got a big opening. You put it right underneath the xiphoid, aim for your left shoulder. You go right through the apex into the ventricle. All right? Pericardiocentesis is how you do it in case you want to save a life one day, folks. Remember, people are going to be panicking all over the place. You say, hey, give me a 20 gauge needle. That's all you do. We ain't even got time to numb them up. Just stab. The guy's going to die if you don't. All right? Put right underneath the xiphoid, aim for the left shoulder. It goes right into the pericardium. Okay? Now, here's the problem that you have. Acutely, when somebody got stabbed, I know that's fresh blood in the pericardium. Does that make sense to everybody? That means what we do is when the blood first flashes, we always take it out, take the syringe out, and squirt it on the gauze, and it should not clot. Fresh blood should not clot. Does that make sense to everyone? Okay. All you want to do is let enough blood come out until you see their pulse and blood pressure come back. Remember, that's their blood. Okay. The reason for that knowledge is you can get tamponade in the setting of pericarditis. If somebody has pericarditis, inflammation, itis, there's going to be fibrin deposition in that pericardium, which means when I get my needle in there and the blood comes back, it should clot. So they started out with a patient with pericarditis. When I squirt the blood on the gauze, it should clot. That's how I know I'm in the pericardium. That should not be fresh blood. Does everybody understand that? All right? Because let's say you don't know the difference in what I just said. You just put the needle in there and blood starts coming out. You're like, dang, man, he had about 8 liters in there. Holy cow. As your patient turns pure white and dies right in front of you. All right, you forgot that's his blood. You were just letting squirt out. You want the one in the pericardium, not the one in the ventricle. That's how you know in pericarditis whether you're in the ventricle or in the pericardium. The pericardial blood will clot because there's fibrin in there. The one in the ventricle should not clot. And somebody with a fresh stab wound, well, that's their blood. It's not going to clot. We just let enough blood out to let their pulse and blood pressure come back, and then taking the surgery. Because remember, they got a hole in their heart. You need to sew it up. Okay? Anytime you have recurrent tamponade, pericardial tamponade, you take them to surgery again and do what we call a pericardial window. Cut a hole in the pericardium. That way, any blood that comes out just drips down to the pelvis, where it cannot kill you. It'll cause a lot of scarring, but that's all right. You're still alive. Okay? So tamponade. Kussmaul sign. Rashmi, describe that for me. All right. So when does it back up from the right atrium? When you breathe in or when you breathe out? When you breathe in, that's Kussmaul sign. Because normally when you breathe in, blood should flow into your chest, right? Everybody remember that physio, right? Well, if it backs up, that means there's too much pressure in there. It won't let it come in. And then JVD with inspiration, Kussmaul sign. And then you see it reflected on the left side when you do a blood pressure cuff or pulse, you see an exaggerated drop when they breathe in. That means it's not getting to the left side either. Okay? That's pulsus paradoxicus. Remember, normal is 5 to 10, so they'll just tell you, oh, it's 17 or 18. Okay? Most common cause is trauma, which is what I just described, usually a stab wound. And second is cancer, metastasis. You understand, Ajay? You understand, Matt? Bartholin? All right, Diana, you understand so far? Cool. Now, to look at effusions, because we looked at it before. Remember, we looked at a filtration equation. Remember this? Filtration forces. I said there are 2 forces for minus 2 forces against, and that equals filtration force. Right? Elvis? All right. Look at the equation again, Elvis. The 2 forces for, because you got to be able to recreate this equation anytime I ask you. You got to be able to picture it in your mind. For filtration will be the fluid in the vessel. It's just moving down the gradient. Plus protein outside the vessel, pulling it out of the vessel. Does that make sense to you, Elvis? So that means next week when I ask you about this equation, you can recreate it, right? You got to be able to see it in here now. Okay. The 2 forces against. Protein inside the vessel holds on to water, and water outside the vessel will oppose any more water coming out. You can't go up a gradient, you got to go down a gradient. All right. That means whenever you got a collection of fluids, you got to figure out, is it mostly water, transitate, or mostly protein, exudate? How are you going to know which one it is, Rebecca? Let's say you come to see me as a patient, and I do an x-ray and I see a large pleural effusion. I ask myself, boy, is that an exudate or a transudate? How do I know which one it is? How am I going to know if there's any protein in it? Miguel, tell her. You got to tap it every time, Rebecca. You understand? So if they ask you what's the next thing you got to do, you always got to tap it because you don't know what it is until you tap it. Now, the two most specific labs. I'm into specific for Nima because I like to click and move. After I click, what do you got to do, Pernima? You got to move, man. Not click and stick and then start thinking about all this other stuff and then change your answer. Click and move, man. All right. So, anytime. So that means you got to do a tap and then look at the two most specific labs. Specific gravity, the cutoff is 10, 12. Less than that, transudate. More than that, too much protein, exudate. And then protein, less than 2 grams, transudate. More than 2 grams, exudate. You understand, Rebecca? All right. So now, if I got a transudate, Rebecca, you say, well, if I got a collection of fluid outside a vessel, and it's mostly fluid, there's only 2 ways it could have gotten there. What are these 2 ways? Based on your knowledge of physiology. You got a collection of fluid, and it's mostly water. That means don't give me an explanation. If I hear the word protein, I'm going to stop you. That can't be it. Okay? Not protein outside anyway. So go ahead, Rebecca. Increase hydrostatic pressure in the vessel or? No, not coming back in. I want it outside. How do I explain water outside of a vessel? The best one is too much water inside the vessel or? No, osmotic means you got protein outside the vessel. I don't want protein. This is mostly water. You got to explain to me the 2 ways water can get outside the vessel without including protein outside the vessel. So 1, there's hydrostatic pressure too high in the vessel. Everybody understand that one, right? Too much water inside, moves out. The second one, Kathia.
It's that there's not enough hydrostatic pressure.
Not enough oncotic in the vessel. In the vessel. You understand, Rebecca? Either you have too much water in here or not enough protein to hold on to it. You understand? Rebecca, give me 2 reasons why you have too much water in your vessel. All right, let me show you how to talk it through. If you tell me there's too much water outside of a vessel, it's mostly water, I explain to you either you have too much water in the vessel or not enough protein inside the vessel to hold on to it. Everybody understand that part, right? Then you ask yourself, well, why would you have too much water inside the vessel? Number 1, you're not pumping it forward. It's called heart failure, the number 1 answer. Number 2, you're not peeing it out. That means you're pumping it forward, but the kidney can't get rid of it. Renal failure, that's number 2. Or you don't have enough protein inside the vessel, then Tony just has to figure out why would you not have enough protein in your vessel? Maybe, Tony, you're not eating enough of it. Do you know the term for that? Protein malnutrition has a special word called kwashiorkor. Or maybe you're not making enough of it, that's called cirrhosis. Or maybe you're just peeing it out too fast, that's called nephrosis. Or maybe you're oozing it out of your GI tract, that's called Menetrier's disease. That's how I talk it out. Mark. It's possible, but most of the time it gives you an exudate because fluid and protein leaks out. Yeah. All right, so that's a transudate. Now, what if I got an ex? Yes, ma'am. Can I repeat what? No, you got to talk it out with me. I mean, it only makes sense if you say it. And Dr. Pence can say it 7 more times, and then what? It's only you say it once, now you know it. All right, you understand the part? If you have a transudate, either you have too much water in the vessel, so it oozes down a gradient, or not enough protein inside to hold on to it, so the water leaks out. Remember, you need protein inside a vessel to hold on to the water.
It can be too much protein outside so water goes out.
Yeah, but that would be an exudate now. You just change things. I got fluid outside the vessel, but it's mostly water. That means it can't be due to protein outside pulling it out. That would be an exudate.
So it would be too much
Water
inside.
inside the vessel, or
No protein.
not enough protein to hold on to it inside. Yeah, those two will make water move out. And then all we do is just figure out the reasons for for having too much water in your vessel. Heart failure, you're not pumping it forward. Renal failure, you're not peeing it out. And then here are the reasons why you don't have enough protein. Yep. All right, now if you got an exudate outside, Diana, what's an exudate mean? No. What does an exudate mean to you? What's the term exudate mean? Manny, what does it mean? Too much protein pulling water out. Oh, you got a collection of fluid, but there's mostly protein in there. That means the protein started this whole thing. No, but you were explaining it. That's not what I was asking. I'll say first define your problem. Because I want to show you how if you define your problem, it then goes right into explanations for it. Okay? It's too much protein outside. So you started with an explanation about inside. The better answer is too much protein outside. All right, so Kimberly, if you got too much protein outside, all you got to do is just look at what the heck is that protein out there? Wait a minute, I haven't said a word yet. I'm trying to lead you to the answer. All right, so anytime you got an exudate, the first thing you got to figure out, what is that protein out there that's pulling water? Does everybody understand my reasoning so far? I want to show you how to talk things through so that you come up with your differential anytime you want. All you got to do, Kimberly, is look out there and it looks purulent. What's out there? Thank you. It's bacteria. Kimberly, I look out there and it's granulomatous. What does that mean? Anything but. Means anything but bacteria. Same thing when you did necrosis. See, you already know the information, folks. You just got to know how to pull it forward. What is the protein out there? They say purulent, it's a bacteria. Granulomatous, non-bacterial. Fibrinous, cardiovascular disease, uremia, TB. Caseous, well, there's TB out there now. Hemorrhagic, trauma, cancer. That's how you figure it out. This way you don't have to memorize and just keep memorizing a bunch of lists. A bunch of lists make no sense. But the test writer will always keep changing the protein out there. That's all he can do. That's all he can do. He can't make something up. It has to be some protein out there if you say it's an exudate. He will give you a hint at what protein's out there, then you got to figure it out. That means if he makes it purulent, then you got to pick a bacteria, and then you look at the list. They got a virus, a bacteria, 2 fungi, a parasite. But if you didn't know, you wouldn't know. He already gave you the answer. He rewards you if you know how to think things through. If you don't, you look at all 5 things on the list, and that's what gets you all confused. You're trying to figure out what a parasite could have done it. Well, he didn't give you a hint at a parasite. So who cares if a parasite could do it? Everybody understand? Okay. That's an infusion. So that's your filtration equation. And here's your congenital heart diseases. Kathy raised her hand. That means she wants to volunteer.
No.
Yeah, that's what she said. Yeah, she wants to volunteer. She got a question for me first, though.
With the exudate, that means that you have increased protein in the interstitium.
Yes.
But you could also have increased hydrostatic pressure in the interstitium.
No.
No?
You have a collection of fluid, but it's mostly protein in there.
But if you have the increase in the hydrostatic fluid in the interstitium, it'd pull water into the blood vessels, so it would look like you have no protein.
But you would never have an excess, though, out here. Yeah, your body never overcompensates, just shifts too much over here. Remember, once you have a gradient, once the gradient is 50-50, it stops. So you'll never have an excess over here.
So the only cause of exudate is increase in clotting from the interstitium?
The only cause of an exudate has to be increased oncotic outside. Yeah, interstitial. Yeah, that's it, folks. That's what I mean by you got to know the main concepts and clues, because the test writer cannot change the truth. He can only change the names and items and details forever and ever. That's why if you just read first aid, if you just read Robbins, all you know is one or two details. Test writer's got another one when you get to the exam. But you don't see that's just another protein. Can't change that part. All right? Everybody understand that? All right, so here, the 4 most congenital heart diseases in order. All right, 7 clues for $10. Who wants to do it? You've heard them before. Don't get your pens all ready to write anything down. This is stuff you already know. Now I'm going to give you the clues. You tell me which one I'm talking about. PJ, 7 clues for $10. Ready? All right, holosystolic murmur. VSD. Fixed white splitting of S2. ASD. Let's see, Turner syndrome, coarctation, non-disjunction, coarctation, cystic hygroma, coarctation, rib notching, coarctation, decrease the AVO2 difference. Well, you know, the last one got to be a little rough on it, huh? PJ the man, baby! Yeah! That's all you collect after class. Good job. Remember, PDA is the same thing as an AVM. Remember, decreased AVO2 difference? You're shunting the oxygen away from the tissues. They never got it. All right? Very good. So VSD, we've talked about all of these. VSD, holosystolic murmur, you got a left to right shunt. ASD, fixed white splitting of S2. What's the most common cause of an ASD? Sakchai? Septum primum, septum secundum defect. No, premier. Remember, primum is supposed to come down from the top and fuse with the endocardial cushion. All right, PDA, remember a connection between the artery and vein always gives you a continuous to-fro or machinery murmur, however they want to describe it. PDA. And then coarctation, differential pulses or cyanosis, rib notching, all right, and then classically seen in Turner syndrome. All right, any questions on these? We've done them all. All right. Now, if they don't use the word cyanotic, don't you bring it up. This list you're looking at are the cyanotic heart diseases. If they don't say the child is cyanotic, you can't be picking any of these. Does everybody understand me? The cyanotic heart diseases are rare compared to these 4. There's no way you're going to say these are part of, common congenital heart diseases. Okay? If they don't use the word cyanotic, don't come to this list. Whenever they say the word cyanotic, you start with the 5 T's. That's what every book teaches you about. Well, when I finally understood that a cyanotic heart disease merely means you have a right to left shunt, I realized it's 5 T's plus 4. That's what I mean. If all you know is what the book said, folks, you don't know enough yet. Test writer got another one in the book never mentioned. You got to always go back to the beginning. What does it really mean to be cyanotic? You have a right to left shunt. That means blue blood is going to the left and going out to your body. All right. If a child is born cyanotic, that means he has a right to left shunt. You can't let his left to right shunt close up. So that means, Cam, if they ask you, how did this baby survive in utero? That's because he has a left to right shunt that corrected it. Does everybody understand what I just said? Cammy, what is that left to right shunt called? That every baby has? It's called a PDA. So every cyanotic heart disease that you see on this list, a lot of times they'll say ductal dependent. That's what they mean. Patent ductus. It has to be open. And that's why within the first 48 hours, as soon as that PDA closes, Ferdy, the baby turns blue. You need to know you better open that PDA back up if the child's going to survive. Because if you got a right to left shunt, Cam, and you give them oxygen, what happens to their PO2? It does not change by 1 bit because you're shunting right to left. So what? Give them all the oxygen you want. They'll still die while you're busy trying to give them more oxygen. All right? So that's why you need to know. Alprostadil is pure prostaglandin E2 that's vasodilatory only. Now, I put both up here, misoprostol that you saw in GI. Misoprostol is PGE as well, but some of it is vasoconstriction, some of it causes vasodilation. You don't want that. Remember, in GI, you learned the misoprostol, if you're going to use it, you're supposed to do a pregnancy test first. Because if the vasoconstriction happens and she's pregnant, she's going to lose that baby. Well, I don't want the part that causes vasoconstriction, so somebody figured out a way to separate them out. And came out with pure vasodilatory PGE called alprostadil. So PDA, if you want to keep it open, you've got to give them alprostadil right away, and then they'll pick up the oxygen. Okay, and then you have time to take them to surgery. All right, so who are they? The most common one we already talked about, transposition of the great arteries. Remember we said every baby starts out with a transposition? That means if you're born early, you're stuck with it. Right, Diana? All right. So transposition of great arteries. Then I said, well, you got to do a switch procedure. You got to switch the aorta to the left, pulmonary to the right. 2 major open heart surgeries on a baby, not good. Half died during the first procedure. Half of what's left died in the second procedure. So now only 25% are remaining. And that's why after a month, tetralogy of Fallot becomes the most common cyanotic heart disease. So that means so be. If they ask you, the most common cyanotic heart disease in an infant, which one are you going to pick? Tetralogy of Fallot. Remember, infant is 1 month to 12 months. That's the part that students keep missing on the question. They forget the age of the child and then they go pick the wrong one. If they say newborn, you say transposition. Anytime after a month, the answer is tetralogy. So I don't even care how that child presented with cyanosis. The answer is still the same. That's my point. If you get too much into the story, you'll forget that. Now you're so busy trying to figure out why this baby turned blue at 3 years of age. Instead of remembering, it's still the same one after a month. Okay? Tetralogy of Fallot means they got 4 things. Faisal, tell me the 4 things. No, the other one. No, so you're right. You're right. Overriding aorta. I almost messed up. So overriding aorta, which then encroaches on the pulmonary artery. So then you get, well, pulmonary stenosis, not pulmonary hypertension, now pulmonary stenosis. No. Stenosis can't be a volume overload. So overriding aorta, think of a cause and effect. Overriding aorta, which pushes on the pulmonary valve, which causes pulmonary stenosis. If you have stenosis, that's a resistance problem, which leads to RVH. And if the right ventricle has higher pressure, it now shunts right to left through the VSD. And that way, so it won't close. Those are 4 things. Pinish, which of those 4 items determines the prognosis in tetralogy of Fallot? Nope. Matt. The pulmonary stenosis. Because that determines how much blood gets to the lungs to be oxygenated, Binish. That's how you make sense of it. All right. Remember, if they have mild pulmonary stenosis, you may not even know they have tetralogy of Fallot, Paul, unless mom calls you with 2 things that could have happened to that child. Tetralogy spells. What are they again? Baby turns blue when he does what? Not breastfeeding. That's choanal atresia. He turns blue when he's doing something. Jennifer. For tetralogy of Fallot, mild tetralogy. Tet spells. The baby turns blue when he's doing what? When he's what? When he's crying. When he cries, Paul, remember, you're exhaling. Pulmonary hypertension develops. So then they start shunting right to left through their VSD. That's why they turn blue when they're crying. And then they pink right up once they stop crying. Because it goes back to a left to right shunt again. Okay? And then the second one, Jenny, was when he's running around with his friends, what does he do? He squats. He's trying to create resistance for the aorta so that you shunt left to right through the PDA. You dump more blood into the lungs to be oxygenated. Okay? The child just figured that out by accident. It just happened one day. He squatted. Oh, burst of oxygen came out. He felt so good. Now he does it all the time. All right, so that's the tetralogy of Fallot. Tricuspid atresia means you have no tricuspid valve, Janice. Tricuspid atresia, Janice, means you have no tricuspid valve. That means there's a piece of tissue just covering it up like that. All right, everybody follow. She's got tricuspid atresia. Is that going to affect my S1 or S2? Janice, tricuspid atresia affects S1 or S2? I can't hear you. Where does the tricuspid make a sound, Janice? Always go back to the physiology or else the mind just starts guessing things. S1, remember S1 is mitral tricuspid. S2, aortic pulmonary. So that means if I ask you about tricuspid or mitral, aortic pulmonary, you just know where it's going to affect. Everybody understand that? That means don't just guess it. Go back to the physio and figure it out right there. All right, so it's going to affect S1. It's going to make S1 louder or softer if there's no tricuspid valve. Softer because there's nothing to close. Hey, what's going to happen to my CVP if the blood can't leave the right atrium? Rise or fall? It'll rise. All right, if you answer a question out of context, you got no chance of being right. Don't forget what you started out with when you answer the question. That's why I always say read the question first so that you know your context. That way I know what to pull out of my vignette while I'm reading. I ignore the rest. If it has nothing to do with the question, I don't want to know. Okay? So tricuspid atresia means you have nothing there. No blood entering the right ventricle. So the volume in the right ventricle decreases. So what happens to pulmonary blood flow? Janice. Decreases. What happens to S2 splitting? Janice. Wide or narrow? Narrow. In fact, it's probably not even existent, is it? All right. All right. What happens to my pulmonary capillary wedge pressure? Janice. Decrease. Remember, that's volume in the lungs. Well, it's not getting there now, is it? You better understand. All right. So what's going to happen to your right atrium? Hypertrophy or dilate? All right. So it's going to dilate. What part of EKG trace will pick that up? The P wave will change how? Increase. Height. What about width? You got a dilated heart. That's correct. It's going to taller, wider. She's all over it. What if you want to be sure that's the right atrium you're looking at? What lead you're going to look for? Which one? AVR or which is the best one? Which one? V1 is right over the right atrium. He's the best one. So AVR or V1, but V1 is the best one to look at. You understand that? Look at that, man. You guys already know everything about these. But now, let me warn you. On the board, Janice. Now, you just went through all the physical findings for this patient without my telling you. All right, so maybe twice I had to tell you. But that's okay. She told me everything else. On the exam, they'll tell you the physical exam. And then at the end of that vignette, you better know it's tricuspid atresia. That's the difference. Right now, I'm forcing you to tell me the whole physical finding to let you know you already have all the parts in your head. But on the exam, when they give you a physical exam, don't start guessing. So here's what I do. The minute they say, okay, you got a newborn baby and he's born with a soft S1, I say, oh, soft S1. That means either he doesn't have a valve or it's regurgitant. Then they don't mention anything about a murmur. I said, good. That means he doesn't have a valve. Because regurgitant should give you a murmur. Everybody follow? All right. Then that means all you got to do is figure out tricuspid atresia, mitral atresia. Okay? That means all they do is give me one more clue. JBD's way up here. Tricuspid atresia. I'm done. Next question. All right? Once you know your answer, get out. That's all they ask you. What heart disease does this child have? Okay? But do one step at a time. Every time they tell you some physical finding, acknowledge what it means. I told you I see students just reading the whole paragraph. No thinking at all till the end. And now you're trying to put all that together? Good luck. You can't hold all that paragraph in your head and then put it together at one time. Put it together as you go. That way you already know what it is. Before you even get down to the bottom, you already know what it is. All right, total anomalous pulmonary venous return means the pulmonary veins all come right back to the right atrium, which means it's never getting to the left side. That's why they're blue. How am I going to know this patient? Well, look what happens. Pulmonary veins go around in a circle, come back to the right atrium. And the blood just keeps recirculating. So much blood keeps going around in a circle, you can actually see that circle on an x-ray. And then the heart's right beneath that. So it looks like the figure 8 sign on an x-ray. Or they'll call that snowman sign. Remember, big body, small body? All right, so figure 8 sign or snowman sign on an x-ray, TAPVR. Obviously, they don't live, folks. That's why you only see them in the neonatal period, when they're first born and they die shortly after. Dahlia. Tricuspid atresia what? Well, we do surgery on those people. They live maybe a couple of years. Well, what you do is, for those people, since blood never got into the right ventricle, leave the right ventricle alone, okay? What you do is cut a big hole in the atrium, let blood go from the right atrium and just go right into the pulmonary artery. They cut a hole so it connects right into the pulmonary artery. Remember, pressure's so low on the right side anyway, so it just come in, go in the pulmonary artery, and therefore then comes back around and use the left ventricle as the only functional ventricle. Yeah, they live like that for a while. And then later they die. Yep. Yes, sir. Pulmonary veins go around in a circle and come right back to the right atrium. They never make it to the left side. So you got blood just flowing around in a circle. Okay?
The circle is on the right side only.
Yeah, on the right side only. It never makes it to the left side. Yep. Truncus arteriosus means the pulmonary and the aorta are still one big trunk. Remember the spiral artery is supposed to separate them, Janice, but it didn't do that. So Tatiana, if your spiral artery does not separate the pulmonary from the aorta, you only have one trunk. That means one big valve. You understand that? Is that going to affect your S1 or your S2, Tatiana? S2, how do you know that? You hesitated. No. I said, how do you know it's going to affect S2? What makes the sound of S2, Tatiana? What makes the sound of S2? So what makes the sound of S2, Tatiana? Aortic and pulmonary valve what? Opening or closing? Closing. And I'm telling you, that means anytime I mention aortic or pulmonary, it has to be S2. You understand? Everybody understand this now? Because you guys hesitate too much. That means you don't have that pattern down in your head. If they ask you something about aortic or pulmonary, S2. Anything that has to do with tricuspid mitral, S1. It's automatic. This way you don't have to rethink it. Every time we get to a new disease that affects one of those valves, boom, that's where you start. I always start there and then say what's going to happen down the line as we go on. Ajay? Spiral membrane is supposed to separate aorta from pulmonary. So they have two vessels. It never developed. Yeah, so you just got one trunk now. Truncus arteriosus. So now you'll see a singular. You'll hear a singular S2. There's just one big valve there. It's not two valves. Yes. No, spiral membrane never migrated down. It never even migrated. Yeah, it's not that the membrane didn't obliterate. It never migrated into that area. All right, so that's truncus arteriosus. Pulmonary atresia, pulmonary valve never developed. If that's true, Jessica, is that going to affect your S1 or S2? Make it louder or softer? Right, because the valve is not there. All right, so far we got S2 be affected. It's going to be softer. How's that? What's going to happen to pulmonary blood flow? Rise or fall? It'll decrease. If it decreases, what happens to S2 splitting? Wide or narrow? I hate S2 splitting. Don't worry, before you leave here, you will love S2 splitting. It would narrow. Remember, the splitting is based on flow into the lungs. If you're telling me they can't flow in the lungs, S2 splitting won't even happen. You understand now? What's going to happen to my pulmonary capillary wedge pressure? Rise or fall? Fall, because it's based on volume again. You understand? All right. Is this a resistance or volume problem? Dilation or hypertrophy? Dilation of the right ventricle causes S3 or an S4. Well, which ventricle is going to dilate? If you have pulmonary atresia. Okay, then that must be the same one I'm talking about. All right, so dilation of the right ventricle leads to an S3 or an S4. S3. Would that S3 get louder when you breathe in and when you breathe out? Right side is when you breathe in. What's going to happen to your CVP, rise or fall? Central venous pressure. Volume sitting outside the right atrium. You can't even get out of the right ventricle. How's it going to fall? Everything's just going to back up, right? So CVP will rise. This thing, yeah, that thing. Yeah, that thing. Hey, wait a minute. If you got a dilated right ventricle, what part of EKG trace will pick that up for you? What part of EKG trace will pick that up for you? Huh? Right ventricle? The QRS will change how? Tell me about the height. It'll be taller. What about the width? It'll be wider. If you want to be sure that's the right ventricle, what lead are you going to check it out on? Just tell me what lead you're thinking about right now. Y'all better get off me, man. What do I keep telling you? The first thing that pops in your head is the answer, but you guys always think, oh, no, it ain't. I've never had a month where any group has convinced me that second answer you guys keep popping out is better. Every time I say, what's in your head right now? Out comes the right answer. But it was a hesitation, see? The problem is I'm not going to be there on the day of the exam to tell you that you better spit it out right now. Although a lot of students tell me after a while, they say, man, I heard your voice, Dr. Francis. I heard your voice during the exam. Click and move, click and move, click and move. I'm telling you, whatever you think, click and move. That's the one. Don't worry about it. All right, aortic atresia will be the same thing that she just told me, except it's just aortic that's doing it now. Hypoplastic left heart means your left ventricle is too small. How do you know that? The baby's heart rate is so fast because there's hardly anything coming out. What's the maximum heart rate for a newborn baby? January. No, not 160. Tim, thank you. All right, you went back to that physio. That's what I'm talking about. No guessing. Go back to the physio. 220 minus your age in years. It's a newborn. Should be 220. So they'll usually give you a heart rate like 170, 180, 190. So it's way above normal. So that's how I know hypoplastic left heart. Okay? Epstein's anomaly. Diana. Epstein's anomaly. Watch carefully. Here is the tricuspid valve. Up here, right atrium. Down here, right ventricle. You understand? Tricuspid valve should be right here in the middle to separate the two chambers. Are you with me? Well, in Epstein's anomaly, tricuspid valve forms way down here in the right ventricle. That means if it's not here in the middle, it can't slide into the slots where it should be, so to speak. That means it's just sitting down here. If it's sitting down here and it can't slide into the slots where it's supposed to be, is it going to be stenotic or regurgitant? It's going to be regurgitant. Is this going to affect my S1 or my S2? It's going to affect my S1. Is it going to make it louder or softer? Softer. Is this a volume or a resistance problem? Volume problem is going to lead to dilation or hypertrophy. Dilation that leads to an S3 or an S4. An S3 that will get louder when you breathe in or breathe out. Breathe in because we're on the right side. What happens to my CVP? Rise or fall? No, regurg goes both directions. A lot of students forget that. So it's going to push everything back and do this. So it's going to rise as well. All right, what happens to the volume in the right ventricle? It'll decrease. What happens to S2 splitting? Wide or narrow? Narrow. What happens to pulmonary blood flow? Decrease. What happens to pulmonary capillary wedge pressure? Decrease. Oh, I think we already know everything about Epstein's anomaly. Final thing, however, Cammie, what drug is the mom on that could have caused this? Oh, shoot, she says. That means you got to make one final connection for me, because that's usually what they're asking at the end of the whole thing. What drug is this mom on? Oh, they'll tell you, or they'll ask you, what diagnosis does the mom have? So now you got to take it one more level after that. She has bipolar, and she's on what drug? She's on lithium. All right, see that? All of a sudden, now we can figure out any heart disease, the whole physical exam, folks. But you got to try this on your own. That means have somebody just drill you on any of them. You don't know that you know, but I know you know. But somebody's got to challenge you and force you to answer the question. Then you'll get comfortable with it. Yes? Mitochondria is so rare that they don't even put it up here. Yeah. For which one now? Yeah, drunkenness arteriosus. Neurocrest cells didn't migrate to the right place? Right, correct. All right? Yes.
With the Epstein's anomaly, the reason for the regurg is because it's...
Yeah, it's not in its rightful spot to be held in tightly. It's just flipping up and down. There's nothing to hold it down. Yeah. All right, most common valvular diseases, most common causes of a valvular disease. Remember I told you I'm about the 90%. We can figure out signs and symptoms for any valvular disease. We can figure out the murmur. We know how to make it louder. We got all that down. But here's the 90% when they ask you, what's the likely cause for this patient's problem? That means unless you know something else, folks, you better be picking this answer right here. All right, aortic stenosis is aging. That's from calcification. Sandeep, is that dystrophic or metastatic calcification? Dystrophic, just with aging process. Okay, you're going to hear a lot of it. Aortic regurg, still aging. Because every now and then the calcium gets so heavy on the valve starts to fall in like that. So calcification both causes stenosis and regurg. You'll be hearing quite a bit of it in elderly people. Okay? Mitral stenosis, rheumatic fever is number one. Still the number one cause of mitral stenosis. For mitral regurg, mitral valve prolapse. Brendan, what's the classic finding on exam for mitral valve prolapse? Physical exam. So mid-systolic click. Very good. So mitral valve prolapse. Remember, estrogen connection. That means for a while it was doing this, buckling. After a while, it can't even hold it anymore. Then you get regurg. Estrogen connection just keeps weakening and weakening everything. So mitral valve prolapse is number one. SBE is number two. Brendan, what bacteria causes SBE? No, Staph aureus is for tricuspid valve. That's acute endocarditis. SBE is mitral valve. Strep viridans. Remember, then you got antibodies on top of the strep, and then you flick off septic emboli. FASO, septic emboli to the brain. What was the name for that? Linda, septic emboli to the brain. All right, let's try Binish, septic emboli to the brain. All right, Malika, septic emboli to the brain. All right, Chukuma, septic emboli to the brain. All right, Paul, septic emboli to the brain. Well, it can cause a stroke, but that's not what it's called. May, septic emboli to the brain. We have a name for it. What? No. That's when a DVT causes a stroke. Jennifer, septic emboli from endocarditis to the brain. We have a name for it. Mycotic aneurysms. In the retina, Jennifer, we have a name for it. Raw spots. Underneath the nail beds, we have a name for it. Jennifer. No, splinter hemorrhages on the nail beds. If they're in the fingers and painful dahlia, then we call them Osler's nodes. If they're non-painful, Janeway lesions. Remember, Janeway lesions are not immune complexes. All right, so after SBE, then collagen diseases. So Marfan's, Ehlers-Danlos, scurvy, all of them got messed up valves too. Tricuspid stenosis, most common cause, rheumatic fever, followed by carcinoid syndrome. In carcinoid syndrome, Diana, what neurotransmitter is being released? You know? That's all right. No, at least you get to 90%. Cammie, what neurotransmitter? Carcinoid syndrome. Serotonin. Serotonin is made from what amino acid, Tamir? Tryptophan, and the breakdown product of serotonin, Nicole. Kathia. Now, VMA and goes with norepinephrine and epinephrine. I went for serotonin. That's all right. Rashmi. 5-HIAA. All right. Tricuspid regurg. acute endocarditis, Brendan, caused by Staph aureus. Here's where it affects. And it's almost always a IV drug abuser. Why do they want you to know that? Because you need to confront the patient about it. Because they don't know how dangerous playing around like that is. You know, I don't know if you guys knew, the use of heroin on the streets is back on the rise again. A lot of teenagers experiment with heroin. They think it's not a big deal. They got all these drug parties that they go to now. I don't know if you guys have seen some of the ads. It's ridiculous what teenagers are doing these days. They're playing with that's why you hear about them dying all the time. Okay? So, acute endocarditis, IV drug abuse. If you confront them the first time, they always deny it. So that means on the boards, even when they say patient denies IV drug use, that's just a smokescreen, folks. They always deny it when you first ask them. And then you come back and ask them again. Well, you know, Mr. Johns, I don't mean to offend you or anything, but almost every time we see endocarditis or tricuspid valve due to Staph aureus, that person's been using needles. So I just have to ask you one more time. Have you ever used IV needles for any drug use? Well, there was that one time. It's always one time. It's always one time. I'm telling you, I think I've had like 2 or 3 of them. Every time I confront them, one time. Everybody else says, oh, okay, it was one time. Yeah. But yesterday when I asked you, it was never. You actually looked insulted by it. But today now is one time. Well, the key is if you don't approach them, folks, they won't know. This is a very dangerous thing to do. I mean, I've had a couple of teenagers come in cocaine. You know, one of the quickest ways, one of the most common ways that teenagers are picking up, or young adults picking up HIV these days, you know what it is? They wrap up a $100 bill and they snort cocaine with it. The first guy had blood leaking from his nose, and it's on the tip of the $100 bill. Yeah, I just read that in an article a few months ago. I was like, holy cow. I never even thought about that. And that's what a lot of teenagers don't think about that. They just think, oh, you know, just sharing a $100 bill. You're not supposed to catch AIDS this way. They forget it's about the blood. It doesn't matter if it's a $100 bill or a needle. They've heard about the needle, though, but they didn't realize you can catch it this way, too. Contact with the blood. All right, folks, just keeping you up to date. All right, pulmonary disease, whether it's stenosis or regurg, almost always due to congenital. That means you were born with it. Chukuma, give me one congenital heart disease that has a pulmonary problem. Huh? No, pulmonary valvular problem, I meant to say. Paul? Total anomalous pulmonary venous return doesn't have a pulmonary valve problem, though. I want a congenital heart disease, Tatiana, that has a pulmonary valve problem. Tetralogy of Fallot, pulmonary stenosis. Anytime you have RVH, folks, you get a boot-shaped heart. That's a classic clue they'll tell you. They won't even say it's tetralogy. They'll just say, oh, you see a boot-shaped heart on the X-ray. That can only be tetralogy number 1 or like pulmonary atresia number 2, but that's rare. All right, folks. Let me just show you a couple of flow volume loops, because students panic every time they change the picture on the boards. All right, everybody watch at the same time. Remember, the picture's already in your notes. You don't have to be writing anything down. Watch at the same time. Okay, there goes my arrow. Here goes my arrow. All right, arrow, come on. All right. Look at down here. This is the x-axis, right? Did I get it right? All right, sometimes I mess up with x and y. All right, x-axis down here. Kathy, if in the x-axis the volume is rising, is that systole or diastole? Diastole. Kathy, if in the y-axis pressure is rising, is that systole or diastole? Has to be systole. Folks, why do you get so scared? Because you're trying to memorize one picture out of your book and swear that's the same one they're going to put on the exam. It's not. They'll just change it. The key is, look at the x and y axis. If you memorize it too hard, they'll flip it around. I see them do that all the time, and students pick the wrong answer. I say, did you look at that x and y axis? And now they look at it. And see, that's how I know you're trying to remember something out of your book or some article, and you forgot. Just read the x and y axis. So when you do one axis at a time, you should get almost every picture, every diagram correct. If you do one at a time. All right, so if this is diastole, that's how I know mitral valve opens here, mitral valve closes here, so this is S1. All Isovolumetric contraction. Boom. Aortic valve opens here, closes here. S2. Isovolumetric relaxation. That means you can answer 1,000 questions off of this. Now watch quickly. Don't write yet. At the end of B, that's end diastolic volume. At A is end systolic volume. I can subtract A from B. That gives me my stroke volume. If I take that same stroke volume, put it over EDV, I can give you ejection fraction. Where does aortic diastolic pressure reside? Whenever you open up the aortic valve. Didn't I say it was 1 above that number? So here's the diastolic pressure right here. You just go across and read that number. What is systolic pressure? The peak resistance the ventricle has to overcome. I go right here and go across and read that number. S2 is right here. So any valvular problem on the left side, folks, they can ask you where's it going to happen right here. So that means if I ask you where you're going to hear an opening snap per NEMA, give me a letter. What? Opening snap is a aortic sound now? Uh-huh. What makes the sound of an opening snap per NEMA? That's the first thing you got to figure out. Use physio. You guys just like to try to guess these things. I'm telling you. That's why you got to be careful. That's why cardiac score is the lowest, because everybody's still trying to guess these things. Opening snap. What does it mean? No. I said opening snap, and you said closing. How can that be right? All right. Wait a minute. Jessica, help her out. Opening snap means what? Why is it making a sound when it opens like that? Tony? It has to be either a stenotic, mitral, or tricuspid valve. Since we're on the left side here, it can only be mitral. Where's the mitral valve going to open, per NEMA? No. Janice? At A. That's why I said everybody watch at the same time. If you don't know what's going on at each one of these levels, you're going to be guessing again. We're right back to guessing. All right, one more time. Everybody watch at the same time. Mitral valve opens here, closes here. This is diastole. That's how you know. I don't want you guys to just memorize what I say. You got to make sense to you. Volume is rising. Well, it starts to rise when the mitral valve opens. Stops rising when the mitral valve closes, right here. All right, here, pressure rises. And then the volume starts to drop when aortic valve opens, right here. And it stops dropping when the aortic valve closes, right here. In isovolumetric relaxation. All right, so now I'm going to change it. Jenny, look at the first one. And tell me what has changed in this patient. Excuse me? The volume has changed the most, hasn't it? Has the volume increased or gone down? Increased. Give me a reason. Dilation of the ventricle due to what? Thank you. Give me another reason, Nicole. No, it's only early in exercise. It's not going to dilate this much. Exercise doesn't dilate your heart. This is a dilated heart. You got way too much volume in here. So then you got to figure out, okay, what could have dilated this person's ventricle? Kathy knows? Stenosis is a resistance problem. Resistance problem. This is a volume problem. Remember, once you figure out your context, you can't figure an answer out of context. Diana, give me a reason for this. All right, Cammie. Oh, wait a minute. Say that again. Give me a diagnosis. I got a person that got way too much volume in their left ventricle. Just give me a diagnosis for it. Aortic what? Stenosis or regurg? What? This is a volume problem. All right, again, I'm going to keep pointing out to you guys. Don't stop letting go of your context. That's why we spend so much time. Volume versus resistance. If the question is about volume, folks, if you don't pick an answer about volume, I don't care how you convince yourself resistance was the answer, you will not get a point. I've never seen that answer be right. As much as students have tried to make that argument, oh, because I read it in Robbins, oh, because I saw it in first aid. I'm telling you right now, on the test writer does not agree with that, folks. I'm telling you. And in real life, you're not going to hear that. It's rare. That's why I say go with the most common. Volume, dilation. Resistance, hypertrophy. Don't try to make it go the other way. Just don't do it. Not even worth it. That would be a rare disease. You don't want to get a rare point off the exam. Okay, Cammie. Yeah, they're only doing the left side. I mean, if they wanted to be right, they'll tell you, right ventricle. Yeah. Yeah, all right. So, Cammie, you do this bottom one. What have you noticed in this patient? What has changed? Volume or pressure? Pressure has gone up or down? Has increased. Everybody see that? So give me a reason. Hypertrophy of what? Of the left ventricle due to hypertension. Give me another reason, PJ. What? Vasoconstriction caused by what drug? Just name one. What? Now you go into a blocker. You just told me an agonist. No. It's epinephrine, norepinephrine, ephedrine, pseudoephedrine, phenylephrine. If you guys don't use the names, you're not going to remember when they ask you a question either. All right, so that's that one. Here's another one they like to use. Okay, now be careful. Watch carefully, folks. This line here is the atrium. The black line underneath it is the ventricle. As you can see, it goes around like that. And up here, the blue line is the aortic. So what they do is take the left side again and graph it a different way. Now, everybody watch carefully. When the left atrial pressure is above the left ventricular pressure, as you see here, that's how I know filling of the left atrium, left ventricle begins here. That's how I know mitral valve opens here and goes around and closes here. Because notice, there's no more filling. And then the pressure of the ventricle starts to rise. You see that left ventricular pressure is now above left atrial pressure. That's why you can't be filling it anymore. So mitral valve will close right here. And then isovolumetric contraction. And then here, you see that? Aortic valve opens here. That's why you see this blue line starts to rise. That's how you know systole began here. And then boom, you see when the aortic tracing suddenly drops underneath? Right here. That's how you know aortic valve closes right here. They call it the dicrotic notch. And then isovolumetric relaxation. And then it starts filling again. Okay? So that's normal. Now notice normal says left atrial pressure should be just slightly above left ventricular pressure when it's filling. Look at this one over here. Left atrial pressure tracing way above left ventricular pressure tracing. Frank, explain. Gotta be a mitral stenosis. All right? That's what I'm telling you. They can graph it so many different ways, folks. That's why you don't just memorize. First, you just got to know normal physiology. That means if any line deviates from normal, then I know what happened. And then I got to explain either more volume or more pressure. That's it. All right? So, Sandeep, look at the aortic pressure tracing versus left ventricle pressure tracing. Look at it up here. It should be that much higher. You see that? But instead, you see left ventricle is way above the aortic pressure tracing. How is that possible? Aortic stenosis. See? Aortic stenosis. Aortic stenosis. There's an endless number of ways to graph things, folks. That's what I'm saying. Don't just memorize this. They got a new graph when you get to the exam. All I tell students, make sure you read the X and Y axis so that you know what's going on. Once you know what's going on, then you say, okay, what deviated from norm? What deviated from the normal that you should understand? And then figure it out that way. Instead of trying to remember, oh, was this aortic stenosis I remember seeing in that book? Or was this, pulmonary regurg I remember seeing in some book? All right, Matt, I'm going to draw one and just see if you can figure this out. All right, so The left atrium is down here, and what you notice is
Can you just repeat that to me, for the aortic stenosis? Why is it an aortic stenosis?
because the left ventricular pressure is way above aortic pressure. Look over here. See that? Left ventricular pressure should be underneath the aortic pressure. But now they've separated. That means there's too much pressure in the left ventricle. That's a stenotic valve. Finish. No. Here's what regurg is going to look like. All right, Binish, follow the line. Regurg, you'll see the pressure go up and then come back down, all in the same beat. See that? Because the valve goes up like this, comes back down like that. So I should see a big swing up and down. So if I saw the same thing up here, see that? That's how I know it's aortic regurg. It should swing up and down. That's why you got a wide pulse pressure. High systole, low diastolic. That's how you know regurg. The path of systole on which one? First tracing? On this one. Okay? Mitral valve opens here, closes here. So systole begins right here. See, left ventricular pressure is above atrium. Isovolumetric contraction, and then boom, aortic valve opens right here. So true systole, I mean blood going out of the ventricle, is from here to here.
Isn't at that point aortic valve in the middle of that is above ventricular pressure? Shouldn't it stop right?
Where?
Right, no, there.
Here?
Where the two lines cross in the middle.
Okay.
Shouldn't it stop there? Isn't aortic greater than ventricle?
No, it's just, remember, it just takes a while for the blood to come out of the ventricle and then enter the aorta. That's what this slow. Remember, you got sustained contraction of the ventricle. That's why it's just kind of a little slow in the beginning, and it rises and then drops.
Doesn't systole stop when aortic pressure is greater than ventricular pressure?
No, not right away. Not right away. That's why, remember, the left ventricular pressure has that 40 millimeter difference. That's to keep that pressure on the aorta, so that blood moves into the aorta, flows for ways before the pressure now recalls back and actually closes the valve. Okay, so it's not as soon as the pressure rises above, it immediately closes.
But as soon as ventricular is greater than aortic,
That's when it opens, right? Okay. All right. Any final questions? Yes.
When you start on the right there, like if I look at that, I would start on the left, and I would say, here's my atrial pressure going up, and put my ventricular pressure down there. So wouldn't that left, the beginning of the left side, be the mitral valve closing?
Where? Here?
All the way in the beginning, all the way to the left.
You talking about here?
No, keep there.
No, remember, the mitral valve completely closes right here when the ventricle starts contracting. So that's why you got to stay here. Because right here, left ventricle has not started contracting. That means it's still filling.
So it's
Yeah.
right in the corner.
Right. So it's filling. Now it starts contracting. So mitral valve closes here. Okay? All right, folks. Antiarrhythmics. Quickly, it's just the clues because you already know all the information. Here's the tracing. Now, this is just any tracing. It's not the atrium. Don't worry about whether it's atrium or not. All right, Kathia, what phase is this? 0. What phase is this? Oh, coming back down. 3. 0. 3. What phase is this? 4. Arrows. What ion is responsible for depolarization?
Is that an atrium like you were talking about?
Well, just go ahead. For atrium, it's going to be? Everywhere else is going to be? Sodium. What ion is responsible for this? Potassium. What ion is responsible for this?
Sodium.
Sodium by sodium calcium or sodium potassium?
Sodium.
Calcium. Remember, resetting is sodium calcium. All right. All right, Cammie. Where did this tracing come from? Atrium or ventricle? Ventricle, how do you know? Rapid rise in phase 0. Cammie, what ion is responsible for this? Sodium. What ion is responsible for this? Potassium and chloride. All right. What about this one? Calcium. What about this? Potassium. What about this? Say that again. What ion? Sodium. All right. Diana. P wave represents what? Atrial depolarization. What ion? Calcium, going which way, in or out? Going in, getting positive. PR segment, Diana, what's that? What's responsible for that? What phase is that? Or what does that represent to you? And it represents atrial. No, there's a depolarization. This is a contraction. Atrial contraction. QRS, Diana, represents what? Sodium going in. Ventricular what? Depolarization. What part of the ventricle does this Q wave represent? No. What part of the ventricle is this? Let's try Sandeep. We'll come back. Septum. The R wave, Sandeep. What's that? Anterior wall. S wave, posterior wall. Remember we demonstrated? It first goes into the septum, anterior wall, posterior wall. All right, got to visualize it. So QRS, ventricular depolarization. All right, back to you, Diana. ST segment represents what? Ventricular contraction. What phase? Phase 2. What ion? Calcium moving in or out? Moving in. T wave represents what, Diana? Ventricular repolarization. What phase? What phase are you thinking of? I'm going to have to start charging you guys $1 for every time the right answer is in your head and you're hesitating that long. Here comes a wrong answer if you hesitate any longer. All right? I say it again, folks. Whenever you're not sure, you better just tell me what's the first thing that pops in your head. Mark that one on the exam. You have a better chance of being right. All right, so T wave is phase 3 and the U wave is just automaticity, so that's phase 4. Sodium calcium. All right, sodium channel blockers will work for what kind of arrhythmias, Elvis? Ventricular. Will they affect your P wave, Elvis? Will they affect your P wave, Elvis? No, that's calcium. Will they affect your PR segment, Elvis? No, that's calcium. Will they affect your PR interval, Elvis? No, that's still calcium. Will they affect your QRS, Elvis? Yes, that's sodium. What's going to happen to the height? It's going to get smaller. What about the width? No, that means you're going to depolarize faster if you say narrower. Do you understand? Duration. So it's going to take longer to depolarize. All right, is that going to affect your ST segment, Elvis? No, it's calcium. Will that affect your T wave, Elvis? No, that's potassium. Will that affect your U wave, Elvis? Yes, because it's driven by sodium. Now, that's the reason for saying out loud, folks. If you guys don't hear it, then the next time I ask the same question, we got hesitation again. You got to know what every one of those things mean. That way, if I ask you what's the EKG findings with sodium channel blocker, you know how to figure it out on your own. That means I don't have to tell you. You already know the pieces. That's how you figure it out. Don't start guessing. If it's not due to sodium, it's not going to be affected. Does everybody understand me? All right, so let's go through them. Quinidine has strong anticholinergic side effects. Chukuma, give me a classic clue for anticholinergic. What? Hot, dry skin and hyperthermia. And then we said quinidine can also act as a hapten on platelets and cause a disease called synchronism. Peggy, what's the triad of synchronism? What? So tinnitus, So the drug buries itself in the membrane of a platelet. Now the platelet looks foreign, so you start making antibodies against your own platelets, so thrombocytopenia. And then the same antibody attacks quinine nerve 8, so you get ringing in your ears, tinnitus, and you lose your hearing loss. That's a triad of synchronism. Again, understand the physiology of a problem. That's what pathophysiology is. If you understand the physiology of a problem, you'll understand the complications and problems you're going to get from it. This way you don't just memorize lists, triads and 4 things, 5 things. You got to say what ties these things together, or else they wouldn't have appeared together on the same list. All right, quinidine and 2 other drugs, trachoma, cause synchronism. Who are they? Danielle. Aspirin and quinine. Quinidine, quinine, and aspirin. Procainamide. Procainamide has the word procaine in it. That's an anesthetic, so neuropathy is a side effect. Hey, Al, is that an ester or an amide? I can't remember.
That is an ester.
That's an ester because it has only one I. Wait. Anesthetics stop at cane. They stop at cane. I asked about procaine. Procaine is an ester. They added the amide to it later. Okay? I asked about procaine. You guys answer the next question. It's an ester that they made into an amide afterwards. It was an afterthought, which is fine. But procaine is anesthetic, so neuropathy. Procainamide is one of the 5 drugs that cause drug-induced lupus. And we have a mnemonic, Jennifer, called hippie. Drug-induced lupus, the H stands for hydralazine, the I and H. First P is procainamide, second P, phenytoin, the third P, penicillamine, the E, ethosuximide for upset seizures. So, procainamide, so we got neuropathy, we got drug-induced lupus, and then it has a breakdown product called NAPA, and acetylprocainamide, which can also block potassium. This is why they talk about class 1A is blocking phase 0 and phase 3. It's primarily procainamide who does that, though. I guess they thought the whole family was going to do it, but the whole family does not do that. Okay? All right, so that's procainamide. Disopyramide has mild anticholinergic side effects. Give me a classic clue for anticholinergic. Tara. Hot, dry skin, and hyperthermia. All right, then class 1Bs. Start out with lidocaine and his brothers. Lidocaine, is that an ester or an amide, Josh? That's an amide, fat or water soluble. Fat soluble. Do I need to use epinephrine with it or not? Yes, because it will redistribute real fast, won't it, Josh? Yes. Josh is feeling good now. He's understanding it. All right, so lidocaine. Again, it's an anesthetic, so neuropathy is a side effect. Lidocaine is a drug of choice for ventricular arrhythmias for one reason. It's attracted to ischemic tissue only. Hey, wait a minute, Chukuma, what's the most common cause of ventricular arrhythmias? Ischemia, that must be it then. Which means lidocaine will work 9 out of 10 times, folks. No surprise, no surprise. That's why I say concepts don't ever change. If you don't remember the original concepts, then you memorize, oh, lidocaine's drug of choice. But do you know why? Once you see the connection back to the original concept, you'll never forget it again. All right, so that's lidocaine. Tokenide comes from tocaine. Maria, is that an ester or an amide? Huh? Yeah, I woke her up out of a coma. Tocaine. Is that an ester or an amide? Ester. It doesn't have 2 I's in it. You understand? All right. So neuropathy is a side effect, and it causes pulmonary fibrosis. Maria, give me 2 more drugs that cause pulmonary fibrosis. Bleomycin and busulfan. So now we got 3. All right. Mixilotine. Tamir. Mixilotine causes bad GI upset. Bad GI upset. Hey, wait a minute, Tamir. Do you know of a dopamine blocker that works for nausea and vomiting in children? Yep, children. That's right, it's called promethazine. But he forgot, that's okay. He'll remember tomorrow though. All right, and then perchlorperazines for adults. Got a drug for nausea and vomiting in chemotherapy patients? Elvis? Michelle? Ondansetron. Say it, folks. Say it, say it. Drill it. If you don't drill it, you won't remember these things. All right, so that's mixed with phenytoin. Blocks folate. What side effect do you get when you don't have folate? Mustafa. What kind of anemia? Megaloblastic anemia and hypersegmental neutrophils. All right, so phenytoin blocks folate. Classic side effects, gingival hyperplasia and hirsutism, just like cyclosporin. We talked about that before. Gingival hyperplasia and hirsutism. Poor girl, you can see, I can tell our phenytoin patient, because they always got fine hair all over their face. I mean, all the way out here. Almost like a werewolf, like they're going through a transformation. Werewolf, if you guys remember some of the old werewolf movies. Yeah. Poor girl, she calls the doc and says, you know, doc, I can't get a date, man. I got hair all over me. What am I going to do? My gums are all messed up. What am I going to do? He says, all you got to do is just comb your back. You should be okay. Gingival hyperplasia and hirsutism. All right. Phenytoin also causes drug-induced lupus. We said that twice already. If you got a mom who's on phenytoin while she's pregnant, okay, you'll see a baby born and his nails will be all messed up. And the jaw and lip. So they get cleft lip, palate, jaw problems, and messed up nails. That's how I know the phenytoin hydantoin syndrome. Phenytoin syndrome, hydantoin, that's just another name for it. Fetal hydantoin syndrome. All right, so that's phenytoin. Class 1Cs, man, these block up to 90% of the sodium channels. You only use them as a last resort. Because they're going to block almost every arrhythmia, including normal ones, which means you may not survive. All right, so enconine, flecainide, propofenone, last resort. So sodium channel blockers. Well, oh, wait a minute. There's one more thing I got to point out to you. Quinidine, procainamide, and phenytoin are 3 sodium channel blockers who also block calcium, Monica. 3 sodium channel blockers who also block calcium. You understand, Monica? All right. Why would you want to know that? If you know a patient's got a disease called Wolff-Parkinson-White, you better know it. Well, James, Wolff-Parkinson-White is the most common cause of palpitations, or SVT, supraventricular tachycardia, in teenagers. So I think you're going to run into it all right, if it's the most common. You understand, Danielle? You understand, Brendan? All right, Brendan, watch my arrow for a second. In Wolff-Parkinson-White, you got normal conduction this way, from S8 AV node, that's what we've been talking about. But in Wolff-Parkinson-White, you also have another one called the bundle of Kent, that goes around the AV node into the ventricle like that. You understand that? All right. Well, if the patient presents, there's a way to kind of see it on an EKG. You'll notice they'll have this upslant in their QRS complex, and then you see a narrow QRS. Okay, together, when you put it all together, that's a wide QRS. But this one is called a delta wave. So on boards 2 and 3, they'll show you the EKG. And you got to recognize that upslant. That's classic bundle of Kent. That's the bundle of Kent, tried to take it, and then normal pathway took it back. Okay? So, Brandon, if you look at the bundle of Kent, some of it is up here in the atrium, some of it is in the ventricle. Now, they always tell you whenever you got palpitations in a teenager, until you know for sure it's not Wolff-Parkinson-White, they say never give digitalis. Why would they tell us that, Brendan wants to know? Because the second action of digitalis, as I explained to you, it stimulates your vagus and the medulla. The vagus will close off this conduction pathway right here, which means there's only one other way around. You'll kill your own patient. Everybody understand that? Remember, digitalis has 2 actions. It's not just block sodium potassium pump. It also stimulates your vagus. So you block off this conduction, and then the person can deteriorate and die from it. Well, Brennan, if you truly want to treat this patient, you got some of the fibers up here in the atrium, some in the ventricle. What does the atrium use to depolarize? What ion does it use to depolarize? Atrium, Brendan. Atrium uses calcium. Ventricle uses sodium. Wouldn't it be nice to know the drugs who block calcium and sodium? That way when you look in your books and you got one book that says quinidine, fine. You go to another book says procrustamine. Go to another book that says phenytoin, you still haven't caught on to what's going on. It's the same three drugs. The three who block sodium and calcium can be used for Wolff Parkinson White. What? And phenytoin. 3 sodium channel blockers who also block calcium. Okay? Calcium channel blockers, what kind of arrhythmias do you use it for? Maria? Calcium channel blockers, what kind of arrhythmias do you use it for? Atrial. We already did these. Verapamil is the most potent, so he's first line. Diltiazem is second most potent, so he's second line. This is for any atrial arrhythmia. I don't care which one it is. Now, we said the ones that end in peen, we said were for vasoselective. That means for angina hypertension. Jessica, which one of these peens was used to stop vasospasm after subarachnoid hemorrhage? Which one? No, not nifedipine. Diana. Nimodipine, with the M in the middle. I remember, for years I remember this because nimodipine, I said M for mind. And that worked for me. And then I think it was 2 months ago, somebody said, hey, wait a minute, amlodipine got an M in it too. Amlodipine got an M in it too. I said, man, you're going to mess up my pattern. I've been happy as a lark for years to get the right answer. Now you're going to point out to me there's a couple other Oh my God, I never even noticed all this. I said, oh man, all this time, nimodipine, it made sense. I just said M, okay, M in the middle, M for mine. And it worked. Every time they ask me a question, I got the answer right. Then somebody's going to mess up my happiness for me. So now I got to figure out another way. But the old one is still there. Until I find out a new way to know it. All right, so that's calcium channel blockers. Will they affect your P wave? Kathia? Yes. PR segment? Yes. PR interval? Yes. QRS? No. ST segment? Yes. All right, so we know how to affect the EKG with any of these drugs now. Don't be writing it down. I'm just drilling you on it. Once you know the parts, don't keep writing it down anymore. Let the brain connect to the concept, not more details. All right, class 2 antiarrhythmics are beta blockers. You recognize a beta blocker because it ends in LOL. You recognize a beta blocker because it ends in LOL. There's about 30 of them out there, folks. You don't want to know all of them. All right, how do you know it's specific beta 1? Begins with A through M, but not L or C. So like ace-butylol, atenolol, that means I can look at the name, look at the first letter, and tell you whether it's specific beta 1 or not. Okay? And then if it begins with N through Z, I should really just say non-specific, not specific beta 2. It means non-specific. It hit beta 1 and beta 2. Yeah. So it begins with N through Z. Now, why would I want to be careful to use a specific beta 1? That means you got to watch out for people who can't tolerate you blocking the beta 2s. Linda, like? Asthmatic. Anybody with obstructive lung disease. Al, like? Same one. Any obstructive lung disease. You don't want to block beta 2s. Give me another category. Besides obstructive lung disease. Oh. We got lawyers in the place just copping the same plea now. All right, Tara. What's the question? Who do you not want to block their beta 2s? I pointed out to you when we did the beta receptors. All right, let's try Faisal. That's still obstructive lung disease, man. Every obstructive lung disease, don't block the beta 2s. Okay, we're done with that category. Now, give me another one. Tim. So I gave you obstructive lung disease. I gave you diabetics. I gave you peripheral vascular disease. I gave you heart block or severe congestive heart failure. You got to know which drugs to use, okay? So that when it's specific Beta 1 is when you want to avoid beta 2. And you got to know when it's non-specific, when it's okay to hit the beta 1s. All right, when it's okay to hit beta 2s. All right, so that means if I show you the list like this, propranolol, is that specific or non-specific? Rashmi? Non-specific. All right, Rashmi, propranolol is the longest acting beta blocker. Who would you avoid this drug in? Huh? No, just long acting. Longest acting. Who would you avoid it in? Tanvi, who would you avoid it in? Obese patients. Josh, who would you avoid it in? Elderly. Who would you avoid it in? Eros. Cammy. Pregnancy. Who would you avoid it in? PJ. Chris. Liver failure. Don't forget your concepts, folks. Remember I told you, I'm going to point out the longest acting, shortest acting for that reason. That way you already know who to avoid it in and who to give it to. Okay? Esmolol, shortest acting. Who uses it? Anesthesiologists. It only lasts about 10 minutes or so. It's just to slow the heart rate down on induction. Remember, you sensitize the heart and it starts to race for a few minutes. Timolol and butoxolol are used for glaucoma. You have beta receptors in the iris that promote aqueous humor production. So if you block them, you decrease aqueous humor production. Timolol and butoxolol come in eye drops for glaucoma, open angle glaucoma. Sotalol is the only beta blocker that also blocks potassium. Sotalol, the only beta blocker who also blocks potassium channels. Then the next two, labetalol and carvedilol, are the two beta blockers who also block, in addition to beta 1 and beta 2, also block alpha 1 receptors. These are now being used heavily for hypertensive crises. Ooh, especially if she's pregnant. Because we don't want to give her cyanide by giving her what drug? Tim? First line drug for hypertensive emergency? Now, Ferdy? Sodium nitroprusside. But that one has cyanide. If she's pregnant, you probably don't want to use that. So labetalol and carvedilol can be used for hypertensive emergencies or crisis. And then the last three, these last three drugs have what they call, hello? Oh, let me get my pen here. All right, these last three drugs have what they call ISA action. Intrinsic sympathomimetic action. What that means is they don't completely block the beta receptor. Sometimes they actually stimulate it. When would you want to know this? If you got to use a beta blocker, let's say in obstructive lung disease, you have to use it. You probably want to use the ones that don't completely block the receptors. What about a diabetic who had an MI? Well, we know that beta blockers decrease mortality, don't we? That means you got to start them on it. Well, you probably want to use the ones that don't completely block the beta receptor. So those 5 groups we talk about contraindicated, these are the ones we use. Okay, that's why there's most hospitals, ERs I go to have atenolol always there. This way you can use it in anybody. That way you don't have to worry about if they're diabetic or not. Okay, so ace-butylol is the most potent of these 3. So ISA action, 3 of them. Ace-butylol, atenolol, pindolol. All right, and then finally, we got one more class, class 3, so potassium channel blockers. Potassium channel blockers will work for every arrhythmia, because what phase of the action potential do they work on? Joseph. What phase of the action potential does a potassium channel blocker work on? Phase 3. What member in your body, Joseph, does not have a phase 3? Let's see if Frank remembers one. Nita, do you remember one? Thomas, do you remember one? Tony, do you remember one? No, Pranima. All of them have one. There is no such thing as a member without phase 3. Oh, look at that. Watch out for the leading questions, folks. They suck you into thinking, well, maybe you kind of missed that in your readings. You didn't miss it. There's no such thing as a member without a phase 3. I told you phase 0, 3, and 4 are found in every membrane. The heart's the only one with a 1 and a 2 in there. Okay? All right, so potassium channel blockers will work for every arrhythmia. Remember, now we're using like amiodarone first resort. When they come in and it's already been more than 10 minutes in that arrhythmia, man, don't be messing around with, shock 'em crap. Just bam, shock them with 360 and hit them with the amiodarone. I told you they had a 96% chance of dying, man. So it makes sense to me when we're changing all this ACLS. Just go right to maximum and hit them with a potassium channel blocker. Stop the arrhythmia. It'll stop, all right, but remember I told you everything else is going to stop too. So then we got to go up to the ICU. But that's okay, at least they're alive. All right, amiodarone is now being used first line for any lethal arrhythmia. Arrhythmias, if you have an implantable defibrillator. Because think about it. If you're having an arrhythmia and you already got a defibrillator inside you, obviously it must be a bad one. And that's why it makes sense to me. Okay? All right, otherwise, any of these can be used. But Napa, I already pointed out, came from procatamide. Sotalol, I pointed out in beta blockers. The pure potassium channel blockers are beryllium, amiodarone, and a new one now called difidylide. Yeah, difidylide. I think it's difidylide? No. Oh, I can't remember if it's DE or DI, difidylide. Anyway, if I'm off by one letter, forgive me. Difidylide just came out, but it's on your boards now. It's been out for a couple of years. So we now have 3 pure potassium channel blockers. All right, amiodarone has plenty of side effects for everybody. Number 1 is made from iodine, so you get hyperthyroidism, then hypothyroidism. Hyper, then hypo. That iodine can react with your skin and turn your skin blue. So bluing of the skin. It causes pulmonary fibrosis, like 3 other drugs that Maria knows. Pulmonary fibrosis, like 3 other drugs you should know. Bleomycin, busulfan, the one we said earlier. I wish I remember what it was called. Tokinide. So now we got 4 drugs that cause pulmonary fibrosis. Amiodarone also blocks the P450. That means you have to be careful about drugs that are heavily dependent on P450. If I block your P450, Jennifer, what's going to happen to the levels, the serum levels of those drugs that are heavily dependent on P450? It's going to do what? Increase. So that means, Tara, what would you advise your patients while they're on amiodarone? Increase or decrease their dose? Al, decrease their dose. Amiodarone is going to raise their levels. You got to tell them, you better decrease their dose or else bad things happen. So the 5 drugs that are heavily dependent on P450, folks, you got to know them. These 5 drugs are so commonly used in America. That's why it's all over your exam, because I can't even begin to tell you how many people die every year from somebody forgot. Okay? The W, used in mnemonic wept. W is for warfarin. That means if I put you on amiodarone and I don't tell you to decrease your warfarin, good Lord, now you'll bleed into your brain and die. Okay, estrogen. See, now your estrogen levels will rise. And all of a sudden, for a female, she got heavy menstrual bleeding. And now you start working her for something else that doesn't even exist. Okay? For a male, all of a sudden now he's got gynecomastia. He's got to go shopping with his wife to get bras now, both of them. He ain't going to be too happy when he calls you. Okay. All right, P is for phenytoin. A lot of adults on phenytoin for seizures, so you got to tell them. All of a sudden they come in with nystagmus, going wobbling all over the place. T is for theophylline. I was just reviewing a CD on the way here, and they were I like these the CDs that give me update on all these diseases and stuff, and they said, there's really no role for theophylline in asthma anymore, which is exactly what I told you, except if you use it at very low levels. Now, how does that follow what I told you, man? Took them that many years to figure it out. I could have told them that years ago. That was a problem. If you use low levels, cool. High levels, the doses they were recommended, no good. And now they're just figuring it out. About, that was back in 88, I met Dr. Shaw. This is 2008. 20 years later, they finally figured out that it's okay to use it as long as you use it at very low levels. Stay at the low levels where it's sympathetic. Oh, folks, that's what I'm trying to tell you. That's why in the beginning, when you start explaining things and people don't understand where you're getting it from, they'll tell you you're crazy. But that's all right. Stand your ground. As long as you can explain the physio behind it. After a while, they'll realize you're right and they're wrong. Okay? But that's why I want you to know the explanation for things. I don't want you to just believe what I say. I want you to see where I got it from. Physio makes sense for me. Biochemistry makes sense of things for me. All right, and then the D is digoxin. A lot of people have died from arrhythmias because they forgot to tell them, decrease your dose of digoxin while you're on theophylline or the low energy state, man, it's the most powerful concept in all of medicine. Why not start with the best one? Because with the best one, you're about to learn the tip of the pyramid. You're about to understand 1,000 things, but you won't know it until I point it out. Low energy state. It occurred to me one day. This actually came from biochemistry, folks. For all those physicians who say there's no biochemistry out in the real world. This came from biochemistry. It occurred to me one day, this is after I met Dr. Shah, that your body spends a whole lot of time making energy. Why is your body making energy every second of the day? Because every cell in your body has to have energy. Makes sense to everyone so far? Got to have energy. And in fact, some cells need energy more than others. Well then, that means if ever you're deficient in energy, for any reason, whatever that source that started it, doesn't even matter. Your body will respond exactly the same way all the time. Oh, I like this. All the time, I like this. That means I don't have to rethink it. The most powerful concept in all of medicine, man. Who uses energy? Well, I just gave you a nice little list of the cells who use the most energy. Over on the left, the brain uses a lot of energy to think. Muscles use it for release, as you'll learn. Not so much for contraction, but for release. So you need for muscle function. Primary active transport means anything with an ATPase after it. Sodium, potassium, ATPase. Every cell in your body has one. Calcium, ATPase. Muscle fibers have it. Hydrogen, potassium, ATPase in your stomach. Okay? Every ATPase has to have energy at all times. Which means without energy, they all stop. Well, look at the heart. Your heart's beating all the time. Your heart just can't take a break. Can't say, well, barbers are off on Monday, so I'm going to be off on Monday too. Problem is, you'll be off on Monday, then Tuesday, then Wednesday, then Thursday, and that'll be the end of you. All right, so your heart's got to be beating all the time. It's got to have energy. Okay? Look at that membrane movement. Endocytosis, bringing things in. Exocytosis, pushing things out. Phagocytosis, bringing large objects in. So membrane movement, got to have energy. Axonal transport, membrane movement. All right, pinocytosis, when membranes wrap around fluid electrolytes. Energy. And then over on the right, what did I give you? A list of rapidly dividing cells. Why? Because they use so much energy for rapid cellular division. So when we do biochemistry, you're going to see cellular division. Nucleotide synthesis requires a lot of ATP in order to do. Right, Monica? That's right. Monica said, yeah. Whatever Monica says, yeah, it must be true. Your name? Gretchen. Gretchen. When Gretchen says it's true, it must doubly be true. Gretchen, and then, just give me the first name. Ramathia. What do your friends call you? Ramathia? Okay, now I was trying to look for an easy way out here. You know, in the hood, man, I grew up in the hood. If your name's too long, they give you a nickname. Forget that. They ain't trying to pronounce anything this long. I mean, for like E.H. Rika, you know what they grew up calling me? They always call me Little Eye. My brother was Big Eye. That's it. They're not going to try to pronounce E.H. Rika. Forget that. Big Eye, Little Eye. That's it. You know, so I thought maybe I'd get away with a nickname. All right, so Ramathia. All right, Gretchen Ramathia. This young man right here. Oh, no, wait a minute. Let me just go down this road. Rahul. And Rahul has spoken and Shane has spoken and Asif. So Rahul, Shane, Asif. Gretchen, you ready? All right, look at these rapidly dividing cells, Gretchen. It says skin, hair, GI, respiratory, renal, especially the proximal convoluted tubule. You understand, Gretchen? Then it says bladder, endometrium, endothelium, breast, sperm. You understand, Ramathia? All right, germ cells, Oh, wait a minute. Germ cells. You know where germ cells are? Underneath every cell lining, every epithelial lining, folks, there's a bunch of cells called germ cells. What are they? Cells that can become anything your body needs. They're pluripotent. What does that mean? It means, let's say if I fall on the ground, scrape my skin, I lose some hair, I lose some muscles, lose some nerves. Germ cells will start dividing and become hair, skin, nerve, muscles. They're pluripotent. They can become anything your body needs. So they got to be ready to divide at any one time. And of course, I just said rapid cellular division is going to cost you nucleotides, which require a ton of ATP. So germ cells, got to be ready. Well, look at the cuticles, not your nails. Nails are dead tissue, folks. Cuticles. You understand, Raul? You understand, Shane? You understand, Asif? You with me there, Gretchen? And Ramathea is right there with me. Aren't you, Ramathea? All right, then. All right, so the bone marrow can be depressed because it's got to provide us red cells, white cells, platelets, right? So that means if it stops having energy, all those cells won't show up anymore. You understand, Asif? All right, first name. Sharice. Who? What? Hepzibah. Now, I remember seeing that name. How do you pronounce it? Hepzibah. Where's that from? From the Bible. Where are you from? That's what I thought. Hepzibah. What do your friends call you? Z. That means I get to be your friend, Z. I get to join the friend list. Non-friends say Hepzibah. Oh, Z sounds good. All right, so we got Cherise, Z, and Amika. All right. So I got that real. All right, cool. All right, so here's all the cells that use energy. You understand, Amika? That means if I'm deficient in energy, do you understand? These cells won't work anymore. You understand, Z? You understand, Sharice? Ah. How do you figure out the presentation of a disease? I got to empower you, man. You don't have to look it up in a book. You don't have to look it up in an article. I'm going to show you how to do it on your own. Look at it, and you'll find it. The presentation of a disease, folks. The way you figure it out is you ask yourself, what would bother a patient the most that they would actually come in to see me as soon as possible? You understand? What would bother you the most that you would come and see the doctor as soon as possible? Well, let me show you. First, I'm going to go back to this list and just turn it into a whole lot of problems. All right, don't write. Just follow what I'm going to do. I'm going to say these areas will run out of energy. So if your brain runs out of energy, if you're a child, you're retarded. If you're an adult, you're demented. In between, you got mental dullness, lethargy, sedation, somnolence, delirium, mental slowness, decreased arousal. All those words mean your brain's running out of energy. All right, go to muscles. Call it muscle weakness, fatigue, exercise intolerance, shortness of breath, decreased cough reflex, constipation, impotence, urinary retention. Ready to follow? All I did was just make your muscles weak and then create problems for you. Okay? In primary active transport, well, the most important one, sodium potassium pump won't work. If that happens, that means sodium gets trapped within the cell. Who comes right after that? Chloride. Who comes right after that? Water. Oh, that means your brain will swell, cerebral edema. That means your eyes will swell, papilledema. That means your heart will swell. That means you got hydropic changes. That means in the lungs, pulmonary edema. That means you get pleural effusion. That means you're going to get ascites. In the GI, we say third spacing. In the liver, we say hydropic changes. In the periphery, we say peripheral edema. If the whole body swells, we say, okay, you got anasarca. All those words mean exactly the same thing, folks. And they've been scamming you guys. Scam, scam, scam. That's all right. I'm about to bust the scam right now. All right, so that's primary active transport. What about the heart? If the heart doesn't work, again, weakness, fatigue, exercise intolerance, shortness of breath. You see that? Decreased blood pressure, decreased ejection fraction, decreased stroke volume, decreased carotid stress, decreased firing by current of 9, 10. I mean, we can go on and on. That's what happens when the heart doesn't work, when it runs out of energy. And then membrane movement. Without membrane movement, that means your neutrophils won't work. You're immunocompromised now. Your macrophages don't work. Immunocompromised again. Cells cannot do endocytosis. They'll die faster. Cells cannot do axonal transport. Your neurons. You get neuropathy. And then we can go on to more neurological problems. Look at rapidly dividing cells. Skin will be dry. Hair will be dry and brittle. GI, nausea, vomiting, diarrhea. If you can't absorb food, it goes right on through and drags water with it. Respiratory. Ineffective cough means more mucus production. That means airway problems. That means obstructive lung disease. That means wheezing, bronchi, crackles. We can go on and on. Renal. Proximal common tubule shut down. That means when you do renal, you learn all the electrolytes handled by the proximal common tubule. Guess what? You can tell me every electrolyte problem is going to be a consequence of this disease. Okay? Bladder. That means ineffective contraction. That means predisposed to UTIs now. Endometrium would be atrophic. That means for a woman, she'll be sterile. All right? Infertile. Endothelium. That means blood vessels will fall apart. When blood vessels fall apart, where you can bleed from? Skin and mucosal surfaces. Dot hemorrhage, petechiae. Larger hemorrhage, purpura. A larger one, we call it bruise or ecchymosis. Striae. You got bleed from the GI, GU, and respiratory. Bleeding. So that means melena, hematochezia, hemoptysis, all that, hematemesis. We can go on and on. Well, look at the breast. Atrophy. Shrink away. Sperm count, low. That means the male will be sterile now. Infertile. Germ cells. Ooh, wait a minute. Here's a good one. If you wear away my germ cells, if you incapacitate my germ cells, amica, that means they can't divide anymore. Do you understand? You understand, Z? You understand, amica? That means if they can't divide, they can't replace cells who died. Do you understand me so far? Now you ask yourself, Z, why would a cell die? One or two reasons. One or two reasons. Well, as far as the body's concerned, that is. Okay? Number one, it was time to die. Okay? Or number two, some mutation occurred. Time to die, we call it apoptosis. A mutation occurred. Your body's always removing mutated cells. Everybody follow me? Everybody with me? Check it out. Name, sir? Nick. Nick, Angie. Ooh, wait a minute. What's that? Bovany. Bovany. How do you spell that? B-A-V-A-N-I. P-A. P-A-V-A-N-I. Bovany. All right, Nick. I forgot already. What is it? I had to concentrate so hard on that one. I forgot the other one. Okay. Nick, Bovany, Angie. All right, Angie. So now you understand that cells, when they mutate, you got to get rid of them. Now all you have to do is ask yourself, what cells mutate the most in your body? Well, Lamika, they got to be cells exposed to radiation. Who are those? Skin, sunlight, bulbs, fluorescent lights. Your skin is exposed to radiation all the time. That means the most mutations occur in your skin. Followed by your GI tract, followed by your bone marrow. That means, Sharice, if I lose my pluripotent cells, the germ cells, where's the first mutation going to occur? In your skin. Where's the second one, Z? In the GI. Where's the third one? In the bone marrow. So that means if I have a low energy state and the germ cells cannot divide, the first cancer is going to pop up. Sharice is going to be the skin followed by GI followed by bone marrow, baby. Come on, come on, come on. We're bringing it home. Bringing it home. All right, we're just rolling, man. All right, so that's the germ cells. Cuticles, your nails fall apart, dry and brittle. Bone marrow suppressed, so leukopenia, thrombocytopenia, anemia. Now let's go back and apply it. How do you figure out the presentation of a disease, Nick? Nick wants to know, how do you figure out the presentation of a disease? Good question, Nick. The answer is, what makes a patient so bothered? What bothers a patient so bad he wants to go see the doctor as soon as possible? You understand? Number one, when they're so weak they can't go to work. Who's going to pay the bills? That's what bothers the most. So weak they can't go to work. You got to eat. So weak, can't go to work. I'm in the hospital today. Doc, something's wrong. I'm in the doctor's office today. Doc, something's wrong. Number one, presentation of a disease is when there is weakness. And then number two, shortness of breath. Everybody who's short of breath always swears they're going to die that day. That's why they run to the emergency room, run to the doctor, but they will be seen that day. You understand, Nick? You understand, Angie? You understand, Poverty? You understand, Amika? You with me, Z? With me, Sharice? Asif? Shane? Raul? Yeah. Gretchen? Ramadhia? Yeah. Okay. All right. Name? Shweta. Name? Shweta, Jesse, Rashid? Oh, Rishi. All right. Rishi. Okay. Shweta. Every time I concentrate on the Indian names, I forget all the rest of them. All right, so Shweta, Jesse, Rishi. All right, Jesse, Rishi. All right, I got a little pattern going there. All right, so Shweta, you understand, the presentation of a disease is what bothers a patient enough that they won't want to come see me the same day. You understand, Pavani? Weakness and shortness of breath. You understand that, Jesse? Okay. Signs of a disease, Jesse. Signs of a disease, Asif. is what do you see? You're the doctor. What are you looking at? So all those things I just told you, the things you can see, like dry skin, brittle hair, brittle nails, those are signs of that disease. Everybody understand the difference? Sign Schweta means what? What you can see. Everybody understand? Well, what can you see when they come in short of breath? Tachypnea and dyspnea. So that means, poverty, when they ask you what's the most common sign for a low energy state, you say what? Most common presenting sign for the low energy state, poverty, you say tachypnea and dyspnea. You understand, Shweta? All right, Jesse. Symptoms is what the patient complains about. Signs you see, symptoms you hear about. Everybody with me? Everybody understand? All right, folks. The reason why this is so important is because one of the biggest errors that students make, answering a question out of context. You're going to hear it day after day, because every time a student makes that mistake, I'm going to point it out to you. You don't realize how easy it is to give away a point because you answered out of context. They asked for a sign, you picked a symptom. It was right, but you answered out of context. You didn't get anything for it. And you swore you were right, but you didn't realize you were out of context with the question. All right? Symptom. What the patient complains about. You can't pick dry skin. Okay? It's got to be what they're going to be complaining about. Okay? You say weakness and shortness of breath. Doc, I'm weak. Oh, doc, I can't breathe. That's what he's going to come and complain about. All right? So symptoms, weakness and shortness of breath. So signs, Jesse, what does that mean? Things you can see. Shweta, the most common presenting sign for low energy state is what? Tachypnea and dyspnea, pulmonary. Symptom, what is that? So things the patient complains about and his weakness and shortness of breath. You understand, Angie? All right, Angie, let's move on to the next one. The most common infection seen with low energy state, Angie. You ask yourself, what areas, when weakened, predispose me to an infection? Well, if you can't cough up the mucus and germs out of your lungs, you're definitely going to get a pulmonary infection. And if you can't empty your bladder, you're going to have a UTI. You understand, Angie? If I ask the most common infections for the low energy state, what do you say, Angie? Pulmonary infections and UTI. And she will say loud with pride in her mind. All right. So signs, what you see. Symptoms, what you hear. Infections, pulmonary UTIs. Complications. What the heck is a complication? Allow me to break it down for you. A complication is everything else that's going to happen in that disease. Why? Because you're afraid a disease started here, but it can affect various organs in your body. All those other organs being affected, we call them complications. So when you have a heart disease and your kidney shuts down, that's called a complication. Here's the disease, here's the complication. Everybody follow? If I have a renal disease and you go to heart failure, here's the disease, here's the complication now. Everybody understand that? I want you to know how to create it yourself without having to read about it. Okay? So complications simply says when you take any disease and it can affect various organs, then those are complications. Everybody with me? You understand? Rishi? All right, so Rishi. Now, when they list a whole bunch of complications, the question is, how do you figure out which one's the most important? All you got to know is what Laura knows. Because Laura knows anytime you got a whole lot of complications, what's the most important organ in your body, Laura? The who? The brain, thank you. Followed by the heart, followed by the kidney. Brain, heart, kidney. As far as importance, that means, Sharice, every time I ask you the most common complication about any disease you're worried about, what organ do you go to? The brain, followed by the heart, followed by. That means Z. They ask you for complications of hypertension. The first organ you look for is the brain, followed by the heart, followed by. Do you understand that, Amika? Anytime they ask you a complication of a disease, the most important organ you got to think about is what? The brain, followed by the heart, followed by. Nick, are you with me here? Anytime you got a complication you worry about, the first organ you think about is what? The brain, followed by the heart, followed by. Every time, folks. The books don't tell you that. They just list off a whole bunch of stuff for you. But if you don't know what order to pick them, you can pick a lot of right answers, but you weren't racking up any points. Because nobody told you. Brain must be picked before heart. Heart must be picked before renal. Way before you look at for anything else. But they set you up, all kinds of right answers. They know it's printed right there in your first day. They know it's printed right in Robbins that you read. And then you forgot what was the real concept behind this question is that brain is more important than heart and heart is more important than kidney. But you just picked a detail, but that was not what they were testing. All right, so complications. Skin, again, I said dry. Hair, you say dry and brittle. Nails, you say brittle. Bone marrow, you say suppressed. So anemia, leukopenia, thrombocytopenia. Well, here's all the other ones. Endothelium, you say atrophic. Endometrium, you also say atrophic. Breast, you say atrophic. Sperm count low. GI, you say nausea, vomiting, diarrhea. Because if you can't absorb, you get an osmotic diarrhea. You understand, Rishi? You understand, Jesse? You understand, Shweta? You understand, Pavani? You with me, Nick? Angie? Cool. All right, so then renal, you say PCT was shut down first. Bladder, atrophic, now you're predisposed to UTIs, Ramathea. Respiratory, you say weak cough, which then predisposes you to infections. Germ cells, Gretchen, you say unable to replicate, so that leads to cancers. And you know in order, what cancer comes first? Skin followed by, GI followed by. Oh, she's been empowered. Y'all better get that girl some elbow room, Monica. Shoo. All right, in the CNS, again, if it's a child, retarded, adult, demented, in between, mental dullness, lethargy, somnolence, whatever you want to say. In the heart, we say heart failure. All right, Rishi, to your right, young man. Ooh, how do you spell that? British, got it. British. Chelsea? Joseph. British, Joseph. British, Joseph. Rishi, British, Joseph. All right, you understand this, Joseph? All right, so that means, Joseph, they ask you what's the most common presenting sign for low energy state. You say what? What? Tachypnea and dyspnea. Tachypnea, dyspnea. Most common presenting symptom, British. Shortness of breath and weakness and infections. Rishi, you got to worry about. Pulmonary infection and UTIs. Jesse, what's your skin look like? Huh? Yeah, what's the skin look like? Dry hair, brittle, bone marrow, depressed, sperm count, low breast size, atrophic endometrium, atrophic endothelium, atrophic, where they're going to bleed from, skin and mucosal surfaces, all of them, not just, all right? And then, of course, we can add bleeding time is elevated anytime you're bleeding from the skin and mucosal surfaces, too. All right, what part of the nephron shut down first? What the? PCT. What cancer they're predisposed to if they live long enough? What the? What? Skin followed by? GI followed by? Bone marrow. But now what if they ask you what's the most common cause of death? Poverty, you say what? Heart failure. Say it again, Poverty. Heart failure. Most common cause of death for low energy state. Poverty, you say what? Heart failure. Anytime you got low energy state and they ask you what's the most common cause of death, Poverty, you say what? Heart failure. Angie, anytime you got low energy state and they ask you most common cause of death, you say what? Heart failure. Nick, anytime they ask you most common cause of death for low energy state, you say what? Folks, that means every time, each and every time you can connect to a low energy state, I better hear the same stuff all over again. Let's try it one more time. Sir, what's your name? Eric? Eric, Joni, Tarek. Eric, Joni, Tarek, Rob, and Jim. Eric, Joni, Tarek, Rob, Jim. All right, Eric, let's try it again. Low energy state, most common presenting sign is going to be what? You can always look in your notes. I don't hear anything new. I don't hear anything new. So give me a dyspnea. Joni, symptom. Weakness and shortness of breath. Tarek, infections. Pulmonary UTIs. Rob, we got to do complications. What organ you worried about the most? Brain followed by? Heart followed by? But what if they just go in line and just say skin? What's it going to look like?
Dry.
Hair. Dry. Bone marrow? Bone marrow. Say depressed. Depressed. Everything's going to be low. All right. Endometrium. Atrophic. It's just not going to grow. You understand? All right. Endothelium. Atrophic. Where are you going to be bleeding from? Skin and mucosal surfaces. What test will be elevated? PT, PTT, or bleeding time? Bleeding time. Breast size. Oh, wait a minute. I have to rub. Brian, was it?
Jim.
Jim. Oh, that was cool. Right. Anyway, I'll get it, man. All right, so Jim, where do we leave off? GI symptoms.
Diarrhea.
Yeah, nausea, vomiting, diarrhea. What part of the nephron was shut down first?
PCT.
PCT. Sperm count? Low. Where they going to get their infections at?
Respiratory UTI.
Respiratory UTIs. If I ask you, what cancer are they predisposed to if they live long enough?
Skin.
Followed by? GI, followed by? Bone marrow. Everybody with me? And the most common cause of death. What is your name? Mayuri. Oh, yeah, I remember seeing that. Mayuri. Okay, so that's how you pronounce it. Most common cause of death for lower anesthesia, you say what? Heart failure. You got it down? Mayuri. Do you got it down? Jim, you got it down pat? Rob, you got it down pat? Tree, you got it down pat? Richie, you with me, baby? Pratish. Yon, you right there with me? Joseph, you with me? All right, man. That means every time we connect to the Lord in state, I want to hear the same stuff. Ramathia, lead me off. You ready? All right, girl. Tell me something about diabetes. What do you know about diabetes? Type 1.5. All right, type 1. Tell me about type 1.
Type 1, you typically see the death.
Tell me the problem. What's the problem in type 1 diabetes? No insulin. What do you need insulin for? I don't get it. Wait. Ramathia? You need insulin for glucose. What does insulin do with glucose? So, and you need insulin to push glucose in the cell. Well, what do the cells do with glucose? Did somebody say something about energy? Wait a minute, Ramathia. Take a deep breath. The most common presenting sign for diabetes is what? Sign for diabetes is what? Sign, Ramathia. You can read off your notes. I don't hear nothing new. I don't hear nothing new. Tachypnea dyspnea, symptom. Keep talking. Keep on talking. Symptoms. Symptoms. Speak. Thank you very much. What's their skin look like? Hair. Bone marrow. Nails. Endometrium. Atrophic. Endothelium. Atrophic. What are they going to be bleeding from? Skin and mucosal surfaces. Wait a minute. What test is going to be elevated? PT, PTT, or bleeding time? Bleeding time. Tell me the GI symptoms. Nausea, vomiting. What infections do they get? What part of the nephron shut down first? PCT. Wait a minute. What cancer can they get if they live long enough? Skin followed by? GI followed by? Bone marrow. What's the most common cause of death in diabetes? Thank you very much. I don't hear nothing new. I don't hear that stuff you've been reading out of the books. Welcome to my world, baby. Pull out any book right now. See diabetes. I bet you didn't know you've been misreading it. That's the clue for diabetes. That is not the most common presentation. See how you guys get scammed? You guys want to quote what your book said? You didn't even understand. My question didn't ask for that answer. That's why you guys keep picking it, and you didn't even know you didn't get any points for it. See that? The question said, what's the most common presentation? You say, no, wasn't it? Mom's seen that kid been dragging around for the last 2 weeks. She'll tell you that when she gets in there. Oh, yeah, he's been kind of dragging around the last 2 weeks. But I thought he just had a cold. Huh? The weakness came before the polyurine polydipsia, folks. Look it up for yourself. It'll blow your mind. You've been marking stuff because you read out a book without even knowing how to think it through on your own. And that's exactly what they're trying to weed out physicians who don't know how to think on their own. They just quote books. They quote articles. But they really don't understand what the information is. Z! You with me, babe? You right there with me? Check it out. What do you know about Crohn's disease? You ever heard about Crohn's? What's wrong in Crohn's? I heard there's a disease named Crohn's. Yep. I heard there's a problem going on in Crohn's disease, too. Amika, help her out. She's frozen in time right now. All right, Amika, in Crohn's disease, what's the problem? Oh, look. All right, let me tell you guys something. All right, because they both are demonstrating it. There's something called a cortisol effect. Whenever you get nervous, you know, epinephrine is the first hormone to come out. Even the little amount of cortisol that comes out in that fraction of a second, studies have shown can, boom, block all long-term memory. That's why all of a sudden you start seeing people. Now, you knew it a second ago. As soon as I call your name, you don't know it anymore. Why? Because you feel on the spot. That's why I always want the person who I call to answer, because I feel that part of helping you out is I'm trying to help desensitize this cortisol effect that happens. Because as long as you panic every time somebody calls your name, you won't come up with the answer. I already know that. It's not because you don't know, but I can see the cortisol in your eyes by the way you're responding. All right, Sharice. I got a problem in Crohn's. What's wrong?
You have a problem with your colon.
Crohn's, let's start it in the small intestine. What kind of problem is Crohn's?
Crohn's is a disorder of the mucous membrane.
Well, so the mucosal surface of the GI tract. So the problem is going to be what? If I mess up the mucosal surface, you cannot...
You cannot have phenocitosis.
Wait. You're moving too fast. If I mess up the mucosal surface of the GI tract, its main function is to absorb. That means you can't absorb anymore. What are you trying to absorb?
Water, electrolytes.
Uh-huh. What's the number one thing your body tries to absorb every day?
Water.
All right. After that is what?
Potassium, sodium.
Okay, let's just stop at water. What's the number one thing your body needs water for?
The functions, the membrane.
What function is that? Talk to me.
To hold the organelles to
Sounds good. But the number one reason why your body needs water every day,
don't dehydrate.
well, you drink to not dehydrate, but I'm saying, what is your body going to do with that water? She just doesn't want to give in. Come on, Sharice, give in, baby. Your body uses great energy, do you hear me? And if there's a problem with energy, tell me again. The most common presenting sign in Crohn's disease is what? Most common presenting sign in Crohn's disease is what?
Oh, tachypnea.
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 And thank you very much. Most common presenting symptom in Crohn's disease is what? Shortness of breath and weakness. What infections do they get?
They get lungs,
Pulmonary infections and UTIs. What's your skin look like? Hair, bone marrow, nails, endometrium, endothelium, sperm count. Give me the GI symptoms.
GI symptoms. Dehydrated.
Wait, what? GI symptoms. You can just read up there. I don't hear nothing new. GI symptoms would be, remember, nausea, vomiting, diarrhea. Oh, what cancer can they get if they live long enough? Skin followed by? GI followed by? And bone marrow. Okay, so that means if I give you all the complications of Crohn's and I ask you to put them in order, what's the first organ you got to pick? What's the most important organ in your body? Brain followed by? The heart followed by? The kidney. You understand? But if I ask the most common cause of death in Crohn's disease, you say what? Thank you very much. Don't fight it, babe. You can look it up if you want. It'll blow you away. You guys been reading the same old stuff over and over again, but didn't know it. That's because nobody told you. Nick! You with me there, babe? You with me there? All right, Nick. How does a mom know when a child is ill? Let's say he's picked up RSV. He's not himself. What's the first thing about not being himself that she notices? Oh, weak! Did you say weakness? That means the most common presenting sign for illness in general is what? Tachypnea indigenous symptom is what? Weakness is what infections are you going to get on top of this?
Pulmonary first, UTI.
Oh, pulmonary UTIs. Look it up, man. Check it out for yourself. Do you know that the low energy state is 98% of illnesses? I'm looking you up, first half hour. 98% of illnesses are low energy state. I'm telling you that anytime you don't understand any question they ask you, default to low energy state. I don't hear anything new. I'm telling you right now, don't give me anything new. Just give me the same old stuff. That way you'll be right 98% of the time. Doggone it, you guys always want to be geniuses. Think about these weird diseases. Try to tell me what Robin said the first day. I don't want to hear it. Just tell me what physio says you ought to be saying. That's a better answer if you want to get a point on the exam. Does everybody understand? So that means, young lady, what's your name? Bindia? Bindia. What's the most common presenting symptom for pneumocystis, cranial pneumonia, in AIDS patients with CD4 count below 200? Weakness, shortness of breath. What's the most common presenting symptom for RSV pneumonia? Strep pneumonia? Aspiration pneumonia? Actinomyces pneumonia? Weakness, shortness of breath? What about histoplasmosis? Blastomycosis? How about cancer? Coccidiomycosis? Chemotherapy? Amika, what's the number one reason for stopping the use of a drug? Weakness, shortness of breath. See how I can apply it 1,000 different ways, folks. You guys can keep on looking at, what's the number one reason for stopping the TCA? What's the number one reason for stopping haloperidol? What's the number one reason for stopping furosemide? Look them all up right now. See if I'm lying. See if I'm lying. It's the same damn thing. But they never told you. That's how it came about. There it is. The number one reason why a patient goes to see a doctor. I'm weak and I'm short of breath, doc. Does it matter if you ask me why he stopped the drug? Why he's got an illness? Common cold, virus, fungus, cancer? It doesn't matter to me. I'm telling you the same old stuff. That'll be the best answer. No test writer can change the truth, folks. They can only change the words. That's how they get you guys. They keep changing the words. And students keep falling for it. Just because they change the words, must be different. No, folks, I'm telling you, better go back to the same old stuff. It'll be boring, but it'll be a high score. It'll be a high score to blow your mind. It's the most amazing thing. Now, here's how they get you. Here's how they get you, Jim. What's the most common cause of death in 30 to 40-year-old white females who got rheumatoid arthritis and they're on at least 10 milligrams of prednisone? Heart failure. Wait a minute. Jim, what's the most common cause of death in lupus nephritis if they require at least 20 milligrams of prednisone and methotrexate too? Heart failure. Wait a minute, Jim. It can't be that easy, man. Hold on, man. No, it can't be that easy. Let me mark something else. That's how you guys do. Well, let me see. I done marked 7 D's in a row. I don't look right. Let me change this one to a C. Let me put an A over here. Yeah, that looks a lot better now. Man, what's that got to do with the answer? If the answer is D 7 times, you better be marking 7 D's. And stop worrying about, it doesn't look that good. That's the right answer. I'm marking it again. That's what will blow you away, folks. It's been the same answer for so long, you guys just didn't even know it. Because they filled your head with so many details, you don't see the concept anymore. All right? That means if they ask you, Gretchen, what's the most common cause of death in America? You say what? What's the most common cause of death in Africa? Ramathia, you say what? What's the most common cause of death from malaria? Rahul, in Africa, you say what? What is the most common cause of death in Russia? Shane, you say what? What's the most common cause of death in India? Asif, you say what? What's the most common cause of death in 3-year-olds in Africa who haven't eaten for the last 3 weeks? Sharice, you say what? Y'all better get off me, man. Y'all better get off me, boy. Better get off me. This is how they fool you, folks. They fill your head with details you don't even see. It's the same old question coming at you. No test writer can change the truth. You can't go telling me, the cause of death is something different. Nah. What initiated is different. The cause of death, I bet you still the same. I bet you still heart failure. It'll blow you away. Holy cow. Why didn't they just tell me this in medical school? That if you just taught me this pattern alone, I'd have got more answers right if I'd have known this in medical school without going to any more classes. All right. So anytime you connect to lower entity state, folks, don't give me anything new. All I'm telling you, apply the whole thing. Because as we learn concepts, that's what a concept is. Remember the tip of the pyramid, except we're turning it upside down. You've just gotten a concept. So that way when we start applying it, don't give me anything new. Just give me the same old stuff. Now if you want to look it up, you'll be shocked. It's been there in the book. But you were so into the details, you missed it. That's why then when you got the exam, you missed it. Because you picked polydipsia when they ask you, what's the most common presentation of diabetes? That's the clue. See? That way, when I can get you to see the big picture, the concept, all I got to do is tell you the clue for what disease they want. See that? That way, if I see aha, I know which lower entity state they're talking about now. See that? Or at least you narrowed it down. This way, you're not all over the place. It also allows you to ignore 90% of vignettes. Because now you understand hair loss, dry skin, brittle nails, that don't mean a doggone thing. But you know how they capture your attention? They call them distractors. They say, well, he's got balding only in the back of his head. Do I really care? You guys do. You try to make up a syndrome. What's that syndrome that bald's only in the back of their head? Go ahead. I'm 3 questions ahead of you while you try to figure that out. Stuff about hair loss, brittleness, folks, I don't even read that stuff. I say, unnecessary. Still doesn't tell me anything. I just read till I see the clue. As soon as I see the clue, click, next question. I say, I know exactly which one they want me to pick now. I'm done. This way you're not trying to figure out everything, folks. There's some things you got to know. So stop guessing. That means you have been empowered in the first 40. All right, turn to vitamins, minerals, and trace elements. Now we're going to apply it. So vitamins, minerals, and trace elements. Now we've learned the concept, which means the signs are the same. Shweta, break it down. The signs of any of these deficiencies will be what? Tachypnea, dyspnea, poverty, the symptoms. Weakness and shortness of breath. Angie, the infections. Pulmonary UTIs. Nick, what's the skin look like? Dry in the hair. Dry and brittle nails. Brittle bone marrow. Suppressed. What about the breast size? Breast size. Atrophy. Sperm count. Low. What cancer are they predisposed to now? Skin followed by GI followed by bone marrow. What infections will they get? UTIs and pulmonary infections. What's the GI symptoms going to be? Nausea, vomiting, diarrhea. What part of the nephron was shut down first, Amika? PCT, and the most common cause of death for all these deficiencies, Amika, is what? That woman's been empowered. That man's been empowered. I didn't hear nothing new. We just covered every vitamin, mineral, and trace element without talking about it. That means all that's left, folks, if they all have the same signs, symptoms, infectious complications, and cause of death, that means you ain't told me squat. You ain't told me squat till I hear one more thing. Lord, what do I need to hear after that? I got to hear the clue. Now I got to tell you the clue for these diseases if you want to get a point when you get to the exam. Everybody understand? Let me show you further application. Now this is, I get a lot of kick out of this because you're like, if a medical school invites me and they say, we want to know, what are you doing down in Champaign? How come you got all these high scores? I said, invite me down there. That way I get a free trip, see? That's how I get them. I said, yeah, invite me to your school. I'll come show you. So I come over there and show. I always pick something in the field or whoever their dean is. Because he's supposed to be expert, right? So I just take something out of his field and then boom, show him a concept to wrap up everything you know in one concept. A minute ago you thought you knew something. All right? So let's say that Lou used the learning stage. One I went to was in St. Louis. The dean there, one of the deans that was there, I had about 8 people, and I want to demonstrate what it is I do in Champaign. One of the deans was a surgeon. So I said, watch what I'm going to do. I said, I'm going to program the crowd. And I said, after about 10 minutes, I'm going to start asking them questions. And I bet you they'll be able to answer them correctly. And they're all like, what? What do you mean? How's that going to be right? Well, you see what just happened. All of a sudden, they saw the concept with me. I fired away questions quickly. They understood it. And then I looked at the surgeon. I said, now, Mr. Surgeon, do you understand why you get a UA and a chest x-ray before everybody goes to surgery? And his jaw dropped. He had no idea. That's why you always do that. See, that's what I'm telling you, folks. Everybody's reading articles. The article says, hey, get a chest x-ray, UA, and everybody going to surgery. Why? Pulmonary infections? UTIs. But nobody tells you this. You just keep following what the article said. And then when I show him that, oh my God, then he realized, holy cow, never thought about that. I said, that's where it comes from. I said, but they didn't tell you that. They just trained you. You've been doing surgery for years. But I'm telling you, I can wrap up everything that you're doing as a surgeon. Just a couple of concepts. Tell you how to manage any patient in surgery. That's how Rick knew how to manage. In every field, he knew more than the doggone expert. Dr. Shaw, same thing. How do you know more hematology than hematologists? Wait till I break it down for you in biochem. That's where it all came from. I said, holy cow. And then when you get to class, they talk about Heinz bodies and this, that, body, and that. All right, great. Could you please tell me where anemia really came from? That way I can figure out anemia for myself? Man, all right. Vitamins, minerals, trace elements. The beginning goes a little something like this. Hey, you know, every now and then I get on the road, okay? And I like a transition. So that means I look at somebody, Mayuri, and then next to Mayuri is Antonia. Not Antonio, Antonia. All right, so anytime I look at you and I say, tell me what I got to do. Lord, tell them what I got to say. You got to say, break it down, Dr. Francis. All right? So when I'm going to roll, I like a little transition before I go. All right? Okay, man, here we go. The beginning, baby. Vitamin A, vitamins, minerals, trace elements. Vitamin A, first got to tell you normal. Remember I told you, focus on normal before we start talking about abnormal. The normal is vitamin A is used for parathyroid hormone function. Vitamin A, cofactor of PTH function, necessary for CSF production, and necessary for epithelial cell maturation. That means anytime you want cells to mature faster, give them a little vitamin A, they will do that for you. Right? Most unique function, however, for vitamin A is night vision. And then it's also a mild antioxidant. So these are the normal functions. Therefore, Antonia, if I'm missing vitamin A, do you see where all the problems come from? Does everybody understand what I'm saying? You understand, Jim?
Yeah.
Look at that. See what leads it off? Its most unique function. If you want to get a point on a test, that's how you get the point. They want to see, did you understand the most unique function is what's going to bring that patient in to see you? Okay? Poor night vision. But on the boards, they'll switch it up a little bit, Mayuri. He can't see when the sun goes down. Click, next question. He can't see when he goes inside out. Click, click, next question. He can't see when he goes in the shade. Click, and move. They don't always have to use these same words. Remember I told you, the test writer can change the words. But as long as you know the idea, folks, that idea will never change. That's why I want you to focus on the idea. Okay? It has to do with low light. Anytime there's low light, all of a sudden the person can't see, vitamin A. Okay? Decreased CSF production is going to be asymptomatic. You won't even know. Okay? Anytime you have less CSF, your body does not know. Hypoparathyroidism, however, you will know, Monica. If your pH is low, your serum calcium will be low and your phosphorus will be high. Whenever pH is involved, Angie, your calcium and your phosphorus are always in opposite directions. At least try to get that. Anytime the calcium and phosphorus are in opposite directions, Sharice, it has to be a pH problem. You understand me? You understand, Z? All right, okay? That's the differentiator for vitamin D we're going to talk about later when they're in the same direction. And then finally, 2 steps to getting it right. Almost every time, folks, calcium and the hormone always go in the same direction. If ever you forget, calcium and the hormone got to be in the same direction. So this is hypoparathyroidism, so I start with low calcium. And that means phosphorus got to be up. Okay? All right. And then epithelial cells will fail to mature. Well, look at AML or promyeloblast leukemia. That's why I added this as a new clue. Translocation 1517. I do it in leukemias. You'll hear it again there, but I wanted to kind of touch on it here. All right. Translocation 1517. Promyeloblast leukemia. They give them vitamin A so that the cells will mature a little bit into AML. What that does for you, Shweta, allows you to live a little longer. Because promyeloblast can be dead in a few months. AML, maybe got a year or 2. That's a lot better. Well, they're going to do more than that, Joseph. That means if you have any disease where you wear away the lining of any organ, and I ask you, how can you regenerate it faster? You give them what vitamin, Joseph? Vitamin A. So that means if they give you a child with measles, Ramathea, who's worn away his pulmonary epithelium, and I ask you, how can you regenerate his lung epithelium faster? You say what? Does everybody understand that? Okay. That's the key. It doesn't matter if they change the context. Don't you go changing your answer. Okay? It could be a cancer. It could be measles. It could be anything. I don't care. But if you tell me that that disease wears away a lot of cells, and of course when we talk about infections, we'll talk about the infections that wear away a lot of cells. I bet you I know how to get those cells to come back a lot faster. And therefore change the prognosis. That's the point. That's what management is if you understand what's wrong, then you'll understand how to correct it, or at least what to correct. Rather than just memorizing an article that says do this, do this, do this, but you don't know which order you should pick it when you get to the test. Okay, so vitamin A deficiency. Vitamin A excess. What if you have too much vitamin A, Gretchen? And now you're going to have too much CSF. You'll have problems now. Because anytime you have too much CSF, Bindi, is that right? Bindia. Antonia. Okay, Bindia, Antonia. All right, got it. All right, let's see. Eric. I got it right? Eric, Joni? All right, cool. So if you got too much CSF, you're going to increase the pressure in your brain. Does that make sense to you? So a headache will be your symptom. Look in your eyes. Evidence of intracranial pressure is called papilledema. You understand? You understand, Joni? So pseudotumor cerebri, too much CSF, headache will be your symptom. Papilledema will be your sign. Anytime somebody comes in with headache and papilledema, you always got to suspect that they got increased intracranial pressure. Right, Antonia? Right, Bindia? What's the first thing you want to do to rule out increase in intracranial pressure? You ask yourself, what's the worst it can be? A mass pushing down on your brain. How do I rule out a mass, Jeff? How do I rule out you got a mass in your head, man? What about you, Rob? How would you rule out a mass in your brain? called a CT scan MRI, folks. That's how I know when they're coming with those complaints, CT scan MRI is your first answer. If you want to get a point, anything else you pick won't get you any. So even though you know it's a pseudotumor cerebri, that's fine, but management for boards 2 is not about knowing what it is. It's how do you manage the patient to make sure they're still alive when you find out what it is. All right? So you always got to say, well, what's the worst it can be? That's what management is. The worst it can be, you better rule that out first before you settle on, oh, it's just pseudotumor cerebri. All right? So you do a CT scan. Well, then you say, what's the next worst it can be if it's not a mass? It's called an infection. Mayuri, how do you rule out an infection in your brain, Mayuri? Take some CSF. What's that called? Lumbar puncture. That's how I know lumbar puncture comes second. Wait before you say, yeah, this is pseudotumor cerebri. This is just management. This is how I integrate it for the boards 2 and 3 people so they understand where that management came from. Otherwise, you're just memorizing what some book told you. But if you don't know what order to go in, that's where most of the boards 2 students made their mistakes. They just remember the book saying all these things, but not which one do you do first, which one do you second. Because a lot of times they say, well, you've already done blank and blank. What do you do now? Oh, they lost after that. Okay, they can remember sometimes the first step, but not the second or third and fourth step. All right, so CT scan, lumbar puncture, and then when you do a CT scan on these people, you'll see dilated ventricles. Too much CSF will just dilate your ventricles, Jess. Make sense to you? All right, you won't see any more problems after that. How do you treat them? Serial lumbar punctures. You actually do lumbar puncture after lumbar puncture. But obviously, first of all, you stop the vitamin A that caused the problem. If you know vitamin A caused the problem, stop it. Most of the time, this is a young athlete who thinks 1 vitamin tablet is good, so 3 vitamin tablets must be better. The 2 that I saw, that's exactly what they were doing, taking too many vitamins in the morning until this happened. Now, see, the importance why they're testing you on this is if you don't tell them, guess what? They'll be back in a couple of weeks with the exact same problem again. Nobody told them it was the vitamins that's causing it. Okay, management is always, what's the underlying problem? Take care of that. That's the number one thing you got to do. I mean, stop the vitamin A. Now do the serial lumbar punctures. And the rule is don't take off any more than 30 cc's at a time. Now, Angie, the reason for knowing that number, especially for the boards 2 and 3 people, Katie, is because if you take off more than 30 cc's, you cause osmotic shifts to occur in the brain. You don't want that. You want to take off just enough without osmotic shifts occurring. Because you don't want to tap off. Remember, there's pressure right now. You tap off too much, they'll herniate. All right, but the problem is, and the good thing is, in pseudotumor cerebri, you don't have to worry about herniation because there's nothing pushing on the brain. It's just all CSF. But we're worried about osmolarity shifts. CSF, remember, is continuous with your plasma. The pons, as you're going to find out later, is the most sensitive to osmotic shifts. If you cause osmotic shift to happen too suddenly, you can cause permanent pons damage. We'll be talking about that more when we do sodium. Okay? All right, the main complication of pseudotumor cerebri. What organ comes first in making that determination? Poverty. The brain. So blindness. Number 1. Notice that's neurological. The brain. All right. So this is the one cause of increasing the cranial pressure, Rishi, where we don't have to worry about herniation. You understand, Pratish? You understand, Eric? Johnny? Oh, good. Okay, let me finish second row. All right. Next to Antonia. To the right of Antonia. Thara? How do you spell that? T-A-R-A. But you pronounce it Thara, like the? Thara. Thara. All right, Thara, got it. Miguel. Thara, Miguel, and? Narek. How do you spell that one? N-A-R-E-G. Narek, okay. So Thara, Miguel, Nareg. All right, Thara. You understand pseudotumor cerebri now? What's going to be the most common presenting symptom? No, that's a complication. Most common presenting symptom. Yeah, remember anytime you got increase in the cranial pressure, headache is a symptom, papilledema is the sign. Always. Okay? All right. So, pseudotumor cerebri. All right, the other vitamin A connection, now you got too much PTH effect, Jesse. If you have too much vitamin A, PTH works too much. Now, Jesse, what's going to happen to your serum calcium? Huh? Too much parathyroid? Vitamin A is used with PTH. So if you got too much vitamin A, too much PTH action. So that means your calcium now will go way up. That means, Jesse, your phosphorus will go down. Remember, they got to go in opposite directions. Everybody clear? Right? Ramathia? Cool. So hyperparathyroidism, vitamin A excess. All right. Vitamin B1, thiamine. Thiamine, thyra, thiamine, B1. Well, what they want you to know is that it's necessary for 4 very important enzymes in your body. They're dehydrogenases. We're going to be talking about each one of them: pyruvate dehydrogenase, alpha-ketoglutarate dehydrogenase, branch amino acid dehydrogenase, and even later transketolase. You're going to see these are needed for a lot of pathways, folks. And that's why if you're missing thiamine, all these enzymes just stop working. You understand, Miguel? You understand, Narek? All right, so you don't want to be thiamine deficient. You understand? All right. Hey, what kind of a person do you know is usually thiamine deficient, Narek? An alcoholic. That means without thiamine, guess what? Pyruvate dehydrogenase shuts down. Laura, if you got pyruvate dehydrogenase problems, can you enter the Krebs cycle without this enzyme? No. That means everything stays out in the cytoplasm. Oh, wait till we get there. I got to break it down for y'all, man. So you see alcoholism through the eyes of biochemistry. Simple. You understand, Miguel? So B1, thiamine. So thiamine deficiency, first disease, beriberi. What is beriberi, Amika? It means your heart's giving out. Why is your heart giving out, Amika? Because your heart needs all 3 of these enzymes. Your heart needs all 3 of these enzymes. So without it, it just dilates. So they talk about biventricular dilation, just dilated cardiomyopathy. Because that means the heart has no energy. Remember, the heart has to keep beating at all times. So beriberi. So we call it dry beriberi until you have heart failure. You got fluid in your lungs. Then we say wet beriberi. That's the only difference. Beriberi, dilated cardiomyopathy, because the heart needs all these enzymes. And then Wernicke's encephalopathy. Wernicke's area, Laura, is located in what part of your cortex? Posterior temporal lobe, correct? So that's why, therefore, Wernicke's encephalopathy is responsible for receiving spoken or written language. If the thiamine is deficient, you cannot understand written or spoken language, and that's what receptive aphasia is. Wernicke's encephalopathy. Receptive aphasia. Now that's to differentiate it from Broca's. B-R-O-C-A. Broca's, that we'll be talking about in neuro, which is expressive. That's posterior frontal lobe. Expressive, talking. Remember, they get monosyllabic babbling. All right, expressive aphasia. So Wernicke's, thiamine deficiency, posterior temporal lobe, receptive aphasia. You understand, Narek? You understand, Miguel? Thara, you understand? Yeah. Antonio? You understand, Mayuri? Understand, Jim? All right, man. Now, we call it Wernicke-Korsakoff syndrome, Rob, when the mammillary bodies are involved. Because now the mammillary bodies help short-term memory move into long-term memory. So if the mammillary bodies are incapacitated because of thiamine deficiency, you can't remember what you said yesterday. That's what confabulation is all about, Tariq. You start making things up. So, Wernicke's, just a receptive aphasia. Once they say confabulation, it's now into Korsakoff. It means it's gotten more severe. Everybody understand the difference? The key is to know that clue, because everything else is going to be the same. Remember, these are all low energy states. That's why the little clue, folks, is the stuff you better know. The other stuff, we can just fill in the gap. I'm not even worried about that stuff. But if you don't know the clue, then you won't know which best answer to pick on the exam. That's the key. Now it's, was that Wernicke's or was that Korsakoff? Oh, yeah. Any, meeny, miny, moo. None of that. All right. So, mammillary bodies have to be involved. They call it Korsakoff. Confabulation is your clue. Vitamin B2, riboflavin. Riboflavin, Raul, is used for cofactors that we're going to be running into, FAD. So that means without riboflavin, FAD can't work. That means the pathways that use it cannot work. You understand, Miguel? That means low energy states, because those pathways can't create energy for you. The best source of riboflavin, Nareg, milk. Well, years ago, Nareg, they put riboflavin in the milk. You know how the milkman would come around and set the bottles on the porch, then your mom will come out later on and pick it up, right? And then years gone by, and they saw a huge outbreak of riboflavin deficiency in children. They said, wait a minute, I thought we put riboflavin in milk. Well, they did. The problem is when the sun came out, it actually broke down the riboflavin out of that milk. So the children were drinking riboflavin deficient milk. And how did they know riboflavin deficiency? Because they all had these little fissures in the corner of their lips. Angular chelosis. Now, you've had angular chelosis many times, folks. Okay? Now, I know, I don't drink any more milk. Blacks and Hispanics become lactose intolerant somewhere between 5 and age 10. So I don't drink milk on a regular basis anymore, unless I got to eat a peanut butter and jelly sandwich. That's the only thing that makes it good, man. Got to have that. I'll bear the pain afterwards just to have peanut butter and jelly. But anyway, the key is, if I don't eat fruits and vegetables, after about 3 or 4 days, fissure, riboflavin deficiency. Did you know? Did you know, Katie? That's why milk is now in cartons. You know what public health is, folks? I'm going to educate you about public health without even reading a book on public health. You know what public health is? Let me just show you the big picture. It's when doctors saw a problem and they lobby with government to make a ruling. That's public health. Rather than reading the public health, why don't you learn the root of that public health? So milk is sold in cartons because sunlight can't get through the carton. See, that's the kind of question they'll ask you, and you're like, what? Why they ask about milk in cartons on Boris 1? Man, where'd they get that question from? You see, it sounds like a pick. If you knew the root, it'd be an easy question. All right, so riboflavin deficiency, ankylosis. B3, niacin deficiency. So B3 is your niacin. So Mayuri, niacin, B3, you understand? Well, you need B3 for a lot of cofactors. Look at that, NAD, NADH, NADP, NADPH. A lot of pathways will stop if you didn't have niacin. Not good. And then all the dehydrogenase is needed that we were just talking about. You understand that, Mayuri? You understand, Antonio? So you don't want to be deficient in niacin because you'd stop way too many pathways. Okay? Well, niacin deficiency, here's your problem. It's called pellagra. So that means Bindia. Bindia, rather. I kind of went over it. Bindia. All right, so pellagra. 4 Ds. You see what the 4 Ds stand for? Diarrhea. Hey, didn't we say diarrhea occurs in low energy state? Dermatitis. Didn't we say dermatitis occurs in low energy state? Dementia. Didn't we say you can get dementia in low energy state? And then death. Didn't we say you can die from low energy state? Oh, my goodness. Well, a long time ago, somebody came up with the 4 Ds for pellagra. Then later on, they found out, heck, every low energy state gives you the 4 Ds. So anyway, on the boards, humor them, don't argue, don't fight. I sure don't argue. If they mention the 4 Ds, I click pellagra every time. But the reason why I'm pointing out to you is I don't want you to be on teaching rounds and then the attending asks you, okay, what's your differential for dermatitis? And you say, niacin deficiency. And that's it? No. Every low energy state gives you that. That means you should be able to give him like 25 of them before he tells you to stop. Okay? So I'm going to teach you guys a lot about survival beyond past program. How to survive in front of an attending, whether he's abusive, whether he's nice, or in a big group, small group, all that stuff. I'm going to show you how to survive in all those situations. All right, so pellagra, 4 Ds gives it away. And then we got a disease called Hartnupp's disease, Pavani. Hartnupp's disease, Jim, that presents just like pellagra. Now, check this out. They're going to say a patient has a pellagra-like disease. Geez, I wonder which one they're talking about. I'm telling you, sometimes the clue is so obvious, your mind just misses it. It says pellagra-like. Well, there's 2 diseases that present just like pellagra. If it ain't pellagra, it must be the other one, Hartnupp's. Click and move, man. Okay? Because they have the same signs and symptoms. The difference is usually what they usually ask on the boards. In Hartnupp's disease is defective renal transport. They love to ask, where's the actual problem? It's not in the sense of niacin. You can't even reabsorb the tryptophan to make the niacin. That's how you get the exact same problem. All right, across from Nareg, you got to finish that row. What's that? Jadeep. All right, Jadeep. Jadeep Marina. What is it? How do you spell it? H-O-V-I-G. Hovig. All right, Jadeep Marina Kovig. Oh, Hovig. Hovig, and finally, Shelley. Okay. Shelley, Hovig, Marina, Jadeep or Gadeep? The J-A-G? Oh, okay, that's where I'm hearing the G from. All right, Jagdeep. All right, gotcha. All right. So you understand pellagra, Jagdeep? What about you, Marina? What about you, Hovig? Shelley, with me? All right. So if they say pellagra-like illness, Shelley, what are you going to pick? Hartnup? Hovig, what's the problem in Hartnups? And what's different about it, though?
You're not getting
From where? All right. So defective renal reabsorption of tryptophan. All right, cool. Vitamin B4, lipoic acid. You need it for the 3-dehydrogenases. You need it for the 3-dehydrogenases. You need it for the 3-dehydrogenases, Marina. But there's no deficiency state of lipoic acid. Vitamin B5, pantothenic acid, Marina. You need it for the dehydrogenases as well. So that means, Shelley, B4 and B5, no deficiency state. That means you can eat dirt and get B4 and B5. You can chew on your shirt collar, no problem, B4 and B5. You can lick the bottom of your shoe, no problem, B4 and B5. What this means is there's never been a human being that's diagnosed with these deficiencies. It's in everything you eat. You can eat Twinkies. There it is. B4 and B5 is found in there too. All right? That means you can kiss your honey and get some vitamins. That means you can say, honey, I'm deficient in B4 and B5. Help me out. I'm going to teach you a lot about physio and biochem, man. All right. All right. Pantothenic acid, however, is used in coenzyme A. So we're going to see that a lot, you know, acetyl-CoA, palmitoyl-CoA. So anytime you hear CoA, they'll ask you about what vitamin is in here. Pantothenic acid is. Okay, you understand Jack Deep? You understand Hubik? All right. You understand Tariq? So, no deficiency state in B4 and B5, Tariq, with me? B6, Tariq, pyridoxine deficiency, man. What do I need pyridoxine for? To make heme. So see, low energy state. Without this guy, you can't even make heme. To carry oxygen, to make ATP. Who else needs it? All the enzymes that end in transaminases. So that means, Katie, when they start asking about ASTs, ALTs, GGTs, see that? They can make it a vitamin question all the way on boards 2 and 3. And then the students have forgotten that stuff because they think, oh, it's just boards 1. I don't think so. All right, there's a drug called INH that pulls vitamin B6 right out of your body. And that's because you need B6 to form the cofactor pyridoxal phosphate. You see that, Laura? Got to have pyridoxal phosphate. Awesome. Pyridoxine deficiency, man, doesn't have anything unique about it. So you need for all transaminases, you need to make heme. Well, every tissue needs it. So that means Asif. If I ask you with a pyridoxine deficiency, what organ are you worried about the most, Asif? Break it down, my boy. Brain. No wonder they say neuropathy is the most common side effect. Gee, where'd they get that from, huh? Folks, that's a default answer. Imagine that. Why don't they never tell you guys that? Anytime they ask you about any drug or anything affecting your body, and you don't know about any clues that I gave you, folks, if you're not sure of something, I told you better default to the Lord and say, if you start guessing, that's how they get you. That's how they get you. Okay? So that means without knowing that valproic acid is associated with neurotube defects, I can still get it right anyway. See my point? Still brain, is it not? That's the kind of stuff they never teach you in medical school. Instead, they just teach you, oh, valproic acid causes meningomyelocele. Great. Then what happens when they switch it to some other neurological problem? You say, oh, no, the book didn't say that. See? Now they got you. You lose again. Okay? It's brain. Anything brain, I pick. Okay? So pyridoxine deficiency, neuropathy. Well, you need to know anytime you talk about treating chronic neuropathy, okay, I do my pharmacology in context with physio and biochem, so you see it. If you got to treat chronic neuropathy, drug of choice is a TCA that we'll be talking about called amitriptyline. Amitriptyline for chronic neuropathy. So anytime we have a disease that gives you chronic pain or neuropathy, amitriptyline is the drug you want to use. Oh, I guess I could put it in white, make it easier. If you want to treat shooting neuropathies, Laura, shooting neuropathies, you use what? You remember that one? Let's see if Monica remembers. Shooting neuropathy? Close enough. Carbamazepine. As long as you give me part of it, I'll give you the rest. Carbamazepine is first line, and now we're using gabapentin as second line. It's this again. I always like to do pharm in context with phys and biochem, folks. That's the way you learn your drugs. All right, so we'll be talking about these as just straight pharm when we get to them. But amitriptyline is the drug of choice for just chronic neuropathy. That means no shooting, no stabbing to it. Once they say shooting or stabbing, carbamazepine is your first line, gabapentin is your second line. Okay? So they'll give you a diabetic for chronic neuropathy, and thyra will be all over it, won't you, thyra? So drug of choice for chronic neuropathy, thyra will say amitriptyline. For shooting neuropathy, Antonia will say carbamazepine. All right, good. Vitamin B9. B9. Let's see. Behind Tariq. Let's learn the next row. Victor. And to the right of Victor. Leanne. Victor, Leanne, and Leslie. Victor, Leanne, and Leslie. All right, Victor. B9. Folate. Folate is the first vitamin, Victor, to run out anytime you have rapid cellular division. You understand that? You understand, Victor? You understand, Leanne? Anytime you have rapid cellular division, you're going to run out of folate first. You understand that? You understand that, Leanne? Oh, man. Wait a minute. Don't say anything. Victor, Leanne. Starts with an L. That's all I remember now. Leslie. Leslie. All right. So, Leslie. That means any disease you can think of where there's rapid cellular division, I bet you we need to put them on folate. You follow me? Then that means if I could take away folate from cells, what would happen to them, Leslie? It would die, wouldn't it? First vitamin to run out whenever you have rapid cellular division, folate. You understand, Leslie? You understand, Leanne? Well, Leslie, can you tell me of a state where you got a lot of rapidly dividing cells? Cancer. Cancer is rapidly dividing, isn't it, Leslie? Wow. Hey, you think that's why some of the drugs we use block folate? Dihydrofolate reductase. Why is methotrexate the most commonly used antimetabolite in America? Dihydrofolate reductase. Ring a bell to anybody? What's the best way to stop cells from dividing? Take away their folate, baby. But wait a minute. If you take away the folate from the cancer, you're going to take away the folate from me, too. Everybody follow that? If I'm the cancer patient? Why do you think they say you better give him leucovorin to rescue your patient before he dies? Oh, see, that's where management comes from, folks. But if you don't understand the root, you're just memorizing, oh, yeah, give him methotrexate, give him leucovorin. And that's just what the book said. But why did it say that? Because if you take away folate, all cells will stop dividing. Well, what other states can you think of where cells are rapidly dividing, Jim? Infections. Cells are rapidly dividing.
In an embryo.
Okay, so I'll take your first one. I just want to make sure I was understanding. So infections, remember like sulfur drugs? What do they target? Folate. Why do you think they came out with sulfur drugs 30, 40 years ago, way before the other stuff came out? Because if you take away folate, guess what? The bacteria has to stop dividing too. Think about pregnancy. Why do you think they tell a woman who's even thinking about getting pregnant, start your folic acid 3 months before you get pregnant? Folks, right here. That's where management comes from. If you understand the original concept, you can apply it 1,000 times, even though you never read any article that tells you should give them folate. Poverty, you know of any diseases where you have rapid cellular division? Besides the ones you heard? What about you, Miguel? Any? All right, Thara, you know of any others? Think about diseases like sickle cell anemia, since their bone marrow is always revved up. Why do you think we got them on folate? A little kid with hereditary spherocytosis whose bone marrow is always revved up. Why do you think we got him on folate? A person who got psoriasis, his skin is rapidly dividing all the time. Why do you think we got him on folate? This is what I mean by I can tell you where you need to be using folate. I just think of any disease where there's cellular division. And I say, I bet you need folate for this person right here. This way, when the patient's in front of me, boom, it clicks. This person should be on folate. And I ask him, do you take vitamins every morning? Otherwise, I say, you need to be taking multivitamins every morning. That way you get your folic acid. You got to have it. If you don't, you put yourself in trouble. All right? So if you need, if you got folate deficiency, look at that. You need it for THF. That means if you're deficient in it, your nucleotides can't be formed. That means rapidly dividing cells will stop. And that's why when you have folate deficiency, Ramathea, you'll see a megaloblastic anemia, hypersegmented neutrophils. Well, Jesse's probably asking himself, Dr. Francis, how do you get this megaloblastic anemia? Jesse, good question. Well, here's how it happens, man. Let's say, Jesse, I got a cell and a nucleus in the middle. Signal comes, hey, cell divides. Cytoplasm, Come on, nucleus, you divide. Hey, man, what'd I tell you? I ain't got no folate. Get off my back. I ain't dividing without any folate. Okay, chump. Signal comes again later. All right, cell divide. Cytoplasm, boom. Nucleus, come on, you divide. Do what I tell you last time. Don't be bothering me no more. I do not divide without any folate. Okay, wuss. Here comes the signal again. All right, cell divide. And then cytoplasm says, okay. See that? Now you got a megaloblastic cell. He says, come on, nucleus, it's time for you to divide. I can't do it, man. Lay off it. Come on, you can do it, you can do it. Okay, I'll try. Okay, I can't do it, I can't do it, I can't do it. And stops. When he stops, what do you got? Hypersegmental neutrophils. You know what a hypersegmental neutrophil is? A neutrophil who tried to divide but never could finish. You want to see physio? You better hang with me, baby. That's what I'm telling you. When you can see it, you get, oh my God, you can hear, you'll retain it for life. Instead of just memorizing terms, and then they have no meaning. I always try to connect it back to what started the whole thing. That way everything becomes part of the big picture versus memorizing a list of items. It's hard for the brain to hold on to everything as an item. All right, so megalobacteremia, hypersegmental neutrophils, you say, well, it could be folate, but it also could be B12. All right, but if you see neurotype defects in the fetus, then you say, okay, it's folate. Most common cause of folate deficiency in America is overcooked vegetables. You understand, Shelley? Did you hear what I just said? Did you hear what I said, Shelley? Did you hear me, Marina? Did you hear what I said? So, Marina, who's more likely to have folate deficiency? Whites or blacks? What do you think? All right, let's say Jagdeep. What do you think? All right, let's say Hovig. What do you think? Okay, blacks, because blacks overcook their foods more than whites. It's a cultural thing. All right, who's more likely to have folate deficiency between blacks and Hispanics? And Angie, you would say? Still blacks. Okay? So that means, Amika, who's more likely to have folate deficiency between blacks and Asians? Blacks. How about whites and Asians? Whites. Asians stir fry their food. That's how they cook that stuff. It literally walks off your plate, man. I gotta go chasing it around the doggone restaurant, man. Excuse me, my lobster just walked across your table. Folks, you know what that means? I can tell you that Asians live longer than whites, who live longer than blacks, who live longer than Hispanics, who live longer than blacks. Right there. Now, you can go read epidemiology, or you can see it with me. I saw it right here. That I can put the ethnic groups in order in which they're going to die just from folate deficiency. Can you believe that? Can you believe that? Look at that. That's the stuff I want you guys to be able to see. See that a concept can be applied 1,000 times. As long as you see the concept clearly, you can use it. You can use it to answer a bunch of questions about stuff you never even read. As long as you're going to attach it to that concept. Blacks overcook their foods more than anybody else. That's why we die faster than anybody else. Then come Hispanics, then whites, then Asians. So death rate, you go the other way. Check it out for yourself. Folate deficiency, then B12. Cyanocobalamin is B12. B12, necessary for two enzymes. Two enzymes need B12, Victor. One of them is called homocysteine methyltransferase. Hey, wait a minute. You need that enzyme to also make tetrahydrofolate. You understand that, Victor? Well, that means, Victor, if you're missing B12, Victor, isn't that the same thing you can make with folate over here? Do you see that? Do you see that, Victor? Does everybody see that's why you can cover up the anemia of B12 by giving them folate? That's why they tell you when somebody comes with megalobacteremia, check both. Never check one without the other. But if you're going to treat one before the results come back, Jim, which one are you going to treat? B12. The B12. Never just give them folate and then let them go home. Because you can cover up the anemia of B12 deficiency and then they look normal the next time somebody sees them and then they won't do anything. Then they come in later on with the even more severe side effects, dementia. And that's irreversible now. Okay? But I want you to see why the connection. You get the same megalobacteremia, same hypersegmental neutrophils with B12 as you get with folate. The difference is the second enzyme, methylmalonyl-CoA mutase, is necessary in poverty to recycle odd-number carbon fatty acids. That means, Nick, that includes myelin. That's how neuropathy becomes a problem with B12 but not with folate. You understand, Victor? You understand, Tariq? So whenever you see megaloblasts, anemia, hyperseminal neutrophils, the two things to think about, Tariq, are? What two vitamins? B9 and B12. If they mention neuropathy, you then say? B12. Well, the two longest pathways in your brain that need myelin, Joni, corticospinal tract and dorsal column. Hey, which two pathways do they usually say affected in your books? Corticospinal tract and dorsal column. They're the two longest pathways, so of course they need the most myelin. It could be any neuropathy, folks. That's the trick to the game. They just give you the most common stuff, the classic, but that's not. It could be any neuropathy. On the boards, they'll throw in foot drop to try to throw you off. Sural nerve is, who cares? You mention anything neurological, I'm picking B12 every time. Okay? All right, so methylmalonyl-CoA mutase is necessary to recycle odd-number carbon fatty acids like myelin. Okay, the number one cause of B12 deficiency in America today, Tariq, type A gastritis, which is pernicious anemia. Type A gastritis, pernicious anemia. You understand, Leanne? You understand, Leslie? All right. Vitamin C is used for hydroxylation. Vitamin C is used for hydroxylation. You need it for hydroxylating protein and lysine and collagen and some in elastin. Vitamin C happens to be the main antioxidant in your GI tract. Antioxidant, Leslie, means it absorbs free radicals. You understand? Now the question is, what's the number one reason for forming free radicals in your body? Well, number one reason for forming free radicals in your body, Laura, is infection. And the most common infection throughout your body, Monica, is? The most common type of infection. No, category. Is it bacteria or virus? Virus more common, remember? CMV 95%. So, viral infection. So that means the problem here, Leslie, is that free radicals don't have any friends. Free radicals are the ones who actually do damage to you when you have the infection. They destroy tissue. Everybody with me so far? So that means the number one reason for liberating free radicals to damage your tissue and make you feel ill is a virus. You understand, Leslie? Now, what vitamin do they tell people to take if you want to fight the common cold? I could have sworn it's vitamin C, wasn't it? I think I know the connection now. Everybody see it? All you're doing is absorbing the free radicals that 95% of the time the virus is in your system liberating. And guess what? You don't get ill from it anymore. The virus is still in your system, but you're not ill. That's the difference. That's what vitamin C is all about. That's what drinking orange juice in the morning is all about, especially on a cold day. See that? Make sure you got plenty of vitamin C running through your system. Why do you think they got it in Hawaiian Punch, since kids love Hawaiian Punch? Why do you think they got it in Sunny D? Why? Because kids love Sunny D. Why do you think they keep putting it in that stuff? To fight viruses. Because that's the most common infection you have in your bloodstream at any given moment. Okay? So vitamin C. The way they'll make it up, boys, 2 or 3 question is you need to give somebody iron. Iron, if it gets oxidized, is useless. That means if free radicals attack it, it's no good anymore. And they'll ask you, gee, what vitamin would you give them to protect the iron you just gave them, Ramathea? Vitamin C, that's why they say give iron supplementation with orange juice. See, but by the time you read it in an article, they just say give it with orange juice, but they don't tell you the reason why. The key is if you don't understand that, then you think it's about the orange juice. Well, if they got orange juice in the house, what are you going to do now? Any juice. Any juice has vitamin C in it, so who cares whether it's orange or pineapple or anything else? That's the key. It's the vitamin C, not just orange juice. All right, so that's vitamin C. Vitamin C deficiency, we call it scurvy. Scurvy, Leanne. Classically, you're bleeding from the hair follicles and gums. If you start bleeding from hair follicles and gums, all you got to do is think about the pirates. You notice their gums are bad and they're bleeding from hair follicles. They had all these little blood blisters all over their skin. It's classic scurvy. Why? There are no fruits out on the high seas, so they couldn't get any vitamin C out there. Okay? Vitamin C deficiency. Any questions so far? Okay? Vitamin D is necessary for bone and teeth formation. Bone and teeth over here behind my Yuri. Let me start on your row. What is it? Malik. And after Malik? What? Nasit. How do you spell that? N-I-S. Wait a minute. N-I-S-I-S-I-T. Nasit. Okay, Nasit. All right, so every time I start concentrating on Indian names, I forget the last guy who talked to me. All right, wait a minute. What was your first name again? Malik. All right, Malik, Nasit, Marcelo, Nasit, Malik, Nasit, Marcelo. Okay, let me try those. All right, Malik, you understand vitamin D, necessary for teeth and bone development. So vitamin D will stimulate osteoblastic activity, whereas remember, PTA stimulated osteoclastic activity because you're breaking down bone. Now, I'll warn you, even though in your books they talk about, if you stimulate osteoclast, you also stimulate osteoblast. On the exam, folks, you better know which one cell to pick. All right? The net result of PTH is to break down bones, so you got to pick osteoclastic activity. Even though your book mentioned osteoblast, you won't get your point. I'm just telling you. Okay? Same thing here with vitamin D. Net result of vitamin D is osteoblastic activity. So on the exam, you pick osteoblastic activity. Even though osteoclasts are also activated, don't pick it on an exam. Okay? All right. So osteoblast, osteoclast. So vitamin D is osteoblastic activity. That's because you need to build bone. You need osteoblast to build that bone. And therefore, you need calcium and phosphorus. And that's how you know with vitamin D, both go in the same direction. When calcium and phosphorus go in opposite directions, Antonia, what do you think about? What hormone are we going to blame it on? PTH. Who needs what vitamin as a cofactor? Vitamin A. Vitamin A. That's all right. All right. Vitamin D is responsible for mineralizing your bones and teeth. Okay? So vitamin D will stimulate osteoblastic activity, stimulate calcium and phosphorus reabsorption from the kidney and the GI tract so that you can put it into the bone. You understand this? You understand Malik? And, oh, man. What was that? Marcelo. All right, Marcelo. Where you from, Marcelo? San Antonio. Marcelo from Antonio. I like that, man. Got that sexy thing. Antonio. I am Marcelo from San Antonio. You got a killer rap just saying your name, man. All right, so vitamin D mineralizes your bones and teeth. What about vitamin D deficiency, Marcelo? In children, we call it rickets. That's bowing of the legs, lateral bowing of the legs. Now, don't get it mixed up with anterior bowing of the legs. That's an infection. Monica, anterior bowing of the legs. What infection is that? What infection? You just mentioned something that's not even an infection. Remember I said if you say something out of context, I'll warn you just so that you catch this habit. You don't realize how it's a habit of the brain to do that, just so you know. That's why I'm pointing it out to you. The best way to get rid of a habit is to be aware of it. Once you're aware of it, the habit starts to die down. Okay? Let's see if Laura remembers. Anterior bowing of the legs. What infection do you think about? That one is, do you know Nick? Yeah, syphilis. Syphilis does anterior bowing. I just want to make sure nobody misheard me. Lateral bowing is rickets, anterior bowing, syphilis. Okay? So we'll talk about that in micro. So rickets, lateral bowing of the legs. In adults, we call it osteomalacia, Angie, which literally just means soft bone. You understand? Poverty. You understand? Shweta. Soft bone, osteomalacia. All right, then there's a disease called vitamin D-resistant rickets. This is one of two X-linked dominant diseases. One of two X-linked dominant diseases. How do I know you got an X-linked dominant disease? The only way to be absolutely sure, dad has it, gives it to all his daughters. Remember, he's got to give his X to every daughter, right? That's the only way to be absolutely sure. Otherwise, you have to wait several generations to actually see it going from mom to the boys, and then you also see it getting to the girls as well. Now you say it's X-linked dominant. Okay? But if they mention dad, give it to all his girls, now I'm sure. Click and move. X-linked dominant, the two you need to know. Vitamin D resistant rickets and then pyruvate dehydrogenase deficiency. Okay? Only 2 diseases, X-linked dominant. Okay? The problem in vitamin D resistant rickets, Monica, the kidney is having a hard time reabsorbing phosphorus. So the phosphorus is leaking out and dragging calcium with it. And that's why when you see them, Malik, it looks like they're vitamin D deficient because calcium and phosphorus are both low. Make sense, Leanne? Make sense, Jim? Yeah, but then when you give them vitamin D, nothing happens. That's why they call it vitamin D resistant rickets. That's because no matter how much vitamin D you give them, they still cannot reabsorb phosphorus because it's not a calcium problem, it's a phosphorus problem. Okay? Vitamin D resistant rickets. Now, there's a survey that went out years ago that said that women think that bow-legged men are much more sexy than straight-legged men. So every month, I always like to take a little survey and find out how many of you fill out that survey. Let's see. We're going to start in the back this time. All right, in the back. What is your first name? Yeah. No. In the back. The females. Yes. Martha? Ooh, Lord. What'd you say? How do you spell it? Oh, Margara. Ah, okay, Margara. You think bow-legged men are more sexy? Nah. Name next to Margara. What? Who? Jennifer. Bow-legged men more sexy to you? No, she says, in front of Jennifer. Janice, bow-legged men more sexy to you? No, she says, to the right of Jennifer. Janice, to the right of Janice. What? Anna, bow-legged men more sexy to you? Anna says no. I to the right of Anna. Johanna, bow-legged men more sexy to you? No, she says. Katie, bow-legged men more sexy to you? Oh, yeah. Pretty, bow-legged men more sexy to you? No. Leanne, bow-legged men more sexy to you? Oh, depends on why it's bow-legged. Allow me to break it down. What Leanne is really trying to tell you, because a female finally gave out the secrets. The reason why women think bow-legged men are much more sexy is because they have this vision of why he's sagging a little bit in the middle there. All right, folks. Now, let me tell you something. Hey, folks, it's not my research. My job is to educate you. Look at that. You know what? It's like the most queasy people about sex go into medicine for some doggone reason. Anything about sexuality, medical students and doctors all get all queasy about it. I always tell students, become comfortable with your own sexuality because you got to deal with strangers about theirs. If you're uncomfortable with yours, it becomes obvious in the conversation. They'll shut up and won't ever talk about it anymore. All right? So, the research said 95% of women, there's a difference between what women, or anybody for that reason, say when they're out in public, i.e. now, versus when you slide a questionnaire underneath the door and they can be truthful. You see that? The majority say, yeah, bow-legged men are much more sexy. Well, men were surveyed as well. Same thing. What do you think about bow-legged men? Bow-legged men, now men thought they were more masculine and powerful. Power. Now, you may not know that this is, they do a lot of research to figure out what's in your subconscious, because when you ask somebody to talk about something, the conscious comes out, they lie. Okay? Yeah, so I already know most of you are lying. All right? If you think that's not true, next time you go by a magazine stand, look at the comic books and tell me, why is Spider-Man bow-legged? Why is Batman bow-legged? Why is Superman bow-legged? Why is Captain America bow-legged? Why is the Hulk with his green ass bow-legged? Folks, they're trying to attract both sexes, and you guys don't even know that. They want both sexes buying those comic books because women are attracted to the strength of the the sexiness of the bow-legged man. Men are attracted to the strength of a bow-legged man. Look at the movie that just made $100 million over the weekend, Iron Man, and explain to me why he's bow-legged too. Right. You think just the guys went to see that movie? Oh, no. You know that wrestling had the top 7 out of 10 shows on television at one time? I don't know if they got all 7 out of 10 now, but for a while there, they were just dominating the airwaves. That's where all these wrestling shows came out of it. Okay? You know who the most popular villains were on there? The bow-legged ones. Go back and look, folks. the women were the biggest audience. You think it was just about men? I don't think so. The women said they love bow-legged men. And then women say, tell you what, we want to check out their buns too. So they said, put them Speedo shorts on them. Them tight shorts on them. It was the women who drove that. It was the women who requested that because they want to see the butt. See? Yeah, but when you get women in public, then they start pretending. Nah, I don't like that. And then get them alone. Oh, yeah. All right, so anyway, vitamin D deficiency. Vitamin E is the main antioxidant in your bloodstream. So that means, Malik, anytime you got free radicals in your bloodstream, vitamin E is the one that can absorb it for you. You understand that? Anytime you got free radicals in your GI tract, who absorbs it for you, Malik? Who? In your GI tract, Malik was my question. Nisit, tell him. Vitamin C absorbs free radicals out of your GI tract. Vitamin E absorbs out of your blood. You understand the two questions? All right, so you understand, Leanne? All right, so, Leanne, what's the number one reason for having free radicals in your bloodstream? Infection due to what, Leanne? Thank you, Leanne. She got that pattern down already. See that? That's what patterns are. It allows you not to have to rethink. Just come up with the same connection. I bet you the answer is still the same. All right, so this way, why, when we get to, what's the number one reason for hemolytic anemia and G6PD? Infection. What's the number one reason for DK? Infection. What's the number one reason for hemolytic crisis and sickle cell anemia? Infection. Folks, you're going to see it over and over again. It's the same concept if you see this. Because free radicals are what's setting them off. Free radicals cause, oxidation of your RBCs. Well, that's what G6PD is all about. Now you can't repair it. Free radicals suck up your oxygen, and then you sickle. That's why that's the most common reason. Oh, my God. Free radicals, number one reason, virus. And that's a stress to the body for a child, and now he can't turn off ketogenesis, DKA. Same old stuff. Vitamin E. So, diseases involving oxidation, big ones, cancer. That's why we give vitamin E to cancer patients. Alzheimer's, vitamin E is being given to them. Coronary artery disease, vitamin E. We always tell them to take vitamins anyway, all the vitamins. So now we got folate and vitamin E, as you can see, are very important if you got cancer. And then G6PD, you've got a hemolytic anemia. The main antioxidants, just to summarize it. In the blood, say E. In the GI, say C. And then vitamin A and beta carotene are some other ones. And then their trace elements are minor antioxidants when we talk about them. Biotin is necessary for carboxylation. Nisit. For carboxylation, well, that means there's a lot of carboxylases out there. And so that means any organ can be affected. But if you have to pick one organ on the boards, Nisit, which one are you going to be picking? Nisit, which one are you going to be picking? Who? Marcelo, remind him. Oh, yeah, the brain. What are you going to pick after that, Nisit? What if brain's not on the list? What are you going to pick now? The heart. What if heart's not on the list, Nisit? The kidney. Don't forget, folks. Because this one has nothing specific, so there's nothing for me to tell you. We're going to be doing a lot of carboxylation. We'll do biochemistry, so they can go for fatty acids, or they can go for gluconeogenesis. I don't know. But the key is, if they ask me complications, I'm going for neuro first, cardiac second, renal third. And it'll still be the right answer. All right? So that's biotin. Vitamin K is needed for gamma carboxylation. Now, what is gamma carboxylation? Marcelo is asking himself. Gamma carboxylation. Well, the vitamin K dependent factors already have 1, 2 carboxyl groups on them. Alpha, beta. That means if you add a third one, gamma. That's what I mean by gamma carboxylation, adding a third carboxyl group on them. Well, more than that, let's understand this. Each one of these vitamin K factors, 10, 9, 7, 2, protein CNS, have actually 10 glutamic acids on their carboxy terminal. That's the one over to the right. 10 glutamic acids. Janice, right? All right, 10 glutamic acids on the carboxy terminal. And 10 glutamic acids already have 2 carboxyl groups. That's 20, right? 20 negative charges. And then I'm going to add a third one. So that means now there's 30 negative charges. You understand, Janice? You understand, Anna? You understand, Joanna? All right. So that way, if I had all these negative charges on these vitamin K factors, what am I doing that for, Bindia? Is because it's got to be attracted to a lot of positive charges. Well, when you learn clotting, don't platelets release calcium on their surface to start the clot? Well, now you know how to attract the vitamin K factors over there. Oh, that's what happens. Well, that means if I give you a drug that blocks vitamin K, Asif, like warfarin, Coumadin, that means I'm going to block all 6 of these. 10972. Just remember the year, 1972. And then protein CNS. Everybody follow me? Everybody follow that statement? Well, Anna, of those 6 factors that I just gave you, protein C has the shortest half-life, which means who's going to disappear first, Anna? Protein C. Everybody clear about that? The problem, Anna, is that protein C is not a clotting factor. It's the first thrombolytic to show up to protect you. Uh-oh, we got a problem. That means, Johanna, if I give you warfarin or Coumadin and block your vitamin K, of the vitamin K factors, which one will disappear first? Protein C. And protein C is a thrombolytic, the first one to show up to protect me. So now I'm going to disable him. If I disable a thrombolytic, am I going to be more or less likely to form a clot? Huh? You're disabling a thrombolytic, the guy who breaks down a clot. So that means now you're more likely to form a clot. You understand that? You understand, Janice? You understand, Jennifer? The problem, Margara, is that if I give you warfarin or Coumadin, protein C has a half-life of only 6 hours. 6 hours, Sharice. How many half-lives do you need to reach steady state? Sharice?
3.
4 to... No, that's all right. Let me teach it to you. That's all right. Remember, whenever I ask you a question, I don't expect you to always be right. I'm going to show you how to be right so that you know it next time. All right? It's 4 to 5 half-lives. Remember, it's like 50%, 75, 84, 95, 99. So that's why 5 half-lives. So if I tell you the half-life is 6 hours, how many hours to reach steady state? No, you take 5 times 6 half-lives. 6 hours, rather. And what is that? What do you get? 5 times 6. 30. That means after 30 hours, all the protein C is gone. You understand? Okay. The problem is, starting at 6 hours, however, Nick, you just knocked out 50% of my protein C. That means I can now form clots. And yet you gave me a drug to stop me from forming clots. Do you understand me? That's the reason why you need some other drug to protect you starting at 6 hours, Nick. When you give somebody warfarin, that's the reason why we always give heparin before the warfarin. And by understanding that, folks, then I don't forget that you got to give heparin before warfarin. Otherwise, one day you might forget and give warfarin before the heparin. You do that, you get one last warning. The person always necroses a piece of skin first. Somebody with protein C deficiency, and you accidentally give them the warfarin before you give them the heparin, they're going to necrose off a piece of skin. That's your last warning. But here's the problem, Tariq. Let's say I, the doctor, don't understand what's going on, and you put the patient on warfarin 2 days ago, and they come in to see me in the emergency room, and I see evidence of clotting. You see how natural the response is, give him more warfarin? You need to anticoagulate him some more? Which means he can now stroke out and die before anybody knows what's going on. Okay? Your last warning for protein C deficiency. Well, it turns out, Amika, that factor 7, remember 10972, the first actual clotting factor, factor 7 has the shortest half-life of the clotting factors, 10972. Factor 7 has a half-life of 2 days. If factor 7 has a half-life of 2 days, Sharice, how many days to reach steady state? That's okay. How many half-lives to reach steady state? What was the number I gave you?
5.
5. And I told you the half-life is 2 days.
Right.
So how many days to reach steady state? 5 times 2 is what again?
5 times 10.
10. That's how long I know you have to stay in the hospital on heparin till you are now therapeutic on warfarin. Now I can stop the heparin and send you home. You understand? So it translates to therapeutics for divorce 2 and 3, management. How long are they going to have to stay in the hospital? That's how long. Okay? So if you put them on warfarin, you got to make sure you put them on heparin first, because starting at 6 hours, they are more likely to form a clot. You understand that, Laura? You understand that, Bendia? Or Bendia? Bendia, right? I just keep saying Bendia. All right, Bendia. All right, you understand, Jim?
Yes.
You understand, Leslie? You understand, Katie? All right, you understand, Prethi? All right, you understand to the left of Prethi? Rick, you understand Rick? You understand, what's your name? What? Lee? Dude, spell it for me. Who? What? Oh, KY. KY. Whoa, okay. I'm gonna have to ask you a couple of times every time I ask you a question, man. Don't be offended now. I gotta make sure I understand what you're saying. But KY, Key. Okay, now I remember seeing that. All right, Rick, Key. You understand, Rick? You understand, Key? All right, so anytime you give somebody warfarin, you must give heparin first. Everybody clear about that? Because at 6 hours, you knock out protein C. That leaves me naked to form clots if I already have a genetic protein C deficiency. That's the key. But you get one last warning. They'll necrose off a chunk of skin. If you don't stop that warfarin, you're going to kill them with the warfarin. Everybody understand that? That's the irony. It's a paradoxical effect. You give them warfarin and now they die of clots. But you don't understand why. Unless you understand this. Okay? All right. So warfarin is a competitive inhibitor of vitamin K or coumadin, whichever form you want to give it orally. Again, always give heparin first because warfarin crosses the placenta. So if the woman gets pregnant, yeah, the baby's going to bleed to death now. So we don't like that. Plus, warfarin is teratogenic to the fetus. Okay? Follow the prothrombin time. Why? Prothrombin time is for the extrinsic pathway where factor 7 is located. That's how to remember that. Remember, extrinsic pathway is tissue factor plus factor 7. So if you knock out 7, PT elevates. Now, PTT will elevate later, but PT is the one we're going to follow because it elevates first. The INR you're shooting for, that means how many times normal? 2 to 3 times normal. What does that translate into, Z? It means you are 2 to 3 times less likely to form a clot. Do you understand? It means it would take you 2 to 3 times as long, Z, to form a normal clot now. Do you understand that? So 2 different ways to interpret the same number. Okay? All right. So they found if you do more than 3, well, then you got more bleeding and hemorrhages. That defeats the purpose. So that's warfarin. If you give somebody warfarin and the PT goes too high, Shane, and you want to reverse it, just give him vitamin KIM. Do you understand, Shane? Yes. All right. Rahul, yep. If you give him warfarin, but they're bleeding all over your floor and you want to stop that bleeding right away, give him fresh frozen plasma because FFP has all the clotting factors in it. You understand, Miguel? You understand, Thara? You understand, Antonia? You understand, Mayuri? Cool. Pretty good. I got half the class done already. Yeah, all right. All right. You understand the reg? All right, man. So heparin is a cofactor for antithrombin 3. This is why you must start it first. That way it activates antithrombin 3, Miguel. So now you have another protection against clots. You understand, Angie? Because remember, protein C can't help you anymore. Then you got to activate the other one. You understand, Bindia? To the right of Bindia. First name. What is that? Jose? H-O-S-E-A? Oh, okay, J-O-S-E. All right, Jose. You understand, then, with heparin. You give heparin first to activate antithrombin 3. That way, antithrombin 3 now protects you from clots starting at 6 hours. Heparin has a half-life of 6 hours. Look how well that coordinates, folks. At the very minute you're naked because of protein C, I got antithrombin 3 protecting you now. Okay? Heparin before warfarin. Okay? And then, of course, as Sharice now clearly understands, after 5 half-lives, 10 days, now you can stop the heparin and send them home on warfarin. Okay? Following the PT. The problem is with heparin, or rather the difference with heparin, you follow intrinsic pattern, PTT. Again, you're shooting for INR 2 to 3 times normal. If you give them too much warfarin, the PTT is too high, Shane, reverse it with a drug called protamine sulfate. Which lets you know, Janice, that heparin is charged or uncharged. Which one? charged. Sulfate is charged. That means heparin better be charged too. And that's how to remember, Janice, why we use heparin only in pregnant women. Because it doesn't cross a percent if it's got that much charge on it. If you give somebody heparin, you follow PTT. Let's say you give somebody heparin. Now I'm going to give you all the complications of when you're on heparin. All right? It goes like this. If I give you heparin and you throw another PE. Let's say you come in with a PE and I put you on heparin, and then while you're on heparin, you throw another PE. That means the heparin's not going to protect you. Laura, what do I do for you now? You're on heparin and you throw another PE anyway. It means the heparin is not going to help you. Let's see if Monica remembers what you're supposed to do. All right, that's when you put in a IVC filter. You put in a filter in the feet of vena cava. It's like a little umbrella. That way any clots that come out get caught in the umbrella and no more goes up to the lung. Because if you're lucky enough to survive 2 PEs, the third one's not going to kill you. So that's why we got to do something drastic. All right, so if somebody on heparin and they throw a second PE filter, it means the heparin is not going to be enough. Okay? When you put somebody on heparin and switch to warfarin, they have to stay on warfarin minimum 6 months, and then you reevaluate. So duration of therapy is automatically 6 months before we reevaluate. Which means, Jose, if you know why they form that clot, you can stop the Coumadin. Like a truck driver or somebody flew in a transatlantic flight, you know why they made that clot. Well, they're not flying every day, so we don't have to worry about it. So you stop the warfarin after 6 months. If you don't know why they formed that clot, then you have to continue warfarin for the rest of their lives. Because that means they can form another one. The most common reason for forming clots spontaneously is something called factor V Leiden deficiency. Now, you'll go through all the clotting disorders when we do clotting this Saturday, but I just want you to know the 90%. Every time we do something, I want you to know the 90%. That way, if I ever ask you, or if you're ever asked on a test question, folks, you should spit out the 90% first before anything else. Okay? So heparin. Now, if they're pregnant, they have to stay on heparin only. There's no other choice. You have to stay on heparin. Okay? Most common complication of heparin use, bleeding. Just like any other thrombolytic, right, Katie? Makes sense to you? Bleeding is number one complication. Number two problem to worry about is that heparin can activate what they call hormone-sensitive lipase. Can be activated by heparin and mobilize lipids. So you get hyperlipidemia as a side effect. So in case they ask you why do your lipids go up with heparin infusion, that's the reason. Heparin can activate an enzyme called hormone-sensitive lipase, the same one glucagon activates. Okay? And then third complication to worry about, heparin can act as a hapten on platelets. This is what that heparin-induced thrombocytopenia you hear a lot about, is the physiology to it. Heparin can sit on top of a platelet, making it look foreign. That means your body has to make antibodies against it now. Heparin-induced thrombocytopenia. So 3 main side effects to worry about. Now, Laura, if you want to decrease the incidence of side effects with heparin, then you switch to what? Low molecular weight heparin. That's the indication for low molecular weight heparin. They do the same thing. Question is, when do I switch to decrease side effects? So if they already had problems in the past, then that's how you know. Switch to low molecular weight. Most places use low molecular weight now. Hardly anybody uses the regular unfractionated heparin. Okay? What if they've had a history of heparin-induced thrombocytopenia? Then you switch to a drug called what, Laura? Agatroban. Something totally unrelated to heparin. This is in people who have had heparin-induced thrombocytopenia, Leanne. Not just they had side effect. It has to be just that side effect. The problem is that's a systemic disease. So you can't use anything that reminds the body of heparin. So that means even low molecular weight can set it off. It's just a lower risk, but it can still set it off. So we use this drug, agatroban, which blocks thrombin. So it's totally unrelated to heparin. So a patient with a past history of heparin-induced thrombocytopenia, I know that's where they're going. They want this answer. Okay? All right.
Quick question. Could you go over the 3 side effects of bleeding?
Bleeding, number one, hyperlipidemia, because it activates hormone-sensitive lipase, and then heparin-induced thrombocytopenia. Okay? What are your germs good for? They make 90% of your vitamin K. They also make biotin, folate, pantothenic acid, and they help you absorb B12. So that means, Malik, you need your gut flora to help you with these vitamins. Well, Malik, if you don't have any gut flora, which one of those vitamins would you miss out on the most? Vitamin K. Does everybody see that? Since they make 90% of it for you. Well, Leslie, think to yourself and ask yourself, when in your lifetime did you not have many gut flora in your GI tract? When you're first born. Wait a minute. Could that be why we give vitamin KIM to all newborns in America? Let me think. Sounds like management to me. See that? You give them one shot of vitamin K, it lasts for 6 to 9 months. By that time, they've sucked enough germs off of mama's nipple. Now they can make their own vitamin K. All right? But the way they'll try to get you on the boards, Shelly, is they'll give you a teenager who was on a cab ride on the way to some friend's house and then delivered the baby in the cab. Well, last I checked, cab drivers don't carry vitamin KIM in their back pocket. And that means if you're not reading that carefully, you won't realize nobody gave that baby vitamin K. And then when they go home, 2 days later, the baby starts bleeding to death, and they're going to actually explain why. In Africa, it happens all the time, folks. They don't have vitamin KIM in Africa. Poor countries. America, no problem. But in poor countries, they don't have it. A lot of babies go home and bleed to death 2 days later. Why? Factor 7, I just told you, had a half-life of 2 days. Once it starts to disappear, they start bleeding. Okay? So vitamin K. Then you got biotin, folate, pantothenic acid. But notice they help you absorb B12, Joni. They don't make B12. They help you absorb it. You understand? Yeah, be careful when they say, well, which one does it make? Hey, wait a minute, Joni. That means if I kill off too much of your normal flora, you start bleeding, won't you? Why is that? Because you can't make 90% vitamin K. Oh, wait a minute. Maybe that's how broad-spectrum antibiotics cause bleeding. Ooh, I think so. See, so they'll give you a patient who went to surgery, you put him on preoperative antibiotics, and then, of course, 2 days later, 2 days again, see that? Now he's bleeding all over the place. You can actually explain it. Probably the antibiotic you gave him. You've killed off too much of normal flora now. Okay? In babies, we call it hemorrhagic disease of the newborn. Okay, and when we talk about the cephalosporins, you'll see the 4 cephalosporins who cause so much bleeding because they block vitamin K. All right. Minerals. Calcium, magnesium, zinc, copper, and iron. Minerals. Here's what we need calcium for. We need calcium more than any other mineral. Intracellular calcium is needed for all muscle contractions. So we're going to see that in neuromuscular phys. Intracellular calcium, key. Not extracellular. Intracellular calcium is necessary for contraction. You understand? All right. Smooth muscle needs extracellular calcium to trigger off its second messenger systems. So we need calcium for that. The atrium, Rick, is the only membrane that needs calcium to depolarize. That's depolarization. Calcium to depolarize. Okay? And then the cardiac ventricle, Janice, depends on extracellular calcium to trigger off intracellular calcium release. You understand? All right. So calcium, we need a lot of it. And that's why for a non-pregnant woman, Janice, a non-pregnant woman needs about 1,000 milligrams of calcium a day. And that's 2 to 3 glasses of milk. That's why the milk industry would rather you get it that way. So they got milk commercials. Of course, Tums would rather you eat Tums to get your calcium that way. And that's something I need for my body anyway. Okay? You see? Everybody's trying to get the market, okay? Because you got to have the calcium. You can take it any way you want. But 1,000 milligrams if you're not pregnant, 1,500 milligrams if you are. Because look at that. You need calcium for axonal transport. That baby's going to be retarded if you don't have enough calcium in that pregnant woman. Look at that. Presynaptic influx of calcium is necessary for release of all neurotransmitters. More mental retardation without calcium to release neurotransmitters. And then calcium is necessary for bone and teeth development. So bad problems if a pregnant mama does not eat enough calcium. You understand, Angie? You understand, Miguel? Nyreg with me? Jack Deep. Marina. Hovik. Shelly. All right. I got a patient who's got night blindness. Shelly, what's his problem? Vitamin A deficiency. What if he's got lateral bowing of his legs? What's his problem, Shelley? Not syphilis. Students always give me all these things that it's not. I always say, skip the long story. Just tell me what it is. All these other things. It's not, well, I know it's not. It's not that. It's not that. It's not that. It's not that. You're praying the whole time. You're telling me all that. Rishi, lateral bowing of the legs. Rickets, vitamin D deficiency. All right. Magnesium is a cofactor for all kinases, Monica. What do kinases do, Monica? What do they do, Gretchen, you know? Kinases phosphorylate a bunch of things. But they produce ATP, that's the thing. That means if you take away my magnesium, all my, literally 90% of my ATP production stops. This is the favorite question of anesthesiologists. They say, well, if you're going to check one mineral before you put somebody under anesthesia, which one are you going to check? Folks, think about it. How do they wake up? If you put them under, they got no magnesium. They die under anesthesia. That's one of their favorite questions. If ever you do an anesthesiology rotation, they ask you the one mineral you want to check before you ever put anybody under. You got to have ATP to wake up. And if they're hypomagnesiemic and then you knock them out, all the kinases stop working while they're out. That means they can't wake up. Not good. Okay? All right, magnesium is also a cofactor of PTH, along with what vitamin, Shelley? Magnesium is a cofactor for PTH, along with what vitamin? Joseph knows. Vitamin A. So now you got one mineral, one vitamin, cofactor for PTH. Magnesium interacts with potassium as well. So by way of PTH, when magnesium is low, calcium is low, magnesium is high, PTH, calcium is high. Everybody understand this? Anytime you got a problem with calcium, they always say check magnesium and vice versa, because they're related by way of PTH. If one goes down, the other one's coming down too. Okay, this is why, like in the ICU, we always check calcium and magnesium together. We don't check one without the other. Okay? So on the boards, the way they try to get slick is they tell you got a patient who's got low calcium, and you give him calcium gluconate, and then 2 hours later, his calcium drops again. It means his magnesium is still too low. You need to correct that, or else this one will never stay normal. Okay? Well, magnesium and potassium have the same yo-yo role because of the distal convoluted tubule. If your magnesium is low, your potassium will go low, and vice versa. Magnesium is high, potassium will go high too. It's a protein in the distal convoluted tubule. So right now, at least we know where it is. Before we didn't even know where it's at. Now we know where it's at, but somebody's got to, do some more research to figure out exactly how it's occurring. Right now, all they're going to ask you is what electrolyte is going to be affected whenever you got a magnesium problem. Calcium and potassium. Okay? Zinc is necessary for hair, skin, sperm, and taste buds. But the most unique function, Tariq, is the taste buds. So you get dysgeusia. Dysgeusia, Jagdeep. Dysgeusia. Anytime you hear dysgeusia, think zinc. You understand, Eric? You understand, Joni? Dysgeusia. That means abnormal tasting. Okay? Zinc deficiency. Copper. It's necessary acid for lysine hydroxylase. Hey, what other vitamin do you need to hydroxylate lysine, Asif? Vitamin C. So you need one vitamin, one mineral. All right, copper hydroxylate lysine in the formation of collagen. All right, copper is also needed in complex 4 of electron transport system. So that shuts down ATP synthesis if you don't have that. Well, copper excess is called Wilson's disease, Shane. Wilson's disease is autosomal recessive. So here's our second genetic pattern, autosomal recessive. Big A, small a times big A, small a. Here's all the combinations. One of these, two of these, one of these. That means, Shane, what's the chance of being small a, small a? Always 25% chance of getting the disease when there's a family history. Everybody clear on that? If they ask you what's the chance of getting that disease, that's autosomal recessive, the answer is always 25%. Then the next question they ask, what's the chance of being a carrier? The definition of a carrier, Shane, says you got to look normal first. Well, 3 people look normal. How many of them are actually carrying the gene? There's 3 people left, Shane. How many are actually carrying the gene? 2 of the remaining 3. So 67% chance of being a carrier. A lot of students pick 50%, just like you heard it blurred out. That's a mistake. The old definition got lost in a lot of books. They don't explain this to you. If you say the word carrier, you got to first look normal. Small a never looks normal, so you can include him in that. Okay, so there are only 3 people left and only 2 carry the gene, so 67% chance. Very commonly missed question. That's for autosomal recessive when there's a family history. If there is no family history, you got to use the Hardy-Weinberg equation, where big A is P squared. 2 of these is 2PQ plus Q squared equals 1. That just means all the combinations you can get. Anybody following that so far? Anybody not follow that? It's just, Hardy-Weinberg just says all the combinations you can get from small a, small a. All right? Well, they give you Q squared, because that's the incidence in the general population. I just go out there and count it. 1 in 2,500. That's what they'll tell you. They just make up a number. If 1 in 2,500 equals Q squared, the instance of the disease, what's the frequency of the gene? Just take the square root of that. Jose, what's the square root of 1 over 2,500? What's the square root of 1? 1. Square root of 2,500? 50. Yeah, 5 times 5 is 25, right? So 50. So 1 over 50, therefore, equals Q. So that's all they want, frequency of the gene. I say, 1 over 50. But if they want the carrier state, then that's 2Q. So it's 1 over 50 times 2, which is 2 over 50 or 1 over 25. So that's how you use Hardy-Weinberg equation to figure out the frequency of the gene and then derive the carrier state. This is when there's no family history. The minute they mention a family history, Jennifer, then you say the chance of getting the disease is what? In autosomal recessive, you say what? 25%. Margaret, the chance of being a carrier in autosomal recessive when there's a family history is what? What? 67%. Everybody clear about that? Read the vignette carefully. Is there family history already said, or do they want me to just use Hardy-Weinberg equation? All right. So, Wilson's disease. The problem here is ceruloplasmin is deficient. So a protein deficiency starts this whole thing. You understand, Malik? All right, then copper is free to just float around Nareg and just deposit wherever it feels like it. The problem is it gets deposited into basal ganglia. That's why they get movement disorders. Then Jesse, it gets deposited into your iris. So you get this orange ring around your pupil, Kaiser-Fleischer rings. And then it gets deposited, Angie, into the liver. And that's how you get cirrhosis. So that's why they call it hepatolenticular degeneration. Wilson's disease. And then you can bind up the copper by giving a drug called penicillamine, Joni. You'll just bind the copper and pull it right out. So Wilson's disease. Wilson's disease is one of the causes of movement disorders in middle-aged people. So let's look at copper deficiency. When you don't have the copper. I don't think this one printed out for you guys, did it? I think I added it late and it just didn't print out on the computer. Just add this at the bottom or somewhere. Copper deficiency is called Menkes kinky hair syndrome. In Menkes kinky hair syndrome, Marcelo, she's got orange colored hair. Orange like copper, and yes, she's copper deficient. You understand, Marcelo? Well, Marcelo, her hair feels like copper, and yes, she's deficient in copper. It's the most ironic syndrome I've ever seen. Okay? I saw one case of this. I mean, her hair was like copper wire. It comes across her face like that, and sometimes it'll cut her eyelid. Oh, just swollen, some bleeding. Sometimes you get an infection right over the eyelid. What do you think is the most common cause of death in that little girl, Marcelo? With the hair just, cutting her face up like that. Was that? Was that? Heart failure. Oh, yeah, that's right. He thought about it for a second, though. Then he said, wait a minute. He did tell me the same answer. You see what I mean? You see how the slow programming? Before, you would have thought all that stuff meant anything. Listen to the question. Most common cause. It's got nothing to do with the vignette. The whole vignette is distraction, folks. Any question that says most common, I don't even read the vignette. It has nothing to do with the vignette. Answer it as is. The most common cause of UTI is always E. coli. I don't care what story you got to tell me. I don't care what syndrome we're talking about. I bet you it's still E. coli. That's the point. Okay, so the key was try to distract you away with all that stuff happening in her face and then ask you a general question. Hey, what's the most common cause of death? Still the same answer. Don't change a thing. All right, so copper deficiency. All right, movement disorders in middle-aged people. Huntington's is the most common cause. That's the 90%. And then Wilson's that we just talked about is the other 10%. This middle-aged person, 20 to 50, also got movement disorders, Jesse. You should always think of Huntington's first. So let's compare and contrast, Jesse. Huntington is autosomal dominant. That's different from Wilson's autosomal recessive. Well, Jesse, if you're autosomal dominant, one good gene, one bad gene. What's the chance of getting the bad gene, Jesse? 50% in one family, one parent has it. Good gene, bad gene, right? Makes sense to me? Makes sense to you? Makes sense to Reese? Okay. Jesse, what's the chance of getting it both parents have it? 75%. Never hits 100%. It's just, all you do is add another 50 times 50%, which is 25 more percent. So if one parent has it, 50%. One good gene, one bad gene. Both parents have it, you add another 25% to that. 75% is the maximum you can go in autosomal dominant. All right, here's some subsets. If you have an autosomal dominant gene, and yet you don't have the disease, that's called decreased penetrance. That's how you explain it. And that's what they're going to ask you on the boards. How do you explain this? Decreased penetrance. It didn't penetrate through the other genes that you had. Okay? Or if you got different family members with the same autosomal dominant gene, but different variations of the same disease, then we say variable expression. Variable expression. Okay? So autosomal dominant. So just sharing with you, there are really only 5 genetic patterns, folks. That's why I don't teach a separate genetics class. It's unnecessary. There's 5 patterns, and that's what I'm going to keep highlighting. And then you can slide in a lot of diseases under 5 categories. That's it. All right, so we've done X-linked dominant, autosomal recessive, now autosomal dominant. Well, other clues of Huntington's? Yes, ma'am. 50% chance of getting it if only one parent has it, 75% if both parents have it. Oh, yeah, if you got different family members with the same gene, but they have different types of the same disease, then we say variable expression. Yeah. All right, Huntington's, that's trinucleotide repeats. Involves a caudate nucleus, if they want to be specific, versus Wilson's involves the lenticular. It has anticipation, which means it comes earlier and gets worse with each successive generation. You understand, Miguel? All right. With Huntington's, they got too much movement, that's too much dopamine. So dopamine blockers will help decrease some of their movement. So antipsychotics help them a lot. Doesn't change the prognosis. They still die from it. Most common cause of death, folks, is suicide. Well, Narec, it's pretty hard to just watch yourself deteriorate and die. So most of them just want to get it over with. Now, Bindia, why do they want you to know that? Because if the patient comes to you and says, Doc, you know, there's a family history of Huntington's. Should we get a blood test to check and see if I got it? You say no. Even if they press, you say no. You know why? Here's the big reason why, folks. Number one, there's nothing you can do about it anyway, so why do you want to screen for it? Except now they're going to go out and commit suicide. Okay? Number two, if they find out by genetics that they have it, the insurance companies will say that's a pre-existing condition. They will not pay a dime when that person ends up in the hospital. So you must make them aware of that. Don't do it. And so that's why on the Boris test, that's the answer. Discourage the patient. Get them some counseling, but do not run the test. Okay? Does everybody understand? You're trying to protect your own patient here. Remember, that's what we're trying to do. Sometimes a patient does not know what's the best for him. You, the doctor, if you know what's best, then that's what you ought to be doing. Okay? So, Huntington's and Wilson's. Well, there are 5 diseases of trinucleotide repeats, Miguel. So you want to know these 5. They also have anticipation. So that means they come a little sooner and they're more severe with each generation. So Huntington's being the main one. Fragile X, that's only some of the cases. I'm not saying all of them have it. Okay? In Fragile X, you get what they call uniparental disomy. That's totally different. Before somebody panics. Uniparental disomy means one parent, uniparental, carries both mutations. It's not supposed to be that way. One parent should carry one, another parent carries the other one. All right, uniparental dies. Oh, wait a minute. I'm talking about Prader-Willi. I spoke too soon. Sorry, uniparental disomy is for Prader-Willi. Fragile X, we'll be talking about. That's also a trinucleotide repeat. So does Friedreich's ataxia. That's the neuromuscular we're talking about. Prader-Willi is the one with uniparental disomy. This involves chromosome 15. All right. Remember when mom carries both mutations? Then it's called Angelman's. It's, mom's little angel. She laughs all the time. She can't take nothing serious. I keep telling them she's smoking weed, but they won't believe me. All right. But I got my own theories. So anyway, and then Prater Willie. Prater Willie's got the voracious appetite, eats everything in sight. All right. But that's when dad. So I always think, proud papa. So dad carries both mutations on his chromosome 15. Myotonic dystrophy, we'll be talking about neuromuscular, also trinucleotide repeats. So very high yield list to know. So that means once they say trinucleotide repeats, you're down to 5 right away. Okay? Iron, that's it for heme and hemoglobin. You need ferrous, not ferric. Ferric is no good. Ferrous, combine oxygen. That's why you got to make sure that iron does not get oxidized, Joni, by giving them what vitamin by mouth? Vitamin C, and what vitamin in the blood? Joni? Vitamin E. All right, because it all depends on where they ask. If it's in the blood, you say E. If it's in the GI tract, you say C. Yeah, very good. And then iron is also necessary for complex 3 and 4 of electron transport system. And finally, the trace elements, which go pretty quickly. You got this list, and here's what you need to know. Chromium enhances insulin action. So this is the one that can cause diabetes if you're deficient in it. So that means, Eric, they'll give you a type 1 or type 2 diabetic and ask you, boy, which trace element do you want to make sure they're getting in their diet every day? I think this is the one they're looking for. Because if you're deficient in chromium, the diabetes just gets worse. Everybody understand? All right. Chromium enhances insulin action. Selenium, necessary primarily by the heart, Gretchen. The heart needs a whole lot of selenium. If you got too much selenium in your system, or somebody poisoned you with arsenic, your breath will smell like garlic. So that's a nice clue. I was on House MD. I knew that one. I got that one. I love House because it leaves you thinking. You're always trying to figure it out before the end when they tell you what it is, Of course, the last few times they've come with some weird, rare disease. I'm like, come on, House, man, come on, get in the books, give me a good one here. They picking rare stuff now. All right, so I think it was probably during the writer's strike. They just picked some rare disease out of some book. All right, so breath smells like garlic. Think of selenium or arsenic poison. Anytime you're deficient in it, the heart, who needs so much of it, you get a dilated heart. So really non-specific, unless they give you that garlic smell in the patient's breath. Selenium toxicity. Molybdenum and manganese are necessary for a lot of enzymes and glycolysis. Which ones? They won't ask, Janice. But they will ask you what enzyme needs both of them. Key. Xanthine oxidase needs both of them. It's the same one that makes uric acid, Leanne, for gout. You see, so we can tie trace elements to gout if we want to. This is how they make it a Boris 2 or 3 question, folks. Because they know that a lot of physicians have lost track of the basics. It's just, treating for this for gout. And then when they ask, well, gee, what trace element might you want to make sure? Oh, boy, anyway. The key is know the connections. All right, 10. No unique clue. Necessary for hair. Heck, so is every other vitamin. So I think I've seen one question about 10 in 20 years, and that's all they ask. What tissue use it? Hair. Yeah, because there's nothing unique about it. All right, fluoride, necessary for teeth and bone growth. If you have too much fluoride in your system, thyra, it'll block an enzyme in glycolysis called enolase. Well, in the old days, thyra, children who needed fluoride, they would have them eat like rock candy. There were rocks of fluoride. And they would bite into it like rock candy. Well, then years went by and they decided, we need to figure out how much of every nutrient a person really needs. That's called the RDA. Recommended daily allowance. You know what that term means? How much of any nutrient does a person need to prevent disease? That's what RDA stands for. Even though it's recommended daily allowance, but you got to understand, how did they come up with this number? That number is how much do you need to prevent disease in 95% of the population. Remember, bell-shaped curve. That's it. We always try to protect 95. The other 5, we leave out there. Okay? So when they found out what the RDA for fluoride was, it was 6 parts per million. You don't have to write that down. It's just something I remember. 6 parts per million means 6 molecules of fluoride swimming around in a million molecules of water. Which means if you just put your tongue on a rock, you already had your RDA for fluoride. But it was too late, Malik. Too late. All these children have been biting into rocks full of fluoride, chewing on so much of it. And then they started showing up in local emergency rooms with all kinds of illnesses, man, and then you do an x-ray, you see these bright, white, shiny teeth and bones. Do you hear me, Malik? You understand, Malik? Man, the problem is if you got bright, white, shiny teeth and bones, what do you think was the most common presenting symptom for that, for these children? So let's see if Prethy knows. When they got bright, white, shiny teeth and bones. Fluoride overdose. And I'm saying just shiny white bones on x-ray. What was the most common presenting symptom when they showed up to the emergency room? Let's try Rick. Kidney stones? Close. What do you think, Key? What do you think, Janice? Weakness of what? Thank you very much. What effects did they have, Janice? What's their skin look like? Dry. What about their hair? What about their bone marrow? Depressed. What about their nails? Brittle. What about their breast size? Atrophy. What about the sperm count? Low. What about the GI symptoms? Nausea, vomiting, diarrhea. What part of the nephron was shut down first? PCT. What cancer can they get if they live long enough? Skin followed by. GI followed by. Oh, bone marrow. But the most common cause of death if you don't catch it early enough is what? Class dismissed, baby. All right, the next group of diseases we need to understand are the vasculitides, so turn to vasculitis. Since we've done vascular physiology, now it's time to understand when that physiology goes wrong. Vasculitis means you have inflammation, do you not? If you have inflammation, then that means you already know most of the information. Well, let's look at it this way. If there's inflammation, what's the first visible change you're going to see? Nicole? What is going to be the first visible change that you can see? Swelling. When do your neutrophils show up? At 24 hours. And when do they peak? 3 days. When do T cells and macrophages show up? Day 4. When do they peak? Day 7. And they'll just continue to be predominant. When do the fibroblasts show up? Day 7. When do they peak? 30 days. How long do they take to finish scarring? So that means if you got, 3 to 6 months to finish scarring. So that means if you got acute inflammation, I expect to see swelling and neutrophils. Everybody follow me? If you got chronic inflammation, I expect to see T cells and macrophages. On biopsy, you expect to see scarring and fibrosis. On x-ray, what are you going to see, May? Joseph, chronic inflammation on x-ray, what are you going to see? Calcifications, because as cells die, Josh, they calcify. Is that true? Is that called dystrophic or metastatic calcification? Dystrophic. Metastatic calcification, Kimberly, has to do with what process? Kathia? No. And B? Metastatic calcification has to do with what? Hypercalcemia for any reason. Because calcium will just leak into cells, and then the cells will calcify for that reason. But there's no inflammation going on. All right, so vasculitis, what am I going to see? You're going to see schistocytes. Schistocytes are torn red cells and platelets. Here's how to envision it, to make it visual. You got blood vessel, and you got fibrin sticking out like that. Now, we just did all that clotting, so there's fibrin. You got damage to endothelium, remember? Clotting will begin. Fibrin is sticking out like this. So as the red blood cells and platelets go by, see that? They get sheared into pieces. Bird cells, helmet cells, just describe the shapes of them. All right? Those are schistocytes. Torn red cells and platelets. So what's going to happen to your red cell count, Tariq? It's going to go down. What's going to happen to your platelet count, Chukuma? What? What's going to happen to your platelet count? It's going to do what? All right, Jessica, what's going to happen to your platelet count? It's going to go down. Shifts the size of torn red cells and platelets, Chukuma. All right, every vasculitis. Follow the pattern. Here it comes. All right, so red cells and platelets are going to be low. So you're going to have anemia and thrombocytopenia. If you have that, PJ, low platelets, what's going to be elevated? PT, PTT, or bleeding time. So bleeding time is going to be elevated. Where are they going to bleed from? PJ? Skin and mucosal surfaces. So there it is. Petechia, purpura, and ecchymosis. GI, respiratory bleeding. Everybody follow me? It's all the stuff you learned already now. If you got anemia, you don't have enough red blood cells. Elvis, what do you need red blood cells for? Carry oxygen. What do you need oxygen for, Elvis? What do you need oxygen for? You have no idea what you use oxygen for. You breathe to get oxygen. What do you use oxygen for? I ought to lead. What do you use oxygen for? For energy. Did somebody say something about energy? I ought to lead. Tell me one more time. What's the most common presenting sign for each one of these diseases? Tachypnea and dyspnea. Symptom. Weakness and shortness of breath. Wait a minute. What about infections? Respiratory and UTIs. Tell me about their skin. Dry. About their hair. Brittle. What about their nails? Brittle. What about their bone marrow? Suppressed. Give me some GI symptoms. Nausea, vomiting, diarrhea. Oh my God. What part of the nephron was shut down first? The proximal convoluted tubule. Tell me about the breast size. Shrunken. Sperm count. For some doggone reason, man, anything that has to do with sexuality, just students, just medical students and doctors just go nuts. All of a sudden they can't pronounce the word right. And then she said, You're going to shrink, atrophy. Use whatever word you want. All right, what about the sperm count? Decrease. What cancer can they get if they live long enough? Skin followed by? GI followed by? Bone marrow. But the most common cause of death or the lead is what? Heart failure. Arlie, how'd you know all that? Thank you. That girl's well trained. I like it. Look at that, folks. Everything about a vasculitis you wanted to know. You just didn't know you knew everything about it already. Check it out. So again, low energy state. Hey, wait a minute. If you got a vascular problem, what's going to happen to overall resistance? Joseph, what's going to happen to overall resistance of a vessel? It's going to do what? Increase. So that means what's going to happen to the pressure in the pulmonary? Increase. What's going to happen to pulmonary blood flow, therefore? Decrease. If pulmonary blood flow decreases, what happens to venous? What happens to blood return to the left ventricle? Decrease. If you decrease the volume in the left ventricle, what happens to your cardiac output? Decrease. What about your stroke volume? What? Decrease. What happens to carotid stretch? No. Back to guessing. Don't do that. Go back to your physiology. I told you the first 7 things never go opposite each other. All the way to firing of 10. They go in the same direction all the time. I told you if I say yes to one, you better give me the same answer for all the rest of them till we get to heart rate. You remember this? All right, so that means stretch will decrease, firing by 9 will decrease, firing by 10 will decrease. Kimberly, what happens to heart rate? It has to go up. What happens to your norepinephrine release from the brain? Has to go up. So what happens to your total peripheral resistance? Has to go up. What happens to your renal blood flow? If you vasoconstrict, now follow your own physio. Don't let the mind go back to trying to guess it right again. All right, you vasoconstrict, that means renal blood flow has to go down. What happens to renin-angiotensin aldosterone? Goes up. So what happens to sodium reabsorption? Goes up. What about the total body sodium? Goes up. What about your urine sodium? If you're reabsorbing sodium, what happens to your urine sodium? It has to go down. What about your fraction excretion of sodium? Has to go down. What about your urine potassium? Urine potassium. I thought you were bringing in sodium excreting potassium. Now remember, you got to remember the actions of aldosterone. So now your urine sodium goes down, fraction excretion sodium goes down, urine potassium goes up, fraction excretion potassium does what? It has to go up. Urine potassium goes up, excretion of potassium has to go up. What happens to your urine pH? Since aldosterone excretes hydrogens, Kimberly, you got to go down. Always go from the physiology and figure it out. All right, so urine pH has to go down, which means your serum pH will have to do what? It has to go up. But when sodium comes in, it drags about 3 molecules of water, diluting the whole plasma. So what happens to your serum sodium? Going to go down, serum chloride. Going to go down, serum potassium. I thought we were diluting the whole plasma. How do you dilute 2 and leave the other one high? Can't do it. All right, you're diluting the whole plasma. Do you understand? So low sodium, low chloride, low potassium. Remember, when you're alkalotic, calcium precipitates out of plasma. So low calcium, alkalosis. Sound familiar? It's just a low volume state all over again. Now, you didn't know every vasculitis was a low volume state, but we just reasoned it out, folks. The key is you got to understand these concepts. And that's why I say know your notes. I still accidentally hearing some of you reading these other books. You haven't even learned your notes yet. You're reading other books. That's dangerous, folks, because at the end of 4 weeks, you're going to find yourself confused and lost because you still don't know the concept that that book is coming from. That's the problem. You're taking the long route. That means you have to either read about every disease known to man or just learn a few concepts that put them all together. I'll take the few versus the many, okay? But when students panic, they tend to do the wrong thing. They go back to reading all these other things, and then when I ask them to explain something to me, they can't explain it. It doesn't matter if you know about this disease and that disease and that disease, but if I ask you to explain it, you can't. You just memorize a lot of good things. You'll know it today. Tomorrow I'll ask you, you lost half of it already. That means you're wasting a lot of valuable time when you do that. So be careful. All right, when we do pulmonary, you learn that all vasculitides give you restricted lung disease profile, and like we already said, T cells and macrophage cells, cell-mediated inflammation. All you need to know now is the clue. Because doggone it, if all of them have the same signs, symptoms, effects, complications, blood gas, chest x-ray, electrolytes, and cause of death, Diana, that means you ain't told me squat, girl. You're holding out on me. What do I need to know? To separate all those diseases out, I got to know why. I got to know the clue. Dr. Thompson in the house. Here we go. This is how you separate them out. 3 of them have IgA in their kidney, man. 3 of them have IgA in their kidney. So that means they go on and on about all that other stuff. That tells me nothing. You mentioned IgA, I'm down to 3. Right, understand? All right, 3 IgA nephropathy. Berger's. This is some French guy. Berger's. Don't call him burgers, he gets pissed off. Berger's. This is IgA nephropathy 2 weeks after a common cold. This is very common in children. Well, think about it. Children get 8 colds a year minimum. All right, and that's the norm. All right? So Berger's, IgA nephropathy 2 weeks after URI, then I know this is the one they want me to pick. Okay? In Berger's, half will go on to renal failure, half will resolve with no consequence. But Tara, how are you going to know which half is which? You follow the UA till it clears up. Everybody understand me? That's how you turn it into a management question. What's the next step of your management? Hey, he looks good now, but so what? You still see him periodically and check his UA again. Okay, so that's Berger's. Half go to renal failure, half resolve with no consequence. All right, next one. Henoch-Schönlein purpura, or HSP for short. First clue, IgA nephropathy associated with gastroenteritis. IgA nephropathy associated with gastroenteritis. So the diarrhea starts to clue me in. Number 2 clue, this is the only vasculitis where the purpuric rash starts from the hips down. Real classic distribution from the buttocks down. That means whatever virus causes this, he's a butt man. He knows exactly where the butt begins. Goes right there. Boom. But now this is a real interesting one because when a patient comes into your office, like I had this one lady come into my office with this, I mean, they just been seeing particular purpura all over their legs. They swear they're bleeding to death because every day 10 more pop up. They're like, holy cow, I think I'm dying. So run to the doctor's office. Doc, all right, what's going on? They give you the history. All right, let me take a look. And as she starts to take off her clothes, all of a sudden I notice there's a sharp demarcation right here at the waist. Blue, clear. I said, oh, that's all right, you can get dressed. What is it? Yeah, don't worry about it. It's called HSP. Huh? What's that? Anyway, but this way you can tell them good news. Don't worry about it. It scares the heck out of you because you've been bleeding into your skin and your legs, but HSP will go away. All right? So, classic distribution. Again, picking up on the clues, folks. You look like a hero to a patient when you can pick up something just like that. Okay? All right, third clue. This is the only vasculitis with a normal platelet count. Because Tatiana knows most vasculitides have high, lower normal platelet counts. Huh? Remember, you're tearing them up, Tatiana. All right, so HSP is the only vasculitis with normal platelet count. Remember I told you normal fools, so many physicians? Folks, make sure you know the context of which you're reading it. So that means in HSP and a vasculitis, and I'm seeing normal platelet count, that's abnormal, folks. That's a clue. Okay, but if you just read right past it, oh, they got you. All right, so HSP. Next clue. This one has a high incidence of intussusception. So if they start complaining of severe abdominal pain, Al, I think you know what they want you to do. All right, intussusception, classic clues, current jelly stool. Current jelly stool. Current, C-U-R-A-N-T. Current jelly stool. Sausage-shaped mass in the right lower quadrant. And that's because in children, most of the intussusception occurs right here in the ileum. So you got a part of the ileum that swells up and it slides into the distal ileum like that. You now have a sleeve. So you got a sausage in here. Okay, sausage-shaped mass, right lower quadrant. Okay, if you do a barium enema, okay, you'll see the barium run around the rings like that. It looked like a stack of coins. So they say stack coin appearance on barium enema. Okay? So intussusception is more common in ileum in children and more common in sigmoid if it's an adult. Now you talk about that more in GI on Monday. So henoch-Sirloin purpura. So we get IgA nephropathy after gastroenteritis. The only one with purpura grass that starts from the buttocks down. The only one with normal platelet count and a high incidence of intussusception. All right? Next one, Alport's. Alport syndrome is IgA nephropathy associated with a family history of deafness or cataracts. You recognize Alports when they walk in your office and they're knocking into things. Say, man, you got cataracts. Hey, dude, I think you got cataracts. Oh, yeah, that's right, you got Alports. I forgot about that. Deafness and cataracts. Zing, look at you guys. All right, so that's how I remember Alports. Cataracts and hearing loss. That means in the books they'll talk about primary family history of cataracts, folks. Anybody who's deaf in that family or got cataracts, I'm clicking and moving. All right, cousin down south, good enough for me. You know, second cousin 3 times removed, good enough. Click and move. If they're going to mention cataracts or hearing loss, folks, I'm not debating what side of the family came from. I'm clicking. All right, don't debate the wrong details. So that's Alports. In Alports, they get their problem as children, but it takes about 15 or 20 years to go into renal failure. So watch out for the statement that says, oh, they go into quick renal failure in childhood. They don't. They get it in childhood, but they don't go into renal failure until they're adults. Again, you just have to follow them. Alports. IgA nephropathy associated with hearing loss or cataracts. Next group, burgers. Burgers. This is bad vasculitis associated with smokers or Jewish people. Necrotizing. Thromboangiitis. Well, you know, anything that starts out with necrotizing can't be good. All right, so burgers is the one where their fingers and toes just fall off, just necrose off. Excuse me? Good question. Tim wants to know what kind of necrosis that is. Al knows what kind of necrosis that is. Yeah, he does. Ischemic necrosis. All right, you're correct. Remember, this is messing around with the vasculature. Look at it, he recovered. And I told you, pick the 90% whenever you're not sure. You're going to be right 9 out of 10 times. Okay, this is blood vessels. If you ruin them, clots start forming. Coagulative is ischemic necrosis.
So the spider you said yesterday, that's coagulative necrosis?
Yes, that's correct. See, you're starting to get it, man. All right, so that's burgers. DIC. Number one cause of DIC, sepsis. We mentioned that earlier. Endotoxin stimulates the intrinsic clotting pathway, Nicole. Sepsis, number one. Trauma, number two. Other ones worth mentioning that I mentioned before, amniotic fluid embolism, because amniotic fluid is real gooey. Okay. All right, and abruptio placenta, for the boys, 2 people. Can be associated with DIC. But again, those are rare compared to the top 2. DIC, best clue, fibrin split products or D-dimers. Fibrin split products or D-dimers. If you got somebody with DIC who starts bleeding profusely, how do you stop that bleeding right away? Diana. All right, Sok Choi. Sok Chai, how would you treat them? Nah. Andre, how would you treat them? Somebody with DIC, they start bleeding profusely. How do you stop that bleeding right away? Fresh frozen plasma. They're chewing up all their clotting factors and all their platelets. I already told you earlier, you never transfuse platelets into a destructive process, so that's out. You stop the bleeding by putting back the clotting factors. Remember, you're learning it in pieces, folks, but now we're learning, you got to be ready to put it together. Okay? All right, so DIC. HUS, hemolytic uremic syndrome, is the most common cause of renal failure in children. That's how common it is. Most common cause of renal failure in children, HUS. This is seen 2 weeks after E. coli gastroenteritis. 2 weeks after E. coli diarrhea, bam, the kidney starts shutting down. The strain of E. coli, if you're interested, is always, there's EHEC, enterohemorrhagic E. coli. That's associated with endemic HUS. That means it occurs every now and then. We say endemic HUS. And if it's epidemic, a big outbreak, 015787. Okay, 015787. So HUS, so 2 weeks after gastroenteritis with E. coli, most common cause of renal failure in children. E. coli is associated with raw hamburgers. So they might mention that the child ate raw hamburger. Now you guys been hearing about some of these E. coli outbreaks, right? With spinach, petting zoos in Florida. The kids were there petting the animal's butt. They tried to pet the animal in the face, and the animal said, "Man, I'm tired of you guys petting my face." And the animal just turned around, and the kid wanted to pet him anyway, and just put his hand right across the butt. Then, of course, now you got a handful of E. coli. That's why now in petting zoos, they now have 2 railings. That way the child can't reach the animal. See, animals play pranks too. They turn their butt on little Charlie. They know Charlie's still going to reach out anyway. All right, folks, that's HUS. TTP. Thrombotic thrombocytopenic purpura, TTP. Classic clue, loves to attack the cerebral vessels first. Now, all of these can attack cerebral vessels, but this guy attacks the cerebral vessels pretty early. So that's why they present with neurological problems. So on the boards, they try to get slick and talk about, oh, he just had a little delirium. Well, that's neurological to me. Seizures, whatever. The key is anything neurological, and then you see this pattern of vasculitis, TTP is your answer. Okay? TTP, I told you earlier, is associated with clopidogrel. So they might slide that in there, that he's also on clopidogrel. It's a side effect, yeah, of clopidogrel. The problem in TTP, von Willebrand factor esterase deficiency. The enzyme that breaks down VWF is missing, which is why then VWF promotes more clots, and then you got to break it down, and you got a vasculitis now. VWF esterase deficiency, TTP. Okay, so neurological. Diabetes, vasculitis, glove and stocking distribution. Glove and stocking distribution, just like the neuropathy. Glove and stocking distribution. What was the chemical made from sugar that causes neuropathies, Omar? Tara? Sorbitol. The aldol reductase pathway. So if you have excess sugar, then sugar has nothing to do. It can enter this little pathway and be turned into something your body doesn't even want. Okay? And then that causes neuropathies. The vasculitis is caused by the hyperviscosity, glucose itself. Remember the Parseau's law? Viscosity down at the bottom. So you're messing up the blood vessels with viscosity. Okay? Next one, syphilis. Syphilis. What do they say? You look at the aorta, it likes to attack the aorta. So they talk about syphilitic aortitis. They'll describe it as a wrinkled intima. Tree bark appearance. Or the worst term, obliterative endarteritis. Now, you know, any term that starts out with obliterative, that can't be good either. Okay, syphilis literally just chews away at that aorta. This is only in tertiary syphilis that you see it in. It's not a body-wide, system-wide vasculitis. It's specific to the aorta. Okay? Syphilis likes to attack the aorta. Specifically in the aorta, it likes to attack the vasovasorum. Vasovasorum. This is the blood supply in the wall of the aorta. The blood supply in the wall of the aorta is being attacked. Syphilis. Next one, Takayasu. Takayasu, best clue, weak pulse in an Asian female. Now, why it attacks primarily Asian females, that we don't know. Obviously, got to be something genetic. I don't know. But Takayasu's, again, you see granulomas in the aorta, just like syphilis. A lot of T cells in macrophage just eating it out. Now, the books always talk about pulseless aortitis. My feeling, she can't be pulseless and be in my office complaining. We wouldn't be worried about it if you were pulseless. Okay? So it's really just faint pulses, weak pulses is what they're really trying to say. Takayasu's. Now, because the aortitis is so severe, the SED rate is real high in this patient. Just like in temporal arteritis, a lot of times they'll give you like a SED rate of 110, 120, just to make it obvious. Okay? Then Kawasaki's, the old name was mucocutaneous lymph node disease. I like the old name because it tells me most of the features of Kawasaki's. Now, before they used to think Kawasaki's was primarily in Japanese children. No, it's in America. It's pretty widespread now. You're going to see it. All right, mucocutaneous. First criteria, mucositis. That means red eyes, red lips, red vagina, red urethra. Mucositis. In fact, they have a strawberry tongue and dry, cracking lips. Strawberry tongue, dry, cracking lips. The mucositis is the first clue. Then cutaneous. They have a red rash all over their body, including the palms and soles. Oh. You might want to know the 7 primary rashes that involve the palms and soles, man, because that is very, very high yield. Tammy, break it down. Oh, no, she says. That's not a good beginning. But go ahead. Take a good deep breath. Tell me as many as you can. Palms and soles, 7 primary rashes. Go. Staph scalded skin syndrome. Toxic shock syndrome. Kawasaki's disease. Syphilis. Rocky Mountain spotted fever.
No, hold up. There's 2 more.
Mm-hmm.
Oh, I haven't been doing these.
That's all right. One more on the staff. Scarlet fever. Scarlet fever, and then hand, foot, and mouth disease. Coxsackie A. All right, so 7 rashes involve palms and soles. Very, very high. When you think of thousands of rashes and a small number like 7, come on, folks, you better know it. It's all over the exam. All right, same thing in real life. When you walk in your office and you see the palms and soles, man, that's a limited list. Okay? What's that? No problem. Tanvi, repeat the whole list for you again. Go ahead, Tanvi. Go ahead. Toxic shock syndrome. Staph scalded skin syndrome. Rocky Mountain spotted fever. Kawasaki's disease. Coxsackie A, hand, foot, and mouth disease.
Syphilis.
Syphilis. Scarlet fever. Yeah, you get out. All right, so 7 rashes, 7 primary rashes. Okay, that means if you got involved with palms and soles, I'm picking one of these 7. Okay, which means for any other rash, it's rare. That's what I'm telling you. Why go for the rare point? I like the common points. All right, so Kawasaki. So first criteria was mucositis. Second criteria was the rash. Third criteria was lymph nodes, cervical lymph nodes up and down the neck. That's criteria 3. Criteria 4, fever of at least 102. And criteria 5, that fever must be there for 3 or more days. So 5 major criteria to diagnose Kawasaki's. Mucositis, strawberry tongue, dry fissured lips. Cutaneous, the rash involving the palms and soles, just a red rash, nothing big about it. Lymph nodes up and down their neck, 3rd criteria. 4th criteria, temperature of at least 102. 5th criteria, that fever must persist for more than 3 days. Then we say you have Kawasaki's disease. Kawasaki's disease is the only vasculitis with a very high platelet count. And that's because Jenny knows a vasculitis should have what type of platelet count? Low. So if it's high, that's very abnormal. Well, there's only one. And Jenny remembers who's the only vasculitis with a normal platelet count. No, HSP. HSP. So only one with normal, only one with high. All right? Now, yes, sir.
The lymph nodes, are they just swollen?
Yeah, just swollen. Nothing unique about them. All right, now, when you have Kawasaki's disease, there are 2 complications you have to worry about. Number 1, it likes to attack the coronary arteries. Remember, because the heart has such a high AVO2 difference at rest, your heart, your coronary vessels are completely flow dependent. They already extract 97% of the oxygen that comes to them. So when you give oxygen to somebody's face, folks, you're not really making that much of a difference for the coronaries. Everybody understand? Let me illustrate that for you. When somebody shows up to the emergency room and says, "Doc, I got chest pain," well, what's the first thing we do? Slap oxygen in his face. He still has 10/10 chest pain. And then you put nitroglycerin underneath his tongue. How come all of a sudden the pain goes away? In case anybody ever argues with you about that point, the oxygen doesn't take away angina, but nitrates do. That's because your coronary circulation is completely flow dependent. It already extracts 97% of oxygen. So extracting 98 doesn't really make much of a difference. That's only 1 more percent. But whereas if you increase flow, 97% or more flow is a bigger number. Okay? All right. So it likes to attack coronary vessels. And they get coronary aneurysms. And these coronary aneurysms make and clot off. 90% of them, Dahlia, occur in the first 6 months. Remember I told you the practice of medicine is based on the 90%. For that reason, you'll understand why we manage it thusly. You do an echocardiogram when you make the diagnosis. Your first echo is when you make the diagnosis. Your second one is when you discharge them. And then every month for the first 6 months. Why? Danielle is asking herself. Because we want to capture the 90% and save them. Kawasaki's attacking the coronary vessels. If any time on echocardiogram you see the aneurysm is 8 millimeters wide or more, so that's the number you need to know because they'll just tell you how wide it is. 8 millimeters wide or more, you must do bypass surgery on that child. For that reason, Kawasaki is the #1 reason why we do bypass surgery in children. Sickle cell is a close second. So that means if you clot out the coronary vessel in a child, folks, we can't let that stay that way. He's a child. That means you're letting his life be cut short. So we bypass it. Okay? Everybody follow. First echo when you make the diagnosis, on discharge, and every month for 6 months. Then you can repeat every 6 to 12 months to follow the anatomy. 8 millimeters or more, bypass. Yeah, this is primarily in children, yeah. Now imagine how devastating this is for a mother. She brings in a child, she thinks it's just a bad cold. You have to hospitalize the child, and then when you make the diagnosis, oh my God, you got to do bypass tomorrow, Mom. You know that is shocking news, very devastating news. What? I didn't know we did bypass surgery in children. Well, we do, okay? So Kawasaki's disease. Well, if you want to decrease the incidence of those coronary aneurysms, we give them IV immunoglobulin. IV immunoglobulin, 1 big dose. It's approximately 4 grams per kilogram, last I checked, for the boys 2 and 3 people. 1 dose is all you need. But that 1 dose, Al, costs about $10,000. So that means, folks, before you order that, you better make sure you got all 5 criteria satisfied, because that's a lot of money to spend on a diagnosis that you haven't solidified yet. Okay, once you're sure, though, then we don't take chances. We spend the $10,000 on it. 1 dose. But IV immunoglobulin has been shown to decrease the coronary aneurysm risk. Okay? All right, the second complication of Kawasaki's we have to worry about is the high platelet count, thrombocytosis. Well, if you want to stop platelets from clumping right now, at this moment, Thomas, what drug could you give them? What drug do you know that can block those glycoproteins? Let's see if Diana remembers. Yeah. No. Do you remember, Mark? Bertholin, do you remember? All right. Ajay, do you remember? Paul, do you remember? Abscissumab. So if you want to stop the plays right now. However, Paul, what is the most effective antiplatelet drug out there? Aspirin. That's how you know you got to put on aspirin, folks. Again, I want you to figure things out so that when you see the recommendations, oh, okay, makes sense. All right? So if they come in acutely and they're already in the middle of a heart attack, whip some abscissumab on them. Okay, because you know it's the platelets doing it. And then when you send them home, you send them home on aspirin. Okay? And then because they're going to be on aspirin for minimum 2 years, you got to make sure they get a flu shot every year. The risk will rise because they have to stay on aspirin. So they have to get that flu shot every year. Don't worry, Michelle won't miss that question ever again. Oh, that's what they were getting at. All right, so again, that's why I want you guys to understand the pieces to the puzzle so your brain can put together the whole puzzle. Okay? So Kawasaki's. Any questions on Kawasaki? Ajay? Thrombocytosis, too many platelets. Berthulin, any questions? You understand so far? All right. Brendan? Fever that lasts for more than 3 days. The fever must persist for more than 3 days. Yeah, the fever. Uh-huh. No. It's usually caused by virus. Not strep. Strep causes its own necrotizing vasculitis. Yeah. But it's not that strep is the only one who can do a necrotizing vasculitis. All right, next group, temporal arteritis, we already talked about. Which neuromuscular disease, Diana, has a high incidence of temporal arteritis? Andre? Sandeep? Chris? Dan? Rashmi? Omar knows. Nicole knows. Eros. It's called polymyalgia rheumatica. Look at all those pages turning. Folks, you got to drill these things if you want to remember them. All right, so temporal arteritis has a high incidence in polymyalgia rheumatica, but I told you it occurs in people after what age, Cammie? After age 60, you expect the sub rate to be higher than what number, Cammie? 60. And what's the last 60? You need at least 60 milligrams of prednisone to treat them. All right, temporal arteritis, temporal headache, in anybody after age 60 equals TA until ruled otherwise. That means, however, Rebecca, if they come in complaining about visual problems, what complication are you worried about? Blindness. So that means when they come in to see you and they already have visual problems, Linda, what's the next step in your management? What? I didn't hear you. Steroids first, biopsy second. Everybody remember that, right? If they just have a headache, biopsy first, steroid second. Everybody clear on that management. That's on boys 1 and 2 now. All right, that's temporal arteritis. If you biopsy that artery, Diana, what cells are you going to see in that artery? Since this is a chronic disease, Diana. All right, Saktai, what are you going to see? Okay, you may see some fibroblasts. What's the main cellular infiltrate going to be, Sobi? T cells and macrophages. Don't forget that. All chronic inflammation now. If it's non-bacterial, same answer. You understand? Okay. Ankylosing spondylitis is one of the 3 HLA-B27 diseases. So I like to talk about all 3 at the same time. The spondyloarthropathies, HLA-B27 positive diseases. Ankylosing spondylitis is a prototype. The clue, first clue, middle-aged male comes in with back pain. That's the most common presentation. Middle-aged male with back pain. Why? They almost always start out with sacroiliitis, inflammation of the sacroiliac joints. That's what then allows you, Tara, to understand the next step in your management. When they come in, is always to do back x-rays. And you will see inflammation of the sacroiliac joints to make the diagnosis. Then the inflammation jumps into the lumbar spine, and you get ankylosing spondylosis. That just means scarring and fibrosis of the lumbar spine. As you scar and fibrose, it starts to pull the lumbar spine down. And all of a sudden you see them lose height. Classic. It's the only disease where you grow to a certain height and then you start losing inches. Because it starts pulling them down by the lower back. They have to come down to meet the scarring. Okay? So much so you end up seeing remember, bamboo spine. The whole thing is just scarred together, looks like a bamboo now. Okay? So ankylosing spondylitis. Again, sacroiliitis precedes everything else usually. 9 out of 10 times. Then you see the ankylosing spondylitis of the lumbar spine. So you get spinal fusion. We call that bamboo spine. When you ask them to bend over, you'll notice the lumbar spine hardly moves. That's called a positive Schober test. Positive Schober test. Which means the lumbar spine hardly moved when you ask them to bend over. Okay? The problem with ankylosing spondylitis is that they end up getting inflammation of the aorta. So this one, again, likes to attack the aorta, and then they end up dying from dissection. So ankylosing spondylitis. All right, now just to be complete, under HLA-B27, after AS, psoriasis, just so we get all of them discussed. Psoriasis is also HLA-B27 positive when it has arthritis with it. When arthritis, Jessica, does not have when psoriasis does not have arthritis with it, then it's HLA-B13 positive. What's unique? Psoriatic arthritis is one of only 2 types of arthritis that can attack the DIP joints, distal interphalangeal joints. Psoriasis, and the second one, Danielle? Not RA. OA. Osteoarthritis. Degenerative arthritis. Remember Boucher's, Herbert, and nodes. Okay? So, psoriasis and osteoarthritis, the only 2 that can typically attack your DIP joints. So that's the first clue, DIP joint involvement. Okay? Second, silver oval plaques on extensor skin. Silver oval plaques on extensor skin. What is the problem with psoriasis? Autoimmune attack against your skin cells. They're being attacked. That's why they're dying. They get dry and flaky, and that's why you get the plaques. Dry, dead skin. In their fingers, you'll see little holes in their nails. Pitting of the nails is another clue. They start to destroy the bones of the fingers, and you'll see what they call pencil-thin bones. I mean, just bony erosions till, one of the phalangeal bones is just a little, looks like a thin pencil instead of a solid bone. Loves to destroy it. Okay? So, psoriasis. Again, if you have arthritis, B27 positive. If you don't, then it's B13. They also have a high incidence of gout because purines. You got to destroy all this dead tissue. You produce a lot more uric acid. So high incidence of gout and uric acid kidney stones in psoriasis. Okay? Then the third B27 disease is called Reiter's. Reiter's syndrome is a post-infectious arthritis. That means after an infection, now you develop an arthritis. So it's immune complex deposition into the joints. This was first described with chlamydia infections. If you remember urethritis, conjunctivitis, arthritis, can't pee, can't see, can't climb a tree, that stuff. Well, they thought it was just chlamydia. But they realized later chlamydia is not the only one who does this type of disease. They found out Shigella can do it. They found out Yersinia enterocolitica can do it. And they found out inflammatory bowel diseases can do it. I think he's falling. So these are the 3 HLA-B27 diseases. The treatment for, like Reiter's, is treat the underlying disease. Treat the infection. And you can just give NSAIDs for the arthritis. It goes away. All right, so ankylosing spondylitis. Next one, PAN. Back to vasculitis. Polyarthritis nodosa or panarthritis nodosa, same thing. First clue, P-ANCA. P-ANCA. Peripheral type anti-neutrophilic cytoplasmic antibody. Anyway, they always say P-ANCA. Okay? Polyarthritis nodosa, 40% of the time is seen with hepatitis B. So they can either give you a patient who's got hepatitis B, and now he starts to develop this vasculitis, and they'll ask you what do you call it, or they give you somebody who has PAN and ask you what infection could he have had that triggered this off. Hepatitis B. Okay? Pianka. All right, now Wegener's involves the sinuses, lungs, and kidneys. That's the first clue. The pattern involves the sinuses, the lungs, and the kidneys. Marker, C-ANCA, C-A-N-C-A. Okay? And Wegener's is the number 2 cause of rapidly progressive glomerulonephritis, which means you see crescents. Crescents in your kidneys means that something is just ravaging the kidney now. Well, good patches, number 1, Wegener's number 2, whenever you see crescents in the kidney. Okay? Other disease can do it, but it's rare you'll ever see it in any other disease. So that's the point. Always pick the 90% first. All right, so that's Wegener's. Good pastures. Good pastures like to attack the lungs and the kidneys. So as you can see, Tamir, when they mention lungs and kidney involvement, don't click so fast. Make sure there's no sinuses in there. Because they'll try to be, oh, he always has this nosebleed that just won't stop. Close enough for me. Okay? So, Wegener's are good pastures. Be real careful. So the first clue for good pastures, lung and kidney involvement only. Second clue, anti-GBM. That means antibodies against your own glomerular basement membrane is what's attacking you. Anti-GBM. Third clue, on EM, they'll describe linear immunofluorescence. That's a type 2 hypersensitivity. You see the antibodies in single file. Linear immunofluorescence. Okay? And then the number 1 cause of rapidly progressive glomerulonephritis or crescent formation. Good pastures. So Wegener's and good pastures. Make sure you verify before you click. All right, next one. Leukocytoclastic vasculitis is the term you give it when a drug allergy caused your vasculitis, Benish, which means leukocytoclastic is nonspecific. The clue in your question would be the guy had an allergic reaction to sulfur or penicillin, and now he has a vasculitis, and they're asking me, what's the term for this? Then I know the answer. Because it's any drug. It's not limited to any one drug. Most times I see it as somebody reacting to penicillin or sulfur drugs, and now he has a vasculitis. And they want you to put a name on it. So leukocytoclastic vasculitis. Sherrick-Strauss is one of what we call a pie syndrome. We'll be talking about this in pulmonary again. Pie syndrome means pulmonary infiltrate with eosinophilia. Pulmonary infiltrate with eosinophilia. It means there's an allergic process going on. Well, the most common one is called allergic bronchopulmonary aspergillosis. So that means if they give you no other clues, you have to pick number 1. Aspergillus has been crawling through your lungs. Okay? Aspergillus can mimic asthma, severe asthma in an adult. That's why they always tell you, any asthmatic who has severe symptoms as an adult, you got to rule out aspergillosis. Remember, a lot of fungus is growing in people's mold and fungi growing in people's basements now. That person may not know they've inhaled a lot of aspergillus into their lungs, making the asthma so severe. Okay? The second one is called Loeffler syndrome. Loeffler syndrome is when a parasite was crawling through your lungs. Loeffler syndrome says a parasite was crawling through your lungs, and we know who it is. In fact, we have a mnemonic for the 5. The mnemonic I use is NASA. 5 parasites that make their way through your lungs as part of their life cycle. So that way they're going to leave a pulmonary infiltrate and the eosinophils that are chasing after them. N is for Necator americanus. N is for Necator americanus. A is for Ankylostoma duodenale. Ankylostoma duodenale. Again, we'll go through all these again in infectious disease. S is strongyloides. Strongyloides. Second S is schistosoma. Schistosomiasis. And the last A is Ascaris lumbricoides. So NASA, Necator americanus, Ankylostoma duodenale, strongyloides, schistosomiasis, and Ascaris lumbricoides. That's Loeffler syndrome. And then the third one is Sherrick-Strauss. Sherrick-Strauss means something, some parasite went through your lungs, but we have no idea who he is. We got so many names for idiopathic, so many names that really mean we have no idea what's going on. But we don't want the patient to know that, so we put a name on it. Essential. Okay, yeah, but we have no idea. Idiopathic. Okay, good. What is it, doc? I have no idea. It's idiopathic, you know. And then here we go again. Sherrick-Strauss. Two guys put their name on it, but we don't even know what it is. Anyway, the key is this one mimics bad asthma in children. Some parasite going through the lungs, but we don't know who it is. We just see the evidence that eosinophils are chasing after him, which means he must have been here. Everybody understand that? If you got a pack of eosinophils hanging around, they're chasing some parasite, because that's one of their main jobs. So Sherrick-Strauss mimics severe asthma in children, just like Aspergillus mimics severe asthma in adults. Well, Sherrick-Strauss can also be P-ANCA positive. Okay? So that's Sherrick-Strauss. What about collagen vascular diseases? Those can cause vasculitis, so we need to talk about them. Crest syndrome is the mildest form of scleroderma. Crest syndrome is the mildest form, Linda, of scleroderma. It means patchy involvement. It's not full-blown yet. Crest syndrome, mildest form of scleroderma. The crest stands for something. The C is for calcinosis, especially now that Tina knows that the cells die to calcify, don't they, Tina? What kind of calcification do you call that again? Dystrophic calcification. All right. The R is for Raynaud's phenomena. This is just spontaneous vasospasm of the arteries in your fingers or toes. All of a sudden, your fingers or toes turn blue, blanch, and then pink back up. Okay, classic, especially when they're exposed to cold or they're nervous. I've seen a couple of women in here with Raynaud's phenomena. Okay, so when it's real cold, they got to wear gloves or else just turning blue for no reason. All right, so that's Raynaud's phenomena. E is for esophageal dysmotility from all the scarring. Esophageal dysmotility from scarring. So a lot of times they have a problem swallowing, choking, gagging a lot because the peristalsis is not uniform anymore. So esophageal dysmotility. S is for sclerodactyly, which means tightening of the fingers or toes. Scarring, sclerodactyly, fingers or toes. Okay? And then T is for telangiectasias. Spider veins, because veins pop to the top when you tighten up the skin. Okay? Remember, veins are superficial. So Crest syndrome, the mildest form of scleroderma. The best clue for Crest syndrome, anti-centromere antibody, which means you won't see it in any other disease. Classic clues. They almost always give you that clue. Crest syndrome. Next one, when it's full blown, then we say scleroderma. Well, look at the term, scarring of the derm, skin. In scleroderma, you have anti-smooth muscle antibody. Anti-smooth muscle antibody, or they'll say anti-SCL. SCL is just short for scleroderma. Anti-SCL70. If you're attacking smooth muscle, that's why it attacks underneath the skin, the blood vessels, and the GI tract. All scarred up. Scleroderma. Scleroderma gives you the worst onion skinning in the kidneys. What does onion skinning mean to you, Sobi? Huh? Yeah, but it means more than just fibrosis. Andre? I know, but what does it mean if I see onion skinnings? But why do you have it layered, then normal, then layered, then normal? Looks like onion skin. Let's see if Sandeep remembers. Let's see if Mustafa remembers. Intermittent hypertension. Remember, every time you get that abrasion, that's when you get the hyaline. That's one layer. Then it normalizes for a while. Then you got normal tissue. Then it goes back up again. And then you see the hyalinization again. That's why you see layers of hyalinization. So onion skinning. Okay? So scleroderma. All right, progressive systemic sclerosis is when scleroderma involves your internal organs. So it's a more severe form. You understand, Binish? You understand, Paul? PSS is the most severe form of scleroderma. Because now it starts to scar up your liver. Now it starts to scar up your spleen. Now it starts to scar up your lung. Man, if you're scarring up all my organs like that, what the heck is the most common cause of death in progressive systemic sclerosis? Purnima. Respiratory failure. We're getting close. Jessica. Why heart failure? What? In progressive systemic sclerosis, what is the most common cause of death? When you're scarring up my liver, you're scarring up my spleen, scarring up my lung, scarring up all my organs. What's going to be the most common cause of death? I would have said respiratory failure. What are you going to say, Manny? I would have said heart failure. Well, who's right, Danielle? Why is it heart failure? Why is it the most common? Thank you. Ischemia. Well, anytime you're messing with blood vessels, any vascular problem, which blood vessels in your body are the most flow dependent? It's the coronaries. Here's the tricky questions, folks. They'll give you somebody who's got his whole carotid clotted off. And they'll ask you, what's the most common cause of death for this person? I bet you it's heart failure. While you're busy concentrating on stroke and all that, they get you. If you forget your physio and the basics, they'll get you. Okay? Why do you think we always got to clear the heart before you take them for carotid surgery? Why do you think you always got to clear the heart before you take them for vascular surgery anywhere in their body? The coronaries are always the first to go whenever you got a vascular problem. They use that so many times as a trick question. Get you all into the brain, and then they ask you, what's the most common cause of death? And then you forget what disease process you're dealing with. Why? Because he's got you all in here now. Be careful. Stand out here and say, what kind of disease process is he describing to me? What's the concept or the clue? Answer the question based on that if you want to stay accurate. All right, so that's progressive systemic sclerosis. Classic clue, anti-topoisomerase antibody, which means you won't see it in anybody else. Anti-topoisomerase antibody. So CREST had anti-centromere, scleroderma had anti-smooth and anti-SCL70, and now PSS has anti-topoisomerase antibody. Okay? And then whenever you have a combination, two or more, we say mixed connective tissue disease. That means any two. So that one is non-specific, but they got to describe things consistent with one disease, and I see some clues for another disease. I say, aha, they want MCDD. Classic clue for this one, Mark, anti-ribonuclear protein antibody, RNP, mixed connective tissue disease. So it's not that when you have RA, you can't pick up lupus, or you have lupus, you can't get scleroderma. You can get a combination of these things. All right, let's go rheumatoid. Rheumatoid arthritis is the most common arthritis in middle-aged females. That means if they give me no more clues, I got to pick a rheumatoid every time. Rheumatoid is the most common arthritis in middle-aged females, followed by lupus. So the top two, but this is the 90% all by itself. Rheumatoid arthritis. Rheumatoid arthritis is the only arthritis that attacks C1, C2, atlantoaxial joint. Rheumatoid arthritis, the only one that attacks atlantoaxial joint. So you give me any middle-aged female who's got atlantoaxial joint problems, I'm picking RA every doggone time. There's only one other disease that has an unstable atlantoaxial joint. It hasn't been attacked, it's just unstable from birth, and that's Down syndrome. This is why Down syndrome are forbidden to play contact sports. You may knock their head right off. C1, C2 is not usually firmly attached, folks. So when you got rheumatoid who's got the same problem because rheumatoid's been attacking that joint, what's your clue? All of a sudden, a woman will call you and say, I'm feeling tingling numbness in all my extremities. Uh-oh. That means in a vignette, folks, you better catch it. And in real life, you better catch it. Because she'll call you and she doesn't know. Should I rest? Should I take some pills? No, you better run to the emergency room. Anybody ever been to the hospital and seen a middle-aged female wearing one of those iron halos around their head? Anybody ever seen that? Yeah, that's to hold their head tightly like that until you can take them to surgery and fuse those two. Because if you don't, it can slip. They become quadriplegic for the rest of their lives. That's why you got to hear the clue. So many times the clue comes across the phone, but most physicians never catch it. If the clue is not in your cortex, you won't catch it. And you might agree with it. Yeah, just take a couple of Tylenols. Why don't you see me in the office tomorrow? And it'll slip. And you missed it. All right? Now, we've had two studies that I'm aware of that came out and said, you know, when they did independent study, they found that doctors are responsible in the deaths of more patients than all diseases put together. So we're trying to figure out a cure for AIDS. We got to cure physicians. We'll save a lot more lives. I'm serious. I mean, that's the sad part of it. Doctors don't kill people by commission, which means we don't go to work and say, oh, I'm going to kill 3 people a day. Oh, yeah, at the end of the day, oh, man, I didn't make my quota. I only killed 2. No, you can't. We don't do that. Doctors hurt people by omission because they don't know what to do, so they just don't do anything. And they let the patient walk right back out of the office with the same problem they walked in with, or leave the house with the same problem they walked in with. This is one thing that elderly people complain about physicians all the time. Doc, I still got the same problem I came in here with. No surprise, folks. If the clue is not up here in the cortex, you won't catch it when the patient's talking. And so you still don't know what's going on. And so you just prescribe something. Hey, why don't you take this? And I'll see you back in a couple of weeks. The patient's pissed off when they get home. I still got the same problem. I've seen the doctor 3 times now. You know, I've seen this specialist, I've seen that specialist. I still got the same problem. Nobody seems to know what's going on. If the clue is not here, you will not catch it. Okay? All right, so rheumatoid, the other clues. Rheumatoid is the only arthritis that likes to attack the synovium of the joint. Synovium, but they'll use the word pannus, P-A-N-N-U-S. Any mention of synovium, click. Pannus, click, click. Next question. That's it. I'm done. I'm not going to argue. I'll take the 90 to 95 any given day. All right, so rheumatoid. Then there's a childhood form called JRA. Juvenile rheumatoid arthritis. Okay, also known as Still's disease. So it's just a juvenile form, but it's divided up into 2 types. 2/3 of them are rheumatoid factor negative. And so they have a very favorable prognosis. 1 or 2 joints are involved, goes away, they do just fine. 2/3 are rheumatoid factor negative. So-called oligoarticular, which means only a few joints are affected and they do okay. But they have one bad complication that you have to worry about. Danielle, do you remember what it is? Iridocyclitis. Very good. This is inflammation of the iris and circular muscles of the eye, and therefore it can cause complete blindness. Iridocyclitis is the main complication. For that reason, on boards 1, they just ask you what's the complication you have to worry about, so you got to know this term. On boards 2, next step in your management, they still have to see an ophthalmologist every year because laser surgery can slow it down when they start to develop it. Okay? So the problem is if you don't know that, though, you just send the patient home. You don't say anything about an ophthalmologist until they start going blind, and then a sharp lawyer reads in your chart that you've never mentioned the word ophthalmologist. That means that now you can be blamed for it. Okay? Very important. So iridocyclitis. The 1/3 are rheumatoid factor positive. They're the ones who have rampant disease. They're the ones who show up on the telethons because the disease is so bad. You see their fingers all gnarled up and they're already in a wheelchair. The joints are all messed up. Man, when your joints are all messed up like that, What do you think is the most common cause in somebody with JRA, Michelle? The ones, yeah, the 1/3 which have rheumatoid factor positive. What is going to be the most common cause of death for them? Especially when they're in a wheelchair. I've seen some of them go over the stairs and fall. And then they get this rash on their back. Oh, yeah, that's right. Heart failure. I'll sure try my darndest, though. All right, folks, don't forget, this is still a vasculitis. Doesn't matter. All right. So that's JRA. Now, the rheumatoid factor that we're always talking about, what the heck is it? The rheumatoid factor is a defective FC portion of IgG. Because yours is defective for whatever reason, you now start making antibodies against your own IgG. So they'd love to ask you now, what is the rheumatoid factor? It's FC portion of IgG that you're making antibodies against. And then it's being deposited throughout the body. All right, now there's sub-syndromes of rheumatoid. If you put rheumatoid with leukopenia and splenomegaly, that's called Felty's syndrome. So they'll tell you his white count is real low and the spleen is real big. Okay? If the leukopenia is real bad and they get into a lot of severe infections, then you can give them what they call granulocyte colony. Oh no, granulocyte colony stimulating factor, GCSF. That's it. Yeah, GCSF. You can stimulate their bone marrow to make more granulocytes. Okay? So I know that one only when they say the white count is like 1,000, 2,000, and they've had so many infections over the past month or something like that. Well, if you want to prolong their lives, you better make their bone marrow make some more granulocytes. Behçet's is rheumatoid arthritis with GI ulcerations. So they'll mention ulcers in their mouth, esophagus, stomach, all the way through. GI ulcerations, Behçet's. And they also have a high incidence of uveitis, which can also cause blindness. So they need to see an ophthalmologist every year too. So that's Behçet's syndrome. Sjogren's syndrome is rheumatoid arthritis with dry eyes and dry mouth. Xerostomia, xerophthalmia. Dry eyes and dry mouth. Now be careful if you have dry eyes and dry mouth by itself, we call that Zika syndrome. They never mention an inflamed joint. Then you can't call it Sjogren's. But most times they start out with someone's got arthritis and now they notice their eye is dry, feels gritty. Classic. They're about to develop Sjogren's. Okay? For the dry eyes, you prescribe artificial tears. There's plenty of them over the counter. Okay? Or you can prescribe some. And then there's an antibody that goes with this, Ro, La, or SSA. Antibody goes with Sjogren's. Ro, La, SSA. Ro antibody, folks, has a high incidence of causing heart block in the newborn. So they'll give you a mom who's got Ro antibody positive, and then ask you, what do you have to worry about in the newborn? It's heart block. What's the treatment for all the heart blocks that you have to treat, Dan V? So acutely, you're treating with atropine. Long term, Danielle? Pacemaker. That's why we discussed the VVI. But no, your answer was right. I didn't say you're wrong now. Yeah, acutely, atropine to speed it back up. Then you got to put in a pacemaker for long term. Okay? Nice, very good. And then finally, the College of Vascular Diseases, which have low complement. Yes, Danielle? For Sjogren's, yeah, you can do a biopsy of their lip if you want to diagnose it. Sure. Because of the Ro antibody. Yeah, it's the antibody who actually causes it. It can cross the placenta, and then it causes fibrosis between the SA and AV node. Remember that's what heart block was? Yeah. That's why suddenly now it takes so long for things the signal to get to the ventricle. All right, these are cardiovascular diseases with low complement. Why do they want me to know about the 6 with low complement? And why did I save it for last? Because, folks, it turns out these 6 causes, these 6 vasculitides, start out in nephritic syndrome. Okay? Every vasculitis starts out in nephritic syndrome. But these 6 can progress all the way to nephrotic syndrome, which means you can get so much immune complex deposition that you eat up all your complement. That's why it's low complement. So that means if they give me low complement, they've already narrowed down to 6 for me. Second reason, when somebody comes in with nephrotic syndrome, 98% of the time, it's one of these 6. So that means the first test you run on somebody with nephrotic syndrome, Tara, is what? You get a complement level. Because 98% of the time, it's one of these 6. That means on a test question, when they tell me the complement level is normal, I bet you 4 answers drop off the list. You get a freebie if you're looking at it carefully. Because you're always being tested. Do you understand the main concept? They purposely told you the complement level was normal. Well, then they put the common stuff right back there in front of you. And then you forget. Why are you looking at these other 4? They have low complement, and you accidentally picked the wrong one anyway. That's why I say always organize. So this is organized. So at the end, I'm telling you the highest yield stuff. Low complement. Once they mention low complement, boom, here it is. 6 places. All right, so here they are. They're clues. Post-strep GN. Caused by strep pyogenes. Specifically strain 12. Strain 12. Yes, they can be that specific. Well, when you consider there's about 150 strains of strep, and one guy causes the majority of cases, they want you to know that. Post-strep GN. Strain 12 of strep pyogenes. What do you see? This is second clue, 2 weeks after a strep throat. Now don't get it all mixed up with Berger's, which is 2 weeks after a common cold. I've had way too many times to work with a student, and they say a patient got 2 weeks after a common cold, and now they got blood in their urine, and they go pick post-strep GN. I said, wait a minute. What is the clue for post-strep GN? 2 weeks after a sore throat? I said, but all they said was 2 weeks after a common cold. Yeah, but, I figured that since he had a bad cold, he probably had a sore throat with it. That's why I say, folks, if they don't mention it, don't you bring it up. Don't you start projecting all these things into the vignette that are not there. Whatever words they use, that's where you start your thinking. Right? Get there? We don't make up any new words. You look at their words, and you think based on those words. Okay? 2 weeks after URI, you pick Berger's. 2 weeks after a sore throat, I'm picking post-strep GN. Okay? Post-strep GN and lupus are the only 2 who can give you subepithelial humps. So just a mention of where the deposits are, subepithelial humps. Everybody can give you subendo. So that's why that's not a clue. But subepithelial humps, oh, I'm clicking and moving now, boy. You're talking about only 2 diseases now, post-strep GN and lupus. That's it. And of course, post-strep is a lot more common. All right, so post-strep GN. Post-strep GN can occur after strep throat or skin strep. So they can give you a child who had a skin infection, and now, boom, blood in the urine. Got to still pick up that connection. So it doesn't always have to be a sore throat. All right, serum sickness, second one. Serum sickness, 2 weeks after a vaccination. Especially which vaccine, Danielle? MMR. In fact, if you read a vial of MMR, it says on there, may get measles-like illness in 2 weeks. It's serum sickness they're talking about. 2 weeks after vaccination, serum sickness. Next one. Now, that's because vaccines used to be made in horses' serum. That's how that term came about. But they've seen serum sickness with even after drug therapy. So anyway, third one, SBE. Subacute bacterial endocarditis. Now be careful. There's an acute endocarditis. That is Staph aureus. That is tricuspid valve. That is an IV drug abuser. Totally different from this one. Subacute bacterial endocarditis. That's why I always stress again, read carefully. This is just stressing you common mistakes I see a lot, just so you don't make the same mistake. So subacute bacterial endocarditis is strep viridans, whole different bug. It attacks the mitral valve, whole different valve. It has nothing to do with IV drug abuse. Totally different patient. So SBE is usually seen after you invade a mucosal surface. Remember, like before, that's why I get prophylaxis before dental extractions, all that stuff. Mucosal surface, especially their mouth, is where strep viridans lives, or GI tracts, or endoscopy. So that's why I summarize it for students and say anytime you have to put an instrument in a mucosal surface, you must give prophylaxis for SBE. Okay? And that's for every heart disease except mitral valve prolapse. Now, when we do cardiac, I'll explain why. Right now, I just want you to know recommendation. Protection for SBE. I just feel like I keep bouncing up and down on this thing. All right, so SBE. The best drug today is amoxicillin. Okay? SB, if you got an infection on a valve, every time that valve opens and closes, it flicks off some of the infection. So you get septic emboli. And the antibody's still attached to it, so immune complexes are being thrown around your body. When they end up in your brain, we call it a myocardic aneurysm. So the 5 buzzwords that go with this disease. You can tell they thought this was a fungus when they realized it was coming from the valves. They never renamed it. So myocardic aneurysm, that's septic emboli to the brain. To the retina, Roth spots. So R for retina, Roth spots. All right, to the nail beds, splinter hemorrhages. To the fingers or toes, and they're painful, Osler's nose. That's the key now. They're very painful because there's another set that can happen, but they're not painful. We call them Janeway lesions. Because Janeway lesions are not painful, that's how I know it's got to have a different pathology than Osler's nose. Janeway lesions is not immune complex deposition. It's just inflammation. That's why it's not painful at the spot. But Osler's nose, you got a clump blocking off blood supply. It's going to hurt. Okay? So these are the 5 clues for SBE. All right, next one. SLE, lupus. Second most common arthritis in middle-aged females. Brendan, what was the top one? Middle-aged female with arthritis. Top one is? Most common arthritis in middle-aged females. No. Rheumatoid. Osteos with aging. That's much later. All right, so lupus. That whole thing about malar rash, folks, you're going to learn a lot of reasons for malar rash. I don't jump when they say malar rash. That's not the best clue. The best clue about lupus is 3 antibodies seen in lupus that nobody else has. Smith. Cardiolipin. Double-stranded DNA antibody. Smith, cardiolipin, double-stranded DNA antibody. You're not going to see it in any other disease. So I like the clues that allow me to click and move. That means there's nothing else I have to worry about. Okay? Malar rash, there's a lot of reasons. Arthritis, come on. You know, there's too many reasons. If you have any one of these 3 antibodies, click and move. Next question. Brendan. Oh, subacute bacterial endocarditis. That means it takes more than a week to get it. SLE, 3 antibodies. Smith, cardiolipin, double-stranded DNA. Cardiolipin antibody is the one that causes a lot of problems. Number 1, it can stimulate the intrinsic clotting system. Number 1, it can stimulate the intrinsic clotting system for you to form clots. And therefore, number 2 complication, multiple spontaneous abortions. It can clot off the entire placenta. Number 1, it can stimulate the intrinsic clotting system, now that we understand what it is. It loves to clot off a placenta. So multiple spontaneous abortions. I actually had one lady who had lupus, and I didn't know at first because I was seeing her daughter. And one time she came to see me, and all of a sudden I see this malar rash on her face. I said, oh, how long have you had this rash? Oh, a couple of weeks. And I said, do you have arthritis? She said, yeah. And I just happened to ask her, I said, is this the only daughter you have? She said, yeah. I said, you didn't want any more children? She said, no, that was not it, but I had 9 abortions before I finally gave birth to her. So I stopped after that. I said, oh my gosh, she got lupus. She just didn't know it. Now, lupus is one of those that can fool a lot of physicians. So it's okay the physician missed it because it unfolds slowly. So the physician didn't get the history I got. I just happened to be lucky at the time, malar rash, and I'm seeing one daughter, and then I put it together. So, aha, that's what she's got, the cardiolipin antibody syndrome. Okay, we're a poor prognosis when that happens. So, Again, stimulates the intrinsic clotting system, multiple spontaneous abortions. Or, number 3, it can block VWF, like I pointed out earlier. If I block VWF, are you going to form clots or bleed, James? Going to bleed. That means, James, from day to day, I don't know if my patient's going to be bleeding or clotting. That's why this syndrome is so bad. They come in with a clot, you start them on heparin, the next day they're bleeding to death. Now you give them an FFP. The next day they start forming clots again. You have no idea what's going to happen. But that's what we're forced to do, folks, until they die. If they're bleeding, FFP. If they're clotting, heparin. And then pray. All right? All right, so that's lupus. Now, so we got multiple spontaneous abortions, stimulating the intrinsic clotting system, block VWF, and cardiolipin can cause a false VDRL. So that's a common question I like to ask. Which antibody in lupus actually gives you this false VDRL we're always talking about? It's a cardiolipin antibody. Okay? The double-stranded DNA antibody is the most nephrotoxic. That antibody destroys the liver so fast. Does that say liver? I'm saying kidney. Sorry, nephritis. Lupus nephritis. That's why I stalled. It just didn't sound right all of a sudden. Okay, I'm glad you guys caught it too. All right, so that antibody destroys the kidney so fast that even steroids doesn't work. Steroids is not the treatment for lupus nephritis. It does not work. Because DNA just floating around is so foreign to the kidney, antibodies just come and start destroying it. In the process, they destroy your kidney real fast. Number 1, that explains to you why lupus is the only vasculitis where they die from renal failure rather than heart failure. If they got that double-stranded DNA antibody, days are numbered. That kidney was shut down very fast. The only chemo drug that we have found that can help, Danielle, cyclophosphamide is the only drug that's made a difference for them. And that's why it's important that you catch it early so you can start them on pulse cyclophosphamide to prolong their kidney, or else they're going to die from it. So again, Smith, cardiolipin, double-stranded DNA. Cardiolipin antibody got way too many problems. Okay, double-stranded DNA, the most nephrotoxic. All right. Then the next one, membranous proliferative glomerulonephritis type 1 and 2. This is a wastebasket term for I see immune complexes in your kidney, but I have no idea who put them there. It's another one of them, we don't know, categories. We just got to come up with a term for it. That way the patient has no idea. We don't know what we're talking about. All right, so MPGN means you see immune complexes, but we don't know why they are there. The classic clue, tram track appearance. It means you got so much deposition here that it splits the membrane into two, so it looks like train tracks or tram tracks. So any mention of tram track appearance, it has to be MPGN. The difference, how do I separate the two of them out? Type 1 has what they call C3 nephritic factor. Type 2 is the one that has low complement. So once they mention tram track, they either have to tell you complement is normal or low to separate the two of them out. All right? Because complement be normal in type 1, or they'll mention the C3 nephritic factor. Complement is low in type 2. Okay, in type 2, there's so much deposition, they even describe it as dense deposit disease. Dense deposit disease. MPGN. And finally, disease called cryoglobulinemia. Cryoglobulins means cold agglutinins. We get cold agglutinins for different diseases, Lucas. Question is, what does it really mean? Well, I got 3 synonyms for you. Cryoglobulins, if you read your books, it says it's antibodies that freeze at 4 degrees centigrade. Now, I know you guys don't carry your antibodies around and put them in the freezer to see if they freeze. So that has actually no clinical utility for me until I finally figure out what they're talking about. Again, I picked up the patterns, and here's what I came up with. Number 1, it's only IgM. That means I never have to think about any other antibody. It's IgM only. Number 2 is non-bacterial infections. Danielle, is IgM acute or chronic? IgM is acute. So as I remember, the third syndrome, acute inflammation only. So cryoglobulins, what are they? IgM only, acute inflammation only, non-bacterial only. That's how I can narrow it down real fast. So let's say if you ask about lupus, I say, well, lupus is chronic. So warm antibodies. Everybody follow? So you use it backwards and forwards too. All right. But which are the 5? We got 5 infections that most notoriously give you cold agglutinin. All right, the mnemonic is I am he. The 5 infections that most notoriously give you cryoglobulins. First one, I, is for influenza. Think about somebody with the flu. Why is it that joints hurt? Immune complexes. Why do they have nephritis? Immune complexes. Hepatitis? Immune complexes. Vasculitis? Immune complexes. That's why when somebody gets the flu, man, they hurt real bad. If they actually explain it, folks, they got immune complexes everywhere. That's the term we give it, cryoglobulinemia. Okay? A is for adenovirus. You see the same problems in adenovirus infections. M is for mycoplasma. That's where you've seen it the most, right? The cold agglutinins that we get. Okay, we do that cold agglutinin test with a strain of strep, in fact. And that sometimes they'll be slick and say, positive for strep salivarius antigen. That's the same thing as cold agglutinins. We use streptococcus salivarius antigen to do the cold agglutinin test. So I am. The H is for hepatitis B primarily. B first, C second. Okay? So they love to give you a patient who's got hepatitis B, and then all of a sudden now he's got this, he's got that, he's got that, he got that, he got that. Uh-oh. Now I have to figure out, is it polyarteritis nodosa or cryoglobulinemia? Well, now you know the clues for both sides. Okay? If they want PAN, they'll mention the pianca. And also, polyarteritis nodosa likes to attack medium-sized vessels, GI and renal. So sometimes they'll just give me that combination. That's good enough. Because cryo will be everywhere, not just 2 organs. Okay? That's the H. And then finally, the E is the EBV. Think about the heterophile antibody you get for EBV. Cryoglobulin. Okay? So IME. So cardiovascular diseases with low complement, folks. Gotta know them. All right, so we left off on malonyl-CoA. I said every round you're going to make fatty acids, you got to make this malonyl-CoA. So now let me take you through the steps. All right? Once you got your malonyl-CoA, in comes the largest quaternary enzyme in all of biochemistry. His name is called fatty acid synthase. He has 7 proteins working together. Remember the largest we've had with pyruvate dehydrogenase was 3 proteins. This is 7 proteins, which require 10 steps to do the reaction. Did they want you to know the 10 steps? Nope. Thank God. That's what I said. I got it down to 4 for you. It's just a recurrence of these 4 steps, okay? So everybody watch carefully. So I'm going to start out with my malonyl-CoA. It looks like this. Here's your carbon dioxide back here, and then the other 2 carbons. We always put it like this. Tells me malonyl-CoA, okay? Now, the reason why you added that carbon dioxide was to create a high-energy bond. All right? Then I'm going to attack the first acetyl-CoA with it. So, round number 1. You always take an odd, attack an even. When I do that, what do I get? Something that looks like this. Oops, sorry. No. Okay. Something that looks like this. And then I attach my other one. Everybody see that? I took an odd, attacked an even, so now I got a 5 carbon. So that's step 1. So round 1. Step 1, attack an odd to an even. Everybody with me so far? Step 2, decarboxylate. That means get rid of this carbon dioxide over here. So that when that comes off, see the CO2 gives off. That means I got 4 carbons now. Okay, so now it looks like this. 4 carbons. This is still round number 1. So step 1 was attack an odd to an even. Step 2, decarboxylate. Step 3, add a hydrogen from NADPH onto the inside carbon. So that means if I add that hydrogen, 1 bond has to go. Step 4, add another hydrogen to it so that the second bond is then broken. And what do you have left? Water, which means the water will move away. How do I know the water will move away, Diana? What does water hate more than anything else? Fat. Aren't we making fat? Look how ingenious your body is. Take that double bond, turn it into water, knowing that as soon as you do that, the water will immediately move away without anything else needing to be done. That way you're always leaving the S-CoA on the end, but all the inside carbons are neutral. So 4 steps to every round that you want to be aware of. They will ask you about it. Step 1, an odd attacks an even. Step 2, you decarboxylate. That's how you let the energy be released to keep the reaction going. Step 3 and 4, add hydrogens for NADPH. That's how to remember, right? 2 NADPH is used for every round. So if you take the number of rounds times 2, that's how many NADPHs it costs you to make it. Or you just take C minus 2. So this is round number 1. And how many carbons do I have up here, Joseph? How many carbons do I have at the end? 4 carbons. And I want to make C16. How many more carbons do I need? 12. And every round I'm going to add 2 carbons. So how many more rounds is it going to take me? 6. 6 added to 1, 7 rounds. So before I gave you the equations to figure them all out, now I just kind of took you through one of them just to show you how all those numbers were arrived at. Again, that way you have a visual and you have an auditory. That's the 2 best memories. That way on the data exam, when they ask any one of those questions, you'll remember seeing it or hearing it and therefore get it right. Okay? So that's how you make fatty acids. So once again, remind you, number of carbons over 2 minus 1. That's how many rounds it's going to take you to make this. Number of carbons minus 2. That's how many NADPHs it took you to make this. And finally, number of carbons, subtract 1. That's how many ATPs it cost you to make it. Okay, so palmitic acid. Yes, Josh. First step, yeah. Malonyl-CoA, attacking your first acetyl-CoA. Yep. All right, so palmitic acid is the main fatty acid you and I make every day. If you say a fatty acid is saturated, it means it has no double bonds. Remember we did this in membrane fizz. If you say it's unsaturated, we say it has double bonds. And I gave you there are 3 benefits to unsaturated fats. SOBI. Benefits of unsaturated fats. Chris, benefits of unsaturated fats. Dahlia, oh, you got it? Dahlia, go ahead. Easy to break down. A double bond puts a strain on it, so it's easy to break now. Number 2. Better temperature regulation. Remember, every time you got a double bond, you got to put a kink in it. That means there's little holes in the membrane for heat to escape. And number 3, remember, lateral movement. It allows proteins to move, swim around in the membrane easier. All right, if you use the term omega fatty acid, it means you're counting the double bonds from the right side. Remember, we count everything from the left and go this way. But if you want to start counting from the right side, then you have to say omega. So you say omega 16 fatty acid. Okay, or the main one, we say omega-3 fatty acid, means you have whatever, C16, but the 3rd carbon from the right has a double bond on it. Okay? That's the one that's used to lower cholesterol. This is the one in fish oil. All right, big now in diet. Get omega-3 fatty acids. Lowers your cholesterol. The main one they want you to know is called personalised. This is now the number one was an export from Cuba. They have the largest source of it. Personalised. You can order it over the internet. Or just eat some fish, folks. Eat some fish. All right, anyway, but that's the main one they're going to ask you about. Rules for fatty acids. Whenever you want to write it, first thing you do is say, okay, I got 16, or tell me how many carbons you got. So we say C16. Then you tell me how many double bonds. And then in parentheses, tell me where the double bonds are found. Okay? This is the routine for writing a fatty acid. All right, number one rule. We do not go beyond C16. So if I see 17 or above, you didn't make that. Number one rule. We do not go beyond C16. We could, but we don't. Number two, double bonds have to be at least 3 carbons apart. And number three, no double bonds allowed after carbon number 10. There's 3 rules you cannot break. Let me show you how to play a little visual trick on you. They'll give you this. That means there's a double bond between carbon number 3 and 4. And then they'll give you this. Oh, sorry. That means there's a double bond between 6 and 7. That looks like it's 3 carbons apart, doesn't it? But it's not. It's a visual illusion. Let me show it to you longhand. Carbon number 1, 2, 3, 4, 5, 6, 7, 8. All right. This one says a double bond between carbon number 3 and 4. So here's your first double bond. Everybody follow? And then only 2 carbons later, see this carbon number 4, 5, 6, only 2 carbons later you put another double bond. That's not allowed. It's a visual illusion to see 3 and 6, so you're seeing 3 carbons apart. So kind of rephrase in my head and say 3 carbons apart, but the numbers have to be 4 apart, just so I don't accidentally miss it. That means if I see a 3 here, I got to see at least a 7 or higher next to it. Okay? To be correct. Everybody understand? And then the third rule, no double bonds after carbon number 10. Here's a trick they try to play. You see a 3, and then you see a 10. Your retina records 10, doesn't it? Except you forgot that's a double bond between carbon number 10 and 11. That's not allowed. Just visual tricks. It catches a lot of students. Don't fall for it. All right, any questions on these rules? So you think you got the rules down? You think you're ready for the exam? And then when you get there, they'll do to you what they did to me. This was on my exam. They say, which of the following fatty acid structures would you find in the hind cut of prime Angus beef? What? I look at 5 structures. I'm like, I don't memorize structures. I have no idea what they're talking about. And that's why I don't teach you guys structures. I don't memorize structures. All right? So then I thought about it. At first I started panicking, and I was like, wait a minute. I wonder if they're talking about those 3 rules. So, I said to myself, I don't even know what Angus beef is. Anybody know what Angus beef is? Why is it the hind cut? Why not the ribs? I'm not sure. I'm totally confused now. But that's exactly what they want you to do. Panic about the wrong thing. When you look at it, there was a guy here, the guy who scored the 220. I looked up his picture. That's the guy who taught me. Angus beef, it just means real tender beef. They raise them to be tender for the market. So they just charge you a lot of money now for it. Anyway, so what do? I looked at the 5 structures. And I started looking at these 3 rules. First thing I did was count how many carbons. All of them had 16 carbons. Then I checked the next rule. And then checked the 3rd rule. And only one structure broke one of the rules. I said, I knew it. Another scam. Another scam. They had me thinking about the structure. That's the same thing they want you to think, that it's about that structure. And then you'll miss the question. Concept or clue, folks. It doesn't matter. Don't go memorize a bunch of structures. It's really not good use of your time. All right, so those are rules for free fatty acids. Essential fatty acids, remind you again. We've done it before. Linoleic, linoleic. And of course, linoleic has an A sound, right, Mark? Used to make arachidonic acid. Essential means what, Monica? Get it only from your diet. If you don't eat it in your diet, Diana, how else can you get it? What cycle in your body can replace it? You can't. It means it has to break you down to get it. And that's why any essential anything, if you don't get it, you're guaranteed to have a disease. Okay? Well, look at arachidonic acid and all the things you can do with it. Arachidonic acid, if you chop it up with phospholipase A, you can then enter two pathways, cyclooxygenase or lipooxygenase. Cyclooxygenase pathway produces prostaglandins. Lipooxygenase pathway produces leukotrienes. So let's go through them one at a time to see what we do with all of this stuff. Everybody with me so far? All right. So cyclooxygenase, prostaglandin pathway first. First one, PGA2, also known as thromboxane. We talked about this in clotting. I said this is released early by platelets to promote platelet aggregation and cause vasoconstriction. This is what you use aspirin for, to stop platelets. Stop the production of thromboxane. And that way they cannot agglutinate. Thromboxane, made by platelets, causes vasoconstriction, promotes platelet aggregation. Aspirin will block that. PGE2 is used to vasodilate. We met him in the kidney to dilate the afferent renal artery. We met him in vascular to keep the PDA open. And what was the pure vasodilatory form of PGE, Maria? What's the pure vasodilatory form of PGE called? Michelle? Benish? Alprostadil. Because then there's another form called misoprostol, but some of it causes vasoconstriction. We use that in GI for NSAID or aspirin-induced gastric ulcerations. Misoprostol. That's also PGE. Okay? And that's why when you give a female misoprostol, you must do a pregnancy test. Because half of it vasoconstricts, half vasodilates. You don't know. All right, so that's PGE2. PGI2, also known as prostacyclin, is made primarily by endothelial tissue, Brendan. Made primarily by endothelial tissue. PGI2 will cause vasodilation and inhibit platelet aggregation. PGI2 causes vasodilation and inhibits platelet aggregation. And as it turns out, PJ, prostacyclin is made primarily by COX-2. And therefore, Dan, if you're on a COX-2 inhibitor, do you understand you're blocking my ability to stop the platelets? That's why with COX-2 inhibitors, if you've been on them for more than 18 months, you start getting more clots. You guys heard of the controversy? Yeah, people who are on it for more than 18 months ended up dying from MIs and strokes. That's the reason. It took that long to block all the COX-2s throughout your body, and all of a sudden clots can now form. Okay? The only one still on the market is Celebrex. All right, Celecoxib. The other two have been taken off. Okay? Because a follow-up study on Celecoxib did not show the same high risk. The other two did, so they took them off the market right away. Okay? Just so you know. But it's by way of prostacyclin, in case they ask you to explain it. All right, PGF2 causes vasoconstriction. PGF2 causes vasoconstriction. This is the one responsible for painful menstrual cramps, dysmenorrhea, as we call it. Painful menstrual cramps. If I vasoconstrict the arteries, it's always painful. This is as the uterus sloughs off. We'll be talking about tomorrow. PGF2 causes vasoconstriction. One responsible for dysmenorrhea, painful menstrual cramps. That's why women take NSAIDs for cramps. PGF2 is also responsible for separating the placenta after you deliver the baby. PGF2 Also there to separate the placenta after you deliver the baby. Again, cause of vasoconstriction, placenta loses blood supply, it sloughs right off. Everybody understand me so far? All right. Then finally, PGF2 is found in semen. Lots of it is semen. This is the reason why we tell an expectant mom, avoid intercourse in the last month, just so we don't get preterm labor. Let the baby come out on his own. But if you have a post-term baby, then you encourage all the intercourse. And dad saying, Doc, I will do my best. Poor dad, he's been holding out for months anyway. So once you bring that up there, oh man, they're ready to go. Okay, Dad, Doc, I got this covered, man. We'll get this baby out in the next week. All right, we actually give out that advice. That's not, it's funny, but we do give out that advice. It works. All right, so that's the prostaglandins. Any questions on prostaglandins? Over on the leukotriene side, there's only one guy you need to know. Leukotriene, C4D4E4, also known as slow-reacting substance of anaphylaxis. This chemical is released 4 to 8 hours after an allergic response. So we'll be talking about it next week. This chemical is released 4 to 8 hours after an allergic response. Manny, this is the most potent bronchoconstrictor that we know. The most potent bronchoconstrictor. So if they ask you what kills most asthmatics, this is the guy you're looking for. That's the reason why we target our medications, trying to stop him. He's worse than histamine. So that's what used to happen in the past. We were just treating the histamine stuff with beta agonists, and then they'd go home and die from this guy. That's why we got more aggressive. Yes, sir. 4 to 8 hours. That's when he's released. All right. To break down SRSA, you need an enzyme called aryl sulfatase. And you should know if you have aryl sulfatase deficiency, it's associated with a neuromuscular disease that you learned about, Malika. Metachromatic leukodystrophy. That's correct. All right, so aryl sulfatase deficiency, metachromatic leukodystrophy. Remember, that's the MS equivalent in a 5 to 10-year-old child. They'll have the same visual problems, optic neuritis, internuclear ophthalmoplegia, but it's a 5 to 10-year-old child, so that can't be MS. All right, so that's normal. Remember, you always got to know normal before you start talking about how do I mess with it. Here's where your pharmacology comes in. First one, aspirin. Aspirin is an irreversible blocker of cyclooxygenase. We've done it several times. I'm just going to repeat it one more time for you. So irreversible. What does he do? He actually acetylates. He buries that acetyl group into the COX and destroys it. When is aspirin indicated? Number one, anti-inflammatory. That's why, like in rheumatoid arthritis, first-line drug, aspirin. Anti-inflammatory. Number two, antipyretic. Take away your fever. Prostaglandins cause fever. And then number three, antiplatelet. Remember I said he also acetylates your platelet. So under antiplatelet, we use it for all MIs. It'll help, remember, decrease mortality in all MIs, primary or secondary. But it's helpful for secondary strokes. Remember I said it does not stop first-time strokes. That's due to atherosclerosis. Platelets have nothing to do with that. But if the plaque ruptures, then the platelets have something to do with closing off that vessel. So all MIs and secondary strokes. Side effects, start with the GI. So gastritis, gastric ulcer, GI bleeding. Then it gets in the bloodstream, poisons your platelets. So thrombocytopenia. Then you get synchronism, tinnitus, hearing loss. We talked about Rye syndrome, interstitial nephritis, Okay? And then, of course, you'll be bleeding from skin and mucosal surfaces. These are all things that connect to stuff you already heard. So aspirin. We also talk about the 3 blood gases you get initially, because it's neutral. Boom. Absorb fast through your stomach, goes to your brain. So respiratory alkalosis is the first blood gas. Everybody understand that blood gas? Anybody not understand that blood gas? Remember, an acid is neutral when it first comes in. That's why it absorbs real fast through your stomach. Okay? Then the second blood gas was the aspirin then starts breaking down into an acid. Now your bicarb starts to fall down. You still keep breathing faster, so your PCO2 still falls down, but your pH now comes down to normal or just below normal. We call that a combined metabolic acidosis and respiratory alkalosis because they almost neutralize each other. And then finally, when the GABA kicks in, you stop breathing. Now you get a mixed acidosis because both of them. PCO2 will rise because you're not breathing. Boy, bicarb is still low. Mixed acidosis. Remember I said pick that only if they say they're comatose, obtunded, whatever. I got to see signs of GABA before I pick that one. All right, so that's the aspirin. How do you treat aspirin overdose? So be. Aspirin overdose, Nita. Aspirin overdose, Diana. Aspirin overdose, Sandeep. Aspirin overdose, Monica. Aspirin overdose, Dan. Oh, man, wait till you hear the answer to this. Eros. No, that's acetaminophen toxicity. How do you treat aspirin toxicity? PJ? No, you can treat it. How do you treat it, Cammie? Aspirin overdose? Stop the aspirin, but how do you treat the overdose problem? You could. There's a better answer, though. Rashmi, give him bicarb. So you guys are hearing details. That's what I'm telling you. You hear aspirin instead of aspirin is an acid. That's what we were just talking about. It's an acid. Oh, I told you forget your biochem and basic stuff. All of a sudden you say they're asking you strange questions. If it's an acid, give them base. If it's a base, give them acid. Don't forget that. Before you hear aspirin, hear acid. Because you're going to be more accurate with the concept than with that detail. Okay? Be careful. So aspirin. Reversible cyclooxygenase, the NSAIDs. NSAIDs have pretty much the same side effects of aspirin. What do you get? Gastritis, GI ulcers, and bleeding. It's pretty much the same thing as aspirin. You get the interstitial nephritis, even more with NSAIDs than aspirin. The only thing you don't get is ascensionism because it doesn't really mess with your platelets. So what are the clues? Here we go. For endomethacin, the most potent, phenylbutazone is number 2. For that reason, endomethacin is used to treat gout, severe pain. Gout, if they can't tolerate colchicine. Endomethacin is used to treat gout if they can't tolerate colchicine, especially due to bone marrow suppression or kidney problems. Then we like this one. Endomethacin. Endomethacin is also used to close a PDA if you don't want it to be open. Remember, flooding the lungs is not a good thing. Endomethacin. Phenylbutazone, nothing unique. Ibuprofen is the most common over-the-counter. You can buy it in any store. Kmart Profen, Wall Profen, Dollar Profen, Sam's Profen. Everybody's got a Profen now. All right, so ibuprofen. Over-the-counter is 200 milligrams. That's a standard dose. And then 400, 600, 800 milligrams are prescription strength. Folks, why can't somebody just put 2 pills, 3 pills, or 4 pills together? I can already tell you some lawyer got fired for ever coming up with that suggestion. They got the FDA to approve over-the-counter dose, 200 milligrams, without thinking. What's to stop them just putting together 200, 300, 400 milligrams, 3 or 4 of them together for all the other ones that are prescription covered? They lost all those sales, man. Nobody prescribes ibuprofen anymore. I mean, just tell them, get a dollar store. If they need 2 of them, take 2 of them. If you need 3, take 3. Crazy. And I'm telling you, a lawyer lost his money. Anyway, so that's ibuprofen. Naproxen is the one most commonly used for dysmenorrhea, painfulness or cramps. But look at that first two letters. Na. It has a high sodium load. So if they got renal failure, don't use. Seizures, don't use. Heart failure, probably want to avoid. So things where high sodium will hurt you, you don't want to use this. Naproxen. But that's the best drug for dysmenorrhea. And these mostly are young women anyway, so they usually don't have those problems to begin with. Next one, baclofen and cyclobenzaprine we did before. Remember, baclofen and cyclobenzaprine for muscle strains. Why? Because baclofen, back pain, has GABA effects. So it relaxes that muscle spasm you get. Baclofen has GABA effects. And cyclobenzaprine has anticholinergic effects, which also relax muscle. Because muscle contraction, remember, is cholinergic. How do you know you got strong anticholinergic side effects? Dahlia, give me the clue. Hot, dry skin. That's usually the clue they're going to give you for that one. Very good. And then finally, ketorolac has the same analgesia effect as morphine. When do we use it? Brandon wants to know. If you know the patient is a heroin addict, an opiate addict, you can't be using, you don't want to be using morphine. They'll get addicted again. So this is when somebody's a known addict, not suspected. Known. You know, ER docs know who the addicts are when they come in. So if it's a known opiate addict, we use ketorolac. Because you get the same analgesic effect as morphine. But you don't have to worry about them getting addicted to it. Because it's non-addictive. All right, so that's the NSAIDs. Then we got steroids. Steroids are the most potent anti-inflammatory drugs in America. Steroids are the most potent anti-inflammatory drugs in medicine. I've separated for you anti-inflammatory actions, physiologic actions. This is all over your exam. One day an attending is going to ask you this. I can't tell you how many times the attending kept asking the residents these questions and no resident would ever answer it properly. And so I looked it up. That's the only reason why I like this, because it got me mega points. The one day he finally turned to me and asked me, how do steroids stop inflammation? And I could break down the 5 actions. Okay? Doctors use a lot of drugs, but very few seem to know what these drugs do. Okay? So, inhibit phospholipase A. Remember, you needed to enter the pathway because it makes sense to me. That's how you remember it. Number 2, kills off the T cells and macrophages. They're the guys who process the antigens. T cells and eosinophils. So when you have bad allergies, eosinophils are part of it. T cells process the allergen. Get rid of them. Inhibit the macrophages from migrating into the area. If they can't process the antigen, no response. Stabilize endothelium. That way, even if they come into the area, they can't enter the tissues. See it? And then stabilize the mast cells so they can't even degranulate. Even if you did stimulate them, they can't degranulate. That's why steroid inhalers are so good in asthma. That's why steroid creams are so good for allergy in the skin. That's why steroids by mouth are so good for autoimmune. Anything that involves inflammation, the best anti-inflammatory drug out there is a steroid. Everybody understand? One of the most commonly used drugs in America, but very misunderstood. Let's put it that way. All right, then I put over here on the right the physiologic actions. Okay? So over here on the left, anti-inflammatory is why you become immune suppressed, because you just stopped all my immune system here. But over here on the right, physiologic action gives you the other side effects. You're going to break down proteins and make glucose out of them. That's how you get hyperglycemia, diabetes, Cushingoid, and then, of course, vasculitis. We go on and on. It's all because of the physiologic action. Whereas steroids have the same action as cortisol. Okay? So steroids. Any questions on actions so far? Cool? Here are the clues. Prednisone, the most common oral form. They'll give you some clues and ask you which form they're on. That's how you got to know. The clues. Prednisone, the main oral form. Remember I told you, you make 5 milligrams a day. Any more than that, you suppress everything after 7 days. Methylprednisolone, the main IV form. So if you got somebody with like temporal arteritis and you want to start IV, you can't be going oral for that one. You got to know which one's the IV form to get a point. Okay? Triamcinolone, the main inhaled form. And then I found out the second most commonly used one is called budesonide. Budesonide. Triamcinolone is most common. Budesonide is now a second. So most inhalers, steroid inhalers we use in adults, usually has one of these two. Beclomethasone and betamethasone we met in surfactant production for the preterm fetus. If they're born too early and they don't have enough surfactant, we can, remember, simulate the stress response so that he thinks he's under stress. Parasympathetic discharge equals pulmonary secretions. Okay? Beclomethasone, remember, 2 B's for babies. That's how I remember those two. Hydrocortisone is the main topical form. Cortisone 5, cortisone 10, all of them over the counter. Cortisone, hydrocortisone is the main topical form. And second, it comes in injectable form too. Rheumatologists use it a lot for like polymyalgia, or fibromyalgia when you need to inject just like one small area to give them some pain relief. Hydrocortisone is the one they like using. Dexamethasone has the best CNS penetration. So when do we use it? Dexamethasone suppression test. We talked about that, right? Where's it going? Brain. Dexamethasone is used to treat cerebral edema. See that? Best CNS penetration. Dexamethasone used to decrease the swelling of meningitis. See that? Brain. Why did they use that in the study? You got to understand, it has the best penetration. So why not use the best one? And show decreased morbidity. All right, so dexamethasone. Fludrocortisone can be used to take the place of aldosterone in somebody with adrenal insufficiency. So if they give you a patient with CAH, then they're going to say, which of the following drug regimens do you have to treat him with? You can find your answer if you find fludrocortisone, because that's the only one we know that can take the place of aldosterone. And then you give them prednisone to take the place of cortisol. So for your CAH on the boards too, they're going to ask that. All right, so fludrocortisone has the strongest mineralocorticoid activity, in other words. Next one, cyproterone is the only steroid that blocks DHT receptors. So we use it to treat prostate cancer, block dihydrotestosterone effect. Cyproterone is used. DHT receptors. So you can use it to treat prostate cancer, hirsutism. Okay, remember, hair growth is based on DHT. Next one, megestrol has the strongest anabolic effects. What does that mean? It increases your appetite like crazy. So when do we use it? In cancer patients who are withering away to nothing. So they give you some cancer patient who's very cachectic and ask you, how could you help stimulate his appetite some? This is the drug that we use, Dahlia. For anorexics? No, nobody's thought about doing that, because since SSRIs work, why use something more toxic? But that's a good thought. Yeah? Fluticasone and mometasone, that's Flonase and Nasonex, are used for nasal allergies. Fluticasone and mometasone, Flonase and Nasonex, 2 good friends of mine, for nasal allergies, especially when the weather's changing rapidly like it is now, boy. Ooh, if I don't blast that stuff, man, and my sinuses just start reacting like crazy. And then finally, danazol is a steroid used to treat endometriosis, which we'll be talking about in reproductive. Danazol. Any questions on the steroids? All right, cool. We go to the next one. 2 drugs will stabilize your mast cells so they cannot degranulate. That means in addition to steroids, you can also use these. When do we use these? Primarily in children, because parents are always afraid of steroids in children. So that means if a child needs a beta agonist more than once a day, add one of these. And then if it's not controlled, add the steroids. Okay, just because of side effects. That's it. Okay? So cromolyn and nidacromyl, man, cromolyn comes in eye drops, nasal drops, any drops. Inhale form. They're mast cell stabilizers. The only side effect you get from them, GI upset. So that's why we like it in children. You don't have to worry about immunosuppression and all the other things you get with steroids. So again, any adult who needs a beta agonist more than once a day, put them on a steroid inhaler. And then the beta 2 agonist, PRN. Any child who needs a beta agonist more than once a day, put them on this. And then a beta agonist, PRN. Okay? All right, mast cell stabilizers. Excuse me? Oh, no, just irritation of the lining. Remember, you inhale, half of it goes into your stomach. Yeah, it's just, when it coats the stomach, it just irritates the lining. Yep. Okay, so mast cell stabilizers. Leukotriene receptor blockers, the LRBs. These guys sound like a bunch of little kids from a German village. That's how I know them. Look like little German kids. See that? Zyferlicast. That's the little one with the beanie cap. Can't miss him. Always playing with his ball. That's Zyferlicast. He's the youngest one. Mom was real proud of him. And then Montelicast, that's the one that ran away to America. Has his own talk show in the afternoons now. You know, Montelicast. His mom was real proud of him. So Montelicast. And then Xylutin is the only one that inhibits lipooxygenase directly. That's their favorite one to ask about. Only one can block the enzyme directly. The other two block the receptor. There's like one new one I just saw in the literature. But you know them because they all end in lacast. So, leukotriene receptor blockers. They're only used in addition to other drugs. They're never used by themselves for treatment of asthma, just so you know. You never use it by itself. That means in addition to cromolyn, in addition to beta agonists, in addition to steroids. Okay? Oh, did you have a question? Oh, lipooxygenase, the enzyme. Okay? Oh, wait a minute. There was one other guy here. His name was Outcast. Yeah, that's right. Except he ran away with a rock band, I heard. Made a good living for himself. Oh, sorry, flashback. Wrong one. All right. All right, let's roll them, baby. Let's continue in our quest to master this stuff. So quaternary enzymes we talked about are allosteric, which means they are rate limiting. Rate limiting enzymes, Janice, are the slowest or the fastest ones? The slowest ones. So they're the ones who control how fast or slow the pathway will go. All right, cooperativity means that rate limiting enzyme doesn't have to go to the other steps, but he still controls what those other steps are doing. Well, that's for pathways. What about just proteins by themselves? So we're going to look at a few of them. Quaternary proteins. The first one discovered, hemoglobin. Hemoglobin. 3 types. Hemoglobin A. A is for adult. 2 alphas, 2 betas. A2 just means a second type seen in adults. 2 alphas, 2 deltas. And then F. F is for fetal. 2 alphas, 2 gammas. A, 2 alphas, 2 betas. A2, 2 alphas, 2 deltas. And F, 2 alphas, 2 gammas. So as long as you have 2 or more different, you have allosterism. Well, let's look at hemoglobin F first so that we see the timeline. As a fetus, you have hemoglobin F. And that's all you have. Hemoglobin F disappears by 6 months of age. That means after you're born, you got 6 months. After that, F is long gone. Why? Because F has a very low affinity for 2,3-DPG. If you have a low affinity for 2,3-DPG, you have a high affinity for oxygen. So that means a high affinity for oxygen works for the fetus. Why? Because his job is to snatch oxygen away from mom. So when the placenta develops, we're going to be talking about this on Friday, the inner lining is always the fetus. The outer lining is always the mom. So the way I remember it is like trophoblast baby, cytotrophoblast mom. They come together, syncytiotrophoblast, and then you see that? The baby starts eating into mom like that. And then when you lay it down, see that? Inner lining, baby, and then right on top, mom sits right there. That means every placenta you look at, the inner lining is always the baby, outer lining is always the mom. Okay? We'll go through the whole sequence on Friday. Now, hemoglobin F works for the fetus. Why? Because if I've got fetal hemoglobin on this side, so pretend I'm inside now, so the baby's over here. Hemoglobin F is right here. Mom's out here. Mom's got all that oxygen. Baby doesn't have that much. So where's the gradient for the oxygen to come this way? But if the hemoglobin F is to snatch effectively, all he does is just come around and he hangs around the fence, just waiting for little oxygen bubbles to come straying away in the playground. Hey, little oxygen bubbles, I got a sucker for you. Come here. Because all I got to do is close enough to the fence, boom, over the other side. And mama oxygen bubble, where my babies at? Where'd they go? Just snatched away. And that's how hemoglobin F works. Has such a high affinity, it can snatch oxygen away from mom. Okay? And that works for the fetus. But after 6 months, you don't want a hemoglobin with such high affinity. Because Chris knows it won't drop off any oxygen for you. So let's look at how the curve works. So hemoglobin A graphed against hemoglobin F. It turns out that, let's get red on here. When your normal PO2 is 60 to 100. Your normal PO2 is 60 to 100. Most people are 90 to 100. Okay? The main point to be taken home here is that you want the PO2 to be more than 60, but not more than 100. If the PO2 goes below 60, that means you're going to lose oxygenation of the three most important organs, right, Eros? Which are? After that? No. After brain, the heart. After the heart, the kidney. All right? So we don't want the PO2 to drop below that. We also don't want the PO2 to rise above 100. Why? Whenever you have excess oxygen, all you do is form free radicals with it. Does everybody understand that? We saw that in lung disease. Free radicals are no good. They're nobody's friends. Free radicals have no friends that destroy anything in their way. So we went from hyaline membrane disease to bronchopulmonary dysplasia. Free radicals is traumatizing tissue. We cause intraventricular hemorrhage. We call retinopathy of prematurity. Free radicals have no friends. You understand that, Miguel? You understand that, Thomas? All right. Now, it turns out that as hemoglobin A is rising, is oxygenating, hemoglobin F is also oxygenating. But look, that hemoglobin F oxygenates much faster. When the PO2 is around 40, hemoglobin F is already 90% saturated. So SaO2, saturation. So that's about 90% here. But look at that same 90%. It takes hemoglobin A all the way for a PO2 of 60 to hit that same number. So that means, Sakchai, when your PO2 is 60, your oxygen saturation is at least what? At least 90%. If your oxygen saturation, Nicole, is 90%, your PO2 is at least what? At least 60. Does everybody understand? Does everybody understand that I'm only worried about if your PO2 is at least 60? Does everybody understand that? You understand, Monica? This is why in the hospital, you write this order for the nurse that says, titrate oxygen, keep saturation above 90%. Where'd that 90% come from? But every doctor writes it, but nobody seems to know where it came from. As long as the saturation is above 90%, you know the PO2 is above 60. Everybody understand that? All right, how do we measure saturation? You put a little clipper on the finger. We call that pulse oximetry. So oxygen saturation, we use pulse oximetry. All it does is measure how many sites on your heme are actually bound. Or all your total hemoglobin, how many sites are bound. Doesn't know what it's bound with. It just says, yeah, 95% are bound, 88% are bound, and so forth. So we test saturation with pulse oximetry. We check your PO2 with blood gases. Okay? So I want to keep your oxygen at least 60, which means I want to keep your saturation at least above 90. Does that make sense to everyone? So here's how you titrate oxygen in the hospital. Patient comes in, let's say, acutely ill. And he's short of breath, so you put on 1 liter of oxygen. Or rather, you check his pulse oximetry before the oxygen. It says 85%. You say, ooh, he's hypoxic. That means his PO2 January is less than 60. That's all I care about. So what I do, crank it up to 1 liter. And what was 85 goes up to 93. Let's say I'll just leave it there. He keeps getting worse because you haven't started any antibiotics yet or whatever you got to do. And at 93, drops down to 89. So, whoa, take it up to 3 liters. Okay, you just keep adding oxygen. Just keep it above 90. That's all that matters. Okay? And then at 93, and then from 89, it goes back up to 95. You say, okay, good. Stay right there. And then later that afternoon, you still haven't started antibiotics yet. And then at 95, drop down to 89. You say, ooh, go up to 4 liters. Everybody understand? And it goes back up to 95. All right, now you start your treatment. Start antibiotics or whatever you got to do. Okay, once you do that, that 95, boom, goes up to 99. Then you go down to 3.5 liters. And it goes down to 91. So, okay, let's stay there. And then the next day, that 91, boom, it goes up to 99. You go down to 3 liters. And it's still 95. You say, oh, no, 2.5 liters, 92. Okay, just keep it there. And then that same 92, later that day, boom, goes back up to 100. See that? And you just keep titrating the oxygen off until they're completely off and stay above 90%. So that's how you wean oxygen off and on. Then every day, you just check 1 blood gas. As long as your saturation is fine, I don't have to keep checking your blood gas. Otherwise, folks, you would have to. So pulse oximetry is a way to make sure you're either above or below 60. And then you check a blood gas to see exactly what the number is. Everybody understand the difference in those 2 tests? Okay. Well, hemoglobin F saturates at 40. Hemoglobin A saturates at 60. Well, it turns out that hemoglobin F follows the same curve as myoglobin. So let's say you're hemoglobin A. So Faisal is hemoglobin A. Well, he has tons of it, so he's decided he's going to exercise. So he decided to start jogging. So he jogs, and all you hear, jogging real hard. No problem, boy. Woo! He's 2 miles, 3 miles. And then as he's running this 3 miles, guess what? His PO2 drops below 60. If it drops below 60, his hemoglobin says, don't worry, I got plenty of oxygen. And it'll desaturate and push this PO2 back over here. This is what they mean by shifting the curve to the right. Really, folks, what you're shifting is the PO2 back to the right. We care more about the oxygen in the tissues, not so much the hemoglobin goes to the right. The PO2 in the tissues goes back to the right. That means higher numbers. Everybody with me? So that means Faisal. Excuse me. Hello? Okay, watch the arrow. Watch the arrow. So you're jogging, and your PO2 drops below 60. Hemoglobin says, don't worry, I got plenty of oxygen. He desaturates, letting that oxygen fall into the blood, and then it diffuses into the tissues to raise their PO2 back over here to the right. That means above 60 again. Because it's when you drop below 60 that you even stimulate this to happen. Okay, if you were above 60, you'd be above 90% saturation. Wouldn't bother hemoglobin at all. Okay, once your PO2 drops below 60, then hemoglobin says, uh-oh, I better let go of some oxygen. That's why it desaturates. Oxygen drops to the ground or in the bloodstream and then goes into the tissue back over to the right. Everybody understand? All right? So Faisal says, I want to get in excellent shape. Got his little woman over on the side checking him out. Go Faisal! Go Faisal! Okay. So she's just cheering him on. So he keeps on jogging, keeps on jogging. So then his PO2 drops below 60 again after about 2 miles. And then what happens? Hemoglobin is here. So hemoglobin goes, don't worry, I got you covered. Desaturates some more. PO2 drops, goes back over to the right. Everybody see that? So really, folks, what makes the curve shift to the right is everything that denotes hypoxia. Anything that indicates hypoxia was shifted to the right. What is that? Increase in altitude, not much oxygen up there. Increase in exercise because you burn up your oxygen. Increase in PCO2 because you produce more when you're exercising. Increase in 2,3-DPG because, as we'll see, you produce more of this when you're exercising too. Increase in hydrogen ion concentration, but decrease in pH. Which means, Frank, when you look at all this entire list, an increase in everything except pH shift to the right, A decrease in everything that said pH shifts to the left. You understand, Frank? That means, Frank, if you were the test writer, which one of these is the student most likely to mess up on? The pH. Everybody see that? Remember I told you your brain learns in patterns? The test writer knows that too. So that every time the test writer asks me, what's going to shift the curve to the right? I said, I bet you he messed with pH. I look, and that's the answer. He said, which one is going to shift to the left? I said, I bet you he messed with pH. I look, and that's the answer. My point to you is, anytime they talk about shifting to right or left, start out by looking for the answer with pH in it. I bet you that's the answer. 99% of the time. You just didn't notice. That's the pattern. They know your brain's got a pattern in it already. Increase, 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 and then you forget pH. It's got to be the opposite direction. Decrease, 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 and then you forget pH. Got to be the opposite direction. That's the one you're more likely to mess up on. So before I look at anything else, I look at pH answer. Almost always the answer. Okay? I don't even have to even read the other four. All right? Everybody understand about shifting the curve? It just means anything that signals hypoxia will shift the curve to the right. Okay? All right. So let's say Fazil keeps on jogging anyway. Keeps on jogging. Why? Got to impress this little woman. You know, summertime's here. She's got these sexy little trunks he wants to fit into. So, all right, he keeps on jogging. And as he keeps jogging more, PO2 drops some more below 60. Here we go and say, I'll help you out one more time. Just one more time, because I'm your buddy and I love you. He desaturates one more time. Yeah. Which means, everybody see, he hardly has anything left. And the PO2 will go above maybe like 65. So he keeps on going. Keeps on going, and his PO2 drops below 60 again. Here we go and say, sorry, man, can't help you. But he's got his little woman on the side. He's thinking of stopping, but she said, no, no, Fazil, no, Fazil, no, Fazil. You're the man, you're the man. Fazil said, ooh, she sounds so good when she calls my name. So he keeps on jogging. He keeps on jogging, keeps on running. The problem is now he's in this period here where there's no oxygen. This is the hypoxic period, folks. This is why you start producing a ton of lactic acid because you have no oxygen left. Everybody with me? All of a sudden, your body is on fire. That's why your chest is on fire. Remember I explained to you before? When your chest is on fire, that means you're just to the left of angina. This is why if you push yourself too much, you can have a heart attack right in the middle of exercise. Okay? Everybody understand that? Now, that's why you always go slow and progressive with exercise. Don't overexert yourself too much. That's when you can hurt yourself. All right, so it's this period right here where the fire begins. But because he's got his little woman on the side, just cheering him on, just calling his name, he's on going, I can do it, I can do it, I can do it. But the effect of acidosis is getting to him. What's one effect of acidosis? It'll denature your proteins. You ever wonder why when the race begins, everybody's just ready? That's how they run it. Just by the end of the race, what do you see? Why do you think their arms are flinging all over the place? Proteins are denaturing. That's why. You can't run a perfect line with your proteins denaturing. All right? Then you start breathing harder. Kuzma breathing, ring a bell to anybody? See, you're breathing faster. See, acidosis. Cardiac output goes way up. That's why your heart is beating so hard in your chest. Sound familiar? I told you, folks, once you understand the physics of biochem, all you gotta do is apply it. Okay? So you keep on going. That fire. And she's cheering you on. That's why we like somebody to exercise with. Kind of push you a little bit. Because if you can withstand the fire of this period right here, once the PO2 hits 40, folks, myoglobin will desaturate for you. He's falling behind. Fazil's number 5 in a race of 5 people. And then all of a sudden, myoglobin desaturates. And this little one, come on, Fazil, you can do it. Go, Fazil. Go, Fazil. All of a sudden, Fazil goes, boom, he's in 4th place. He's in 3rd place. He's in 2nd place. All of a sudden, he's in 1st place. That is called the second wind. Myoglobin desaturates if your PO2 drops below 40. Now, I say that, but you got to know that's easier said than done. Yeah, if you can just withstand a fire, you'll be okay. At PO2 of 40, then myoglobin desaturate for you. Well, if you look at hemoglobin F following the same profile, that's what happens in utero. So let me take you through blood circulation in utero to show you why hemoglobin F works for the fetus, but it'll never work for you. Andre. Yeah, because this is for muscle. All right, so even though your heart gets it as far as getting some oxygen, but what about blood flow? It's still not getting much blood flow. Only when the PO2 drops below 40, though. It won't drop it off until then. Yeah, that's why only if you can withstand the pain, then you stand to gain. Remember, no pain, no gain? All right, that's where all this came from. All right, so let's just take it a step at a time, though. Fetal hemoglobin. The highest oxygen in a fetus in utero is coming back from the umbilical vein. Why? The baby breathes through his placenta, not through his lungs. Remember, the lungs take a while to mature, and then it takes 32, 34 weeks for surfactant to even come along. So in utero, the lungs are not being used. It's the placenta that does all the breathing. Does everybody understand that? And, of course, the blood coming back from the placenta is the umbilical vein. Everybody with me? All right, PO2, the highest PO2 is around 80. Here's a pattern I noticed. It drops about 8 to 10 millimeters every time we pick up some more blood. Just in case I lose you, just go back to the pattern and follow it again. All right, so umbilical vein, 80. And then as soon as it goes through the internal iliacs and joins the IVC, inferior vena cava, you pick up blue blood from the legs. It drops to about 70, 72. Notice 8 to 10 points, okay? Then that blood goes up through the IVC and then shunts through the liver through what they call the ductus venosum, picking up blue blood from the GI tract. Now it drops another 8 to 10 points. Now we're about, 64? Okay? I'm just dropping it 8 to 10 points each time. Blue blood from the GI tract. And then it, boom, hepatic vein goes back into the IVC and starts going up. Once it comes here, the right atrium, you pick up blue blood from the head and neck. Now it drops into the 50s. Now you're about 54, 56. That means blood entering the right atrium and right ventricle is 54 to 56. That's the maximum you're going to get. Okay? Everybody with me so far? All right, well, 90% of blood that entered your right atrium was shunt right to the left atrium. Through what hole, Rebecca? Foramen ovale. Because remember the separation between secundum and primum, foramen ovale. So 90% go that route, straight to the left side. The other 10% go into the right ventricle, and then boom, get punched out through the pulmonary artery. Everybody still with me so far? All right, let's follow the 10%. The 10% went into the right ventricle, pumped into the pulmonary artery, and then it says, oh my God, the resistance in this lung is way too high. There's no oxygen here. Remember, hypoxia constricts all the pulmonary vessels. The resistance is too high. That blood shunts immediately back to the aorta through the PDA. That means then the 90% that went to the left atrium goes down to the left ventricle, gets pumped out. That means the baby's brain gets PO2 in the 50s. Everybody with me? And then goes around the arch of the aorta, meets up blue blood coming through the PDA, and drops into the 40s. That means blood going down the aorta only has a PO2 in the 40s. Well, what was the average AVO2 difference of the human body? Anthony, what percentage? Nah, Thomas. Let's see if Diana remembers. What's the average AVO2 difference for the human body that we talked about in vascular phys? What percentage gets extracted by the body by the time it comes back? Manny? What? Nah. Josh? 25 to 40%, remember? So 60 to 75 came back to the right atrium. So if I subtract away 25% away from a number in the 40s, notice, folks, I'm now in the 30s. Look at the graph. Hemoglobin F works for the fetus because he does that routinely. Wouldn't do squat for you, folks. When's the last time you were walking around with a PO2 in the 30s? Not alive. All right? So that's why it doesn't work for you. Okay? But if you happen to have sickle cell anemia, then hemoglobin F can be helpful. Why? Because it holds on to the oxygen in the blood, Mustafa. which means your RBCs will forever see oxygen in the blood, fooling them into not sickling. What causes sickling? Hypoxia. What if that oxygen never leaves the blood? RBC doesn't know his hemoglobin F with that oxygen. He just sees oxygen in the blood. Says, good, I don't have to sickle. That's why hemoglobin F works to decrease sickling crisis in sickle cell anemia. And Michelle remembers what chemo drug do we use to induce hemoglobin F in sickle cell patients? Hydroxyurea. See, that's how it works. Okay? All right, so that's the PO2 in the baby. Now, let's go back to myoglobin. Myoglobin desaturation is the reason for the second win. Everybody understand me so far? That's only if you can withstand this spot right here. Anytime you have acute hypoxia, what symptoms you're going to get? January. Yeah, symptoms. Shortness of breath and what? And weakness. What signs you going to get? Tachypnea and dyspnea. Sound familiar to anybody? Okay, so we're not going to go through that whole thing. That's what I'm telling you. You already know all the information. All right, so acutely, signs and symptoms we already know. Chronically, how does your body respond to hypoxia? Number one, you will develop more mitochondria in your muscles. Number two, your hematocrit will go up. Because what's the signal for erythropoietin? Hypoxia. So chronic response or adaptation to hypoxia is you will see polycythemia. You will see more mitochondria in all your skeletal muscles. See that? Which means you become more efficient at making ATP. Which means you spend more time in first order. See that? See that? You have more mitochondria now. That means you're going to have a lot more ATP before you run out. That's why you then can withstand the exercise. That's what endurance training is. That if you do it a little bit at a time, then your body sees the hypoxia in small increments and then adapts to it slowly by producing these things for you. Your hematocrit starts to go up slowly. The amount of mitochondria starts to go up slowly, which means then you can spend more time. See that? That's why you can then exercise longer without getting short of breath and so forth. Everybody understand that? All right, well, let me illustrate it for you. You ever wonder why those three guys from Kenya always come to America to win every damn marathon? Same three guys. They win every marathon in America, man. If you ran a race with the Kenyans, folks, the only time you get to see the Kenyans is at the starting line. After that, that's it. Number blur. They just take off and that's it. You'll just read about them in the paper after you come back to the finish line. They finished yesterday and you just now come across the finish line. All right, gone. Well, I started thinking to myself, why would a guy from Kenya travel all the way to America just to run a race? It seems to be closer to run a race in Kenya instead of traveling thousands of miles to come run a race to America. Because I thought it was just a race until I found out what the winning tab is, what the winning prize is. Anywhere between $25,000 and $50,000 to the winner and a Mercedes-Benz. Then I finally understood why they came. I said, holy cow, man. They run these races. I mean, same three guys at the beginning. They just talking, hey, how was your trip? Yeah, pretty good. You ready, man? All right, let's do this. What time is the flight? I think 7 o'clock today? All right, man, we'll get out of here in no time. I mean, that's it. You just overhear the conversation and pew, where'd it go? Huh? Oh, yeah, that's it. They're long gone, man. Long gone. Winning the race. 2 hours, 6 minutes. 26 miles. I'm like, what? 2 hours, 6 minutes, 26 miles. 2 hours and 6 minutes, where am I at? 2 blocks down the road with my thumb out. Give me a ride, give me a ride, give me back to the starting line. It's too much. I can't be running no 26 miles. 2 hours and 6 minutes, they're done already. Man, I'm telling you, this is why Americans can take it. Because all they saw was a blur. And then they find out that Kenyans already got their check and took off. You can imagine back in Kenya at the American Embassy. They same three guys walked through the door. We want to go to America. So they say, okay, what do you want? 6 months, a year, 2 years? No, 1 day. We go, run race, pick up money, cash check, come home. That's exactly what they do, man. That's how it only takes them 2 hours and 6 minutes to win the race. They got just enough time to go to currency exchange, cash the check, get that money back in the bag, and boom, take off. My goodness, it's amazing. Now, you imagine if you're in Kenya, I don't know what their dollars are called over there. You take an American dollar over there, exchange rate is huge. That's why they come over here, win a race, and man, imagine now you got like Chicago Marathon, Boston Marathon, New York Marathon, and they make $25,000, $50,000 for each one of those. Those same three guys take home over $100,000 a year. Just coming over to run. That's it. You know, America's jealous, man. America's vain. America does not like to be whooped by anybody. So America said, man, we better check out what they're doing. So what do you see? They put the satellites on them. And what do you see? Kenya's running up in the mountains. Increase in altitude. Do you see that, folks? The Kenyans have tall mountains that we don't have here in America. And guess what? They're running all the way on top of the mountains. They're experiencing hypoxia all the time. That means before they come here to America, sea level, they got so much mitochondria in their muscle. They got so much hematocrit. They blow by the Americans and everybody else who's standing at that starting line, and they're gone. They're gone. They're not even short of breath. You just see them in the middle of the race, running at full stride. What are they doing? Talking. Hey, man, how was your flight? What'd they serve you? Chicken? Oh, no. I think I had French fries. What'd you get? Asparagus? I don't like asparagus anymore. What'd you like? Broccoli? I don't know. I mean, they just still having a conversation. And the rest of us, and they're having a conversation at full stride. Oh, my God, man. Well, America said, holy cow, they're practicing up in the mountains. That's an advantage. So what did America do? Move its training centers to Denver, which has the high mountains. That's still not as high as Kenya. But that just means now at least the Americans can see the Kenyans past the finish line. That's it. At least you're close enough to see them cross that finish line. But you're still not going to beat them. Those three guys will still be making all the loot, man. Now, if you take the camera, let's go to Kenya, see what's going on over there. Hot, dry desert, man. Hot, dry desert. One tree in the middle of the desert. One tree, and everybody's building a hut right around that one tree. And behind one of the huts, there's a Mercedes-Benz. That's the guy that keeps winning all the races. Now, if you've ever been to the dry, dusty Kenya, man, a Mercedes ain't going to last that long. But the engines that do last pretty long, because Nigeria's the same way. Most cars can't last in Nigeria. It's so dry and dusty. But Mercedes, Peugeots, and Volkswagen, about the three that can last the longest in that area. That's why they like Mercedes, okay? Because even in the dry, dusty, windy areas in Africa, Mercedes still holds up because of the way they engineer the engine. But most American engines, I remember I flew into Nigeria, into the village, and somebody's picking up some family member, and they drive up in the Lexus. And I'm like, what? I didn't know Lexus was here in Nigeria. Man, all you got to do is just wait a few weeks or a month or two, and you'll see that same Lexus on the side of the road. Can't move no more. Because there's no Lexus dealer anywhere near you. If you need a part, too bad. And when the dust gets into that engine was not made for dusty, it'll be on the side of the road. Because it's not like you can just go to the nearest gas station and get a part. That's just it. The car's gone. So that's just somebody who's very wealthy who can afford to just drive a car for a few months and then leave it on the side of the road. All right. So this is saturation now. If you look at athletes learn how to withstand this period of time. It's called endurance training. A guy like Lance Armstrong. Remember? Was it 5-time or 7-time winner? 7-time winner, right? You know what Lance Armstrong does? Lance Armstrong goes to, I don't know what country he goes to, very high mountains to train. Sound familiar to anybody? That's why Lance Armstrong would start off maybe in 3rd, 4th, 5th, 6th, 7th place out here sometimes. Do you know when Lance Armstrong always took over the lead? In the mountain stage. when all the other competitors couldn't stand the hypoxia of the mountain, and he could. He's been training there. They said the average hemoglobin for Lance Armstrong was 19.5. You and I are walking around with 10, 11, 12. This man's walking around with 19 and a half on the average. But that's real RBCs. That means if you're a dishonest athlete, that's what blood doping is. You try to transfuse yourself before the meet to try to get away with it. But they'll bust you. Because if you transfuse yourself with a whole lot of RBCs, what's going to happen to your erythropoietin level, Sandeep? It's going to do what? It's going to go down. They'll catch you. They'll know you didn't make those RBCs for real. Lance Armstrong made his for real because you can see the erythropoietin high and the RBCs high, which means this is from hard work. Versus the person who injects himself, just like, remember C-peptide and insulin? You inject insulin, we'll catch you because C-peptide will be low. All right? That's what blood doping is. Somebody trying to not train like everybody else and then just transfuse right before the meet and then got all this hematocrit to use. Okay? Everybody understand that? All right, let's go to football and basketball, let's say. Off-season training is how you do the exact same thing. Off-season training. You take guys like Michael Jordan. Michael Jordan used to train hard in the off-season. That's why during the season, man, the boy has strong muscles, mitochondria up the wazoo. You saw him. He'd only have like 10 points, fourth quarter. They're down by 10. He said, man, I got this. Y'all go ahead and chill for a little bit. All right? All the rest of the team, what are they doing? Patrick Ewing over holding on to stuff. Michael Jordan got all his moves doing, and then Patrick Ewing go up and try to block him, and then hit his elbow. You got a 7'2" trying to block 6'6" or 6'8". I can't remember how tall he is, and all he could hit was his elbow. That's because Michael Jordan had plenty of spring in his muscles. Patrick Ewing had no spring left. Okay, that's what happens. They tire out. So that's what happened with him. Guys like Jerry Rice, wide receiver extraordinaire. Oh my God. I went to see him at, it was either Mississippi or Mississippi State. I can't remember which college. Was it State? Mississippi Valley State? Oh man, they had the #1 offense for 4 years in a row. You know what the offense was? I went to see one game. It was Jerry Rice and another wide receiver on one side. 2 more wide receivers on this side. Okay, go. That's all I saw. Go. And then they would throw the ball. Only one guy was fast enough to ever be underneath that ball right when it was coming down. And that was Jerry Rice. You know what Jerry Rice did to Trey? He said he would run up and down the stadium steps. You know how big the stadium steps are? About that big. You got to run a lot of stairs just to go one flight. If you ever been to a game, you're there with your buddies. I'm going to get a couple of dogs, man. What you want yours? Mustard? All right, man. Relish? Got it, man. I got this. And then what do you do? Get on the stairs. You got sweat coming off your head. Dang, that's only one flight. Hey, man, we just got to skip them dogs. I'm going to stay right here and watch the game. Man, you're pooped out. One flight. But this man would go up the stadium, down the stadium, up the stadium, down the stadium. Guys like Emmitt Smith or Peyton, you saw how strong they were, right? Oh, my God. They would run up gravel. Everybody know what gravel is? A bunch of little pebbles, which means every time you step on it, you slide back down. But they would have to keep their feet moving, in order to, the thing's only 10 feet high, but it took about 45 minutes to get to the top. Constant foot motion. Your muscles are burning. One time I saw a magazine, and it had Emmitt Smith's picture on there. I thought it was his waist, and it was one thigh. Holy cow, he had something like 38, 40, 45-inch thighs. I'm like, holy cow! That's why Peyton was the same way. You see, it would take 4, 5, 6 guys to bring him down. One guy couldn't bring him down because the muscle mass with all that mitochondria was so strong they couldn't deal with it. That's how strong those guys were. That's how you do the same thing in sports. You have to keep training, okay, and withstanding the hypoxic period. If you can withstand the hypoxic period, you will gain. That's why they say no pain, no gain, because you feel the pain during this period. If you never hit this period, then you're not getting any better. Everybody understand that now? All right. Hemoglobin F. Erythropoiesis, the timeline, begins in the yolk sac at 4 months gestation. At 4 months gestation. Now, how do I remember it? Because all the organs develop in the first 3 months. That means including the heart and blood vessels. So then the 4th month, give me the blood. Does everybody understand? You don't need blood if you have no heart and blood vessels in the first trimester. So that's how I remember. 4th month, now we start making RBCs. So yolk sac at 4 months, at 6 months, it moves into liver, spleen, and flat bones. Liver, spleen, and flat bones. By 8 months, it's now in your long bones. That means, Nita, when a baby's born, he's got liver, spleen, flat bones, and long bones all making RBCs. Do you understand that, Nita? This is why a baby can have double your hematocrit just in a few hours of labor. You couldn't do that. But because he has so many sites open, he can double it in no time flat, just in hours. You get to keep liver, spleen, and flat bones until 1 year of age. That's why if a child became severely anemic anytime in the first year of age, he can open up all those sites. So like in, thalassemia major, severe sickle cell crisis in the first year of life, oh my God, you see their head start swelling up. You see the sternum start sticking out. You see the iliac bone start enlarging. Why do you think you see all that? Liver, spleen, flat bones. All of them will have to enlarge. You'll see a big liver hanging way down here, big spleen hanging way down here, because they still have every site open up until 1 year of age. After 1 year of age, Brendan, liver, spleen, and flat bones will close. And that's why all you have are the long bones. But Brendan, if ever you lose your long bones to any disease, if ever, Chakuma, you lose your long bones to any disease, then only one organ can reopen, and that is your spleen. And that's when you will see what we call massive splenomegaly. Which means, Jennifer, anytime they describe massive splenomegaly in any vignette, that person has lost their bone marrow. That means you got to pick something off that list that can wipe out the bone marrow. Jennifer, give me a chemo drug that can wipe out your bone marrow. Now it says platinum. It's on that list, but that's the wrong one. Actually, sorry, the list over. Nicole. No, I want to blast that bone marrow, Cammy. It's called vinblastine. For antibiotic, chloramphenicol. Anti-HIV, AZT. And then benzene are the 4 drugs that can wipe out your bone marrow in no time flat. If they want a virus that can wipe out your bone marrow, Andre, what virus are you going to be picking? That's all right, let's try Fazel. What virus are you going to be picking that can wipe out your bone marrow? Binish. Parvovirus B19, notorious for wiping out bone marrows. Yes, ma'am. Excuse me? What is benzene? Oh, this is a chemical used in industries. You know, to clean those machines, big, huge mega machines. Yeah, it's not something we use every day. All right, so massive splenomegaly. You got to pick a disease that wipes out the bone marrow. As far as bone diseases, there's one called osteopetrosis. Osteopetrosis. In osteopetrosis, you have decreased osteoclastic activity, Frank. So you're not even breaking down any bone. So you got so much bone, it obliterates your bone marrow for you. They call this marble bone. The bone is so thick like marble, but it shatters easily too. Osteopetrosis. The problem, decreased osteoclastic activity. That's what they usually like to ask. So you end up with too much bone that obliterates your bone marrow. So erythropoiesis. So now, pathways, some of the pathways. Here's the big picture about pathways. The pathways that you need to know every step, I'm going to show you every step. The pathways where you don't have to know every step, I'm not going to waste my time showing you every step. But you need to know there are 3 most important things to know about a pathway. Before you know anything else, you better make sure you know these 3. Because these are the things they're asking about most of the time. Why? Because these are things that are clinically relevant. All right? Fact number one, always know the end point. Which means, why are you running this pathway? What's the clinical application? If I know what you do with that end point, that means I can tell you every part of your body is going to be affected if this pathway does not work. Ready to follow? So that means, you know, like here with heme synthesis, if at the end I need to make heme, and you got a problem with this pathway, that means all your heme will be messed up. That means hemoglobin will be messed up. That means the electron transport that uses heme will be messed up. Everybody see? That means I can tell you every problem you're going to have as a patient, and then translate that into signs and symptoms and complications and labs and anything else they want to ask me. Okay? So number one, what is the end point? Number two, who controls that pathway? What is the regulating enzyme? Just like I said before, if you know what turns them on and turns them off, given any disease, you can tell me what pathways are going to be turned on and off. And number three, what do you need to know? What begins the pathway? Because what begins the pathway shows you the connection to other pathways. Just like here, succinyl-CoA begins heme synthesis. I said, well, I got to get that from the Krebs cycle. See that? So that means if there's a problem with Krebs cycle, you're going to be a problem here with heme, which means it's going to mess with hemoglobin, which means it's going to mess with electron transport. You see how you expand it out? That's why they want you to know those three things, because those are the three most clinically relevant pieces of information to know. Most genetic diseases, enzymes. See that? If it's a regulating enzyme, they want you to know what problems you're about to have. You can figure it out for yourself. All right. Then the other rule you need to know, in biochemistry, if you're doing catabolism, breaking down, we do it in the mitochondria. If you're doing catabolism, breaking down, do it in the mitochondria. If you're doing anabolism, synthesizing something, do it in the cytoplasm. If you're doing anabolism, synthesizing something, do it in the cytoplasm. So the body separates things in compartments. If you want to break something down, do it inside the mitochondria. If you want to make something, do it out here in the cytoplasm. However, glycolysis is the one purely catabolic process that goes on in the cytoplasm. You would not have predicted that. Glycolysis is the only purely catabolic process that goes on completely in the cytoplasm. You can't predict that. But once we do it, you'll understand why the body put it there. Because it has to feed so many pathways. So it has to be in a central location. That's how I make sense of it. It feeds way too many pathways, and some of them are on the cytoplasm, so you got to put it there. All right, so glycolysis. And then we have three pathways that go on in both compartments. Three pathways go on in both compartments. Both cytoplasm and mitochondria, and they are heme synthesis that we're about to do, gluconeogenesis that you'll see tomorrow, and urea cycle. Heme synthesis, gluconeogenesis, and urea cycle go on in both compartments. Otherwise, synthesis of anything, Andre, goes on where? Cytoplasm. Breakdown of anything, Andre, goes on where? Mitochondria. Everybody understand? The way to make it specific, just say, well, gee, where do you synthesize glycosaminoglycans? Where do you synthesize Kathia? In the cytoplasm. But most students say, what the heck is glycosaminoglycans, Dr. Francis? Why do you think they picked it? Because they know you start obsessing about what it is, instead of just answering the question. The more time you spend on other things, folks, you will quickly forget what it is they asked you. We all have ADD. Some of us just have it worse than others. And the test writer is making use of that. That's why he always wants to try to distract you from what he's really asking you by putting nice details for you to obsess about. Be careful. All right, so heme synthesis starts off with succinyl-CoA that comes from the Krebs cycle. So this one is one of the pathways. We don't have to know everything. I'm only going to share with you what you need to know. So here's what you start out with. Succinyl-CoA. Okay? What amino acid we're going to use? Glycine. I told you he's going to be everywhere. What vitamin we're going to need? Pyridoxine. See that? This is how you work vitamin deficiency into this pathway. So succinyl-CoA comes from the Krebs cycle. I need glycine as the amino acid. I need pyridoxine as my vitamin. Okay, here's my regulating enzyme. delta aminolevulinic acid synthase. Gotta always know the rate limiting enzyme. Delta aminolevulinic acid synthase is the rate limiting enzyme for heme synthesis. Any questions so far? All right. What you're going to do is go through a lot of successive steps and you make these rings. We call these porphyrin rings. We call them porphyrin rings until you add iron in the middle. Once you add iron in the middle, Fe2 plus, then you call it heme. So again, you start out with succinyl-CoA. What amino acid do we need? Glycine. What vitamin do we need? Pyridoxine. What's the rate limiting enzyme? Delta aminolevulinic acid synthase. We go through a bunch of steps and make 4 rings. We call them porphyrin rings, which means they're nothing until they come together. Then you put iron in the middle, and the enzyme that does that, ferroketolase. That's the only other enzyme you need to know. Ferroketolase, we'll put that iron in the middle, and now we call it heme. Okay? 1 gram of hemoglobin contains 4 heme sites. 1 gram of hemoglobin contains 4 heme sites. The average adult has about 15 grams of hemoglobin. If you multiply times 3, you get the hematocrit. Okay, so 45 is hematocrit. Excuse me, 15 grams is the hemoglobin. It's important that when you add iron, it must be in a 2+ state, ferrous. When you add iron, Jennifer, it must be in a 2+ state, ferrous. Ferrous iron binds oxygen. Ferric 3+ iron does not bind oxygen. You understand, James? Ferrous binds oxygen, ferric does not. For that reason, James, we want to make sure that the iron does not get oxidized. For that reason, James, we want to make sure the iron does not get oxidized. Where do you absorb most of your iron from in the GI tract, James? Duodenum. And if I want to make sure your iron does not get oxidized, what antioxidant could I put in the GI tract? Vitamin what? Vitamin C. So that's why whenever you're giving somebody iron supplements, you give it with orange juice. Or any juice for that matter. Just orange is the most commonly used. All right? Because you want to make sure while it's in the GI tract, it does not get oxidized because it's worthless if it gets oxidized. Does everybody understand that? Well, while it's in your bloodstream, Fazil, you also want to make sure it does not get oxidized. So what vitamin do you want floating around in the bloodstream to eat up the free radicals? Now it's vitamin E as the answer. Very good. Oh, now this I like now. Folks are starting to click. All right, because we're bringing everything around. You got to be ready with your concepts. Okay, so you got vitamin C helping you in the GI tract. Vitamin E is helping you in the bloodstream. Everybody follow? And then, to make sure that protons, acid, Coke, Pepsi, Sprite, so that protons, when you drink it, does not protonate your iron and make it Fe3+. That means you want something that can buffer that iron for you. Tatiana, what amino acid would be a good choice to buffer that iron for you? Histidine! Sound familiar to anybody? Okay, so in your book they talk about a histidine in front of and a histidine behind that iron to protect it from protons. You see how the body protects it? It protects it in the GI tract, that's what you need vitamin C for. Protects it in the bloodstream, that's what you need vitamin E for. And then it puts histidine on both sides of it to protect it from protons just floating around. Well, what's the number one reason for forming free radicals? Number one is infection. And the number one infection is viral. We talked about that on the first day. Why does vitamin C protect you from colds? That's the connection. Number one is viral. Number 2, drugs. Number 2 cause of free radical formation, drugs. The main drugs that cause free radicals, number 1, sulfa drugs. Number 2, anti-malarial drugs. Number 3, metronidazole. And number 4 is INH. Sulfur, anti-malarials, metronidazole, INH, the 4 drugs that love to oxidize. If you oxidize your iron, it's going to go into the ferric form, and we call that methemoglobinemia. If you have methemoglobinemia, Michelle, can you pick up oxygen? Does everybody understand you cannot pick up oxygen? How is that patient going to present, Michelle? With what symptoms? Weakness and shortness of breath. When a patient shows up weakness and shortness of breath in the emergency room, Al, what's the first thing the doctor will do for him? Give him some oxygen. Michelle, can he pick up that oxygen? No, so he gets more weak and short of breath. And what do? Give him more oxygen. Can he pick up that oxygen? So that he still gets more weak and short of breath. Now he turns blue. Now he's got no pulse and blood pressure. So the ventilator, put him on a ventilator. Put 100% oxygen. Can he pick up that oxygen? No. So folks, this person is praying that you know your biochemistry. So when they come in and their hemoglobin cannot pick up oxygen, you'll notice they still have oxygen in their bloodstream. So we have an equation that says total O2 content, your total oxygen content in your bloodstream equals bound oxygen, hemoglobin, plus dissolved oxygen, PO2. Whenever you have methemoglobinemia, your hemoglobin is fine, but it can't pick up oxygen. That means if I check pulse oximetry, how's it going to read, Janice? If I check your pulse oximetry, how's it going to read? Normal, high, or low? If you got methemoglobinemia, Janice, you're testing your pulse oximetry. What does pulse oximeter detect for you? Saturation, whether the iron is bound or not bound. So the saturation will read what? Low. It's not bound to any oxygen. Everybody follow me? But the PO2 will still be normal. Because methemoglobinemia is not about PO2, it's about hemoglobin. Everybody understand? You got to be careful so that you pick the best answer. Because they'll have all kinds of answers that sound right. But whenever you have methemoglobinemia, your saturation will be low, but the PO2 will be normal when they present. The way you got to interpret that is that, oh my God, there's oxygen, but he can't pick it up. Oh, baby, the iron is 3+. See that? Now, primary methemoglobinemia is rare because that child would have had problems when they were a baby, so he wouldn't be an adult for the first time having it. Secondary is far more common. That's the one due to drugs or an infection or something. So on the boards, it's almost always somebody who got a UTI and you put them on a sulfa drug and then bam, here's the scenario, and you got to catch it by what they describe. Saturation is low, PO2 normal. You got to say, aha, bitch, that sulfa drug did it to him. Okay? Whenever you have methemoglobinemia, you need to reduce the iron back to 2+. So what do we give him? A drug called methylene blue. Methylene blue. Just a bunch of electrons. So it'll reduce the iron back to 2+, and you watch it pick up just like that. It's a glass bottle of blue liquid. In pediatrics, we say, give them something blue and watch them turn pink. Because a child is cyanotic. Usually they're cyanotic before anybody even thinks about it. That's what that is, which is not good for us. We're not even thinking about it. That's what I'm saying. It's that biochemistry put together. Saturation low, PO2 normal. You got to think, oh, he's not picking it up. Ooh, maybe it's in the 3+. Turn the bottle over, hook it into his IV, and you see him turn pink just like that. Because once the iron goes back to 2+, there's plenty of PO2, right? Pick up the oxygen just like that, and deliver it to the tissue. And the child will be fine, or whoever it is. Okay? So methemoglobinemia. Any questions about that? All right. So those are the steps you need to know from this. All right. So now here's where I stop and I show you how to organize your thoughts when it comes to anemia. So hematology came from biochemistry. Woo! Imagine that. So get a blank piece of paper. I'm going to show you how to organize it. All right. So anemia. Means that your hemoglobin is below 11. This is for both sexes. Remember I said normal is 15. So when it drops below 11, which means a hematocrit of 33, if you like hematocrits, that's too low. On the boards, you'll see them always playing with numbers right around that 11. It'd be 10.7, 10.8, 10.9. That's what I see almost every vignette. They want to see, do you know 11 is the cutoff for both sexes, so you don't have to worry about whether it's a male or female. Okay? That's anemia. It's moderate when it falls under 9, and it's severe when it falls under 7. So 3 different levels. Anemia. There is only one reason to ever transfuse somebody who has anemia, folks, and the answer is only if they are symptomatic. You don't transfuse based on numbers. I used to hear a lot of doctors talking about, oh, well, let's give him a couple of units, his hemoglobin is low. That's not the reason for transfusion. Okay, but you see how, as an impressionable resident, I'm hearing this, so I'm thinking that's what you're supposed to do. And then everybody's doing the same thing. And so everybody thinks that's what you're supposed to do, but that's not the right thing to do. We messed that one up for so many years. Now you have to fill out a form for why you're transfusing somebody. Because we have transmitted so much disease to so many people, transfusing based on numbers, that they've taken that away from physicians. So every time physicians grumble about what's being done, folks, I've been at it for only 20 years. I can already tell you we caused most of our own problems. Okay? Because it went on for a long time. They kept saying, hey, docs, you got to cut this out, just transfusing for numbers. But I remember hearing that all the time. Oh, I give them a couple of units. It won't hurt anything. Well, here it comes. It did hurt something. Did a lot of damage. All right, so that's anemia. When you got symptoms, we already said weakness, shortness of breath, signs to kidney dyspnea. I gave you the chronic findings. Okay? On physical exam for chronic hypoxia, okay, will be what we call clubbing. If you have chronic hypoxia, you'll see clubbing in their fingers and toes. Why is that? Fingers and toes are the furthest away from your blood supply. So if you're severely anemic, then they're going to get the least amount of blood flow and oxygenation. And so what do? Grow new blood vessels, angiogenesis. The problem, so be, is that new blood vessels are very leaky. So what you're seeing is localized edema. That's just swelling from blood vessels leaking out. Okay, localized edema. But their fingers look like little clubs. And that's why we call it clubbing. Okay, so now we know what they look like on physical exam. We know what's going on in their muscles with all the mitochondria. We know what's going on in their blood with polycythemia. But one thing I want to caution you, though, anemia does not equal hypoxia. Let's look at the equation again. Look at the equation. I said O2 content equals what? Hemoglobin plus PO2. If you say the patient's hypoxic, here's what you're talking about. But anemia is talking about this one. That's how you know it's not the same thing. But once again, folks, I see students who've heard it many times, so they swear now it's correct. Every time they see anemia, they want to pick an answer with hypoxia. I said, that's why you didn't get it right. They never said the person was severely anemic. The only time anemia equals hypoxia is when the hemoglobin is 6 or less. So, you see, under 7. So if the hemoglobin is 6 or less, then I know it's okay to say anemia equals hypoxia. Otherwise, folks, don't make that stretch. Studies show that up to half of women are anemic because of heavy menstruation and poor iron intake. That means half the women in here right now are anemic. I don't see anybody in here panting for air. So that means, folks, don't ever make that stretch again. I can already tell you it's a trap. to say hypoxia when they ask you about an anemic patient. Sounds good, but that won't get you a point. I've seen it happen over and over again. The student is shocked they didn't get a point for it. I always got to remind them about this equation. All right? So hypoxia. Well, anemia also does not mean cyanosis. Cyanosis, Rebecca, means you have turned blue. You understand? The question, Rebecca, is what makes you turn blue? Is when at least 5 grams of hemoglobin are fully desaturated. That means 5 grams of your hemoglobin, Rebecca, have to be running around with 0 oxygen on them for me to see blue anywhere in your face. Does everybody understand that? The definition of cyanosis does not have anything to do with the level of anemia. So you can't say, oh, they got a 6, they're cyanotic. That's not true. I've seen it with 3, and they weren't blue yet. Folks, it all depends on what's going on, okay? So cyanosis. Let me show you something. Let's say I got a patient with a hemoglobin of 8 and another patient with a hemoglobin of 25. PJ, how many grams of hemoglobin must desaturate for you to turn blue? 5 grams. So here's my 2 patients. PJ, 5 grams over 25 is what? What? 5 over 25 is what again? Huh? Right. So, okay. So, yeah, just give me the fraction. So, this is only what percentage? What percentage? Huh? Give me a percentage. 5 over 25 is what percentage? 20%. Okay, I just didn't hear you. That means 5 over 25 is 20. 5 over 8 is about 63%. PJ, which one is easier to accomplish? The 20 or the 63? The 20 or the 63, PJ, which one is easier to accomplish? The 20. Does everybody understand that? 20? Is it easier to make 20 cents or 63 cents? That's all I've asked so far. I haven't even applied the information. You guys are moving ahead right now. I can already tell why you're lost. You're trying to figure out something I haven't even talked about yet. All I said is just look at the numbers. 20 versus 63. Does everybody understand? It's easier to get 20 than it is to get 63. What? I just gave you a patient with a hemoglobin of 8 and another patient with a hemoglobin of 25. I just made it up. But it's always 5 grams of hemoglobin have to be desaturated for you to turn blue. Everybody understand? Everybody understand? So that means 5 over 25 is 20%. 5 over 8 is 63%. Which one is easier to accomplish? And Tony says, the 20%. So that means, Tony, who's more likely to turn blue? An anemic patient or a polycythemic patient? The polycythemic patient. Why do students keep saying the anemic patient does? See? Because I know you guys have heard it somewhere and you swear it's right. It's so far from the truth. So far from the truth. Folks, you want to see it apply? Why is it that polycythemia rubra is blue? Why don't you look it up? Why is it, in COPD, they call them the blue bloater when they become polycythemic? That's when they turn blue. When they were anemic, they weren't blue. How do we treat polycythemia rubra? We bleed them. See the biochemistry? If you make them anemic, they'll pink right up. Not even give them oxygen. Bleed them. That's my point. If you understand the physio and biochemical problems, folks, you understand the management. That means I don't have to go read about the management of polycythemia rubra. I can tell you what you need to do. Get rid of some of those RBCs. That's why they're blue. They got too many of them. Making it too easy to turn blue. Make it harder for them. And they'll live far longer. Imagine that. That's the therapy for polycythemia rubra. Bleed them every 60 to 90 days. But I want you to understand that rather than just read it somewhere and then to memorize it. Yep, that's what we do. Every 60 to 90 days, have them come in, we bleed them. There's a reason. It came from biochemistry. All right? So that's hypoxia and cyanosis. Now, anytime you're anemic, I'm going to show you 2 approaches to anemia. Remember, the key is organization. If you're organized, you'll figure out the reason why they're anemic. If you're not, you're guessing why they're anemic. You'll be wrong too many times. All right, so the first thing we do if you are anemic is we check a reticulocyte count. Reticulocyte count should be less than 1%. Reticulocytes, Tim, are immature RBCs fresh out of the bone marrow. Reticulocytes, Manny, fresh RBCs just out of the bone marrow. So less than 1% should be circulating around. We want to mature, not young like this. Reticulocytes, however, are huge, Dahlia, huge. They're 5 times the size of a normal RBC. That's how you recognize a reticulocyte on a peripheral smear. They're huge compared to an RBC. Well, if I check reticulocyte count, if your reticulocyte count is low, it means you got a bone marrow problem. Does everybody understand that? That means the reticulocyte count is low. That means your bone marrow is not working. That means you got a bone marrow problem. That's a million reasons. I'm not doing differential right now. I'm just showing you. How do I organize it? Then you got to pick something off that answer that would create a bone marrow problem. Maybe you're deficient in iron. You got lead in the way, or you got deficiency of B12, pyridoxine. I don't care what they pick, but it's got to be a bone marrow problem. Everybody understand me so far? But if your reticulocyte count is high, then you got a hemolytic anemia. That means you're destroying them out in the periphery. The bone marrow is trying to make up for it. Does everybody understand how to use reticulocyte count to separate them out? That's the reason why, therefore, Jennifer. Anytime somebody's anemic, what's the first test you want to run, Jennifer? That's why we check a reticulocyte count. Because immediately it tells us whether it's a bone marrow problem or hemolytic anemia going on. Does everybody understand me so far? One simple test that comes back in a few minutes will tell you, where is your problem? All right, if you got a hemolytic anemia, there's 2 places it could be going on. It could be intravascular, which means within the blood vessels, or it could be extravascular, which means it's happening at the spleen. That means outside of blood vessels. So reticulocyte count is high, it means there's a hemolytic anemia going on. What does intravascular hemolysis mean? It means you have a vasculitis. And as I believe, you guys have already heard about vasculitis. If you have a vasculitis, Jessica, what are you going to see in a peripheral smear? Schistocytes. Jessica. Schistocytes. Remember, torn red cells and platelets. Burr cells, helmet cells. Where are you going to be bleeding from if you're messing with my platelets? Skin and, remember, skin and mucosal bleeding go with platelet problems. Clotting factors give you cavitary bleeding. So if you're tearing up my platelets, they can hint at it by just saying, oh, this guy's got petechiae purpura ecchymosis. Remember? GIG, respiratory. There's so many ways to hint at the cause. The key is your mind's got to be organized to look for these clues, or else you won't see them. You won't know. Let me check the reticulocyte count real fast. I go over to the labs. Oh, it's high. I said it's got to be hemolytic anemia. And then I continue reading. Now I'm looking for the clue for why this person has hemolytic anemia. That's how you got to process it. That way you don't read unnecessary words. Once I see my clue, I get out. I'm done. I already answered their question. What is it? Okay? So once I see schistocyte, I say, aha, it's a vasculitis. Now we've already gone through all the vascularities and their clues, which means they have to give me another clue for which one it is. Everybody with me? All right, another thing is they can tell you the haptoglobin level is real low. Haptoglobin is a protein that carries free-floating hemoglobin. Why would the hemoglobin be free-floating? Unless you destroyed an RBC, i.e. hemolytic anemia. So when the haptoglobin is low, that's an indirect way of telling you you have a hemolytic anemia going on in the blood vessels, and therefore hemoglobin is floating around free, so the protein has to drag it back to the bone marrow or liver to be reused. So schistocytes and low haptoglobin are the best indications this is an intravascular hemolysis. That means I'm clicking and moving, folks. I'm not interested in what else it could be. Does everybody understand so far? All right, so that means Sandeep, what about if it was extravascular hemolysis? If it was extravascular hemolysis, that means you're destroying them in the spleen. That's why you always see splenomegaly. So that means, folks, anytime I see just splenomegaly, I always suspect this person has an extravascular hemolytic anemia going on. So this is how you separate them. Now, the number one cause of extravascular hemolysis, you got to figure out, what is the spleen? Why does the spleen destroy RBCs? The spleen destroys RBCs that are defective in any way. That's the spleen's job. Remove defective RBCs. So if I see splenomegaly, I say, extravascular hemolysis, I say there's something wrong with the membrane of that RBC. Everybody understand me? Question is, how do I detect what's wrong with the membrane of the RBC? The 90% by itself, antibodies to your RBCs, i.e. autoimmune attack against your RBCs. So the first thing you always do is a Coombs test. There's a direct, when you detect antibodies right on the surface, or indirect, when you detect antibodies circulating in plasma. But folks, it still tells you the same information. You have antibodies to your RBCs. Yes? Extravascular. Yeah. Remember, all we've done so far is organize into intravascular and extravascular hemolytic anemia. Yeah. So extravascular is a vasculitis. We've already done our clues for vasculitides. They will hint at it with one of those two clues and then give you an additional clue. Now you know which one it is. What if they just say splenomegaly? I say, aha, it's extravascular, which means there's something wrong with the RBC membrane. Number one thought, autoimmune. There's 1,000 of those, so it's not necessary for us to go through it. But the key is they'll tell you direct Coombs test was positive or indirect Coombs test was positive. It still tells me you got autoimmune attack against your RBCs. Okay? Drugs that cause autoimmune attack against your RBCs is usually the one they like to go for. Because when you already have autoimmune disease, lupus, RA, that's too easy. They know you'd figure that one out. But if they put the patient on penicillin and then they show up, you may not make the connection. All right, so drugs that cause autoimmune attack against your RBCs. Penicillins are notorious. Cephalosporins, notorious. Sulfa drugs, notorious. Alpha-methyl dopa, we mentioned. PTU, we mentioned. Drugs that act as haptens on top of RBCs. Occasionally, anti-malarial drugs. Dapsone can act as a hapten. So those are the main ones that act as haptens on top of RBCs, and now you're attacking your own RBCs. Okay? So that means, let's talk through it. FASM. I got a patient that comes in with anemia. What's the first test you want to run? Huh? A reticulocyte count. Al, if the reticulocyte count is low, where's the problem? Bone marrow, if it's high, Kathia, where's the problem? Well, it's just peripheral. You don't know. And then you start looking for clues, whether it's intravascular or extravascular. If they got splenomegaly, Nicole, which one is it? Extravascular, which means something's wrong with the RBC membrane. If I see schistocytes, Kathy, which one is it? What? Intravascular hemolytic anemia. Then that means it has to be a vasculitis. And then they tell you they have anti-GBM antibodies. So which one is it? Anti-GBM antibodies. So which one is it? Maria? Then you know it's good pastures. Everybody understand how to process? Everybody understand what you... All right. Now let's look at funny looking RBCs. I call the next part funny looking RBCs and what they can tell you. Okay? Again, it's language. If you know what these words mean, come on, man. They're giving you the answer almost every time. All right? Language is key, folks. All right, so from the beginning, we say reticulocyte count is an immature RBC. It differentiates bone marrow problems from hemolytic anemias. Everybody understand that? Okay? If I give you something like iron, maximum reticulocytosis, well, reticulocytosis starts at day 4 and is maximum at day 7. So if I give somebody iron or B12 or folate, and they ask you, when do you check the reticulocyte count, it's usually at day 7. If it's high, then that means whatever you're doing is working. If it's not high, that means whatever you're doing is not working. That means there's something else going on that you haven't detected yet. So reticulocytosis begins at day 4, peaks at day 7. All right, so that's reticulocyte. Haptoglobin, we said, is a protein that carries free-floating hemoglobin. So it tells me you got intravascular hemolysis going on when I see haptoglobin is low. Everybody clear about that? All right. Third, Coombs test, whether direct or indirect. Direct tells me the antibodies detected on the surface. Indirect tells me you found it floating around. But either way, you got antibodies to your RBCs. Everybody understand that? Yes. No, either one is fine. But, well, I mean, you could. Let's say, yeah, if they describe the disease, then I can tell where it's supposed to be. If you ask me about rheumatoid or lupus, well, it's probably still circulating around in the RBC. I mean, in the plasma. But if you got some baby who's got Rh disease, I'm only interested in the one that's attached to his RBCs right now. Yeah, the ones that are floating around are still in mom, so I don't care about those. I want to know how many are attacking the baby. That I was about to say that's their favorite one. Yeah, so that means whichever one they ask me about, I got to answer it. So direct was detected on the baby's RBC. If you want to detect in mom, you do indirect because they're still floating around. Question is, in intravascular, you're going to have low haptoglobin? The answer is yes. Remember, haptoglobin is a protein that picks up hemoglobin just floating around free. That means an RBC just got destroyed if I see hemoglobin floating around free. Oh, no, it's not the free hemoglobin. It's picking up free hemoglobin. All right, so other funny-looking RBCs. How jolly bodies. How jolly bodies are nuclear remnants. Well, Rebecca wants to know, how does an RBC get processed? Before it leaves the bone marrow, Rebecca, the nucleus has to be removed. Whatever little bit is still remaining, Rebecca, the spleen will remove it. You understand me? So that means if I see how jolly bodies, that means there's still some nucleus remaining. I say, okay, what happened? Number one, either your bone marrow is just pushing them out so fast, which means you have a hemolytic anemia going on. Then I look for my clues. Or the spleen is now removing them. Everybody follow me? Everybody understand that? You gotta talk it through so that you understand what does this information help me do? Helps me decide. Ooh, how jolly bodies, that means the bone marrow didn't remove it or the spleen didn't remove it. If the bone marrow didn't remove it, that means it's pushing them out too fast. Hemolytic anemia. Everybody follow that? Okay? And they'll give you a clue for that one. Or if the spleen is not removing it, that means it's not working. Number one reason for splenectomy in America is trauma after a car accident. A lot of people lose their spleens after a car accident. The seatbelt goes right across your spleen, folks, but at least you're alive. That's why it's still okay. So how jolly bodies think of a splenectomized patient? Trauma being the number one, cancer being the number two. Or their favorite would be a sickle cell patient after age 6, when the spleen no longer works. Okay? How jolly bodies. What else can we see? Look at target cells. Target cells are RBCs that look like a teardrop. I'm sorry, wrong one. Next one is teardrop. Target cells are RBCs which have more clear area in the middle, which means they have less hemoglobin. So when we do the last way to categorize anemias, the whole list of anemias that have less hemoglobin will all have target cells. All you got to do is figure out, why would an RBC have less hemoglobin? You know, like iron deficiency. Without iron, can't make it. Okay? So target cells simply means you have less hemoglobin than normal. That's all it means. Then there's a teardrop cell, which is the one I blurted out already. Teardrop cells means an RBC that got squeezed out of the bone marrow and looks like a Hershey's Kiss. A teardrop cell is an RBC that got squeezed out of the bone marrow Kimberly, and looks like a teardrop now. Looks like a Hershey's Kiss. Now, Kimberly got to think it through. Why would the bone marrow be squeezing an RBC out of there? Number one, you got a hemolytic anemia. That means it's real bad. The bone marrow just push them out so fast, they get squeezed out of there. Or number two, you got cancer in the bone marrow pushing them out. Teardrop cells. Okay? Then we have Heinz bodies. A Heinz body is precipitated protein, Beanish. A Heinz body is precipitated protein. What's the main protein within an RBC, Beanish? Hemoglobin. So for all practical purposes, anytime you see Heinz body, the answer is G6PD. It means without the ability to repair RBCs, then the hemoglobin gets oxidized. So that's what you're seeing. Heinz body. Precipitated protein along the sides of an RBC equals a Heinz body. Always diagnose G6PD. When you have too many Heinz bodies, well, we didn't want to say Heinz bodiosis because it didn't sound right. So then we call it basophilic stippling. It means that you got so much protein stuck along the sides of RBCs, and protein stained blue, so it looks like blue dots everywhere. So that's why they call it basophilic. Blue and basophilic are the same thing. Basophilic stippling goes with lead poisoning. So when you see Heinz body, think of G6PD. When they say basophilic stippling, think of lead poisoning. Then there's elliptocytosis. That's hereditary. If it's inherited, Jennifer, how's it going to be inherited? Since it has to do with the structure of an RBC. Autosomal dominant. Remember, anything structural, say dominant. All right, then right after that, spherocytosis. How's that one going to be inherited, Dahlia? Autosomal dominant, still structural, folks. Follow the patterns, follow the rules. Don't let the mind wander off to a guess. Okay, spherocytosis. Number one reason for spherocytosis is just old or aged RBCs. As they get older and older, the macrophages in the spleen and liver just bite off chunks out of them. Bite off chunks out of them until they start to look more and more like spherocytes. So number one reason for spherocytes are just old RBCs. Okay, not hereditary spherocytosis. That's a rare disease, folks. Okay, so old RBCs. Well, then there's acanthocytes. Acanthocytes are RBCs coated with lipids. Nita, give me a reason for that. Frank, give me a reason for that. If the RBCs are coated with lipids, that means there's too many lipids in your bloodstream. Give me a reason. All hyperlipidemia. Cirrhosis. Renal failure. Nephrotic syndrome. All the diseases that have hyperlipidemia, folks, acanthocytes. Diabetics, because they have hyperlipidemias too. Okay? So acanthocytes tells me I got to pick any disease off that list that has hyperlipidemia. Okay? Acanthocytes. Then there's anisocytosis, and poikilocytosis. Anisocytosis means different cell sizes. And poikilocytosis means different cell shapes. Anisocytosis, different cell sizes. Poikilocytosis, different cell shapes. How do I use this? Well, anytime you have a disease, if you have one disease, Joseph, shouldn't all RBCs look the same? Does that make sense to you, Manny? Does that make sense, Diana? If you have one disease affecting all RBCs, shouldn't they look alike? That means I shouldn't have anesthetocitosis or poikilocytosis then. Everybody with me? So anytime I see different cell shapes or different cell sizes, what's that tell me? You have two diseases. Two or more. Or you got one disease in the second phase. What do I mean by that? Let's say you got iron deficiency. All your RBCs look small. Remember, microcytosis, right? Microcytosis. And now I give you iron supplementation. And then your bone marrow starts pushing out new RBCs called reticulocytes, which are much bigger. See that? Now I got two cell sizes, two different shapes. Now you see anesthetocitosis and poikilocytosis. That's one disease in the second phase. What about if you got malabsorption? Well, you can malabsorb iron, B12, folate. See that? It's three causes of anemia right there. That's why you see different cell shapes and sizes. Because the ones affected by iron, small. Affected by B12 and folate, huge. Okay? So poikilocytosis and anesthetocitosis are very nonspecific. But at least it tells you got to pick a disease which can cause two types of anemias, like malabsorption is the best answer. Okay? Or one anemia that's actually being treated, so it's in the second phase now. Everybody clear about that? Any questions about that? You understand it, Monica? Okay. That's the different types of RBCs. Now, the final part is the most common way to look at anemias in the hospital. What do? You get a CBC, and on there it gives you the RBCs, but it also reads out your MCV and your MCH. Some of them will read out your MCV and your MCHC. MCV and MCH. So what we're about to do is the most common way that doctors use. Why? Because, heck, you get a CBC on almost everybody. But when you look at that piece of paper, folks, it gives you a ton of information if you know how to read it. Okay? This is one of the grand rounds I actually gave to when I was a resident. Teaching physicians. These words, when you see it printed out on the CBC, did you know it tells you a lot about your patient? Most of them didn't know that. Everybody just goes right to the RBCs and reads that. Oh, hemoglobin is 12. I said, if you read the words that they put on there, they told you a lot about your patient. Okay? All right. So, MCV and MCH, I'm going to use that. And here's how I'm going to do it. Some anemias have low MCV. That's microcytic, small. As well as low MCH. That means low mean corpuscular hemoglobin. So hypochromic. Some of them have small MCV, so microcytic. But increased mean corpuscular hemoglobin concentration. MCHC is just MCH, the hemoglobin, over MCV, the size of the cell. So this person is really hyperchromic. Look at it carefully. A lot of students mess up on hypochromic versus hyperchromic because they're not reading it carefully. Some people have a normal MCV and a normal MCH. So normocytic, normochromic anemia. And then some have very huge MCV, so we say macrocytic anemia. So this is the most common way, because you watch the show ER or any of the medical shows, you see them always, give me a CBC, give me electrolytes, give me a chem panel, all that stuff. Well, folks, you got to know what it is you're going to get. You got to know how to read those numbers. They have a lot of information. That's why they're great screening labs. Only if you know what you're looking at. All right? So microcytic hyperchromic. I like physio. So that means I'm going to tell you what's going on just by hearing these terms. You got small cells with not enough hemoglobin. What's the problem? You don't have enough hemoglobin. Remember, chromicity is based on how much hemoglobin is in that RBC. So that means if you ask me what kind of funny looking RBCs you're going to see, I'll do the first one. I say, oh, you can see target cells in all of these. Isn't that what I told you target cells meant? You don't have enough hemoglobin? See? What's the reticulocyte count going to be, Rashmi? It's going to be what? It's going to be low, because without this stuff, if you don't have enough hemoglobin, your bone marrow is not going to be doing much. It's going to shut down. Everybody understand? This is how you figure out labs that should go with their disease. All right, if you don't have enough hemoglobin, maybe you don't have enough iron. That's number one. If you don't have enough iron, what's going to happen to your serum iron, Maria? It's going to be low. And then your storage iron is called ferritin. So what's going to happen to your ferritin, Maria? How can you store it if you don't have it? Don't forget what you start out with, iron deficiency. So serum iron is going to be low, ferritin is going to be low. Now it turns out that 90% of your ferritin, Rebecca, is found along the mucosal cells. 90%. You know what that explains, Cammie? That explains why all mucosal bleeding leads to iron deficiency. Doesn't matter if it's a uterus, doesn't matter if it's a GI, doesn't matter if it's a GU. Why do you always get iron deficiency for every one of them? Chronic bleeding from any mucosal surface will lead to iron deficiency because 90% of your ferritin is stored in the mucosal cells. 10% is in your bone, in the bone marrow. That's the one you're measuring, and that's continuous with what's in the plasma. All right, so iron deficiency is number one. So serum iron is low, ferritin is low. And if your iron is low, what do you want your transferrin to do, Ferdy? To go get you more or get you less iron? Get more. That's why your transferrin, also known as your TIBC, goes sky high. So if they want to give you labs, I'm just showing you how you can create the labs anytime you want. Because a lot of times they start out with the labs and ask you what anemia is going on. Okay? You got to be able to look at the lab and say, oh, that's iron deficiency. I see low ferritin, high TIBC. Got to be iron deficiency. Okay? All right. What about chronic disease? Chronic disease is second in line, and this is a late chronic disease. Anytime your body perceives that you're in a chronic disease state, which means anything lasting more than 3 weeks, Thomas, lasting more than 3 weeks, the body starts shutting things down. Which means, Tim, it'll shut down your bone marrow. If it shuts down your bone marrow, can it use up the iron? No, that means the iron will be normal, then high, but it will never be low. If your iron is high, January, what do you want your transferrin to do? Increase or decrease? It's going to decrease. So it's going to be normal at first and then go low, but it'll never be high. The labs always separate iron deficiency from chronic disease. But do you know, according to their reports, these are the two most commonly mixed up anemias on the boards? Which tells me students are picking the wrong answer without even looking at the labs because they don't know the labs tell you the answer. When I know the labs make the difference, folks, I look at the labs. And when you know the labs make a difference, then look at them. When you know they don't make a difference, don't look. In iron deficiency, ferritin's low, TIBC is high. In chronic disease, ferritin's high, TIBC is low. Their labs don't even overlap. Okay? So chronic disease. What's going on here? If your body says this, whatever this disease is going to be here for too long, more than 3 weeks, it shuts everything down. So a protein floating around in plasma will start killing off RBCs in a short amount of time, 60 to 90 days rather than the normal 120 days. So in anemia chronic disease, the RBCs die faster. Die faster. 60 to 90 days rather than 120 days. How did they figure it out? Let's say if Kathia's got a chronic disease. I don't care what it is. Her RBCs started dying in 90 days. So what they do? They took her RBCs, put it in somebody's normal plasma, and guess what? They lived 120 days. Then they said, wait a minute. They took RBCs from a normal person, put it in Kathia's plasma, and guess what? Those RBCs died in 90 days. That's how they knew it was something in the plasma. They don't know where it's, they don't know what it really is, but we know at least it's in the plasma fraction of things. Okay? It kills off RBCs much faster. Now, in early chronic disease, when the bone marrow shuts down, the pulmonary RBC still look the same. That's why chronic disease is number 2 over here too. Except this is early. Because when you first shut the pulmonary down, the RBC still look normal. But after about 60 or 90 days, the spleen starts taking bites out of them because they're getting old. And that's when they start looking small. So now they enter the microcytic hyperchromic list. So chronic disease can be normocytic, normochromic early, microcytic hyperchromic late. Okay, so chronic disease. Next is lead poisoning. We'll be talking about that this afternoon. After that is the hemoglobinopathies. Hemoglobin S and C. So we'll be talking about that too. Then after that, thalassemias. We'll be talking about that this afternoon. So again, we're going to focus on the most common ones. And then last one on this list, sideroblastic anemia. In sideroblastic anemia, your macrophages are eating the iron. Notice it still comes back to the same theme here. You have less iron and therefore less hemoglobin. So the 6 top causes. So let's say if you ask me, well, how come pyridoxine deficiency causes a microcytic hyperchromic anemia? I say, well, I just taught you guys you need pyridoxine to make heme and therefore hemoglobin. See that? That's how I know where it plugs in. There are only 6 ways to get microcytic hyperchromic anemia is what I'm telling you. No test why I can change that part. But to call it B6 deficiency, because your book never told you B6 deficiency causes iron deficiency. See, that's how they get you. They get right to the details. But once you learn the pathway, you say, oh, okay, that means B6 deficiency. Feeds in right here too. Okay? All right, what about microcytic but hyperchromic anemia? If it's hyperchromic, look at the equation. If it's hyperchromic, that means your hemoglobin is normal, but your cell size is too small. So that's why it looks super concentrated. What do we call that? That's hereditary spherocytosis. In hereditary spherocytosis, there's something wrong with the RBC membrane shape. They're shaped like spherocytes rather than the biconcave shape. Tatiana, tell me one thing you'll find on physical exam on this patient. No, schistocytosis means vasculitis now. This is not a vasculitis. What's that? Splenomegaly. All right, Janice, tell me one lab value you'll find abnormal in this patient. Jenny, you tell me one lab value. Excuse me? Not necessarily. Ferdy, give me one lab value. Huh? Reticulocyte count will be high. Cammy, give me one lab value. All right. Well, what the lab value though? So I got high reticulocyte count. PJ knows one. Increase what? Well, no, they're just anemic. They're not hypoxic. Now, hypoxia is a signal for EPO, not anemia. Dan, give me one lab value. No. There's no antibodies to these RBCs. This is just something's wrong with their shape. Dinah, give me one lab value. Fazla, give me one lab value. Andre, one lab value. They're anemic, they're not hypoxic. We just said anemia does not equal hypoxia. Don't make that leap. All right, Al.
Well, from what I've read and understand,
break it down, my son.
I believe the hemoglobin would be below 11.
Thank you very much, but nobody said anything about it yet. Yeah, overlooked the obvious, huh? The hemoglobin would be low. That's what I'm saying. I just said give me any lab value. See, students always think I'm asking for some real esoteric stuff. That's what I'm telling you guys. You guys are still thinking about that esoteric stuff. Give me the simple stuff that you've been learning. Like bilirubin. Nobody said a word about bilirubin. Anytime you're lysing RBCs, don't you get bilirubin? Last I checked, you do. Okay? LDH, things that leak out RBCs. If I destroy an RBC, what electrolyte will leak out, Miguel? No, Rebecca? If you lyse an RBC, Lucas, what electrolyte will leak out? No. Mark? It's called potassium. Oh, now come on, folks. Pull those concepts back out now. This is all stuff you already learned. I'm not even asking you anything that I have not talked about in this classroom. But the key is you got to be able to pull it forward when you're asked. And then you realize you already know the information. This is nothing new. All we're doing is just organizing our thinking. All right, so this is how you can take a disease and tell me the labs, the physical findings without guessing. Okay? How do we test for spherocytosis? The problem here is a protein called spectrin is messed up. Spectrin is defective. Spectrin stabilizes the membrane. If you don't have it, then if I put you in osmotic fluid, hypotonic fluid, water will just move right into RBC and lyse it. And that's why they call it osmotic fragility. So any vignette that mentioned osmotic fragility test was positive, it has to be spherocytosis. You understand, Binish? You understand, Matt? Ajay? Bartolin? You understand? All right, so osmotic fragility, spherocytosis. All right, under normocytic normochromic anemia, listen to me carefully. If you're anemic and yet your RBCs look normal and the hemoglobin is normal, that means there is no problem with RBCs or hemoglobin. Everybody understand me? That means for some reason you just don't have enough RBCs. Everybody follow that? That means you're bleeding, man. Acute hemorrhage is number one. I already explained chronic disease. Number 3 is renal failure. Why renal failure? Gee, where does erythropoietin come from again? Oh, maybe you're not stimulating bone marrow anymore. So renal failure causes it because lack of erythropoietin. And then hypothyroidism causes it because it's permissive. So that's how I remember the 4 causes of normocytic normochromic anemia. Remember, the thyroid permits all processes to occur under normal conditions. The way cortisol permits them to happen under stress, which means they upregulate all receptors. Okay? No one process, all of them. So without thyroid hormone, the bone marrow can't work, even if erythropoietin's around. Okay? Under macrocytic anemia, it means you have defective nuclear division. Defective nuclear division. Top cause of this, B12 and folate. 30. The 2 enzymes that use B12, what are they called? The 2 enzymes that use B12, Heron. Methylmalonyl-CoA mutase and homocysteine methyltransferase. What's the most common cause of B12 deficiency in America today, Heron? Pernicious anemia. Is that type A or type B gastritis, Heron? Is that type A or type B gastritis that gives you that? Type A for anti-parietal cell antibodies. Remember, autoimmune. Okay, B12. Folate. What's the most common cause of folate deficiency in America today, Diana? Let's try Tony. What kind of diet? Let's see if Ferdy remembers. Getting closer. Overcooked vegetables is the best answer to pick. All right, so B12 and folate are the top 2. They make up 90% of causes. So that means on any test question, you give me Macrocytic anemia, you better rule out B12 and folate answers before you worry about anything else. All right, so number 3 would be anytime you got reticulocytes because they are huge. So that means all the hemolytic anemias go under here too. So that means we can put those here. Alcohol does it because alcohol poisons the nucleus and stops nuclear division. What's the clue, Brendan, for fetal alcohol syndrome? What do you see on physical exam? There's one classic clue, man. Yeah, anything about their filter, I don't care what they say about it. I click and move. Okay, that's the one classic clue that no other disease has. Fetal alcohol syndrome. There's something wrong with their filter. Okay, so alcohol. Under mess with my nucleus, chemo drugs. All of them mess with your nucleus somehow. Anticonvulsants do it too. Like phenytoin. Remember phenytoin blocks folate. Gingival hyperplasia and hirsutism. Ethosuximide. First line drug for absence seizures, but causes bone marrow suppression. Nuclear division. Carbamazepine. Drug of choice for psychomotor or temporal lobe seizures. And then shooting neuropathies, we've already talked about. But remember, it causes agranulocytosis. Okay? Valproic acid. Drug of choice for mixed or myotonic seizures. Second in line for bipolar. But I said it causes bone marrow suppression and liver disease. Okay? And then, of course, at the end we can say cancer in general, because cancers will be attacking nuclei too. So myelodysplastic syndromes, leukemias, there's a ton of them. So this is how I organize my anemias. Sure. Oh yeah. There's other antibiotics. Other antibiotics that mess with folate will do it. Yeah, sure. Because like sulfa drugs, they mess with sulfa, right? All right, so let me give you one question before we break. You got a 53-year-old female who comes into you and says that she's got a breast lump she found in her right breast about a week ago, and it's been bothering her. She's just been feeling a little bit of weak, but not complaining about anything in general. You do a good history and physical, and on physical exam, you notice she's got a breast mass in right upper quadrant, upper outer quadrant of her left breast. No mass in right breast. Axilla is fine. No supraclavicular nodes. She looks okay otherwise, but when you do a workup, do some labs, the CBC shows a microcytic hypochromic anemia. All right? Now, how do you approach it? Watch what I do. I say in my mind, if the person has a microcytic hypochromic anemia, here are the 6 causes. Then I ask, how does my patient plug into one of these? How do I take a breast mass and become one of these? Iron deficiency? Doesn't make sense. Chronic disease? Oh yeah, that means she's had this cancer for quite a while, just didn't know it. But it doesn't plug into any one of these. You understand that? That means if you want to get a point on the test, you got to pick chronic disease as the cause of her anemia. That's how it's done. Okay? So let's say, same patient, Nicole, you put her on chemo drugs, you send her home and she comes back 3 weeks later, complaining of more weakness and shortness of breath. You do some labs and you notice she's got a normocytic normochromic anemia now. Explain. How are you figuring it out? I don't hear anything. No, the eyes are shifting too much. 53. All right, folks, everybody watch at the same time because you got to be able to do this. I can say it 10 times, but if you don't know how it's done, That means when I now ask, then your mind will start wandering and guessing again. All right? If I say now she comes back after chemo with normal neurochromic anemia, here are the 4 causes, folks. You got to figure out, is she bleeding? She didn't tell me she was bleeding. Chronic disease early? No, she was already late when I saw her. Renal failure? Doesn't chemo destroy the kidney? Especially what part of the nephron, Kathia? Thank you very much, folks. That's how you organize your thoughts. Not guess what the answer is. Not go back and tell me what some book or article told you were supposed to say. Okay? Because as you already seeing, that's not the one they were asking for on the exam. You keep quoting the books and the articles, you're not thinking about what they asked you. Because that's the wrong answer. Too often. They're trying to weed students out who just memorize what a book says, but don't really know how to think through medicine. There's already too much of that going out in the real world right now. All right? So organize. If they give me the reticulocyte count, I gave you how to figure that out. You just got to figure out, is it a bone marrow problem or hemolytic anemia? And then there'll be an answer in there. If they don't give you a reticulocyte count, they'll give you MCV and MCH. And then you got to decide, how does this patient's disease plug into one of these? You follow? That's how you figure it out. This way, when I asked normal neurochromic anemia, you actually went straight to those 4 causes. And then you can start talking it out. Does she have acute hemorrhage? Well, she didn't say so. Just talk it out. If you don't, the brain will start wandering. That's what happens. That's what I mean by we all got ADD. If the brain doesn't hear you follow a certain path, it starts following all kinds of other paths. But it's going to lead to the wrong answer now. Lock it into one frame of thought. Lock it into, it's got to be one of these 4. Brain, you find me how to connect to one of these 4 things. And the brain will stay locked into those 4 things. Otherwise, it'll start looking at the other ones. That's what I'm saying. When I saw her eyes start moving around like this, uh-oh. All right, the last granulocytes we need to talk about are the lymphocytes. They're the ones who have the ultimate control. All right, there's 3 areas you need to know. Development of the cells, where they mature, and where they differentiate. The reason for that is, if the question has development, you should have a certain organ in your mind. If it has maturation, you should have another organ in your mind. If they use the word differentiation, you should have another organ in your mind. Just that alone gets me the answer the majority of times. Okay? So, for development of all cells, we know you got to start out in the bone marrow. So both of these. This is why anytime you have a disease that wipes out the bone marrow, like SCID, it affects both arms, humoral land cell mediated. In fact, sometimes you have a drug that can wipe out the bone marrow, and you still affect both arms. Fasel, the 4 drugs that wipe out the bone marrow. Not vincristine. Vinblastine. All right, Andre, the other 3? AZT, benzene, and chloramphenicol. So 4 drugs that blast the bone marrow. The virus, Linda, that can blast your bone marrow. The virus that can wipe out your bone marrow. What B19? Parvovirus B19. And what about if they said a pregnant woman, Kathia? Hepatitis E. All right. For maturation of T cells, they're going to go to your thymus. A newborn baby's got a large thymus. You can see a huge thymic shadow on an X-ray. However, by adolescence, Kathy, the thymus shrinks away to nothing. That means after adolescence, the T cells, then we postulate, mature in the lymph nodes. Because that's where they also differentiate. So lymphoid tissue. They take up what we call a paracortical position. That means on the sides. They surround the B cells. So that means anytime you have paracortical hyperplasia, Cami, is that a bacteria or a virus? It's a virus. Everybody understand that question? Paracortical, you got to hear T cells. Oh, cell mediated. Non-bacterial. Of course, virus is top 1. All right, so that's T cells. B cells develop in the bone marrow as well. They mature in what they call a bursa of Fabricus equivalent. Where do you find a bursa of Fabricus? In birds. So they figure, Nicole, there's got to be an equivalent site in humans. But nobody knows where that site is. So what does bursa fabricans equivalent really mean? Duh. It means we have no idea where these B cells go to mature. But one day we're going to find them. They leave a trail of crumbs. We'll get them. We'll get them. All right, so differentiation, where do they go? Where do they go? Lymphoid tissue as well. Except now, Maria, they take up the germinal centers. That means, Maria, anytime you see germinal center hyperplasia, did that kid have strep throat or adenovirus in his throat? Strep throat, everybody understand? Now, that's one of their favorites. Why? A lot of students forget the tonsils or lymphoid tissue. See, that's how they make it a boys 2 or 3 question. They can tell you a kid who had a tonsillectomy after having a lot of throat infections, and then a biopsy of the tonsil shows, either pericortical hyperplasia or germinal center hyperplasia, and you got to know what kind of infection this child has been having. If they say germinal center, anywhere, the answer is a bacteria. If they say pericortical, anywhere. Does everybody understand? You got to pick non-bacteria, of course, virus being the top answer. Everybody clear? All right, so this is the algorithm. Just kind of understand it so you have a picture. Development, maturation, differentiation. Now we're going to talk about them, starting with the B lymphocytes. B lymphocytes start on the bone marrow. In fact, when they leave the bone marrow, they have 2 numbers on their surface, CD9 and CD10. CD9 and CD10, that's how you can detect an immature B cell. In case they show you a cell with that marker and ask you what does it mean. That's an immature B cell. They're looking, CD9 and 10, they're looking for this bursa fabricans that nobody seems to be able to find. So B lymphocyte differentiation goes like this. You got to process an antigen. Remember the sequence of events. I told you got to make sure you know this sequence because this is how you process all antigens. Because one day a question will come along and they'll just pick an antigen out of blue and ask you how you're going to process this thing. If you know the steps, it's always the same answer. So PJ, first you got to ingest it. Then you form a phagosome. That means the lysosome wraps around it. That means now you're going to digest it. Now you're going to present it. Anytime you're presenting foreign antigens, it's always the MHC2 complex. Anytime you are processing foreign antigens, it's always the MHC2 complex. Always. Always. Anything foreign, the answer is MHC2. Therefore, you got to just figure out who processes antigens. T cells, B cells, macrophages. That's how you remember the 3 cell lines that have MHC2 complex. T cells, B cells, macrophages. T cells talk to B cells. T cells talk to macrophages. T cells have been talking to B cells for a long time, and you remember the receptor through which they speak, Rashmi? No, that's T cells and macrophages. Remember, Michelle, do you remember? How do T cells talk to B cells? We had a receptor. Remember IL-4? No. No. IL-4. What's the IL-4 receptor? T cells talking to CD40 ligand. That's how T cells talk to B cells. T cells are going to talk to macrophages through the B7 molecule. B7 and CD28 protein. Now, how do you remember this? B7 molecule from the T helper cell anchors right next to the CD4 receptor. So 7 times 4 equals 28. All of a sudden, there's a CD28 protein between the 2 of them. It allows the molecules to go between the 2 cells. That's how they speak. So B7 molecule off the T cell anchors right next to the CD4 receptor. Okay, so 7 times 4 equals 28. All of a sudden, there's now this tube. So electrolytes can go from one cell to the next. That's how they speak to each other. Okay, so 7 times 4 is 28. So that's how T cells talk to macrophages. When you bind MHC2 complex, Bartholin, are you going to bind the alpha or beta chain? $50-50 chance. Subconscious says what? I say beta with you. All right, so remember, variable region of the beta chain, V beta region. Once the V beta region is bound, remember, invariant chain, the lock to the MHC2 complex. The invariant chain moves out of the way, and the first interleukin to be secreted, Nicole? The first interleukin to be secreted is what? IL-1. Who's processing the antigen, Nicole? No, who? What cells are processing the antigens right now? Who? Yeah, the macrophage. That's how to remember. The only cell that can release IL-1, the macrophage. A macrophage can only release 2 interleukins. IL-1 to start the whole thing, and then IL-6, remember, for acute phase reactants that we talked about already. So IL-1 is responsible for what, Nicole? 3 things. Fever. That means IL-1 is a pyrogen. What area of your brain is responsible for fever, Al?
That would be the anterior cool. So.
Of what structure are we talking about? Hypothalamus. So a pyrogen just goes to the hypothalamus. Remember, anterior cools, posterior warms. So it goes to the posterior hypothalamus, causes release of norepinephrine. You vasoconstrict. That means the heat stays in now. That's how your body temperature goes up. So your heat thermostat is in the hypothalamus. All right, IL-1 also does. Which lymphocytes? Who are they presenting to? That's how you know. IL-1's got to call them over. So IL-1 recruits T helper cells as well. And then IL-1, remember, non-specific symptoms of illness. So that one's kind of general. So fever recruits T helper cells, non-specific symptoms of illness. That's IL-1's job. The lead. The benefits of fever. Raise your heart rate. How many beats per minute? 10 beats per minute for every degree. Everybody remember this, right? If your heart rate does not go up as high as I predicted by your fever, that means that patient likely has what? Heart block. That means you better know the 5 infections that cause heart block. Right, Tim? Those 5 are very important to know, aren't they, Tim? That's why Kathy is going to tell you what they are. Go ahead, Kathy, tell them. Legion. She's trying to win my heart now. Look at that. Every month someone tries to do that. That's pretty cute. I like that. Leonella. Okay. Everybody around the country now is going to know I get turned on by Leonella. Okay. All right, so we got Legionella, Lyme disease, diphtheria. 2 more. Chagas, and 1 more. Yes. Salmonella typhi. That's pretty good. So you got 4 out of 5. That's what I told you. Just keep trying. The more you say it, the easier it is to remember it. But if you don't rehearse the list, you won't remember it. All right, so that's IL-1. That means you got to know, how can I treat a fever if I need to treat it? Ways to treat fever. Maria, give me a drug that can take away your fever. NSAIDs. Michelle, give me a drug that can take away fever. That's the NSAIDs. Tamir knows. Acetaminophen. We already said how acetaminophen. Aspirin and NSAIDs. So it's aspirin, NSAIDs, acetaminophen. Aspirin and NSAIDs, we already talked about. They work by blocking cyclooxygenase. Which one is irreversible, Ferdy? Aspirin or NSAIDs? Aspirin is irreversible, NSAIDs are reversible. That's the only difference. But they block the prostaglandins that are pyrogenic. That's what they're doing. That way they don't even go to your hypothalamus to cause fever. Acetaminophen does something different. Acetaminophen goes up to the hypothalamus and treats your fever from there, Mustafa. How's that going to be done? First thing I got to do is cool you off, take away that fever. What part of the hypothalamus is it going to bind to, Mustafa? I think I want to take away your fever, so that can't be the heating part. Al, I'll remind you.
Anterior.
Anterior cools, AC. That's how you know acetaminophen goes to the anterior to cool you off, and then blocks the posterior so your temperature doesn't go up either. That's why acetaminophen can take away your fever and block any further fever. Okay? Whereas aspirin and NSAIDs, they're going to block the pyrogens from even going up to the hypothalamus. Everybody understand the difference? But acetaminophen is toxic to what organ in your body, James? Liver. Remember I said it destroys the sulfur groups out of the liver. That means, Joshua, what drug do you use to treat it? To treat acetaminophen toxicity. Rashmi, remind them. N-acetylcysteine, which has sulfur in it, to put right back. And which hour's level will make that decision for you? Thomas. The 4th hour. So remember that on the boards when they say, oh, 2 hours after ingestion, it's only this much. Doesn't matter. You wait another 2 hours and check it again. If it's high, now treat him. If it's not, okay, he's going to be okay. What are you going to see in the liver, Sandeep? Micro or macro steatosis? Microsteatosis. Luckily, there's 2 other diseases who also give you microsteatosis. Tina, name them off. Rise syndrome and pregnancy. All right, so that's IL-1. All right, review, man. All right, IL-2 recruits everybody. That's how to remember that IL-2 is the most potent interleukin. IL-2 recruits everybody. That means T cells, B cells, macrophages, neutrophils, fibroblasts, eosinophils, mast. I don't care who they name. Just say IL-2 did it. All right, IL-2 recruits everyone. That's why if you truly want to block inflammation, he's the one you got to block. What I mean is the question, the way they like to ask is, cyclosporin has increased the longevity or duration of keeping a transplanted organ. Which interleukin is he blocking? Well, he blocks all the interleukins, but what they're getting at, which one's the most important one to block, as IL-2, because he's the one that recruits everybody to the scene. Okay? So we talk about cyclosporin, which works by blocking what protein, Kimberly? All right, Elvis, cyclosporin works by blocking what protein? All right, Dan. PJ's on it. I said cyclosporin works by blocking what protein? Blocks a certain protein within the T lymphocyte so it can't make the interleukins. Calcineurin. Or you can give them a drug that just destroyed the T lymphocyte. Tatiana. What drug can just destroy the T lymphocyte? Kill them off. Maybe Tara knows. January knows. Tim knows. Basil knows. Andre knows. Linda knows. Miguel knows. It's called prednisone. Oh, that's right. Yeah, that's one of the actions, isn't it, huh? Okay, folks, that's why all transplant patients are given cyclosporin and prednisone. Look at that. I told you, once you understand the physiology of things, it's easy to figure out what the treatment is. Okay? In fact, we have an antibody that can neutralize IL-2. That antibody is called daclizumab. Now, there are so many MABs and Ns out there. This is a whole new area of medicine. We can now make antibodies to anything. All you got to do is fuse that antibody to multiple myeloma, and it'll make you a ton of it in no time flat. So you hear about all these MABs out there now. So the ones I'm familiar with, the popular ones out on the market, I'm going to share them with you as we go. But that's a whole new area of medicine. So daclizumab neutralizes IL-2. It's an antibody to IL-2. IL-3 does B-cell proliferation. Where once there was 1,000, now there's 10,000. Proliferation. And Joseph, if you want to detect cellular proliferation, what let me see. Yeah. Which nucleotide do you want to label? A, G, C, U, or T? T. Remember, T labels all DNA replication. Anytime cells are replicating, DNA's got to replicate too. So IL-3, B-cell proliferation. IL-4, B-cell differentiation. IL-4, B-cell differentiation. That means anything about class switching, antibody function, stimulating B cells to be what they're supposed to be. IL-4. IL-5 controls class switching only for IgA. So it's one of those things, if you ask me about who controls class switching, I look for IL-4 first. But if they ask me about IgA, I look for IL-5 first. If I don't see 5, then I look for 4. Because 4 does all of them. IL-5 controls class switching only for IgA, nobody else. IL-6 controls acute phase reactants. And Frank knows anytime you have too many acute phase reactants, or for that matter, too much of any protein floating around in your blood, what blood test can detect that for you? ESR or C-reactive protein, very good. Whenever it's elevated, it means you got too many proteins or inflammation going on, but we don't know where or from what. Whenever you get too many proteins deposited all around your body, Tatiana, if I biopsy it, it looks Congo red. It looks red on Congo red stain. Apple green briar fringes. Doggone it. What disease am I talking about? What? Amyloidosis. Of which there are about 5 or 6 of them, Kathia. What's the most common type of amyloidosis? Primary or secondary? Secondary. The most common type of secondary? No. Most common type of. Yeah, is it A, B, AB2, A, E, F, or AL? Getting close. Nicole. AA. The second A is for acute phase reactants. That's how to remember it. All right. AB. Amyloid. Jenny goes with what disease? No. Ferdy. AB. No. Janice. Alzheimer's. Remember beta or tau protein. And now they're even more specific, Janice. Apolipoprotein E4. Early onset Alzheimer's. Janice, what disease? Down syndrome, of which the most common cause is non-disjunction. More common in mom or dad? More common in? And dad. But the ones that gets transmitted? Janice does. What she eat for breakfast this morning? Dang it, man. That's beautiful. I like that. She got a whole new confidence in her eyes now when I look her way. Not that, ooh, don't ask me. Now she's waiting for the next question. She's just, I got the next one too. Come on, ask me again, Dr. Vance. All right, very good. That's what I call progress. That's what happens. All right, IL-10 suppresses cell-mediated. IL-12 enhances cell-mediated. Remember we talked about that day 3 to 4 when the body has to decide who's invading? IL-10, when he realizes, oh, this is bacteria, he'll say, okay, T-cells, matter of fact, go home. We don't need that many of you. When the body realizes, oh, this is not a bacteria, IL-12 comes out, tells the neutrophils to go home, macrophage and T-cells, you guys take over. So that's what this is about. IL-10 suppresses and IL-12 enhances cell-mediated. That means if they ever ask you, why did the cell-mediated go away, or why did the cell-mediated get worse? Now you know which interleukin look for in your answer. All right, speaking to cells, T cells talk to B cells via the CD40 ligand. We've mentioned that many times. And B cells, when they mature, they now display 19 and 20 on their surface. So it's like graduation. Remember, they left the bone marrow with a 9 and 10. So then you up it by 10 when you graduate. So now you're a 19 and a 20. All right? So kind of a good way to remember it. All right, any questions on interleukins? These are all high yield, folks. You got to know these. Okay, all inflammatory diseases, all these chronic diseases we deal with, you're going to see all these problems. They're going to ask you which interleukin are you going to attach it to. Who's that? Yes.
What was IL-6?
IL-6 is responsible for acute phase reactants. Okay, stages of B cell development goes like this. You got 3 stages. On the boards, they'll describe it. You picked which stage, Michelle? In the pre-B cell, all you see is mu chains, mu as in IgM, within the cytoplasm. In the pre-B cell, Joseph, all you see is mu chains in the cytoplasm. In the immature B cell, you see some of that IgM on the surface, which tells you, Joseph, that the first antibody secreted by every B cell is IgM. Everybody see that? That means, therefore, Al, when a baby is born, which antibody is he going to secrete first? That would be IgM. Does everybody understand why an ELISA test that measures IgG is worthless in the baby? Just so you don't just memorize that. The baby doesn't even make IgG when he's born. So why do an ELISA test that detects IgG? Okay, so IgM is the first antibody made by every B cell. What does it look like? It's a monomer. That means one FAB and one long part FC portion. That's it. Now the reason why you got to know that because that's a different structure than when it gets secreted into a plasma. It has a whole different structure. So the IgM that's on the surface of a cell, surface marker, is a monomer. One FAB, one FC. IgM. Well, when it's a mature B cell, now you see IgM and IgD on the surface. And a way to kind of remember this, Jenny, is that in a way, Jenny is working so hard so that she can be just like a mature B cell. Jenny, what does a mature B cell display on its surface? MD. That's what she wants to display too, MD. All right, so that's how I remember the mature B cell, the MD. So on the boards, they'll say, well, you got a B cell that's got this on the surface or that on the surface. What does that mean? So now you know 9 and 10 says it's still just fresh out of the bone marrow. 19 and 20 says it's mature. And then if you want to use antibodies, when the MD is on the surface, it's mature. Okay, these are 3 stages that you got to know. IgD is also a monomer and serves only as a surface marker, Monica. IgD has no other function. So that means, Monica, anytime they ask me a question, a negative question about antibodies, man, just look for an answer about IgD. They always got IgD doing something he got no business doing. It just makes it easier for me. Okay? There's almost always a statement about IgD doing something. Fixing complement, binding this antigen, binding this allergen, doing this, do that. It does nothing except sit right there on the surface and just look good. That's it. IgD doesn't do anything else. Everybody clear on these 3 stages? All right, cool. To stimulate a B cell, I told you before, endotoxin and pokeweed monogen. And then, of course, you label the thymidine. Tina, how old did you say your child was? 8 months. So we're going to use Tina's child to illustrate antibodies and vaccines. You guys hear me? Oh, got to give you one little excitement right before we go to lunch, man. And it goes a little something like this. All right, Tina. Primary response. That means the first time you come in contact with an antigen. The first antibody is going to be which one? IgM. Well, look at the algorithm there. The chart. It arrives when? 3 days. So, Tina, tell me, if IgM doesn't show up for 3 days, who the heck's been protecting me for 3 days? No, this isn't anybody. Just tell me, who's been protecting for 3 days if IgM doesn't show up till day 3? Melanie knows. Who protects you in the first 3 days, Melanie? What's this natural immune thing? What's it called? I think it's got a name. All right, let's see if Linda remembers. It's all the neutrophils. Show up at 24 hours, peak at day 3. Everything's organized in your body, folks. Nothing is just haphazardly occurring. You got to see how it's all overlapped. So the body says, if the neutrophils can get rid of it by 3 days, I don't have to show up with these antibodies. But if the neutrophils have not got rid of it, the antibodies help them out. Who are those? B cells. Didn't we say B cells and neutrophils work together? See that? See that? Now you're seeing it in action. Okay? Show up at 3 days. When does it peak, Tina? IgM. 2 weeks. IgM peaks in 2 weeks. Does everybody see that? That means before 2 weeks, you still got too many antigens, too many germs, whatever it is, right? But at 2 weeks, now you got tons of antibody. You should be able to clear the infection now, shouldn't you? Everybody understand? Everybody see that? This is why, therefore, if you got leftover antibodies that cross-react with your body, you're about to develop an autoimmune disease. Have you ever wondered why every autoimmune disease is always 2 weeks after the infection? I got to break it down just a little bit for you, man. I got to show you where they're getting all this stuff from. Why is it always 2 weeks after a URI? Then you got this. 2 weeks after a sore throat, post-strep GN. 2 weeks after meningitis, now you got multiple sclerosis. It's always 2 weeks after the infection. It also lets you know, Mustafa, that when a patient presents with autoimmune disease, is the infection still in their body? Is the infection still in their body? No. Infection is long gone. We just have antibodies left over. Does everybody understand that? Do you see that, Melanie? Do you understand that now, Melanie? Do you truly understand that? That means if your immune system is normal and healthy, you should clear that infection by 2 weeks, should you not? That means, Melanie, if you are sick, you come to see me, the doctor, and I put you on some medication, when should I see you back? Did you guys ever know where the 2-week visit ever came from? I got to break it down, baby. I got to break it down just a little bit. I haven't met a pediatrician yet who knew that. That the 2-week visit first came from immunology. But that's just something every pediatrician does. But everybody forgot where it came from. That means if you have a normal immune system, you should be better in 2 weeks. That's why, if you're going to treat a patient, we say, come back in 2 weeks. You should be better. And that way, when they come back in 2 weeks and they're fine, you say, good. It means your immune system did what it was supposed to do. All right? 2 weeks. Then it lasts for how long, Tina? 2 months. Tina. When that baby was born. That baby was gifted with your antibodies that you lent him. Say, here, my baby. Borrow my antibodies. No, you don't have to return them. Keep them as mama's gift to you. Now get out of here. But mama, there's a masked man out there. I think it's just the doctor. Get out of here. All right, so the baby's born. Shows up at the doctor's office at 2 months. You give him an injection. What antibody's going to show up? IgM, when is it going to show up? 3 days, when's it going to peak? 2 weeks, when is it going to be gone? That's why they tell them, bring that baby back in 2 more months at 4-month checkup. When? If you give that shot at 4 months, when did IgM show up? At 3 days, when does it peak? And when does it go away? That's why they say bring it back at 6 months. Oh, I got to break it down, baby. Check it out. When I was a resident and I asked my attendant, how do you figure out the vaccination record for a child? You know what they told me? Just carry your Harriet Lane. Just carry your Harriet Lane. Just carry another book. Nobody seems to know where all this stuff comes from anymore. Everybody's forgotten the basics. Everybody just reads the big books. Well, whatever the expert says. Folks, I'm about to show you how to vaccinate anybody and everybody if you know immunology. That's how simple it is. Because that's where it came from. You don't have to carry a Harriet Lane anymore. If you understand immunology, you understand vaccinations. The baby can only make IgM when he's first born. Everybody understand? That's why you see him at 2 months, 4 months, 6 months. Everybody understand that? Okay. However, starting at 6 months, a baby can now make IgG. Starting at 6 months, Andre, a baby can now make IgE. Do you understand that? Okay. So at 6 months, when you give him the 6-month shot, the IgM that he made shows up when? At 3 days. When does it peak? 2 weeks. When does it go away? 2 months. That means at 8 months, that IgM is gone. But he also made IgG at that time. Look at IgG for primary response, Andre. Tell me when does it show up? In 2 weeks when the other one's arising. Everybody see that? When does it peak? 2 months when the other one's going away. See that? Well organized, folks, never just by random. How long does it last? 1 year. Tina, when that baby had a 6-month shot and they give a shot, IgM showed up when? 3 days. Peak when? 2 weeks. Took off when? By 8 months, gone. IgG that baby made showed up when? 2 weeks. Peak when? 2 months. How long is it going to last? When is the next shot going to be due? 18-month checkup. Oh, y'all better get off me, man. Get off me, boy, because I got to get some elbow room up in this joint. Show you where this stuff came from. The whole pediatrics, man. Immuno. But nobody seems to know that. It's just whatever Harriet Lane says, that's what they do. Folks, if you know your immuno, you'll never forget what vaccination to give somebody anymore. All right, so that's IgM and IgG in the primary response. Everybody understand? Now, let me teach you the second half of vaccination. The second half of vaccination says you vaccinate to protect those who are susceptible when they are susceptible. Everybody understand me? You vaccinate to protect, okay? Active immunity. We talk about active immunity. Either you get the infection, that's the best one, right? Active. Or I give you that antigen so that you have the full response. Everybody understand? Why not give you the full antigen? Well, if you give me the full antigen, I'll get the infection. You understand that? Okay, so that means anytime it's a bacteria, you just take a piece of that bacteria. Just show you how to make vaccines. If it's a bacteria, take a piece of it. Because you're giving the whole bacteria to get the infection. Everybody follow me? I'm trying to prevent the infection of the child, not give them the infection. All right, if it's a virus, we say live attenuated. That means give me the virus, but weaken it so it doesn't give me an infection. But this way, my body can respond to it. Live attenuated. If it's a disease with a toxin, toxoid. That means an inactivated toxin. Again, just showing you how to apply it so that no matter what vaccine we're talking about, if they ask you what's the best way to prepare this vaccine, now you know. If it's a bacteria, take a piece of it, Hampton. Remember we talked about the hip. If it's a virus, live attenuated is the best type. Okay? That's how you know live attenuated is better than a killed. Like if they ask you to compare contrast oral polio and IPV, that's how you know. The oral is better if you have to choose one. All right, so, and if it has a toxin, you would say toxoid. Everybody understand what I just said? Okay, so here's the vaccine record for Tina's child. At 2 months, so DPT, oral polio, Hib, and pneumothorax, and pneumococcus. All right? When do children get these infections? Starting at 2 months of age. They are susceptible to these infections all the way out to age 10. You understand me, Tina? You understand, Andre? All right, so Tina, let's protect your child. During the time they're susceptible, everybody understand? All right, so you said give one at 2 months, and then you said give one at 4 months. Then we come back 2 months later, give him 6 months. He's protected now for those first 6 months. Follow me? IgG now shows up at 6 months, right? All right, how long is that going to last? 1 year. That's why you don't have to bring him back until here. Is he out of the susceptible population yet? No. That means we got to keep on vaccinating. Everybody understand? All right. But memory, let's talk about memory. Memory will develop at 12 months and is fully developed by 15 months. So memory is fully developed by 15 months. We also call it the anamnestic response. So Andre, help Tina out here. Memory response, Andre, involves only IgG. You understand? That's the only antibody we're talking about if you say memory for the bloodstream. If you say mucosal surface, that's IgA. You understand me now? You understand, Faisal? Memory in the GI tract. What antibody, Andre? IgA. Memory in the uterus. Which one? Okay. So you got it then. I just want to make sure you're with me. All right. We're only talking about IgG. Look at when it arrives. Andre, tell me when does it arrive? It arrives in 3 days. Why? Because IgM's not showing up. This is memory. There is no IgM in memory. That means IgG better show up then when IgM would have shown up. All right. When's it going to peak, Andre? 5 years. When's it going to go away, Andre? 10 years. Hey, Josh, how often are you supposed to get a tetanus shot?
Every 10 years.
Damn, I wonder where they got that 10 from. Right here. Now they're talking about getting repeating pneumococcal vaccine every 10 years. Do you see where the 10 comes from? Okay. All right. But here I've got Tina's child susceptible for the first 10 years. So now let's go back to our graph here. So at 2 months, I give him all of these, right? Tina, you with me all the way up to 18 months, right? But you told me he's still in susceptible population, is he? All right, so here at 18 months, does he have memory or not? Yes, he does. So what antibody is he going to respond with? IgG only. Showing up at 3 days, when's it going to peak? No, memory.
Oh, sorry, 5 years.
5 years. That means at 5 years, how old is he? So that's about 6 years of age, 6.5, right? Is he out of the susceptible population yet? No, that's why they say, well, don't let him come down yet. See that? He's at his peak at that age, but if we let him come down, you're leaving him vulnerable for the next 5 years. So we say, don't let him come down. Boost him back up and let him stay up there again. Everybody see that? That's how I know you got to revaccinate him right there. You understand? You understand, Michelle? All right, Michelle, you do one. So MMR in America, when are you susceptible? From 18 months out to age 10. 18 months out to age 10. And then again, 18 to 25. All right, Michelle? Since memory starts at 12 months, fully formed by 15 months, that's why we give the first MMR at 15 months. Why? Because the child was not susceptible to these illnesses under 15 months. Everybody understand that? Well, in the Philippines, measles is endemic under a year of age. So they give measles vaccine at 2, 4, and 6 months. But Al, you got a Filipino child that just arrived in your office, 15-month-old child. And the mom says, this child's already had 3 measles vaccines. 15-month-old baby, should I give an MMR? I don't know. That's what I'm asking you. Should I give the MMR? Okay. Tara, what do you think? Should I give the MMR or not? No. All right. Here's the way to think about it, Al. This child has memory right now, right? Did he have memory of getting those 3 vaccines under a year of age, Al? I suppose not. His body has no idea he's ever gotten those vaccines. You still give it again. They love that one, folks, because it makes you think, well, he's only had 3. He doesn't need any more. Except he didn't have memory back then. He has no memory of having received those shots. Okay? All right. So that's MMR at 15 months. All the way out to age 10. Didn't we say that, Michelle? Susceptible period? All right. So at 15 months, you give him a shot. He's got memory now, doesn't he? What antibody will respond? IgG only, showing up at day 3, but peaking when? At 5 years of age. If he's peaking at 5 years of age, is he out of susceptible population yet? No. That's why they say jacking right back up again. Michelle, you give him another shot at 5 years of age. Which antibody's going to show up? IgG only, shows up at day 3 and peaks when? At 5 years. At 5 years later, how old is he now? 10 years. Is he out of susceptible population now? He's leaving. That's why you don't boost him up again. However, when's the next vulnerable period? At age 18. That's why they say catch him one more time before he enters college. That's what vaccines are all about. It's not about a Harriet Lane or a CD or a Red Book. All right, that's what everybody's always looking in there to figure it out. Immunology. Told me the whole thing. In fact, I remember having one student who was here before who got a residency because of this. She called me right after they were having the teaching rounds. And the attending they were having an argument about what vaccine to give. And she raised her hand. Well, from what I really understand, I mean, she broke it down for, she showed them the whole immunology of the vaccine record, the way she had learned it here. That chairman was so impressed because he had never understood that's where the vaccine record actually came from. He offered her a residency right there on the spot. You remember, 4 medical grads can get residency out of match. They don't have to wait for match. She got the residency right on the spot. It's amazing. I'm telling you, there's so much we do in medicine today. Most physicians have no idea where he got it from. It's just the article keeps telling them what to do. But the problem is you don't know if that article is incorrect or not. If you don't know the whole theory behind it. That means what's the basic foundation of information I need to know? Tell me that before we get all up here. Because after years of articles, all of a sudden it becomes just what we always do. Nobody knows how to explain it anymore. Okay? So that's MMR. Any questions on that? Now, last point to make on MMR, then we're going to stop right here, is that I said you give the MMR at 15 months, and then I also mentioned after that you got memory. You got to ask yourself, Dr. Payne, how'd you get memory when you only get 1 shot? Everybody understand that? That didn't make sense right at first until you understand this. Somebody came up with a way to make up a vaccine, this is live attenuated, so that the antigens leak out slowly. That way, the day I give you the vaccine, you'll have your primary response, and then later you'll have your secondary response for the same vaccination. MMR, when I give you an injection, leaks out for 2 months. Because this is live attenuated, Al, and we know we don't want live rubella attack a pregnancy. This is why they tell a mom, don't get pregnant for 3 months after vaccination with MMR. See that? That way you're 1 month outside of live viruses floating through your bloodstream. That's why you need to understand this, so that somebody don't always have to remind you. And then you don't forget. You don't forget, because here comes mom, you vaccinate her, and then she gets pregnant a month from now. Oh, she's going to start trying to blame you for it now, okay, if something goes wrong. It's going to be hard for you to defend yourself against it, because you're the one who messed up. You should have told her, Ma, don't get pregnant for the next 3 months. Okay? All right, so that's MMR. Varicella. Susceptibility period starts around 18 months and goes out to age 10. So that's why they say anytime after a year. So, at the 15-month checkup, give them just one varicella. Now, that was another controversial vaccine, too, because I used to think, why are we vaccinating children against an illness that's so benign in children? Chickenpox is more malignant in adults. It's always better to just go through the disease. That way you have good, strong immunity against it. If you remember in the old days, if a child got chickenpox, all the other kids in the neighborhood came over and got it at the same time and got it over with. So I just thought, why are we doing this vaccination to children? Well, when you followed a vaccine, for years they were developing it, phase 1, 2, 3, 4. Well, when they got to their double-blind trials, it really had no benefit. So they couldn't figure out, oh, Lord, FDA is going to turn this down because there's no benefit anymore. And I said, I was like, okay, thumbs down. And then they sent their statisticians into the boardroom, say, find us one benefit in this thing. It cost them like about $150 million to develop. They didn't want to lose all that money, right? Well, the statisticians worked real hard. Shirts were unbuttoned, coffee, Ritz crackers. And then they came up with one benefit. You know what the benefit was? If you vaccinated this group of children, the mothers got to go back to work one day earlier. I could have sworn that's not what the vaccination was supposed to be about. But somehow they found an economic benefit. They said, well, if the mom got to go back to work one day earlier, times how many moms, times the percentage of children with chickenpox in any given year, that translates into several $billion of savings to the GNP. Okay, fine. You're approved. Wait a minute. Somewhere along the way, we lost track of what the whole thing was about. There's been so many other controversial recommendations that the FDA has allowed to go across, folks, and that's why so many physicians have lost faith in the FDA. Because, look at how many drugs we find are harmful to people, and FDA still lets it stay out there anyway. The drug companies have so much power over these decisions now. Before it was FDA worked in autonomously. Your job was to protect the population. You're not Republican, you're not Democrat, you do whatever is medically correct. That's not true anymore, folks. There's a lot of decisions that are not based on medical, what their medical evidence shows. So you hear it on the news all the time. Anyway, that's varicella. Now, of course, guess what? You vaccinated the children, and now you turn them into adults. After 10 years, their antibodies have disappeared, right? Right? The only problem is now there's a high incidence of shingles with this vaccine. Well, then that means now mom's got to stay out of work for another 7 days. So much for that one-day savings. Oh, they should have listened to the bunch of us who disagree with this one, man. All the money that they thought they were going to save this country by approving it. Who made all the money? The company who got them to approve it the first time. Because now they're considering revaccinating everybody again. Only that company can be very happy about that decision. Hepatitis B became a problem in the first year of life because of children born to prostitutes, IV drug abusers. They got hepatitis B, transmitted it to the baby was dead by 4 months of age. Remember I said you vaccinate the susceptible population when they're most vulnerable, correct? That's why they say if mom is surface antigen positive, that means you got a vulnerable child here. If mom is surface antigen positive, you give the first vaccine right there at birth. They also say give the immunoglobulin at birth. Elvis, why would they say that? Since you're giving a vaccine, why give immunoglobulin as well? Yeah, but why am I giving the baby immunoglobulin if I'm already giving him vaccine? Isn't the vaccine going to be protective? It is, but there's some reason why we're still giving immunoglobulin. Let's see if Kimberly can figure it out. So you're giving him IgG? What's the benefit of giving him IgG? Well, the argument is okay if you finish it all the way through. I just got to follow you. That's all. Nicole. IgG, maybe the baby cannot make IgG. IgG has the highest affinity. So the baby can only make IgM. So we say, let's give him IgG, which has even a higher affinity than the IgM is going to make. Plus melanie. When is that IgM going to show up? Yeah. It rises in 3 days. What's the baby supposed to be doing for 3 days? Oh, forgot that, huh? Can't leave the baby naked for 3 days. He has no immunity. That's why we say give the vaccine, immunoglobulin, as soon as he's born. You see, I want you guys to understand it, because if you understand it, you won't forget it when you're out there in practice. Because it'll make sense to you. You'll know what you got to do. Okay? Otherwise, for the regular population, because their risk is a little lower, we say, well, wait till their 2-month and 4-month checkup and give them a hepatitis B vaccine. But the ones that are most vulnerable, vaccinate them immediately. Then give them another one at either 1 or 2 months. Remember, IgM is going to be gone in 2 months. See, that way, if I give him another one at 1 or 2 months, he's protected for another 2 months. You see that? That way, he's protected all the way up to 3 to 4 months. And that's the reason why we vaccinate him twice in that 4-month period, because that's the most susceptible population. Then they say you can give the third one anytime, you know, after memory develops, at least 6 to 12 months later. Okay? Because now that one is for lifetime protection. The first two are to protect him during the vulnerable period. Okay? So hepatitis B. Yes, Tina. Yeah, that's a new one. That's a new one. Yeah, I'll talk about it a little bit, just what it's for. But that has now come on. It took them years to develop one that didn't cause problems. Yeah, so that's now being recommended. All right, antibody structure and function. What do I need to know? You got an FAB and an FC portion. What do I need to know? You have 2 heavy chains and 2 light chains. What do I need to know? You got an FC, C for complement binding, and FAB, AB for antigen binding portions of an antibody. FAB and FC. 2 heavies, 2 lights. Notice the 2 heavy chains are on the outside, 2 light chains are on the inside. Notice also, the light chain is found only in the FAB portion, whereas the heavy chain is found in both sections. You see that, Miguel? All right? You got 2 heavy chains, 2 light chains. Your heavy chains, 5 different types. Gamma, alpha, mu, delta, epsilon. So you have 5 different heavy chains. Your heavy chain determines your isotype. So the isotype, Jenny, just simply means which class do you belong to. Following? Because that's the language they're going to use when they're talking about antibodies. The isotype tells you what class they come from. And there are 5 classes. G, A, M, D, and E. That means 5 heavy chains. Gamma, alpha, mu, delta, epsilon. 5 isotypes. Then you have 2 light chains. Kappa and lambda. 90% of your antibodies contain kappa light chains. We mentioned that when we're talking about multiple myeloma. And 90% of the antibodies you have in your bloodstream right now, gamma, IgG. Why? It's all the memory you pile up all throughout your lifetime. Every germ you come in contact with all your life, you got IgGs to them floating around. So 90% of your antibodies at any one time, IgG. Most common light chain, kappa, because over 90% antibodies have kappa light chain. Now if we look within each one, there are variable regions, 1 and 2, V1, V2, and then there are constant regions, 3 of those. 2 variables, 3 constants. What do we need to know? The antigen binding spot is in the variable region only. The antigen binding spot is in the variable region only. In fact, in the variable region, Linda, there is a hypervariable region, and that's where the antigen will bind. In the antigen binding area, the FAB portion, there is a hypervariable area of the variable region, and that is where the antigen will bind. Now, how do I remember that? Think about the millions and millions of germs you got to come in contact with all your life. And you got to have an antibody that can grab around it like that and fit it. It's like a Rubik's Cube. The antibody binds around it, starts moving around until it locks in. That's why you got to have a hypervariable region, because the hypervariability a hypervariable region multiplied by a hypervariable region equals billions of combinations. Everybody follow that? That's how to remember it. Hypervariable region is where the antigen actually binds. Okay? The antigen, when it is bound, we now call it an epitope. See, again, language just changing because of location. Epitope is the antigen when it is bound to the antibody. And the site that it is bound to, Tony, is called the idiotype. So the hypervariable region of the variable region is your idiotype. That's where the antigen binds. And once the antigen is bound to that site, now we rename it an epitope to let you know it's not just floating around free anymore, it's actually bound to an antigen. Any questions on those definitions so far, Fergie? Idiotype is the actual site the antigen binds to. That's the hypervariable region of the variable region. Okay? Now, the difference between one person and another, the difference between two members of the same species equals allotype. You have an IgG, I have an IgG. But if I inject my IgG into you, your body will destroy it in no time flat, even though they have the same structure and everything. But they're not genetically the same. So the genetic difference between two members of any species equals allotype. That is the reason why when you just inject antibodies to someone else, we call that passive immunity, because it's never going to be long lasting. Let's say you want to travel to Africa. Hepatitis A is rampant there because of the water. So what do? Get hepatitis A immunoglobulins right before you leave. But it only protects you for about 2 months because your body will destroy it all in no time flat. But by then, you've already gone and come back. So passive immunity is short-lived. It's made up of just antibodies. We talked about it in Kawasaki's. We talked about using it for children who have low gamma globulins when we were talking about transfusions. But it's not going to last very long. Your body knows the genetic difference and therefore will attack it and destroy it. That's why we like active immunity. Yes. Why doesn't your body destroy right away? It does start destroying right away. But the key is, remember, you got to mount a response against it. How long before IgM shows up? No, IgM shows up in 3 days. That means you can't start destroying it for 3 days. Yeah, and then it just takes over time till you can clear it out of your system. Most people, you get the vaccine within 2 weeks of travel. Why do they say within 2 weeks of travel? When's your IgM going to peak? Yeah, 2 weeks. That way you better be wherever you want to be while you got plenty of antibody. Because that antibody now becomes the antigen. That means your IgM will clear that out pretty fast. But at least most people have traveled and gone and come back by that time. So that's allotype. Xenotype or heterotype. Xenotype or heterotype is the difference between two members of different species. That means, Benish, let's say you got a baboon and a chicken. They both have IgG, but if you inject IgG from a baboon into a chicken, that IgG is cleared in no time flat. Everybody understand that? Well, let's put it into medical practice. In the old days when we used to inject insulin from pigs and cows, everybody understand why in a few hours that insulin was nowhere to be seen. Your body mounted a response and that's it. All those units of insulin were gone. And then after a while, you got so many antibodies to insulin, no amount of insulin will help you now. All right? So a lot of children just died because we didn't know what else to do. And that's why they had to go back to the lab and engineer human insulin. Amino acid for amino acid. And that's why they call it humulin. It was the first insulin to come out because, my goodness, the pork and beef insulin just killed a bunch of people because they were reacting against it and destroying it just as quickly. Everybody understand that? All right? All right. It also explains to you, let's say, when we used to, you take pig valves and put it into a human being. Does everybody see why your body's going to attack that pig valve? Doesn't belong to you. Even though it looks like an aortic valve, guess what? Your body knows the genetic difference and will attack it like crazy. Okay? All right, so again, that's big picture. Now let's go back to antibody. C1, C2, and C3, they're going to ask you where antibodies bind their complement. FC portion, complement binding. All right, here's how I remember it. IgA is the only one that shows up to mucosal surfaces, and IgM is the first one to show up to inflammation. They bind complement at C1. Again, the brain likes patterns. That's how I fold it up and put it away in my brain. IgA, the only one that shows up to mucosa. IgM, the first one to show up to inflammation. They bind complement at C1. Well, Pernema, the second antibody to show up to inflammation, is called IgG. So he binds complement at C2. The second antibody to show up to inflammation is IgG. So he binds complement at C2. And because IgM has 5 arms, he's so avid at binding antigen, he also binds it at C3. So guess who uses up the most complement whenever you have inflammation, Josh? Which antibody? IgM. He's binding 2 per arm at C1 and at C3. Well, somebody was playing around in the lab with a bunch of enzymes and discovered something. That first of all, you got 3 very important disulfide bonds in an antibody. Well, Jessica, when you hear disulfide bonds, what amino acids are you hearing? Cysteine. Tells you there's some important cysteines in here. Well, the first thing he did was use the drug pepsin and trypsin. Pepsin and trypsin cut right here underneath the disulfide bond in the FC portion. That's called the hinge region. So pepsin and trypsin cut right under that hinge region. When you do that, the FAB portion still works. That's when they realize this is one functional unit, the FAB. You have to have both arms, and it works. But you can't bind complement. The FC portion is not attached. So that's when they found out the FC portion must be another functional unit. Because if it's not attached, all of a sudden it doesn't work. When it is attached, it works. Well, somebody was playing around in the lab with another enzyme and cut it like this. That was papain. Papain cuts underneath the 2 disulfide bonds up in the arms. So guess what? The FAB now gets split into 2 pieces, none of which can work. And then FC is just one solitary piece. It can't work either. That's when they realized what's really going on in this antibody. Number 1, that disulfide bond that forms a hinge is very important. You must keep the 2 arms together in order for it to function. Everybody follow that? And that the FC portion must be attached in order for it to function. Okay, that's what came out of these enzymic cleaving studies. Okay, any questions on that stuff so far? Al?
That makes pepsin or trypsin in some resemblance kind of good for like problems against autoimmunity, other than it would take out all of them.
That's the problem. It'll take out a lot more than just your antibodies. You do a lot more harm to the patient. So we just keep that in the lab and nowhere else. So it's worth one question on the boards. That's what they'll ask. So the person who did it at least showed us that there are 2 very important pieces to an antibody. All right, so you got 5 antibodies. Let me teach you about each one of them. First one, starting with IgD. 1 FAB, 1 FC. What's its role, Tamir? No, the IgD. What's its role?
It's found on the lymphocyte.
On the surface. It's a surface marker only. That's it. That's all you need to know about IgD. Does not bind antigens, doesn't bind fixed complement, just serves as a surface marker. All right, next one, IgE. IgE is also a monomer. 1 FAB, 1 FC. 1 FAB, 1 FC. Even though it has an FC, Danielle, it does not fix complement. IgE is active in binding what, Danielle? So it's involved in binding allergens and one other group of antigens. Sandeep? Jennifer? Parasites. All right, that's the only two things IgE can bind for you. An allergen or a parasite. Can't touch anything else. Now, we went through that whole allergic response already for you. Okay, so IgE, one FAB, one FC. That FC force, remember, anchors into a mast cell to cause degranulation. Right, Tatiana? And when the mast cell degranulates, what three chemicals will it release? Let's see if Lucas remembers. Histamine for early symptoms. What else? Eosinophil chemotactic factor of anaphylaxis to bring the eosinophils over. What else? Mark, the third one. SRSA, slow reacting substance of anaphylaxis. In order, though, remember, histamine first, SRSA 4 to 8 hours later, and the eosinophil chemotactic factor. And that's because you want to bring the eosinophils over, Diana, to keep an eye on these mast cells so they don't get out of hand. What chemicals do the eosinophils release? Let's see if Sakchai remembers. Let's see if PJ remembers. And that's all right. Let's see if Monica remembers. The chemicals that the eosinophils release. Let's see if SOB remembers. All right, let's try Miguel. Rebecca. Beanish. First letter. Let's try Linda. Histaminase to break down the histamine. Heparin for any clots that form when you vasodilate, clots form. Aerosulfatase A to break down SRSA. Y'all better start hanging out with that girl right there, man. She knows those. That's good. What, excuse me? Which one? You talking about eosinophils? Ooh, not that I know of. Remember, interleukins come out of B cells, not the eosinophils. Uh-huh. I wouldn't pick that on a test, put it that way. Yeah, I've never seen that be an answer on anybody's test. Yeah, I'm not sure about that, so I can't say one way or the other. All right, but those are the main chemicals they want you to know of. All right, so that's IgE. Too many IgEs is part of a syndrome called what? Since Diana's got her hand up. What disease has way too many IgEs in it? Joseph, what disease? Well, yeah, asthma could have a lot of IgE, but there's another disease in the red-haired female, Dan. Who knows? Who knows? Oh, Kimberly knows. Job syndrome. Remember Job syndrome, red-haired female. How do you explain that she got so many IgEs and can't make IgM, Kim? All right. Kathy, I can explain it for you.
Class switching?
Class switching is messed up. Kimberly, join in. She said class switching is messed up. Maybe IL-4 is defective. Oh, wait a minute. Maybe there's another explanation. Kathia, what receptor is that? No, CD40 ligand's broken. Or the second messenger, Kimberly. Or the lead. Tyrosine kinase. Remember, cellular growth. All right, so that's IgE. On to the next one. IgA. IgA is found in mucosal surfaces and secretions only. Well, not only, mainly. IgA is a dimer. That means 2 FABs, 2 FCs. Then they have one J chain joiner to join them together. IgA is a dimer in your secretions and mucosal surfaces, but it's a monomer when you see it in the blood. How do you make IgA in secretions and mucosal surfaces? The B cell will secrete the IgA as always. What's interleukins controlling that, Nicole? Rashmi knows. IL-5 controls class switching for IgA. But what happens is when the IgA is secreted into the secretions, then the mucosal cells, or whatever organ we're talking about, secrete another protein, okay, called a secretory protein or secretory unit. Why? That's what protects it against degradation. Think about it. You got bacteria throughout your GI tract, yet IgA, a protein, is just hanging out like nothing's going on, just waiting for an infection to start up. Okay? IgA is protected against degradation because of this secretory component, but they love to ask you where it came from because the B cells don't make it. It comes directly from the mucosal surfaces, mucosal cells. They attach it to the IgA. Now IgA can swim around in your stomach with a pH of 1 to 2 and not be denatured, and go right next to bacteria and not be eaten. That secretory component allows it to live in the mucosal surfaces. IgA is the antibodies available in breast milk, but that's because it's secretion. But just don't forget. So that's the antibody, one of the antibodies transmitted by mom. As far as breast milk, it's the only antibody transmitted by mom through breast milk, IgA. IgA is seen in several diseases. Selective IgA deficiency runs with selective IgG2 deficiency 95% of the time. But I told you the clue, the best clue for it, Linda. How do you detect somebody who's got selective IgA deficiency besides mucosal infections? Let's see if Al remembers. Tara remembers? No, the key is they do get respiratory infections, but there's a lot of reasons for respiratory infections. The best clue, Jenny. The best clue, Ferdy. Tim? January. Selective IgA deficiency. Tina? A for anaphylaxis with any blood product transfusion. Remember, one of the 3 blood transfusion-related reactions. A for anaphylaxis. Don't forget that. All right, so IgA. Then another disease associated with it is heavy chain disease. Heavy chain disease, remember, IgA multiple myeloma of the bowel wall. That's the only way you're going to know it is on biopsy. You don't know it otherwise. There are other reasons more common for malabsorption, so that's why the malabsorption is not my clue. It's when they biopsy the bowel wall, then they show you IgA plasma cells everywhere. Then I know it's heavy chain disease. Okay? So IgA. All right? Then we got IgM. IgM, we said is, first of all, a surface marker. But when it's on the surface, Thomas, it's just a monomer. 1 FAB, 1 FC. When IgM is a surface marker, 1 FAB, 1 FC. But when it is secreted into the bloodstream, it's a pentamer. 5 FABs, 5 FCs. That's why we say he is the most avid, because he does everything 5 times more than anybody else. So IgM, 5 FABs, 5 FCs. And remember, each unit fixes 2 pieces of complement. So IgM eats up a lot of complement. IgM, surface marker is a monomer, secreted into the bloodstream is a pentamer. 5 FABs, 5 FCs, and 2 joiner chains, 2 J chains to hold it all together. Anything about avidity, pick IgM. Disease associated with it, too much IgM, we call it hyperviscosity syndrome, or Waldenstrom's. Waldenstrom's disease. Hyperviscosity. Why do we call it that? Because your IgM is so big it starts ripping up your blood vessels, which means you're going to die from what, Melanie? I said you start ripping up your blood vessels, which means you're going to die from what? So what would that be? Anytime you got a vascular problem, Manny, what are you going to die from? Yeah, heart failure. The coronaries are always the first to go. All right? That's why they name it hyperviscosity. Anytime you have viscosity like diabetes, polycythemia, they end up dying from heart failure first. It'll rip up the coronaries pretty easily. Okay? So IgM. Then you got Wiskott-Aldrich. Remember, they got IgA and IgE and can't seem to get back to M and G. Wiskott-Aldrich, give me a clue for that disease, Sakchai. Huh? No, that's Sturgey Weber. I'm on Wiskott-Aldrich. So B. Eczema. Remember, thrombocytopenia and infection. Thrombocytopenia, infections, eczema. They're also fair skinned, and it's X-linked, and then 10% risk for lymphomas. Again, the same 4 reasons. Class switch is messed up, IL-4, CD40 ligand, and tyrosine kinase. But they're stuck with A's and E's, but can't get back to M and G. Okay? All right, so IgM. Last one is IgG, gamma. IgG has 4 subtypes. IgG 1, 2, 3, 4. IgG has 4 subtypes. IgG 1, 2, 3, 4. IgG1 crosses the placenta the best. So, of course, you know they want you to know that one because that's what gives the baby his immunity. Without IgG1, the baby has 0 immunity. Okay? IgG1 crosses the placenta the best. And it's the FC portion that gives it that ability. That's another common question I see. If you do anything to damage FC portion, they'll ask you what's going to happen. Well, the baby will get no immunity then. Without that FC portion, cannot cross the placenta. Okay? So IgG. IgG 1, 2, 3, and 4. IgG2 is the most common subclass defect or deficiency. We talked about that before. Selective IgG2 deficiency runs with selective IgA deficiency 95% of the time. Why? Alpha and gamma are in the same gene. So if you're missing one, you're going to be missing the other one too. Well, what do I need to know about IgG? IgG, remember, is the second antibody to show up to primary response and the only antibody to show up for secondary response. Right, January? IgG. The second antibody to show up for primary response, remember, shows up in 2 weeks, peaks in 2 months, gone in a year. And then for memory, shows up in 3 days because IgM is not showing up, peaks in 5 years, gone in 10 years. Okay, IgG. Because he's the second one to show up, fixes complement on C2. Got to know that. IgG has the highest affinity. So remember, IgM had the avidity. Now, anytime there's a question about affinity, IgG has got to be your answer. Okay? IgG. All right? IgG4 does not fix complement. So you got one subclass that cannot fix complement. IgG4. IgG has a lot of diseases associated with it. As you grow older, folks, you got a lot of IgG in your bloodstream. I said about 90% of your antibody right now is IgG. IgG is the number 1 opsin in your body. What is an opsin? Something that coats encapsulated organisms. Remember that? IgG is your number 1 opsin, then IgM. That's because, again, 90% of your antibodies are IgG. So anytime you're deficient in IgG, encapsulated organisms become your worst enemies. And that's why Faisal knows these encapsulated organisms. The only gram-positive capsule. Faisal. No, Andre. The only gram positive with a capsule. There's only one on the left side of the page, man. Remember? Somewhere on the left side of Linda knows it. Strep pneumonia. It's the only gram positive with a capsule. And then we have 6 gram negatives with capsules. Eros. Some killers have pretty nice capsules. The S stands for Salmonella, Klebsiella. H stands for H influenza B. Make sure you pick the one with B after it. Pseudomonas. And Neisseria. And a C. Citrobacter. And Neisseria has the largest capsule. So if you're missing IgG, you're in trouble from a lot of capsule organisms, the most common of which obviously is strep pneumonia. That's right in the back of your throat. Okay? All right, so IgG. What if you have a defect in the FC portion of IgG? That could lead to what disease, Dahlia? No. You have a defect in the FC portion of IgG, Maria. That could lead to what disease? So let's try Elvis. Or the lead. Rheumatoid arthritis. Remember, that's the rheumatoid factor itself. And then you make IgM and IgG against it. Remember, rheumatoid is the most common arthritis in middle-aged females. Don't miss it. All right, so IgG plays a lot of roles. Well, next thing you need to know are the live vaccines. Live attenuated. Live attenuated. Why do I need to know this? If there's an immunocompromised patient in the household, you shouldn't give these. If the patient is immunocompromised, you should not give these. Does that make sense to everybody? See, even though it's attenuated, which means it's kind of weakened, but if you have zero immune response, then even that will hurt you. Okay? All right. So 9 live vaccines. MMR, that's 3 of them right there. BCG, oral polio, varicella, rotavirus, smallpox, yellow fever. Now, who should not get it? Again, immunocompromised, anybody in the family who's immunocompromised. So you got to ask, is anyone in the family have AIDS, cancer, or on chronic steroids? If the answer is yes to either one of those questions, you cannot give the vaccine. Remember I told you MMR, you shed live virus for 2 months. Oral polio sheds live virus for 2 weeks. We don't want outbreak of polio cases all across the country. That's the problem. All right, everybody clear about that? So like varicella, if somebody who's immunocompromised got exposed to varicella, you know, maybe little Tommy went to visit grandma, didn't know that he had it, and then next day he breaks out, right? Well, he's already exposed grandma. That's when you use varicella immunoglobulin. If somebody gets exposed to an infection, then you give varicella, then you give the immunoglobulin if it's available. The main one that we have right now is varicella. Okay? Rotavirus was taken off the market years ago because they had a high incidence of intussusception. Now they've mastered it and gotten it to be much more improved, and now it's back out. So now it's become a recommendation for children. I haven't seen the age range, though. Have you seen that, Tina? Anybody seen the age range for this? I haven't seen the age, when they're going to stop. I mean, it's supposed to be for all children, but I don't know when the cutoff is. But anyway, that's a new recommendation. It won't be on your boards anyhow, as far as I know anyway. All right, so rotavirus, intussusception. Yes? More than 7 days. Yeah, if you've been on more than 5 milligrams for more than 7 days, you've suppressed your own axis. As long as you don't get vaccinated any time in the next week, you're okay, Ajay. All right. But remember, as long as you stop under 7 days, you're okay. So live vaccines, folks, beware. All right, 2 vaccines are made in eggs. So some people have egg yolk anaphylaxis. You can't give them these. Egg yolk anaphylaxis, You cannot give them MMR or influenza vaccine. It means you just tell them to stay away from anybody who's ill during that part of the year. All right? Because it's better to do that than to give them a vaccine and they have anaphylaxis and die right there in your office. Okay? So MMR and influenza. Yellow fever. What do you think? Yellow fever. Somebody told me. I think it does. Somebody brought that up and I didn't know that. Huh? Fry an egg?
Yeah, so it's MMR, and then R is just flu and influenza, and Y is yellow fever.
Oh, okay. Yeah, somebody had brought this up and I had not had time to verify it. Yellow fever also in eggs. So we got 3 vaccines you can't give to somebody who has anaphylaxis. Now that's anaphylaxis. Not just I don't like my mama's eggs. That's not what we're talking about here. It means I blew up like a balloon, almost died last time they gave me that. Okay, good. You can't take it anymore. All right, so live vaccines. Interception, give me a clue. Faisal. Give me a clue. That means give me a classic one. Andre, give me a classic clue for interception. No, I'm saying give me a classic clue to know that a child has interception. Yeah, sausage-shaped mass around lower quadrant. That's the telescope. Current jelly stool appears like a stack of coins on a bare minimum. Don't forget your classic clues. All right, because all that other stuff is just too general to click and move. You can't click and move. Oh, I got tummy pain. Doesn't work. Okay, that means you got to read the whole vignette now. I like the words when I see it, I click and I move, I'm gone. Okay? All right. Interception, remember, is more common in ileum in children and sigmoid in adults. Vaccine changes at age 6. Yes. Yeah, now it's been approved. I was going to get to that after this change. Let me just do the changes first. Here are the main changes right now for vaccines at age 6. Big D becomes a little d. Why? Because the incidence of diphtheria is not that high anymore. Pertussis drops off the list. Why? Because the incidence is now 1 to 3%. And then HIP drops off the list. Why? Because the incidence drops back down to 1 to 3%. Remember, you only vaccinate when the risk is high in a vulnerable population. Which means what? It means, if you understood that whole vaccine record I've just given you, anytime somebody comes in, no vaccine record, or has lost a vaccine record, wherever they come in, folks, just start right there. That's the trick to the question. It makes you think you're supposed to change up somewhere. Nope. You know how many times I missed that question? Because I kept thinking you were supposed to do something different? No. If they come in anytime before age 6, just start wherever they come in and move forward. You don't have to change anything. They were just lucky they never picked up anything before. You don't have to go back and recover any of that. Especially under a year, they didn't have any memory anyways. So it doesn't matter. But the trick is to make it sound like there's supposed to be some change by asking you, well, how would you vary his vaccine? You don't have to under age 6. Here's where you start changing. Is at age 6, now you got to know the 3 changes. Okay? Now, that means anybody starting from age 6, let's say a migrant worker, homeless person comes in. Here's how I now figured out. Well, rather than DPT, all I need is a little d and a T because pertussis is falling off the map. You don't outgrow polio because that's just bad water. So I know I got to give them that one. Right? They're still under age 10. They need an MMR. They're still in a susceptible population. They're under age 10. They still need a pneumovax if they haven't had one. That's how you know what to give them. This way you don't just start guessing or just memorizing. You just got to remember the 3 changes. Just drop HIP, drop pertussis, drop the big D to a little d. There it is. That's what you need to give them. You give it to them when you first see them, repeat it 2 months later, and then repeat it 1 year later. Why? So we can jack you up, jack you up, jack you up. That way you got super, super high levels of antibodies because you never had resistance. So we got to really make you immune because you're the one now that's the, let's see, that's making yourself, oh, what's the word? You're putting the other children around you at risk now. That's why we have to jack up your immune system so high. Okay? Because if you don't do this, folks, they can't go back to school. Somebody who's lost their vaccine record, migrant workers, homeless, you can't get them into school unless you give them all of this when you first see them. And then they show that they got a 2-month appointment to get the next one. Because remember, the other children at risk, if they don't at least receive the first set, they won't even allow them into school. Manny. Yes.
Whenever we're reading something about, whenever the homeless person shows up in the community, we tend to think that they're, whether they're alcoholic or immunocompromised. Would you think that they are immunocompromised if we were to reach this? And
Now, an alcoholic, and the question is whether do we consider an alcoholic immunocompromised? In some ways, yes, but it's not the immunologically immunocompromised. So that means you can still give him his normal vaccines. The alcoholic is immunocompromised because of his hygiene. He eats, all he does is drink. He doesn't eat, and then he doesn't wash his hands. That's how Klebsiella from his colon ended up in his lungs. It's poor hygiene. All right, so it's not that his B cells don't work or his T cells doesn't work. Yeah, that's totally different. Everybody understand that? That's a very good question. All right, so that's the vaccine change at age 6. Isotype again, antibody class, gamma. We call an identical twin spare parts because they can always give you a lung, a part of the liver, kidney, just whatever you need. So where are some siblings going and borrow a pair of shoes? You show him you want to borrow his kidney. But hey, what can you do? That's nice. But when it's twin to twin, we don't have to worry about any HLA problems. It's 100% matching. Okay? Allografts. 2 members of the same species. That's human to human. That's why we do, liver, kidney, lung, pancreas, heart transplants. Well, with all allografts we do in America, what do you think is the most common allograft that we do? So, dude. What do you think, Dan? It's called blood. Most students and most physicians don't remember that blood is a tissue. Okay? So we got to do type and cross. That means you got to treat it like a tissue. Blood is the most common allograft. Now, I had a student call me from another, she was doing a surgery rotation, and she called me because she got a residency with this piece of information. Just this piece of information, man. When you shock and attending, they're just so impressed that your mind works just right. They had just come out of a transplant, I think a liver transplant. That's like 10, 12 hours of surgery. And so the surgeon asked, there was a senior resident and 2 junior residents. And he just said, well, with all the allografts that we do in America, what do you think is the most common allograft? And of course, the senior resident thought, oh, since we just did a liver, maybe it's got to be liver. So he said, liver. He said, well, let's see. What do you think? He asked the 2 junior residents. He said, no, we think it's kidney. So both of them picked kidney. And so here's a student that just came from the FAST program. And he said, well, what do you think? To the student. From what I read and understand, broke it down, man. And the attending was shocked that she knew it better than the senior resident, 2 junior residents didn't know the information. They were just guessing. She heard allo. Okay, tissue. Blood is the most common tissue that we transplant all the time. The one tissue that we don't have time to run all the tests on before we transplant it is the heart. They love to ask you, why do heart transplants fail so much? You ain't got time to be running all these tests. We're going to talk about it, but you don't have time to be running them. Because you got to fly that heart to wherever the matched recipient is and transplant it as quickly as possible. So you don't have time to do the overnight stuff that we do. Okay? But that's why there's about 50% rejection rate. That's just sky high. Okay? But they still, the ones who live, live. All right, so allografts. Autograft is self-to-self. That would be like skin grafts, right? Coronary artery bypass grafting, taking your own veins, put it in your heart, right? Don't forget to flip it upside down. You guys do remember your veins have one-way valves, right? Okay. When you pick the answer, make sure you pick the answer. It said take the vein and flip it upside down before you sew it in. Otherwise, the valves won't let the blood come through. All right, so autograph, self to self. Anyway, the reason for going through this is because they'll ask you samples of each. That's why I'm giving you the samples that you like. Okay? So for iso, twin. For allo, blood. I mean, there's plenty of organs there. For auto, skin and blood, veins are the best ones that they like. Xeno, it'd be like when we used to transplant baboon hearts. Baboon hearts. Well, you can see why it didn't take very well. They lived for the first couple of days, and they were paraded on CNN. Look at that. They're still alive. Yeehaw. Yeah, they were both dead within 2 weeks. Can anybody tell me what they died from? Jenny. So what did they die from? No. Ferdy, what do you think they died from? Nope. What do you think they died from, Kimberly? Graft versus host? Nope. Maria, what do you think they died from? Nope, not renal failure. Who thinks they know what they died from? Tina? CMV followed by what? Thank you very much. Do you know how much prednisone and cyclosporin you have to put that patient on to be able to take an organ from a strange genetic animal? Come on, your body wants to attack that so bad, it attacks it in no time flat. Before you got no resistance. CMV is already swimming around your blood. Boom, dead in no time flat. Okay? Man. That means, Tara, because we give cyclosporin and prednisone to every transplant patient, what's the most common cause of death after a renal transplant? CMV followed by. Most common cause of death after a heart transplant? CMV followed by. What's the most common cause of death after a lung transplant? Followed by. Can it be so simple? Yeah. When you break it down, baby. You see? Now you can go read all the transplant literature. Help yourself. I'm clicking and moving. While you're busy looking it up. The concept tells me the answer. You don't have to keep looking it up. As long as you see that connection, it's like, oh my, you got to be kidding me. Look it up in the book, same stuff. Look it up in another book, same stuff. And nobody ever told you that was a real connection. Leukocytes are white cells. Leukocyte cells. So you put it together, and what do you get? Leukocytes. Shoot when you see the whites of their eyes, man. Let's look what they do. All right? There's a mnemonic that says, when you look at the leukocytes, I'll get to the mnemonic in a second. Leukocytes, normal white count. Always got to know normal before we start talking about other things. Normal is 4 to 12,000. That means as long as between 4 and 12,000, we say that's normal leukocyte count. Under 4,000, we say you are penic, leukopenic. Above 12,000, we say leukocytosis. Osis means too many. When it's extremely too many, that means at least 2 standard deviations above normal, then we say emia. And that's why they say leukemia. See that? So the word leukemia tells me you got a white count at least 2 standard deviations above normal. Definition, folks. Because these are words they got to use in the doggone vignette, man. But if you know what they mean, they're literally telling you the answer. Okay, so that means if I see a white count of 20,000, I say, they're going to probably feel leukemia because this is more than 2 standard deviations. Okay, this way you don't say, oh, it's an infection. Probably not. Probably not. Okay, so normal, 4 to 12,000. Under 4,000, leukopenia. Now, anytime you do somebody's white count, you check it in their veins. What you are measuring is only 10% of the total circulating white cells. The other 90%, folks, are actually marginated. They're not circulating, which means they're stuck to the sides of the vascular endothelium. They're stuck to your arteries. They're stuck to your veins. And they just hang out, literally just chill, just waiting for something to happen and then be called to action. Well, of the 90% that are marginated, 95% are mature neutrophils. Why do I want them to be mature neutrophils? Because they're your first line of defense, Andre. So that means when I need them for an infection, I want them to be mature and ready to go. All right, neutrophils will eat anything in sight. Okay? The other 5% or less than 5% are blasts. So it is normal to see less than 5% blast in somebody's peripheral smear. But anything more than that, then there's a problem. So again, Your white count represents only 10% of circulating white cells. The other 90% are marginated. Well, how do I get them to demarginate? You need two hormones, epinephrine or cortisol. Remember the two stress hormones. Epinephrine and cortisol can demarginate them and call them into action. So that means anytime I see a whole lot of neutrophils suddenly show up in circulation, I can truly say you are under stress. Now, a lot of students, a lot of residents, a lot of physicians immediately run to, oh, you got an infection. Oh, I don't know about that. Be careful, folks, because that's usually not the answer. That's a trap. I'm going to show you how to use somebody's white count to figure out exactly what they came in for. Okay? So demargination, epinephrine, and cortisol. That means, Maria, if I want to elevate your white count right now, how do I do it? How do I increase your epinephrine or cortisol, Maria? I put you into stress. How do I put you into stress? Just ask you a question. That's correct. All you got to do is just ask somebody a hard question. As soon as the stress comes out, white count goes up automatically. On the boards, they'll give you somebody who's on chronic steroids. Remember, that's a form of cortisol. Someone who just got finished with epinephrine after anaphylaxis. What's his white count going to be like? See that? They want to see if you know this connection. Anytime you elevate my epinephrine or my cortisol, I will have an elevated white count. I will have an elevated white count automatically. Okay? Now, that means you demarginate them and call them to action. So let's say I got neutrophils in my feet, but I got cut in my hand. I need them up here. So boom, cortisol and epinephrine tell them, hey, there's inflammation going on. Well, neutrophils say, all right, we'll get right to it. And they all start running. And they say, hey, man, where are we going? I don't know. Where are you going? I don't know. I'm just following the crowd. Okay, well, just follow them. How do we know when to stop? They have no idea when to stop unless you give them the signal. When they get to the area of inflammation, there's a bunch of proteins that popped up. That means if you cut your finger, cut your hand, whatever, first group of proteins that pop up are called selectrins. Selectrins select them out of circulation. That's how I know it. So here's the white cell floating overhead, and all of a sudden the protein pops up and grabs them. Come down here. That means inflammation is here. Okay? So selectrins select them out of circulation. Integrins integrate, anchor them to the endothelium. The main one I want you to know, remember, is ICAM1. That's the one that's written in all your books. That's just for integrating the cell onto the endothelium, so anchoring it. Okay? Adhesion. That whole two-step, selecting and integrating, is called pavementing. That just means moving towards the pavement. After they get to the endothelium, they flatten out. That's called margination. They flatten out, so we call that margination. After they flatten out, they start walking. That's called diapedesis. It's just a little slinky motion of the membrane, just kind of sliding along like this. Anytime the membrane moves, what do you need to get adequate membrane movement? Nicole. We talked about membranes before. Membrane movement requires what? Josh? What's that? No, that's what's within the membrane. Membrane movement for action. Remember, calcium, ATP, microtubules. Remember we talked about that endocytosis, phagocytosis? You got to have all three in order to move the membrane around. All right, so that's diapedesis. And then all they're looking for is a crack in the endothelial cells. Remember I just said you cut your finger, right? See that? There's going to be a cut. That means there's going to be a hole. And the white cells will just slide into the tissue that way. That's how they know where the inflammation is going on. And neutrophils are non-specific phagocytes. They'll just start cleaning up everything. But that's good because you have no idea what's going to enter your bloodstream when you cut a skin. Could be bacteria, could be a virus, could be a fungus stuck to your hand. You have no idea. And that's why neutrophils are non-specific. They will eat up anything they see that should not be in the body. Everybody understand me so far? All right. So demargination, pavementing, margination, diapedesis, migration. The 5 steps. Any questions about this? Jessica. Selectrins, pull them out of circulation. So I always think about it, select them out of circulation. Okay? And then integrins, integrate. So allow them to adhere to the endothelium. Leukopenia, the most common cause of erythema, folks, just so we get it all done right now. The most common cause of erythema, Danielle, is an acute viral infection. A virus can pick any cell line and wipe it out in your bone marrow, or pick all the cell lines and wipe it out in your bone marrow. Just like we've talked about drugs that can cause agranulocytosis. They can just pick your white cells and wipe them out, leave everybody else alone. Okay? So, viral infection number 1, drugs number 2. For any cell line, erythema, same 2 answers. Virus first, drug second. So viruses that suppress the white cells or the whole bone marrow if they want to, number 1 is parvovirus B19. Number 1, parvovirus B19 can wipe out the entire bone marrow, causing aplastic anemia, or it can just wipe out one cell line. Hepatitis E can do it, Joseph, primarily in pregnant women. Primarily in pregnant women. Hepatitis E. And then occasionally hepatitis C. And that would be in somebody who's had blood transfusions. Then I would pick that one. Okay? So viruses suppress. What about drugs that suppress the bone marrow? We listed them off earlier. The 4 drugs that can wipe out your entire bone marrow. Vinblastine, AZT, chloramphenicol, benzene. Wipe out the whole bone marrow. Vinblastine blocks what, Diana? Let's see if Manny remembers. Joseph, vinblastine blocks what? How does it work? Frank, vinblastine blocks what? Monica. Vinblastine, Mustafa. Microtubules. Vincristine, vinblastine, and paclitaxel. That's right. Slap yourself in the head, Frank. Because he knew the answer. He was just too scared to say. I'm telling you, folks, whenever you're not sure, just spit out the first thing that pops in your head. It's usually right. But you guys are so afraid to be wrong, you make yourself wrong. All right, so be careful. Drugs that cause agranulocytosis. We've talked about them. Carbamazepine, first line drug for what type of seizure? Tim? No, not tonic-clonic. Temporal lobe or psychomotor seizures. Carbamazepine, first line drug for what kind of neuropathy? Faisal? Shooting neuropathy. Okay? Carbamazepine. But it also causes SIADH, along with agranulocytosis. Ticlopidine is an antiplatelet drug. It blocks ADP receptors of the platelets. But 2 other drugs block ADP receptors too. Melanie, what are they? Clopidogrel and dipyridamole. Antiplatelet drugs. We've talked about them. Ticlopidine, clopidogrel, and dipyridamole block the ADP receptors so that they have no energy to clump. Remember, it's second line for someone who cannot tolerate aspirin. First line. Okay? Ticlopidine, however, causes agranulocytosis and seizures. Then we talk about clozapine. Clozapine blocks what receptors? Penish. D4. Remember, atypical antipsychotics. Primarily for negative symptoms. Social withdrawal, catatonia, that kind of thing. Poverty of speech. But clozapine also causes agranulocytosis and seizures. Okay? What about the other side? Too many. If you have a high white count, Joseph, 5 reasons to have it. Maybe it's just stress. Now that you understand what stress demargination is. Because if I got a white count of 10,000, that means I got another 90,000 that's marginated. Remember, it's only represents 10%. If I got a white count of 5,000, there's another 45,000 that's marginated. Everybody follow that? Okay. So stress demargination just tells me your neutrophils have been called into action, but you don't know why. Number 2 is infections. Number 3 is leukemoid reaction. It means it looks like it's leukemia, but it really isn't. Number 4 is leukemia. And then number 5, myelodysplasia. That means the entire bone marrow is involved. So now I'm going to go about showing you how to organize these 5 causes of a high white count by looking at it this way. If you have a high white count and you turns out to be almost all neutrophils, that's how you know it's stress demargination. It means the stress just happened. First line of defense, the neutrophils, when do they show up to inflammation? Elvis. When do they show up to inflammation? Before 24 or at 24, Elvis? At 24. Make sure you say at, because anything less than 24 would be wrong. Now remember, it's only swelling for the first 24 hours. Neutrophils show up at 24, peak at day, Nicole? Peak at day 3. Okay? So, stress demargination. First 3 days when somebody comes to the hospital, I don't know why they're there. Not by looking at white count anyway. Everybody understand me? Alright. How do I know you got infection? If the white count is high and I see bands. What are bands? Danielle wants to know. Bands are immature neutrophils with maximum germ killing ability. Not maximum clean up an MI ability. Not maximum clean up a seizure ability. Maximum germ killing ability. So that means if I see bands, now I know for sure you have a germ in your system. Everybody follow that? But do I know what germ? The answer is no. But at least I know it's a germ in your system. Does everybody understand? You can't say, oh, it's a stress demargination. Bands don't marginate, so how can you call it stress demargination? Okay? You can't call it leukemia. There are no bands in leukemia. That's my point. I like the specific stuff. So that means if I see bands, okay, I know for sure I got to pick an infection off this list. Okay? Yes. Are immature neutrophils with maximum germ-killing ability. All right? How do I know it's a leukemoid reaction? When the white count is high, and I see that you have demarginated everybody, even the less than 5% blasts that are marginated. It means you've demarginated the other 95% of neutrophils. For me to see this less than 5% who shouldn't be circulating, it means you demarginated the other 95%. And this was the only guys who were left. Your body just said, hey, you guys got to come out and fight too. Okay? Remember, your 90% is marginated, is 95% mature neutrophils, less than 5% blasts. So if I'm seeing them all in circulation, then that means your body had an extreme demargination so that everybody was called to action. Does everybody understand that? That's the important one. That's why I'm highlighting it. The neutrophil is sky high. Okay? But what tells me the answer is the blast, not the high neutrophils. Okay? Yes. Less than 5% blast. Remember, less than 5% blast is still normal. More than 5% blast, abnormal. So that wouldn't be a leukemoid reaction anymore. Now, the reason why they call it leukemoid phasal is because, let's say your white count is 10,000, and then you demarginate the other 90%. That means now your white count just went up to 100,000 in just a few minutes. You follow me? That's why it looks like you got leukemia. So that's why they call it leukemoid, which just means leukemia-like. Okay? Because you're well above 2 standard deviations, way above. So that means anytime I see a leukemoid reaction, phasal, it means you had an extreme demargination. That means something extremely stressful to the body did this to you. What would be extremely stressful to your body, Danielle? What kind of trauma? Like a head-on collision. Man, if you ever do trauma rotation, man, that's where I saw a ton of this. When that head-on collision, in that fraction of a second, when you see somebody about to plow into you, and you're afraid you're about to die right then and there, if that doesn't demarginate everybody, I don't know what does. Okay, you will see a ton of leukemia reaction in the ER in car accident victims. You got another one for me, Monica? Sure. ICU is pretty stressful. All right. Cammy? If she didn't want it, that can be pretty stressful. The labor process. Okay? So we can get a leukemia when she finds out she's pregnant, she didn't want it. Or she wanted it and now she feels the pain of labor and she's not sure she wants to go through all of this. Give me some morphine, doc. Give me some morphine, quick. You should see him just start calling for some drugs, but all right. So yes, it can happen. Another place I saw was like dissection of the aorta. Oh man, when you feel your aorta ripping, that scares the heck out of you. Or 10/10 chest pain for an MI, you swear you're about to die. So that's why they demarginate like crazy. Okay? All right, so leukomoid reaction, another clue to it, they have increased leukocyte alkaline phosphatase, LAP scores. LAP, Andre, comes out of those blasts. So even though the books only mention LAP with this, folks, LAP is not specific for leukomoid. It's specific for what's on this list. I mean, differentiate these 5, but you can see it in other diseases. All right, how do I know you got a leukemia? And this is only an acute leukemia. Is when I see your white count is high and you have more than 5% blast. And to make it easy on exam, they usually have like 25, 30, 35% blast. The problem is, and the reason why we're going through this organization is, they give a patient with a high white count and 17% blast. And I hear a student discussing maybe it's HIV. Then I'm starting to hear about all these other infections. I'm saying there's no way that's what they want you to think with 17% blast. That's why, again, I want you to organize your thoughts. And this is real simple when you go to the wards, folks, and you pick up a CBC from somebody. Guess what? Read the CBC. You should be able to tell me why they're here. You should be able to tell me why they're here, if you understand immunology. Okay? All right. So leukemia, acute leukemia is when they have more than 5% blast. How do I know it's lymphoma? It's got nothing to do with high white count. First of all, is when they biopsy a lymph node. Again, I see them biopsy a lymph node. A student wants to diagnose an infection. I said, when's the last time you biopsied a lymph node to diagnose an infection? That's not what we do. That's what I'm saying. You would get a rare point out of it. I wouldn't do that. All right, so I say, what's the number one reason why we biopsy lymph nodes? We're looking for cancer. Okay, what's the number one cancer lymph node? Lymphoma. All of a sudden, one answer pops right off the screen like that. And you would have seen it. If you process the information, folks, if you look at the whole list and start guessing, you won't see it anymore. Then it looks real hard. That's because you're looking at all these other things that are not lymphomas. Okay? How do I know it's myelodysplasia? The entire bone marrow is involved. It can be high or low, but they're all involved. So this is how we separate them. Now I'm going to show you how to master getting it right like this. Any questions on this so far? Al?
You said blasts are typically less than 5%.
Yes. In a normal person.
What about bands? You said it's high in infection, but what's the normal band?
Normal is less than 1% bands. So anything higher than 1%, that's more bands. And I'm glad you brought up that point. Bands, a lot of times they'll say left shift. Rather than saying there's a lot of bands, they say, oh, you have a left shift. Same thing. Bands are immature neutrophils, so remember, everything immature starts off on the left and then matures as you go to the right. That's what they're talking about. Left shift means you've gone to bands. Okay? Good question. Yeah, blasts are not even mature enough to do anything for you. Right. That's the less than 5% that were marginated who were never supposed to be in circulation. And you call them to action. It means you needed everybody. But if you see more than that, that means even your bone marrow is pushing them out. That's a leukemia, an acute leukemia. Dan. Oh, you mean the white count? When the stressor goes away? Oh, it can be within minutes, yeah. Like somebody who's got a leukemia reaction because of a head-on collision, it's high when you first bring them in the emergency room, but the next day the thing is like half the white cells are gone now. They go back to margination again. Okay, it's just that traumatic moment when you shake them all off the end of the tree. Who had their hand up? Jenny. What is the value of what? Oh, normal's up to like 12,000, so it's like, I would say about 4,000 for each one. So, up to 16 is one, up to 20, that's how I know. That's 2 standard deviations, you're above it now. All right, so white count. Leukomoid reaction means extreme demargination. That means you got extreme stress. That means you can't pick something minor. You can't say, oh, he's got a cold. That won't do it. All right, and then increased LAP gives it away too. Leukemia is a cancer, so all that stuff you learn about cancer applies. Signs and symptoms we already know. Cause of death we already know. It involves B cells, so we even know what type of infection you're going to die from. We even know what organs you're going to get those infections. All done. Okay, leukemia. Lymphomas, cancer of the lymph nodes. So everything about cancer applies. No, nothing different. We know you're going to die from infection. And because these are mostly B cells, we even know what type of infection you're going to die from. We even know what organs you're going to get those infections in. Okay, lymphomas. And then myelodysplastic syndromes means the entire bone marrow is involved, so that all cell lines are now involved. Now I'm going to show you how to start separating them out. So let's say I'm going to use Cammie, and I'm going to use Tatiana. All right, Cammie, you're ALL. Tatiana, you're AML. I'm going to show you how to figure this stuff out without even reading the book. All right? ALL. Now, if you use the word acute, acute means the cancer started in the bone marrow. If you use the word acute, it means it's starting in the bone marrow. That explains why they have bone pain, bony destruction. See that? And then the next letter tells you which cells are cancerous. So an ALL is the lymphoblast, and AML is the myeloblast. So acute tells me it's starting in the bone marrow. The second letter tells me which cells are the cancer. Okay? So lymphoblasts are supposed to be lymphocytes. What percentage of lymphocytes are B cells? I told you it's 98%. T lymphocytes, 2. So that means ALL is 98% B cell, 2% T cell. Everybody follow me? Everybody follow me so far? All right. AML. Myeloblasts are supposed to give rise to neutrophils, monocytes, and macrophages. Myeloblasts are supposed to give rise to neutrophils, monocytes, and macrophages. But if they're stuck in the myeloblastic phase, they can't go on. That means you won't get the other 3 then. You understand, Tatiana? You understand, Cammie? All right. Now, whichever cell is cancerous in the bone marrow, it'll start destroying all the other ones because there's only a certain amount of space within the bone marrow. So it's going to crush the other ones just by taking up room. You understand? All right? So we got acute lymphoblastic leukemia, Tatiana. ALL. Acute means you started where? The cancer started where? Bone marrow. So that explains bone pain. Well, if you got acute in the bone marrow, then it says lymphoblastic. What cells are cancerous? The lymphoblasts, who are supposed to give rise to lymphocytes. What percentage of lymphocytes are B cells? 98. What percentage are T cells? 2%. So that's the ratio. Breakdown. You understand? Well, if the lymphoblasts are cancers, they're taking up all the room in the bone marrow. Do you understand? So that means what's going to happen to your neutrophil count? Decreased. What's going to happen to your red cell count? Decreased. What's going to happen to your platelet count? Huh? Decreased. Everybody following? You're just crushing whatever's in the way. What funny looking RBCs you're going to see in a peripheral smear if you got somebody pushing things around in the bone marrow? Now shit is nice. Teardrop cells. Remember, they get squeezed out, look like a Hershey's Kiss now. Teardrop cells. Okay? If you're missing your platelets, Tatiana, where you going to start bleeding from? What? I didn't hear you. Where are you going to start bleeding from when you have a platelet problem? Skin and mucosal surfaces. What's going to be elevated? PT, PTT, or bleeding time? Platelet function, Tatiana. Bleeding time. So that means, according to Tatiana, if you're listening well, they're going to have bone pain, bony destruction. They're going to have neutropenia, anemia, and thrombocytopenia. They're going to have teardrop cells in peripheral smear. Because they're anemic, cancer, low energy state, explains all the signs and symptoms, infections, complications, and cause of death. They're going to have primarily bacterial infections. And if they ask you for bacteria, strep pneumonia, E. coli. They ask you for organs, you say pulmonary, UTI. Uh-oh, I think that's all of ALL right there. Everything you always want to know. We didn't even open up a page. Wait a minute, Cammie. What about AML? It says it starts with acute. Where did cancer start? In the bone marrow, bone pain, bone destruction. So we got myeloblasts that are cancerous, which means they're going to crush everybody else. What funny looking RBCs? You're going to see the peripheral smear? Teardrop cells. What's going to happen to your neutrophil count? Decrease. What about your monocyte count? Decrease. What about your macrophage count? Decreased. What about your platelet count? Decreased. What about your RBC count? Decreased. Oh, wait a minute. Tatiana told me that her patient, ALL, is going to present with bony pain, neutropenia, thrombocytopenia, anemia, teardrop cells, and a peripheral smear. Cammie just told me the exact same thing. That ALL and AML are going to present exactly the same way. You got the same platelet problem, bleeding from skin mucosal surfaces, increased bleeding time. There's absolutely no difference in the two in presentation. Question for you, however, Eros. If ALL and AML show up to your office at the same time and you can't separate them out, how are you going to know which one it is? All you have to do is ask yourself, Eros, where did this problem start? Let's try with Chikuma. Where did the problem start? In the bone marrow. That's how I know that bone marrow biopsy is the first thing you do when somebody comes in with acute leukemia. Because they sure look alike when they show up. You can't tell them apart by a history or physical exam, folks. Amazing. Amazing. That's how, again, you got to understand something if you understand the management. You do a bone marrow biopsy first because I got to separate them out. They look exactly alike. Why am I doing a bone marrow biopsy? Because when I look at ALL, you'll notice the lymphoblasts stain positive for TDT, terminal deoxythymidine. Now I know it's a lymphoblastic leukemia. The lymphoblasts are PAS positive. PAS stains a little pocket of fat right above the nucleus. So we know lymphoblasts have it, myeloblasts don't. So if they say PAS positive, then you know it's lymphoblasts. And then you check for an antigen called CALA. This is one of the questions where I call it hide in plain sight. They'll say, which of following leukemias is CALA positive? And students don't know that means common ALL antigen. See? The brain can either see a detail or see meaning. All right, so CALA positive is ALL, automatic, is right in its name. But more than that, for boards 2 and 3, they love to ask, what does it mean to be CALA positive? It means good response to chemotherapy. It's a good prognostic factor to be CALA positive. Good response to chemotherapy. And in fact, Cammie, poor Tatiana's got ALL, and she's looking to you for help. She really wants help with this leukemia. What class of chemo drugs would you use to treat her? Anti-metabolized. Why? Because it's still rapidly dividing. And they put 5 of them in front of you. Which one are you going to pick, Cammie? Just a little methotrexate. Look up the treatment for ALL. See if you don't see methotrexate, you don't let it. Oh, baby. Keep telling you guys, man. Concepts don't change. I think right now they're using methotrexate and prednisone. Because remember, steroids kill off T cells too. So, it's amazing. Once you understand the concept, you can answer a lot of questions about stuff you never read about. All right, so that's ALL. Also good prognosis if you get it between the age of 1 and 10. They don't respond well to chemo under age 1 and after age 10. Okay, so CALA positive or the age can tell you good prognosis or bad prognosis. What about AML? AML, you can stain it for hour rods. Or they might even show it to you. Here's the myeloblast. big nucleus, and then you see the rods over in the one side like that. So they might show you the picture instead. Our rods are always off to one side. Those our rods will stain positive with Sudan black. So they might mention that instead. Okay, so AML. Terminal deoxythymidine. Now, Al, before I answer your question, which one of these two leukemias do you think would have the worst prognosis, more severe prognosis? ALL or AML?
The worst?
Yeah, between these two.
I would think that the worst one would be ALL.
Why ALL, Al?
Because there's a lot of other things out there other than bacteria to take you out. Like everybody has not, lots of people have CMV and EBV.
All right, so you're going by lymphoblast, lymphocyte route?
That's not the way to go.
Well, it could be, except they're 98% B lymphoblasts. They're missing their B. That's humoral.
ALL is missing the B?
Yeah, the lymphoblasts that are having trouble are the B lymphoblasts, primarily. Oh, okay. So which one has a more severe prognosis here?
Well, now I'm going to go with AML.
No, he's going to go with AML. Now explain it to me.
Because we don't have any of the neutrophils and the monocytes and macrophages.
That means you just shut down both arms. Bam. Everybody see that? Myeloblast gives rise to neutrophils, monocytes, and macrophages. Isn't that what I said? So if you're stuck in a myeloblastic phase, can you get a neutrophil? No. Can you get a monocyte? No. Can you get a macrophage? No. You just shut down both arms of the immune system. AML has the worst prognosis because of that. That means we can figure that out as well. Okay? And as a rule, cancer is more common in men under age 30 and after age 50. Cancer is more common in males under age 30 and after age 50. I forgot to point that out when we were doing our cancer profile. It was written, but I didn't point it out then. All right, under age 30, more common in males. After age 50, more common in males. Cancer is more common in women only between the age of 30 and 50. That's it. You understand, Michelle? Okay. All right, so that means now we go to CML.
Dr. Fred, you mentioned something about percentages in ALL. I missed that. Percentages
Of lymphocytes, 98% lymphocytes are B cells. So that means 98% of leukemias are lymphoblast B cells. Okay? So that's how you know they're going to die primarily of bacterial infections. Okay? AML will die from anything because he has nothing on either side. He has no neutrophils or processed humoral. He doesn't have monocytes and macrophages processed cell mediated. Yes?
When you say worse, you're saying with no treatment? Like
Yeah, that's without treatment. Yeah. Yeah, even with treatment, they'll still die first. That just matures it. It just prolongs their life. Doesn't mean they're going to live as long as the other ones, though. There's a difference. It lives longer, but it's not as long as the other ones. Yeah, still has the worst prognosis. Cammie. Okay, January. Okay, Cammie. Right. When you take a look at a population of lymphocytes, for every 100 lymphocytes, 98 are B cells, 2 are T's. But the B cells don't work. These are lymphoblasts. They're stuck in the immature stage. They never mature to work, to do anything for you. Yeah. So they're B cells that can't do a thing for you. January.
I have a lot of lymphoblasts in the ALL, right? But then my neutrophils will decrease too.
Right. Because you're just crushing them. Yeah.
But I still have some.
Yeah, they'll have some. But here, AML, they'll have close to zero. Yeah. Because they never matured to even become a neutrophil or a monocyte or a macrophage. So you literally have no immune system on either side. Okay? All right. Just a case in point, I had a guy that was here for the program. In fact, his mom was here at that time. And he got a call that his father was just real sick in the hospital. Came in just in shock, in septic shock. And I asked him, was your father sick before? He said, no, he's been a healthy man all this time. I said, no, that means the only way a healthy man becomes deathly ill like that is he's got immunodeficiency. That means there's something wrong that you didn't know about. So I asked him, have him fax the CBC over to me. Fax over the CBC. And what did I see? Myeloblasts everywhere. I said, your father's got AML. I said, pack up, go see your father. He doesn't have long to live. The man was dead by the end of the week. He was dead by the end of the week. Now imagine if he didn't know that, if nobody told him. This is the worst prognosis, man. Rush, go see your father right now. Then you know how much guilt that is? If you say, well, okay, we'll wait till the doctors work on him a little bit. No, you wouldn't have never seen your dad then. All right? So that's why, again, my job is just to show you how to figure things out on your own. I'm not into numbers. Oh, this number versus that number. It's just, I want to know more or less, that kind of thing. That way, anytime I ask you a question, you know how to make your decision. Okay? CML. Michelle will be CML. And Kathia, you'll be CLL. If you use the word chronic, it means it started out in the periphery. Remember acute, man, it started in the bone marrow. Right, Nicole? Chronic means it started out in the periphery. That means they left the bone marrow, got out to the periphery somewhere, and now they became cancers and started dividing. So that means you don't see that much bone pain, that much bony destruction. You won't see the teardrop cells anymore. Everybody follow me? Now we go out to the periphery. Okay, so Michelle, you're CML. That says chronic myelocytic. That means these are mature myelocytes before they started becoming cancer. Do you understand? All right, so that means if myelocytes are supposed to give rise to what three cell lines again? Neutrophils, monocytes, and macrophages. That means in CML, Michelle, what's going to happen to your neutrophil count? It's going to be increased. The only leukemia with high neutrophil count. What's going to happen to your monocyte count, Michelle? Increased. The only leukemia with high monocyte count. On this list, anyway. What happened to your macrophages? Increased. Folks, any one of those three labs will get me the answer. I'm clicking and moving. It's the only one that's going to have all those things elevated. The other ones, all those lines will be low. Well, Michelle, let's say you're a macrophage just strolling around in the blood. What are we going to call you? A monocyte. Then you crawl into the brain. What are we going to call you? Microglia. Crawl into the lung. What are we going to call you? Type 1 pneumocytes. Crawl into the liver. What are we going to call you? Kupffer cells. Crawl into the spleen. What are we going to call you? Yeah, R-E-S. R-E-S. Crawl into a lymph node. What are we going to call you? Dendritic cells. Crawl into a kidney. What are we going to call you? Mesangial. Crawl into Peyer's patches. What are we going to call you? M cells. Crawl into bone. What are we going to call you? Osteoclast. And crawl into connective tissue. What are we going to call you? Giant cells. Epithelioid and histiocytes. What if you crawl into the skin? What are we going to call you now? Langerhans cells. So in other words, whenever you have CML, you have mature cells. That means they actually matured to become a macrophage first and then started to become cancer. Everybody understand that? That means wherever a macrophage can go, there you will find CML. Guess which leukemia presents as a skin rash? With meningitis, pneumonitis, hepatosplenomegaly, enlarged lymph nodes, renal involvement, bony involvement. Check out where Robert's got that information from. Check out where Harrison's got that information from. It's better if you understand it yourself. No, so you don't have to read Robert's and Harrison's. You can figure it out on your own. I'm telling you, man, all you got to do is understand the basics, and you can figure out a ton of stuff. I remember this one that helped me big time because this was after I met Dr. Shaw, right? So now things are clicking for me. So, I had a hematology rotation. And sure enough, a lot of these stuff I'm teaching, the attending was just grilling me on it, man. I was racking up points, but I was wearing her out. Wearing her out! Because I remember she asked me this one. She said, which leukemia is going to present as meningitis? Because we had a kid present with meningitis. It turned out leukemia. She said, which one is it? Well, I had to break it down a little bit. From what I read and understand, doctor, I just saw, what the connection really was. It's not just let's memorize which one comes from meningitis. I taught her where it came from. And that's how you gain a lot of points and a lot of respect from the attending. That way it's not just, yeah, here it is. No, I said, no, let me teach you where it actually came from. That way they understand, oh my God, you actually understand this, versus you just memorize it like they did. Okay? So CML, skin rash. So everywhere macrophage goes, we'll be involved. Okay? CML. CLL! Who was my other person? I forgot. Was it Kathia? Yeah, Kathia, CLL. Chronic, where did it start? In the periphery. So the same old thing. No bony involvement, no bone pain, no bony destruction, no teardrop cells, right? Then it says lymphocytic. That means those are actually mature lymphocytes before they started dividing rapidly. Now, where do lymphocytes mature? Where are they going to mature? Kathia. Everybody starts out of bone marrow. Up until puberty, they like to go to thymus to mature. However, by puberty, your thymus is shrunk away to nothing. Then they go to lymph nodes. Since this is chronic, mature, older person, where's it going to be? Lymph nodes. CLL presents as diffuse lymphadenopathy 90% of the time. Boy, I wonder how they got that one. That's all it is. This is usually older people. There's no thymus at this age. All right? So CML, CLL. Another marker for CML, remember, translocation 922, also known as your Philadelphia chromosome. CLL doesn't have any markers. Now, look at the age. ALL, 0 to 15. AML, 15 to 30. CML, 30 to 50. CLL, greater than 50. That means, man, you just give me the age of the patient, I'll tell you which leukemia they got. That means if I don't understand the vignette, I'm not going to start guessing. The age will tell me the answer too. They always tell you the age of the patient before they start going on and on. It's only if you're organized, you'll see. That age is a big clue when you're talking about leukemias. Now, Michelle, which leukemia is more common in women? I think, I don't see you looking at the chart. That's how I know you're guessing.
CML.
How do you know it's CML? Okay. That's how you do it. Don't be guessing. No more guessing. Once you learn the patterns, use them. Yeah, so that's how I know ALL more common in boys, AML more common in men, CML more common in women, CLL more common in men. That means we know almost everything about these diseases without ever reading a book. Okay? That's why I don't do these under a neoplasm lecture, because I realize this is really immunological cancer. I said, let me do it under immuno. It'd be a lot easier for students to understand it. And it worked. Yes, Diana. Yeah, remember, after age 50, under age 30, more common in males. So CLL will just be an old man with swollen lymph nodes. Now remember, those are mature lymphocytes. Mature lymphocytes work, don't they, Joseph? Mature lymphocytes work, don't they? But at least it works better than all these other ones, and that's why CLL lives longer than the other leukemias. Yeah, but it's right beneath CLL as far as longevity. Okay? The key is myelocytes, occasionally they can undergo a blast crisis, and all of a sudden now you got an AML out of it. Yeah, you rarely see that. CLL can also undergo a blast crisis and get ALL, but that's not as common. But the swollen lymph nodes, you can live with. In fact, we don't even treat them most of the time. You only treat them when the white count is so high it's clogging up their vessels. Otherwise, leave them alone. The white cells work. That's how you know. Why treat numbers? That's what I'm saying. We don't just treat numbers, treat the patient. The lymphocytes don't kill you, they work. So leave them there. But when they get like over 100,000, then we worry about they might start clogging up the vessels. Then we go ahead and blast them with some drugs. What kind of a chemo drug are you going to give them, Nicole? She said, and so beautifully, I might add, well, since they are slow growing, I think I'll use alkylating agents, Dr. Francis. That was so beautiful. Thank you, Nicole. Now that's what I've been wanting to hear. There's a way to figure it out. That way the mind doesn't keep that habit of just kind of guessing things. Stab, stab, stab. No, go backwards. Take one step at a time. That way you come up with the answer. Now you know why you're going to say the answer, and you know you're right. All right, very good. Promyelocytic leukemia is the one with that British staging thing, stratification. Skip it. Just know this. M3 is 90%. Remember I told you guys I keep picking M3 every time. I don't even care what they say. I say M3. M3, 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 M3. No matter what they describe, M3, 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 M3. All right. So that means I miss it 10% of the time. I get the other 90% right. M3 is the most common type of promyelocytic leukemia. This is the one that presents with DIC. So they give you a great clue to pick up on. The other ones, man, I don't even know what they're describing. So there's no sense in my even worrying about it. DIC, what's the clue for that one? Rashmi. D-dimers are fiber split products. I'm clicking. All right? But I learned a clue for M5 and M6, though. So I'll share it with you. Because it's so class, I've never seen it in any other disease. So now I can actually keep it straight. M5 has more than 30% erythroblast. I've never heard of a disease with erythroblast. The blast form of RBCs. Never heard of it. M5 has more than 30% erythroblast. M6 has more than 50% erythroblast. Huh? I have no idea if there's monoblast in there. I just say I know the erythroblast is my clue. Uh-huh. No, erythroblast is just a level of number. They describe some stuff about their monocytes that I don't understand, so I don't even include the monocytes in my getting it right. So here's what I use. DIC is the M3. That's the 90%. That's the most common one. M5, more than 30% erythroblast. M6, more than 50% erythroblast. And then M7 includes something wrong with their monocytes as well, which I can't understand. I've read this thing several times. I don't understand what they're describing. So that means I have no picture in my head, so I don't know how to teach it to you. So I just left it alone. So that means with these three, with the M3 alone, I was picking it up 90% of the time, so I was happy with that alone. But with the erythroblast, I can pick up another 2%. 92, I'm taking it, man. I don't care about these monoblasts. They could be bald for all I care. All right? So, they describe some stuff in there. I don't even know. I don't know what they're talking about. Tim. Yeah, that's way before the retics. That's what I'm saying. I've never heard of a disease with erythroblast till I saw that. I said, oh, okay, I can remember that because there's nothing else to confuse me about it. All right, but that's just to pick up 1 or 2 more percent. So don't worry about it. If ever confused, which one are you going to click, Andre? Thank you very much. Remember, anytime you're confused, you go back to your 90%. Don't go back to a guess, you go back to your 90%. You say, well, what 90% can I use in this? Just click. Just like I keep pointing out, 90% for like second minute, second MP. If you don't know, click the same one. That's all I do. I'm telling you, I'm just trying to teach you guys how to get a high score in anybody's exam. They can't change the truth. All right? They can only change the questions. They can't change the truth. Hairy cell leukemia. Danielle, give me clues. TRAP, tartrate-resistant acid phosphatase. What do the cells look like? They look like fried eggs. Got hairy projections on them. Are most of them B cells or T cells, Danielle? What? Thank you very much. Remember, it's still 75-25. Still 75% B cells. It's still most common. That's why be careful how they ask the question. There's a higher incidence of T cell, but not that it's the most common. Because I see them sneak that question and change it. What's the most common type of hairy cell leukemia? It's still B cell leukemia. All right, so that's the leukemias. Lymphomas, there's 2 types. Hodgkin's and non-Hodgkin's. Hodgkin's lymphoma and non-Hodgkin's lymphoma. Hodgkin's lymphoma, Miguel, like to attack 20 to 40-year-old people. That's people in their prime. That's why they want you to understand this cancer. It's also highly treatable, Miguel. That's the other reason why they want you to understand it. Highly treatable. Okay, you're talking about 70 to 90% 5-year survival if you treat it right away. All right, so Hodgkin's lymphoma, age range 20 to 40-year-old. Characteristic cells, read Sternberg. You never have to worry about any other disease. Anytime you see that, click and move. Has to be Hodgkin's. Okay? But it has a CD marker, CD30. Sometimes you just slide that in and skip telling you it's a read Sternberg cell. And so you see a cell with a CD30 marker on it. Good enough for me. I'm clicking. All right, lymphomas usually present as swollen lymph nodes. Lymphomas present as swollen lymph nodes. So that's why you got to know the most malignant lymph nodes. Which ones would you worry about the most? Number one, risky, most malignant lymph node, supraclavicular. Remember Burkhouse nodes? We talked about it for GI cancer. That was the first one, but breast cancer goes there. Thyroid cancer goes there. So many cancers go there. Supraclavicular nodes is cancer until ruled otherwise. What does that mean? We biopsy today or tomorrow. I got to know which cancer it is, because the earlier you intervene, the better. So supraclavicular is the most malignant lymph node. So anytime they present that to you on the boards, you biopsy right away. Okay? That's the management. But if they want the association for the boards 1 people, you just got to pick a cancer, GI cancer being the most common. Okay? All right. But then there's epitrochlear. Epitrochlear is right here at your elbow. And then inguinal, right here in the groin. Okay? For those, biopsy as soon as possible. For any other lymph node, most common cause of lymph nodes any place else, infections. So that then allows you to understand how and why we manage lymphadenopathy in the following way. If you got a swollen lymph node in one of those 3 places, you must biopsy it today or tomorrow. Everybody follow me? Everybody understand that, right? It's malignant to rule otherwise. So you must find out. If you got lymph nodes anywhere else, because it's due to infection, that's why the answer is treating with antibiotics for a couple of weeks and have them come back. Okay? If it has not changed in size, now you can rule out cancer with a biopsy. If it's shrunken, it was an infection. Just let it finish shrinking. Okay? So we played a 90% game in medicine all the time. So Hodgkin's lymphoma. Then there's non-Hodgkin's lymphoma, Elvis. Non-Hodgkin's lymphoma usually affects immunocompromised patients. Do you understand, Elvis? That means, Elvis, anytime you diagnose a non-Hodgkin's lymphoma, you got to find out why that patient is immunocompromised. Do you understand, Elvis? So that means when they ask you the next step of your management, that's what they're alluding to. You must rule out immunocompromised state. The top 2 immunocompromised states right now in America, HIV. That's why you learn how to screen for them with what, Tara? Screen HIV with ELISA. And then colon cancer, which means you look with what procedure, Tara? Colonoscopy. So when they say next step of your management, that's your 2 choices. Anytime somebody has non-Hodgkin's, you got to rule out immunodeficiency state. Okay? It presents as an abdominal mass in America, jaw mass in poor countries. Now your book says poor jaw mass in Africa. Well, I thought I could believe Robbins when he said Africa, until I got to the exam and they said Cuba. Then I got to another question, they said Haiti. I'm like, damn, I don't know. I kept changing my answer. Man, it has to do with poverty. Now, why didn't you just say that? See, once you say Africa, then you think, oh, it's about Africa. No, it's not about Africa at all. Poverty. Here's the reason why. The child in Africa, you see him in the commercials, he or she's walking along the garbage dumps, picking up any food that she can find. Everybody following? If she picks up food and it's decayed, all the toxic junk gets released right into her mouth when she bites down on it. That means the lymph nodes in her jaw will drain that toxin. Cancer will start here. In America, we eat pretty good, right? But you eat toxic junk in that food too. And that's why, where is the majority of lymphoid tissue going to be found in your body, Monica? Where in the abdomen? Where is that Peyer's patches located? We're back to the abdomen again. Dan, help her out. In the ileum. Remember I told you 70% of your lymphoid tissue is in the ileum. That's why it's an abdominal mass. You see? Again, that's why I always like to go back to the root. Where did this information start? I like that information because I know as they write it in books, all of a sudden it becomes something to memorize. And then I don't understand it anymore. And that's why physicians, they don't understand the real root of the information. And that's why when they changed countries, I kept missing it. I kept thinking it was about Africa. Yes? Good question, man. Andre says in those countries they have immunocompromised conditions. And the answer is yes. But Andre, answer me this. What is the most common immunodeficiency in the world, man? HIV. That means you've been watching the news and reading the books. Unfortunately, that's not the answer. Cammy, tell me, what is the most common immunodeficiency in the world? I'm betting $5 Freddie knows it. Okay, I'm betting $7. Edos knows it. You're the man. See that? That's the point. I want you to see that's what it's about. It's about poverty. If they're poor, they can't eat food. Of course, that's what it is. $7. That's right, man. Free lunch on me, man. I've seen that question on the question pools, and that's exactly the way they ask it. What is the most common immunodeficiency in the world? And what do you think answer A? HIV. Because they know what you've been reading. They know what you're reading. First aid tells you that. Book tells you that. When you get to the exam. You forgot to use physiology to figure it out. I told you. The authors of the books are fascinated with things, so they go on and on about it, and so you then get confused. You think that's the most common, but that's not it. Always go back to the physio to figure it out. The most common reason for suppressing bone marrow is nutrition. Low energy state. And that's why it's so common in Africa. All right, most common for non-Hodgkin's lymphoma, because there are so many of them, you don't want to waste your time trying to memorize them. Very low yield. I just want to know the top two. Most common one is called follicular lymphoma. I mean, there's like 20 types. But this guy's 90% all by himself, so I'm taking it. Follicular lymphoma has BCL2 as a marker. We saw that yesterday. And then, of course, translocation 1418. So they'll give you the clues. You just got to know what it goes with. So non-Hodgkin lymphoma. The one we know the most about, however, is Burkitt's lymphoma. Also has BCL2 marker. But in addition, Elvis has CMYC. Has translocation 814 rather than 1418. And then it's associated with EBV, just like nasopharyngeal carcinoma. And it has a starry sky appearance. Elvis, what cancer is associated with LMIC? Kimberly, LMIC. All right, Maria, LMIC. Goes with what cancer? Tamir. L is for lung cancer. Small cell carcinoma of the lung. All right, so Burkitt's lymphoma is their favorite lymphoma. Simply because we know the most about it. That's all. So here's how you approach lymphomas. The person usually presents with a large lymph node, especially in those three areas that I outlined for you. First thing you do, biopsy it. Because I got to know. If it's positive Sternberg, you're over here in the Hodgkin's. If it's negative Sternberg, you're over in the non-Hodgkin's. That means you got to rule out immunocompromised state, do an ELISA, and then do a full colonoscopy. Everybody understand that arm? Everybody understand that side? Any questions about how to work up non-Hodgkin's? All right? On the other side, Hodgkin's has the Reed Sternberg cells, positive CD30, and has 4 types. Nodular sclerosis, lymphocyte predominance, lymphocyte depleted, and then mixed lymphocyte and histiocyte. Now, if I got nodular sclerosis type, Monica, and I do a biopsy on it, what do you think I'm going to see on biopsy? Nodular sclerosis type of Hodgkin lymphoma. What are you going to see on biopsy? Was that increased number of white cells? B cells. No. What are you going to see, Mustafa? You're going to see what? Whose cells? Lacuna cells? There might be. What do you think you'll see when you biopsy that cancer? Sandeep? What do you think you're going to see, Joseph? What's that? All right. What do you think you're going to see, Diana? What? Fibroblasts. Why fibroblasts? All right, let me tell you something, Diana. I can already tell you have the answer in your head. But now all of a sudden you're not sure because you only said half of it and I haven't said a word yet. So you guys always look at that early reassurance. Am I on the right track? No, I purposely stay silent. I want to see if you saw the whole thing. You already saw it, but stop hesitating. That hesitation costs points. All right, Arrows, break it down for the other $3. I'll give you a solid 10. Let me tell you what they see on nodular sclerosis. They see cells arranged in nodular pattern and a whole lot of scarring. Well, let me see now. How are we going to name it, George? How are we going to name it? The reason why I usually do that at this point is to show students. The name of a disease tells you a lot about it if you look at it carefully. Remember I said if you look at anything as a detail, you won't see anything in it. It has no meaning to you. Look at the words carefully. I bet you it'll tell you a lot about it. Look carefully. Okay? Don't overlook the obvious. Why would we say nodules if there weren't any nodules in there? And see, Diana, you started out fibroblasts. I mean, to me, that tells me you saw the connection, but all of a sudden you came out halfway and, I don't know if I saw it. Let me back off. See, now you start backing off your answer. Don't do that. You saw something. Sclerosis means scarring is in there. All right. So, lymphoma stage, remember I told you it's different than Dr. Francis made a ridiculously simple way. So I got to teach you this one. Because this is only for lymphoma. Yes. Burkitt's is under non-Hodgkin's. Non-Hodgkin's. That's immunocompromised. Follicular and Burkitt's, that's the only two you want to know. Leave the rest alone. Huh? No, Burkitt's and, well, yeah, it's in the 10%. Follicular is the 90% all by itself. Yeah. But Burkitt's is worth knowing. That's the reason why I went through it for you. Because we know the most about it. All right, lymphoma, stage 1. One group of lymph nodes is involved. Stage 2, Jennifer, 2 groups of lymph nodes are involved. But it's on the same side of the diaphragm. Which side of the diaphragm is that going to be, Jennifer? What? Right or left side? No, I'm just kidding. Now, with diaphragm, it's a tricky one. They know your brain already knows every other part of the body. We're always saying right, left, right, left, right, left. This is the only time you say up, down, up, down, up, down. Remember like shifting curve to right? pH is the one you're going to goof up on. This is the one they're going to ask you about, stage 2 or stage 3. Because students still think right. Let me show you what showed up on my boards because I missed it. They said the patient had supraclavicular nodes on the right. Notice they highlighted right. Then they said he's got abdominal lymph nodes on the right. You see that? My brain picked up, oh, right. Oh, good. Stage 2. Forget it. Wait a minute. What about what it doesn't matter about right and left? It's up and down. But why do you think they put that word right in there? Because they know it'll distract your brain. Because they already know your brain is programmed to see left and right because that's the main pattern that we work with. So that's why, again, I'm pointing it out to you. Only if you're aware of a trick would you even know it's a trick. Okay? So with stage 2, same side of the diaphragm is up and down. Ignore right and left. Ignore right and left. I'm going to tell you right now, that vignette will have right and left all over it. But that's not what you should be paying attention to. Is above or below the diaphragm. So stage 2, 2 groups of lymph nodes, but they're above or both below the diaphragm. Stage 3, 2 or more groups, but now both sides are involved. Above and below are involved. And then stage 4 is always metastasis. Josh, you got a question? No, any other part of your body, we always say to the right or to the left. Yeah, lymph nodes. If you got breast cancer on one side, I'm worried about if it gets all the way to lymph nodes on this side. Because they should have drained the lymph nodes only on this. The only way it could get over here, it's already throughout your whole body. Yeah, that's different strategy. Yep. All right, so that's lymphoma staging. And here's these drugs. Arrows. You're on a roll today, baby. So here are the drugs we used to treat lymphoma. It used to be MOPP, MOP program. Then we switched to the CHOP, CHOP program. Currently we use the ABVD program. Oh, there's a lot of chemo drugs in here, Arrows. A lot of them with side effects too, man. And I'm betting for a clean $20 bill, man. Double your money, baby. Just give me 5 clues. Go ahead. You got 4, 8, 12 drugs to pick from. All you got to do is give me 5 clues. And you can eat nice lunch, man. All kinds of wings. You get fries with it, too. Who? Which one? Which one? Oh, you're okay. I got you. Yeah, you can use any one you want. I just want to make sure which one you do. So bleomycin does what? There you go, pulmonary fibrosis.
Then Christine is going to blast my kidney.
No. Then blasting blast. You keep putting that blast in the Christine. That blasting is only with blast. All right. Wait a minute. No, you already got $20. I got you 20. I even got you some new $5 bills in there. She said, give me my money, boy. All right, so Linda, you feel like making some money? All right, Michelle got her hand up. Oh, wait a minute, Nicole. Go ahead. 5 clues for $10. Don't worry, you get the chance to. Oh, you want this one? Okay. Go ahead, 5 clues for $10. Go. To increase or decrease? Which one? Increase it. All right. I thought you were going to switch on me now. All right, that's 1 point. 4 more. Adriamycin, cardiac fibrosis. Very good. 2 points. Bleomycin, lung fibrosis. 3 points. Prednisone is the most common oral steroid. Very good. 4 points. Just one more. Take a deep breath. Smell those wings. Smell the pizza. Cyclophosphamide. Just one more. Just one more. That's all it takes, yeah, just one more. Just one more time. But you got to give me a clue. Not just tell me what it is. Give me a clue. For who? No. Give me a clue. Same clues I gave you. How do you recognize somebody's on Christine? That's what I want to know. All I need is one more clue. Got lots of drugs to choose from. Boom, 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 boom. All right, tell you what. I'll give you one chance to get to $10. Ready? I'll give you one clue. You got to tell me what drug is associated with it. You got 8 on this side, 4 on this side. Which drug is associated with Mesna? Mesna. No, anybody say a word? You gotta tell me which one's associated with Mesna. Look at 3 lists. And you can still have the 10. Cyclophosphamide. Yeah! All right, collect after class. Very good. All right, those are the big ones anyway with good clues. Vincristine is neuropathy. Remember, neuropathy. All right, moving on. Nodular sclerosis is more common in women, and it has the fewest Reed-Sternberg cells. So if they say there's a paucity of Reed-Sternberg cells, there's a reason why they're telling you that. It's a clue for nodular sclerosis. And it has intermediate prognosis. Phoenix, how old are these women? Okay, very good. Lymphocyte predominance. What are you going to see on biopsy, Eros? Yeah. Yeah. What are you going to see on biopsy? PJ, remind him. You're going to see lymphocytes everywhere.
I'm already with you.
See, I told you, man. When you panic, you see details again. You don't see anything in those words anymore. Why did they say lymphocyte predominance? It means they're everywhere. Lymphocyte depleted. What are you going to see on biopsy, Josh? The man's got to get paid for this one, huh? Oh, yeah, I'll pay you for another list later on, man, since you're feeling good. Yeah, they'll say a paucity of lymphocytes. Good enough for me. Okay? And then mixed lymphocyte histocytic. Gee, what are you going to see on biopsy now, Al?
We're looking at lymphocytes and histocytes.
Probably so. I'm guessing the same thing, Al. Okay. And then mixed lymphocyte, mixed has the most Sturberg cells. So if they say you got lacunar cells everywhere, boom, they want the mixed. Okay? So know the worst, every cell's wiped out. That's how you know, lymphocyte depleted. The best, all lymphocytes are still everywhere. Can't be that aggressive. Okay? And then the nodular and mixed are intermediate prognosis. But you can separate them because the most Sturberg cells are with mixed, the fewest with nodular sclerosis. Again, organization. Myelodysplastic syndrome means the entire bone marrow is involved. 2 of them are too many, 2 of them are too few. You understand, James? You understand, James? In 2 diseases, all the cell lines are too high. In 2 of them, all the cell lines are too low. Do you understand? All right, so James, in polycythemia rubra vera, all the cell lines are high and RBCs are the highest. You understand me so far? All right. In essential thrombocythemia, all the cell lines are high, but the platelets are the highest. That's why they named it after. So polycythemia, named after RBCs. Essential thrombocythemia, named after the thrombocytes, the platelets. You understand, James? Okay. Now let me ask you a question, James. Tell me one vitamin you put that patient on. No, Dahlia. Give me one vitamin you put that patient on. Why folate? Rapidly dividing. What vitamin runs out first? Oh, I told you be ready to apply what you've learned now. Nicole, this person came in and complained about his big toe hurting. What drug are you going to start him on? His big toe is hurting. What drug you want to start him on? Colchicine. You got to assume it's gout. Remember, rapid cellular division means rapid cellular death too. Everybody follow? All right. So anyway, that's how you separate them out. So you can think a lot of these through on your own. So polycythemia rubra vera, the high hematocrit is the best clue. It's right there in its name. Hematocrit is usually above 60%. They itch after a hot bath. Why? Because they have too many mast cells. Remember, they have too many of everything. Mast cells degranulate when you heat them up. Okay? Uric acid stones or gout is a problem. Okay? Splenomegaly. Why do they have splenomegaly, Sandeep? Because what? Yeah, because you got way too many RBCs and the spleen is supposed to remove them. Okay? Why are they jaundiced, Sandeep? Because you're breaking up the RBCs. Is that intra or extravascular hemolysis going on? Extravascular hemolysis. All right. I have one more question for you. Can't remember now. All right, sometimes you can see increased LAP. Anytime you got blast, you can see leukocyte alkaline phosphatase. Polycythemia, rubra. Here's my question, Sandeep, I remember. Why are they blue? Why are they so blue? Very good. Why are they not saturated? She said, although they have too many RBCs, most of them are not saturated. Remember, we talked about that? Why are they not saturated? Because what? Right, VQ mismatch. You got a VQ mismatch. So the RBCs don't have enough oxygen on them. Okay, so polycythemia rubra. Essential thrombocythemia, all cell lines are high, platelets are highest. Classic clue, platelet count is above 600,000. What's the most effective drug against a platelet? Joseph. Most effective drug against platelets, Eros. It's called aspirin. How does aspirin work? Eros. Irreversibly acetylates what enzyme? Cyclooxygenase. My man, Dr. Sanchez, you sounding good over there, man. My man got smooth with his explanations now. Irreversibly acetylates. That's sweet, man. A couple of weeks ago, he had a hard time remembering what even aspirin does. Now all of a sudden, and he irreversibly acetylates the cox. Man, my boy been empowered over here. I like it. All right, very good. All right, if you can't tolerate aspirin, what kind of alternative can I give you? Ferdy. What are second-line drugs? Antiplatelet drugs, if they can't tolerate aspirin? Clopidogrel, diclopidine, or... That's all right, dipyridamole. And then there's also silostazole. All right. So essential thrombocythemia, the main problem is their platelets. What's the most common cause of death for this patient? Pernema. Why infection? I said, what is the most common cause of death in essential thrombocythemia? Look at their problem and tell me why they're going to die. Let's see if James can figure it out. Maybe Thomas can do it. Why do you think it's heart failure, Thomas? Has to do with blood. Another empowered young man. You're the man, baby. You see that? So in polycythemia vera, it says that even though they're both cancers, this is the only time you're going to die from heart failure. Because you're clogging up my arteries. What's the first artery to go? Coronaries. You won't even live long enough to die from an infection. So remember, the other times it was you don't live long enough to die from heart failure because the infection will get you. Two exceptions to the rule. Because you're clogging up the arteries with way too many cells. And they're going to have a MI or stroke real quickly. Okay? And that's why you have to treat them when their counts get way too high. Like in polycythemia, we'll bleed them, phlebotomize them. Every 2 to 3 months, just come in and just suck a lot of blood out of their veins. I mean, just so to prolong their life. Okay? Aplastic anemia, all cell lines are depleted. In fact, the bone marrow is replaced with fat because all the cell lines are gone. Number 1 cause is a virus. Number 2, drugs. January. What's the top virus that can do this? Aplastic anemia. There was a bug I gave you earlier. Tim. No, Tina. Parvo B19 for aplastic anemia. If it's just for leukopenia in general, then you go back to CMV and EBV, the top 2 viruses. But as far as wiping out everything, Parvo B19 is the 90%. Okay? And then we talked about drugs. We've done them, the same list of 4 so many times now. Reticulocyte count will be very low. That's how you know the bone marrow is not working at all. Remember we said anytime somebody's anemic, the first thing you do, check the reticulocyte count to rule out an aplastic crisis. And you'll see the reticulocyte count is close to 0. Yes, sir. What about it? No, the most common cause of bone marrow suppression is virus. That means CMV and then EBV, number 1 and 2. But if you talk about wipe out the entire bone marrow, Parvo B19 is number 1. Okay? What about, let's say, in pregnant women, Andre? Aplastic anemia in pregnant women. She's pregnant, Andre. And now her bone marrow is all gone. I want to know. Well, he had to confess. I spaced out, Dr. I don't know what you're talking about. All right. Aplastic anemia in pregnant women. What virus do you have to worry about? Hepatitis A, B, C, D, or E? E for pregnant women. Okay? All right. Aplastic anemia. Here are the viruses. Virus B19 for the general population. Hepatitis E for pregnant women. Hepatitis C is only occasional. Aplastic anemia for drugs. We've done these 4 many times. Make sure you know them. Myelofibrosis, the last one, means the bone marrow is destroyed by cancer and replaced by scarring. Fibrosis, scarring. That means cancer. That means the teardrop cells will be there to show you that somebody squeezed everybody out. You see a low reticulocyte count, which means the bone marrow no longer works. And now the final question that shows up on the boards, listen carefully to my question, Monica, is, I got a child, 3-year-old child with myelofibrosis. What would be the underlying cause of that? ALL. You understand? All right. Watch my hands. Okay? If you got myelofibrosis in, let's say, a 55-year-old female, what would be the cause of hers, Rebecca? Not ischemia. Miguel, myelofibrosis in a 55-year-old female. Remember in a child, Monica said it was ALL. What's it going to be in a 55-year-old female? CML. Okay, what do you think, Tina? CML? What do you think, Tim? Don't say a word. All right, CML. What do you think, January? You think what? I don't know. Eros, what are you going to say? Thank you. Now we get into the cell. January smiling. She says, oh, I want to learn some more, Dr. Francis. Please break it down for me. All right, so here we go, January. We're going to break it down. All right, we got to learn the cell. Why? Because if you learn the cell, you can understand the tissue. If you understand the tissue, you're going to understand an organ. Understand an organ, understand organ systems. If you understand organ systems, you understand the organism. That's you and me. But understand, we're going to go from the micro level all the way out to the macro level. To show you, if you understand the basics down here, it's easy to extrapolate out here. All right? So, cell organelles is what we need to understand. Starting out with the nucleolus. All right, sorry, the cell nucleus. The most important cell organelle, is called a nucleus. The most important cell organelle is a cell nucleus. If you damage this nucleus, folks, the cell will die. Does everybody understand? What's the most important cell organelle, Omar? The nucleus. Ferdy, if you damage the nucleus, what happens? The cell will die. So that means damage to the nucleus is the first sign of irreversible cellular damage. You understand, Al? That means if you damage this nucleus in any way, Al, what's going to happen to this cell?
Say that again, sorry.
If you damage this nucleus in any way, what's going to happen to this cell?
It's done.
It's done. What's going to happen to this tissue? It's done. What happens to the organ? It's done. What happens to the organism?
I'm starting to see Jesus on the wall.
I'm starting to see Jesus on the wall already. Thank you. That's my point, man. You start from the micro, bring it out to the macro. That's the point. It means if I see nuclear damage, put away the TPA, streptokinase, it's too late. That's the big picture I want you guys to see. How does a pathologist help you in deciding when no therapy is going to help? Anytime there's nuclear damage, you might as well forget all your therapy. It will not work. Everybody understand that? Okay, big picture. All right. In the middle of a nucleus is this little circle. For a long time, I thought they were messing up on the picture. It's a circle called a nucleolus. The nucleolus only gives us one thing, then V. That one thing is ribosomal RNA. Ribosomal RNA. You only have 2 types of ribosomal RNA. Well, 2 types of ribosomes. One is floating around free within the cell, January. One is floating around free within the cell, Kathia. Free floating ribosomes produce proteins you use within the cell. Free ribosomes, once again, produce proteins that you use within the cytoplasm of that cell. So when we do biochemistry and you learn all the pathways that go on in the cytoplasm, that's how they can make it sound more specific, Paul. It's by saying, well, gee, where would you synthesize hexokinase? You would just have to remember hexokinase is using glycolysis in the cytoplasm of the cell. Now the question is easy. Okay, but to put the word hexokinase in there, aha, makes it sound like it's real picky. That's why if you focus on hexokinase, you'll forget what you learned, and then you start trying to remember what you read about hexokinase. No, you didn't read it. Okay, it's a combination of two pieces of information in order to get it right. Okay, that's the type of questions they're asking on the boards. So again, the second type of ribosome is rough ER. Ribosomes, Thomas, when they're attached to their endoplasmic reticulum, produce proteins that need to be packaged. That means they need to be sent somewhere. Do you understand, Thomas? You understand, Ferdy? All right. Let me start working on the rest of the row. Oh, wait a minute. What's my man over here? Oh, Ajay. Okay, I got it. Ajay, right? Did I get it right? Ajay. All right. A-J-A-Y. So just Ajay. Okay. One short A, one long A. I got it now. All right. So Thomas, to the right of Thomas. No, to the right of Thomas. First name. Bia what? Biatola. Biatola. How do you spell it? B-E-R-T-H-O-L-A. Biatolan. Biatolan. What does that mean in French? Just like Hidriga. After a while, I get, yeah, fine. Okay, so biatolan. What does that mean in French? Okay. My biatolan. Okay, biatolan. Gotcha. Biatolan. To the right of biatolan. What is it? Margov. Bargov. Okay, I remember seeing that name. Bargov. All right. What does that mean in your language? Don't know. Okay, Bargov. Gotcha. To the right of Bargov. Samir? Tamir. Bargov, Tamir, biatolan. Ooh, I got some work. Okay, biatolan, we got the most important cell organelle is what? The nucleus. If you damage the nucleus anyway, what's going to happen to that cell, biatolan? It's going to be damaged for good. What's going to happen ultimately to that cell, biatolan? Die. That means the first most important sign of irreversible cellular damage, Bargov, is what? Huh? The first most important sign of irreversible cellular damage is what? What cell organelle damage? Nuclear damage. If you damage a nucleus, there's no coming back. Do you understand that? You understand, Tamir? All right. What comes from the nucleolus, Tamir? Ribosomal RNA. And if we go over here, Diana, free-floating ribosomes make proteins that ultimately end up where? Within the cytoplasm of the cell. Everybody understand? Rough ER. So rough ER, ribosomes attached to the endoplasmic reticulum produce proteins that ultimately end up where? Diana. No, they just have to be packaged. No one place. They go to a lot of places. But everybody understand the difference between free ribosomes and rough ER, because that's the question they're going to ask. All right, so that's the nucleus. So irreversible cellular injury, first thing is nuclear damage. Well, it can happen for one of two reasons. The first reason is called apoptosis. Apoptosis is programmed cellular death. You got to go quietly, Michelle. Apoptosis. Got to go quietly. When it's time to go, in apoptosis, the periphery will disintegrate first. How do you know that? Because all you do is ask them, who has the software for cellular death? It's your nucleus. So he has to go last. Whenever you have programmed cellular death, i.e. apoptosis, the nucleus will go last. Everybody understand that? That means the periphery of the cell membrane, will disintegrate first. That I call an implosion. Everybody understand what I mean? Implosion, you're going this way. Start from the periphery. So they'll ask you, which of the following descriptions, typifies a cell undergoing apoptosis. Shh. Just look at the word periphery. I don't care what comes after that. Click, move, next question. The rest, details to me. I've seen the answer just be your peripheral aggregation of who cares. Click, next question. I don't stick around to see of what. Who cares? They said periphery, that's the most important issue. That's my point. The more details you get into, the more details are going to be used against you now. Then you say, well, maybe I don't remember that being part of the periphery. See, now you're debating the wrong issue. Issue is periphery. I don't care what comes after that. All right, so apoptosis, cell membrane disintegrates first. It's programmed cellular death, and because of that, Maria, it's non-inflammatory. Means it doesn't set off any problems. Why? Because your body knew it was going to happen. That's right, Michelle. Your body knew that skin cell on your toe was going to die today. So because the body knows, nobody says a word. Charlie's going. Well, it was his time. He was 84 hours old, man. That's a long time. For a skin cell, that is a long time. So he's got to go. That's why the body doesn't do anything about it. Well, look at the main words that they'll use. Pyknosis. Pick your nose. The nucleus forms blebs. That's the way we're in. Pyknosis, picking your nose. You pick out blebs. All right, so they'll describe it, you pick the right term. That's my point. Pyknosis, the nucleus forms blebs. Karyohexis, the nucleus breaks up into chunks. So it was just kind of pinching off, and now you see 7 or 8 pieces to it, and we say karyohexis. And then karyolysis, look at the rest, lysis, dissolve. They'll say the nucleus has dissolved. They say, aha, karyolysis. You understand, Tanvi? When it's not programmed cellular death, then we call it necrosis, Rashmi. You understand, Tamir? You understand, Bhargav? All right. Necrosis is not planned. That means it happened on a Tuesday when that cell was supposed to be around for Wednesday. It says, hey, man, how can you take me out today? I'm not supposed to go for another 24 hours. No, let me stay around. I'm protesting. Ah! You hear screams and shouts, and then all of a sudden, nothing else. Ooh, what happened to Charlie? Oh, you didn't hear? He's gone. So necrosis produces a lot of inflammation because it wasn't supposed to happen. That means hell, if I see inflammation in your skin, was that programmed or non-programmed? Non-programmed. Was that necrosis or apoptosis? That was necrosis. What part of the cell disintegrated first? That would be the nucleus. You better understand the point. That's how you bring it all the way out to the macro level. That means if you show me a biopsy of any tissue and I see the nucleus is already dissolved and before anything else happens, I say, this is necrosis. If you give me a disease and you describe inflammation, I say, this is necrosis. Everybody follow me? There's so many ways to move that information around as long as you see the big picture. You can use it to answer a lot of questions. Even if you don't know what it is, at least I know the answer has to have something to do with necrosis before I look at it. All right, so unexpected. And look down here, you see the same 3 words. It's just what order it happens in, Tara. When the nucleus dissolves first, we say necrosis. When the nucleus dissolves last, we say, Tara, apoptosis. Everybody understand that? All right. So that means, therefore, Nicole, if I see a cell in your body that did not die because it was supposed to die, what failed to happen? I see a tissue that's still there that was supposed to die but didn't die. What failed to happen? When you're supposed to die, Faisal, apoptosis did not occur. Do you understand? I know the boys twos are probably thinking, Dr. Faisal, how is this relevant for boys too? Gabby, tell me what I got to do.
You gotta break it down.
I got got to break it down one time for you, man. Open up your eyes. Show you how many times you use the same information. Let's say I got an extra finger on here. It's not supposed to be here, is it, Tim? What failed to happen? Apoptosis didn't happen. So you got duodenal atresia, Cammy. How come the duodenum was not attached to the rest of the duodenum? What failed to happen? Apoptosis failed to happen. Oh, you got esophageal atresia. Ferdy. How come the esophagus is not attached to the rest of the esophagus? What failed to happen? Thank you. Look at that, folks. Every atresia in your body has just been covered right before your very eyes, but you didn't see it coming. That's the way I roll. You learn more in 10 minutes than you can read in a month, folks, when you see the basics explain all this other stuff. But nobody tells you that. They just keep teaching you all this other stuff, but you still don't know where that information came from. And that means when they pick out another atresia and ask you, hey, what happened? How come you got 8 toes in Patau syndrome? And then you don't have an explanation for it now, do you? Because you think you got to go read about Patau syndrome to figure it out. That's the scam in the question. Is do you already know the concept, or do you think you got to read about Patau's? If you think you got to read about Patau's, then you missed the concept of the question. All right, so apoptosis and necrosis. Everybody understand the difference? Cool. Necrosis now. Let's focus on just that. So everybody understand the big picture for apoptosis. That means a tissue is supposed to leave quietly, no inflammation, nobody knows anything about it. But if I see a tissue that did not go, then you say, well, apoptosis did not occur. Everybody understand that? So every atresia can be explained. Anytime you got extra tissue anywhere in your body and they ask you, how did this thing end up here? You say, okay, apoptosis didn't occur then. Okay, because it's not supposed to be there. All right, so how do we evaluate necrosis? Different types of necroses. The most common cause, the most common type, Paul, the most common reason, Paul, for necrosis is called ischemia. That's the 90%, B-Nish. That is the 90% AJ. Or is it AJ? Oh, AJ. I'll get it by Wednesday. Okay, AJ. You understand that ischemia is the most common cause of all necroses. Do you understand that? What's the most common cause of inflammation? AJ. Huh? Okay, then ischemia must be the answer. Hey, Kathy. Hey, got a quick question for you. If I go to the next point. You know, when you see elderly people and they got tissue missing in the medial wall of the lateral ventricles, what's the most common cause of that? They call it leukoencephalomalacia. I thought maybe you'd come across that reading before. That's just an elderly person who's missing some tissue right here. Medial walls of 2 lateral ventricles. What would be the most common cause of that? Orderly. What's the most common cause of that? Ischemia, Kathy. Sorry. Gotta demonstrate this stuff for you. See how the test writer does it? Something so simple, but you forgot. I said elderly people, they're missing the cells. Well, where do the cells go? Either apoptosis or necrosis, one of the two. What's the most common cause? Come on, right here, folks. Leukoencephalomalacia, just a fancy term. Well, those are the cells that died. I can tell you why they died. Cammy, what's the most common reason for a small kidney? What's the most common cause for cerebral atrophy? What's the most common reason for dry skin? Everybody follow? You see how simple it's getting? You see how easier it's becoming as you start to see the concepts with me? But before you actually see the concept, if I would ask you what's the most common cause of dry skin, you'd swear I'm asking you a hard question. When all of a sudden you see, oh, dry skin, that's cells that died. They hung around. Okay, well, still necrosis. Ischemia is the #1 cause of necrosis. Everybody clear? Everybody clear? That means if they ever ask you why cells died and you don't know, you never even heard of the disease, you're not even sure they spell it right, Melanie, what are you going to pick as the most common cause? What are you going to pick as the most common cause, Miguel? What are you going to pick as the most common cause, Thomas? What are you going to pick as the most common cause, Ferdy? Yeah, you say that now. We'll see later. I like to make the challenge fun, folks. I'm warning you and I'm telling you. I'm going to catch you guys. You just got to you got to make sure you listen carefully to my question. Okay, that's how I know when your mind starts to make the transformation into hearing concepts and clues versus just hearing a lot of details, is when I can just put all kinds of information all around a basic concept and ask it to you in a whole different way. Because when I come back at you with the same question, you won't hear the same words I just used. It'll be totally different. And that's how I'll know if you really understood that or not. Because I told you, students like to shake their head like this. Yeah, I understand. Yeah, right. You understand? When you can demonstrate for me, you can understand. All right, so that's necrosis. We call it also coagulative necrosis because coagulum, blood clot, ischemia, clot off the blood supply, right? Anytime you have ischemic necrosis, tissue dies, but the architecture is maintained. That's important to know, Ferdy. Tissues die, but the architecture is maintained. What do I mean by that? Diana's asking herself. It means I cut off the blood supply to part of your brain dies, but the rest of the brain still looks like a brain. That's why the prognosis is good. You understand that now, Ferdy? Ischemic necrosis is the 90%, but the prognosis with it is very good. Why? Because architecture is still maintained. The rest of the brain still works. You have an MI, Al. I clot off a chunk of your ventricle, but guess what? The rest of the ventricle still looks like a ventricle and works like a ventricle. That's why the prognosis is good. Everybody understand? Coagulative necrosis. Purulent. Purulent necrosis. Anytime you see the word purulent, you should think about pus. Anytime you see pus, what should you think about, Nelson? Bacteria. So anytime you see purulent necrosis, you think of bacteria. Everybody understand? Okay? That means each and every time. That means, folks, I know you can have purulent with viruses. I know you can have with spirochetes. I know you can have with fungus. But on an exam, Al, when they say purulent, which one are you picking? Bacteria. Thank you very much. Just so we don't argue. I'm telling you the 90%. I don't want to hear about the few exceptions. For exam's sake, folks, you cannot be thinking about all those other things it could be. On an exam, take the 90. Okay? Because I'm not going to pick the 2% of the time as a fungus. I'm not interested in 2%. I want the 90%. Everybody understand? Purulent, you pick bacteria every time. All right. They say granulomatous, then you pick non-bacterial. They say granulomatous, you say non-bacterial, Chris. Well, when you look at granulomatous, the word granulomatous, Nicole, what two cells are in here? What two cells are represented with granulomatous? B. Nish knows this. Macrophages and? No. Macrophages and? Who always hangs out with macrophages? T cells. So wherever there's one, there better be the other one too. You understand? All right. So granulomatous means T cells and macrophages are represented, Maria. It means non-bacterial. Do I know who besides that is not a bacteria? I don't know who. It could be anybody. All right. Granulomatous. So some words obviously are real specific. Some are not very specific. Granulomatous just rules out bacteria for me. That's it. Can't do anything else. What about fibrinous? Fibrinous means there's fibrin deposition here. Fibrinous means there's fibrin deposition. Anytime you have fibrin deposition, top three things to worry about. Collagen vascular disease is number one. You understand? Eros. You understand? You understand, Tanvi? Anytime they say fibrinous, collagen vascular disease, number one, uremia, as in renal failure, number two, and tuberculosis, number three, in that order. Anytime I give you a list, folks, I try to give it to you in order, because on an exam, when they have multiple right answers, they're really adding a layer of epidemiology to it. Do you know the order in which it should come? Okay? So it's collagen vascular disease, number one, whenever you see fibrinous necrosis. Uremia, as in renal failure, number two, and then TB, number three. Okay? Cases, Tara. Anytime you see cases, what do you think of? Cheesy, as in what infection? TB. So, folks, look at this. That means if you say granulomatous, I say, well, it's not a bacteria. You say fibrinous, I say, well, it could be collagen vascular, it could be uremia, it could be TB. But when you say this, now I know for sure it's TB. Everybody understand? So some are very limiting, some are kind of general. That's why they can put more than one clue in a test question. I like the ones that are most specific, folks, the ones that allow me to click without worrying about anything else it could be. Okay, this one, I just know I can cross out bacteria off that list. But that's as far as I can go. Everybody understand me so far? All right, so caseous, cheesy, think of tuberculosis. Fat necrosis occurs in organs where you have mostly fat. 2 places they want you to know. Chronic pancreatitis. Remember, the pancreas sits on a bed of fat. So anytime I see fat necrosis in your retroperitoneum, pancreatitis is the issue. You understand, Barga? You understand, Tamir? You understand, wait a minute. Hang on. Ajay. Did I get it right that time? Yeah. Yeah. All right. Ajay. Got it now. Okay. So, fat necrosis, chronic pancreatitis. Okay? Number 2 location, breast. Breast is 95% fat. But when a woman comes in with fat necrosis of her breast, folks, there's more to it than just that. It means she has suffered significant blunt trauma to her breast. That's usually, the battered woman. In the articles, they call it the hidden second diagnosis. She never tells you why she's really coming to see you. She's always complaining about little aches and pains. So on the boards, they always describe it as some woman who comes in kind of shy, head bowed down, looking down the floor. She doesn't maintain eye contact when she's talking to you. She tells you, oh, it hurts right here, doc. This has just been bothering. And then, of course, on your physical exam, you find out she's got fat necrosis of the left breast, and they ask you what that means. Okay? So the hidden second diagnosis is she's been battered. Now, if you ask her what happened,